या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिः देवै वन्दिता सा मां पातु सरस्वती.
I request Dr. Yashwant Patil sir to welcome all the delegates and address them.
Good morning to all. I, Dr. Yashwant Patil, President, International Association of Health and Disability. I welcome you all for this workshop, which is a surgical workshop. What we are seeing in the actual conference, it's a medical management, but this is a surgical management of the disabilities and to solve our questions with the interactive session. This workshop has been organized on the occasion of International Conference of COMHAD and BAPIO UK 2021 in association with NNF Foundation, NNM Foundation, and along with other partners are BAP, UNICEF, as well as DMER, and so many others, such as OTPT, councils, colleges, medical colleges, all these, along with IIP, NNF, all these organizations, they are participating in this conference. So it's a good time that we are looking after the surgical aspects also, other than the medical aspects. So we have eminent surgeon who supports us for these conferences to conduct such workshops every time. Whenever the conference is there, he is ready to undergo these workshops. And we are very much thankful, grateful to him, the NNM Foundation team, and especially Dr. Viraj Shingade, Madam Shingade, and their team members. So with this, I think you all people, you take advantage of this workshop, get the knowledge, and carry on that knowledge for the welfare of the society. Thank you very much.
I request Alpana to acknowledge the work done by Dr. Yashwant Patil for this conference by giving floral bud. So you are inspiration. So you three are inspiration. So we have to. Thank you so much. I invite Dr. Bodhankar sir for blessing us.
Good morning to all of you. Thank you, Dr. Prayata Kaduskar. I respected Dr. Yashwant Patil sir, International President of COMHAD. I will tell you in short because you are new. What is COMHAD? Dr. Yashwant Patil will tell you. COMHAD is Commonwealth Association for Health and Disability, UK. It is the association of 54 Commonwealth countries, and our chief patron is Her Majesty the Queen Elizabeth II. And I was the executive director. Dr. Yashwant Patil is the international president. I will request him to be here with me on the stage. Also, you also come here on the stage. I will tell you about BAPIO. Also, I will request Dr. Viraj Shingade. Madam, to me, please. I will request all of you to be here so that we don't waste time. So I will tell you about BAPIO. The BAPIO is British Association of Physicians of Indian Origin. म्हणजे आपल्या इंडियामधले जे डॉक्टर्स काम करतात आहे युके मध्ये ते 65,000 डॉक्टर्स आहे इंडियामधले. So all of them, they deserve to be complimented. Give a big hand to COMHAD team, BAPIO team. Of course, UNICEF team is there. UNICEF DMR, ज्यांनी आम्हाला sponsorship दिली आहे. So about Narayanji Foundation, NNF, which is there with Dr. Viraj Shingade, or beloved Rashmi Shingade madam, who is here. Definitely, they deserve special compliment. Give a big hand to them. Because every year the participants, every year whenever we don't ask them, but they come forward. This is very rare. People don't come forward with volunteering, but they come forward. So we are grateful to you, your team of anesthetists. Everybody deserves special compliment. About other people who are there on the stage, respected Umanjali Damkevanam, you know, she is the director of physiotherapy school, government medical college. Welcome her. She is a great helper. We have got Dr. Pradeep Jaiswal, Secretary General of COMHAD, which is the organization of 54 countries. Give a big hand to him. We have got my left hand, the lady behind the success of this conference. The only one and only one I will say is Dr. Payita Kaduskar. Yeah, she deserves special compliment and bouquet from all of. I will give bouquet so that we don't wait. We have got Meenakshi Wankare, madam, you know very well. Pediatric physiotherapist, Alpada Moy, give a big hand to them. I am doing both the work, giving thank you. And I will request Dr. Yashwan Patil to give Rahul Tian Apla. We have got some gift of Ganpati to Shingade family. So I will request him to give that as a surprise gift because they are done. Man, this is just a token of love from us. Kamar, yeah. Virat ne happen to me, madam. Yeah, yeah. So this is just in all our Indian this thing. We start with Ganesh Vandana as you are saying. So I am giving Ganesh chip this thing to her. So with this, I think the workshop which is there, it is on the management of cerebral palsy mostly, management of how spasticity can be there, and we refer all our patients to Viraj Singare, the only one orthopedic, pediatric orthopedic surgeon which was available to us in more than maybe 1 decade, 12 वर्ष झाले? 6, so more than that. So my patient, anybody come to me, I said, sir, ऐसा चलने में शिंगाड़े सर के पास जा, मैडम के पास जा, and they get relief. Only thing is, it is not that they are doing service, it is affordable, acceptable, approachable. 3A. But they पैसे नसेल तरी करतात काम, त्यांचे foundation, NNF, doing Yemen services which are recognized by even Honorable Mohanji Bhagwat, I know, even by all people, whether irrespective of caste, religion, and party. So they deserve a special compliment for NNF give a big hand, that foundation. I must recognize presence of all delegates who are here, and of course I must recognize the work done by Rahul. I think he will be given full from this patient. I will request him to give a full. See, we must recognize those who are working behind the scene. Yeah, yeah. So definitely he has been there 24/7. We are working every day up to 2 a.m. I will request him to give bouquet to Payita Kaduskar. Yeah. And of course, Pradeep Jaiswal too doing there. Maybe I'm taking your seat. Of course, you must recognize presence of respected Umanjali Damke madam, director, who has always there. Madam, मेरे को 25-30 ये होना. बोले सर आप 50 मिलेंगे आपको. Thank you, madam. Then recognize Dr. Mrs. Shingare madam again. Yeah. Of course, Meenakshi Wankade always there as a pediatric physiotherapist, as a member. Yeah. And of course, Alpana Moy madam. So I have done both the work together because of shortage of time. I thank you all. Yeah, madam, please come. Good morning. Yeah. So with this, I think we are led to welcome you all delegate for this unique workshop, which is managed by Dr. Viraj Shingade family. Also, we recognize the presence of anesthetists. I think they have gone for the work. So also convey our regards and best wishes and greetings to them. With this, I convey you greetings and enjoy academic fees. Thank you.
Thank you very much, sir. So for your blessings, I request Dr. Yashwan Patil, sir, to offer you a floral bud.
Thank you.
Thank you very much. I request Dr. Pradeep Jaiswal, sir, to propose a vote of thanks very short, briefly. Yeah, so that we can start with the workshop.
So I thank all the people involved in this workshop, especially Dr. Viraj Shingare, NNF Foundation, and all our OTPT colleges, all the organizers who made this workshop possible, and all the delegates who will be benefited. So I thank them and offer my blessings to them for a better learning and knowledge experience. Thank you.
I request all the dignitaries to occupy their places of the dais. I invite Dr. Rashmi Shingade, MOC, for today's session to take over for the further proceedings.
Thank you, Prajakta. Respected dignitaries, faculties, and dear delegates, a very good morning. On behalf of NNM Foundation, myself, Dr. Rashmi, Vice President of the Foundation, I welcome you all. A very warm greeting on this cool winter morning. So as a therapist, you all are aware of the management of cerebral palsy, that is medications, therapy, and surgery. But you must be very curious about what exactly happens inside OT, right? So that exactly what we are demonstrating to you through a live surgical workshop. And the main purpose of it is to give you in-depth knowledge or view, 3D view of what happens in operation theaters. So there are two sessions. First session is the live demonstration, and the second will be interactive case discussions. So coming to the surgery, so orthopedic surgery, there are 6 types of orthopedic surgeries which we perform on the spastic kids. First is muscle lengthening, second is tendon lengthening, third is tendon transfer, then there is orthodesis, and for very severe cases, osteotomies, tenotomies, or muscle cutting, that is myotomies. So today we'll be demonstrating the most common procedure which we do more than 90% of cases, that is muscle lengthening and tendon lengthening. So I request Alpana to present the case which will be demonstrated. Thank you.
Good morning, everyone. All those who are present for this workshop. I'll just have what I plan to do is we'll have a short presentation. The first would be the case which is being operated. Just give a short evaluation and assessment of that details, and then we'll be discussing on that thing. Today's workshop is making cerebral palsy easy, because that's one of the commonest cases as therapists we come across. And in spite of handling cases for a long time, everyone of us still has a lot of challenges and issues. So we need to constantly update our knowledge and keep discussing so that we find better options to help children. So the purpose of having this workshop was trying to discuss cerebral palsy from various aspects. We kind of shortlisted, or you could say we've realized that we could discuss CP in the following points, like early intervention, a therapist perspective from ICF model, a surgeon's perspective and his inputs for rehabilitation, and then of course the recent advances that we keep getting. So one by one, I'll just try to say that. Next slide. What is cerebral palsy? There are various definitions. The commonest being it's a group of disorders that affect movement and muscle tone or posture. It's caused by damage that occurs in the immature brain, developing brain, before, during, or after birth. It commonly affects your movements, muscle control, coordination, muscle tone, posture, balance. It can also impact fine motor skills, gross motor skills, and oral motor functioning. These are the commonest problems that we encounter. Patients come to us with these problems, and we are supposed to give them solutions. Next slide. Management of cerebral palsy. Shortly, like three or four gross major components that we have. The medical management. In case of patients like having convulsions or any other medical history that they have, because a thorough medical investigation is the first line of intervention that is being done. And once that is being cleared, then the patients are referred to us as therapists. Then comes the rehabilitation part, and then of course the surgical part. All these three together try to we try to make the person as functional as possible. Next slide. Next slide. Rehabilitation. that grossly you can say the type of treatment which is given is physiotherapy, occupational therapy, language and communication therapy, commonly administered modes of therapy, rehabilitation that are given. Next slide. Early intervention, as we said, that we keep on insisting on early intervention because in a country like India, where we may not have the facilities and the resources to identify the child early in time, that getting diagnosed and finally coming to the setups where the treatments are available. So early intervention, as we say, that why it is important, because it can provide the infant or the baby with the opportunity to practice functional movements that would otherwise not be possible due to his problems, that of muscle
Hello?
weakness.
Alpana?
Yes, sir.
Rashmi, am I audible?
Yes, sir.
Yeah,
You are audible.
we have to make the patient prone because already patient has been induced. So just before making the patient prone, I would like to demonstrate some examination, why we are operating this child, so some of the,
So could you, sorry to interrupt, sir, could you just tell the diagnosis?
yeah, this is a spastic hemiplegic child where she had a equinus deformity, right? Right side there is equinus as well as mic dharta येईल का please? Mic dhara. So इथे दाखवता येईल. So she had a equinus, and you can see by Tardy scale the R1 is -30 and R2 is around -10. And I will just okay. So there is a fixed equinus contracture, and by silver skewer test, I will just reconfirm whether the main component is gastrocnemius or the soleus. So by flexing the knee, where we are realizing the origin of the gastrocnemius, we'll just again try to dorsiflex. Even it is not, it is in equinus only. So that means both the gastrocnemius and soleus component are involved. So she will require a TL ending. That is what we are planning. And then we can see the popliteal angle is around 55 to 60 degree, right? So the hamstrings are very tight, so they need to be also lengthened. So we are planning the hamstring and the TL ending in this child, right?
Okay.
That is there. Maybe by that time I will position the patient. You can ask some anesthetic input as well as you can show the gait also, gait of the child.
I think we'll show the gait video of the gait of the child, which we have recorded.
So we'll make the patient prone by that time. Yeah.
Okay.
Thank you.
Right. Yeah.
Hello. Sorry, in short, I would say this is just brief history. She's an 8-year-old female child, one of the twins, who came to us at this time when she was 8 years with the chief complaint of having equinus gait and poor balance and control. Now, if you see her gait, it's typically equinus, the compensatory, she has hyperextension at knee. She also has exaggerated lumbar lordosis, anterior pelvic tilt. This is the gait. She came with this chief complaint. The parents were concerned that, if she goes on, how she will be able to participate in her daily routine, like school, going to public places, and as she grows, even the cosmetic problems. Over to you, sir.
OT मध्ये connect कर. Hello. Dr. Deepali, can you hear me? Hello. Connect करा था. हा नको कळला नको. मागचे सगळे line. Hello.
Hello, am I audible?
Yes, now you're audible. Cameraman to focus on anesthetics, please. Yeah. Hello, madam. Good morning. Good morning, Dr. Deepali
morning,
and Dr.
good-
Manish.
Yeah, good morning, Rashmi. Good morning, everyone.
Yeah. By that time the draping and everything it gets ready, I would like to ask you a few questions about anesthesia.
Yeah, sure.
So all delegates here are all therapists and not much aware of what exactly is anesthesia and inside OT environment. So for a spastic child, like what kind of different approach you take for anesthetizing rather than the normal child, what you routinely do in pediatric cases?
Yeah. So actually, cerebral palsy child.
Please hold the mic close.
Okay. Can you hear me now?
Yeah, it's clear now.
Yeah. So in a spastic child, okay. These
So
are
what
the
kind of
very-
anesthesia you have given to this child
Okay,
particular?
so
I
now
mean,
we-
does she have a history of convulsions?
No, she does not have history of convulsions.
Okay,
Many of them may be nutritionally impaired also
right.
because of their their disease as such.
Mhm.
And in older children, we find that many of them are become obese because of lack of physical activity.
Right.
So actually, when older children come for surgery,
Mhm.
it's handling them can be difficult.
And in older child, you may get contractures also. So positioning would be
Yeah,
also
yeah.
difficult.
Exactly, yes.
Right.
Positioning is difficult. Many of these
Mhm.
surgeries are in prone position.
Okay.
So you have to keep a deeply sedated child in a prone position and monitor the child.
Okay. You please
So-
hold the mic close.
Okay.
Huh.
Okay. So monitoring a child or monitoring a patient in prone position.
Right.
So that is also a challenge for us.
Yeah.
Because
Mainly the airway.
Yeah. Because the airway is less accessible in prone position.
Mhm.
Yeah.
Okay. So what kind of anesthesia you have given to this particular child?
We have given epidural, combined spinal epidural.
Okay.
So actually what we did was when the child came inside,
Mhm.
we sedated the child. The first thing you do is actually sedate the child.
Right.
So once the child is under deep sedation, she's not
Mhm.
aware of the surroundings.
Right.
Then you turn her in a lateral position
Okay.
and give her a lumbar epidural.
Spinal epidural.
Yes.
Okay.
And make them supine, wait for some time for the drug to stabilize sort of.
Settle. Yeah.
And then make them prone or give them whatever position which is
Okay.
required for surgery. And you have to actually keep on continuously sedating the child. because
So
the moment
what drug
they
you
are
have
not
given
aware.
for sedation?
We gave a combination of pentazocine or sometimes fentanyl and midazolam
And midazolam.
And
Okay.
propofol.
Propofol
and
also.
ketamine is a little pro-convulsant.
So,
So
okay.
it may be depending on history of convulsions. So if there's no history of convulsions, here we have used a little small sedative dose of ketamine also.
Okay.
Yeah.
Right. And what drug you have used for spinal anesthesia?
Yeah. Those are mainly local anesthetics. So lignocaine with adrenaline and bupivacaine.
Do you use lignocaine? Now, I don't think, we are any longer using it for spinal.
Not for spinal.
Okay.
For epidural, we are using lignocaine as
Okay.
well as bupivacaine.
Right.
But for spinal, we are using bupivacaine heavy. Yeah.
Okay. And how long the effect would last of the spinal anesthesia?
Yeah. So now in adults, the action of bupivacaine, the spinal bupivacaine, may be for about 3 hours or
Right.
so.
Mhm.
But this in children,
Okay.
the dose required that is less. I mean, the dose you can give is less, and so the duration of action also
Is also
decreases.
less, right?
So now, normally in an adult, when you're using 3 or 4 ml of bupivacaine,
Mhm.
here she is a 15 kg child.
Okay,
So we have used only about 1.2 ml of bupivacaine,
okay,
which will I expect it to last for only an hour or so.
okay. So we'll
Okay.
we need to be in a hurry
yeah,
now.
So
Okay.
once, so after 1 hour, we will top it up with the epidural. dose.
Epidural.
Yeah.
Okay.
And the epidural catheter we will keep even later on.
Right, right.
Huh.
And sometimes if for some or the other reason, if the surgery prolongs, you can always prolong the anesthesia
Yes, we
with
can
epidural
always-
top-ups.
Yes, yes.
So it
we
is
can-
always better to be on a safer side by putting an
Yeah,
epidural.
yeah, definitely.
Okay. I think that's a very safer and the most safe option for pediatric population.
Yes.
Okay. I hope the penting and wrapping, is it done? Positioning, is it ready?
Usually we give epidural anesthesia.
Dr.
Hello?
Manish. Yes,
Yeah,
yes.
So that helps in early recovery as well as comfort of the patient. Post-operative, we can give low doses and analgesic doses of local anesthetic
Right,
in guarded manner, and
Mhm.
we can take care of the pain part. Plus,
right.
we usually give NSAIDs, diclofenac or paracetamol suppositories are
Mhm.
available.
Mhm.
So it's a multimodal analgesia,
Okay.
which usually helps in good recovery
Acha.
and early rehabilitation of the patients.
Right.
And
So
the
that would be
comfort of-
mainly,
yeah.
mainly important would be in the post-operative period,
Post-operative period,
immediate
yeah.
post-operative period.
Yes, yes, yes.
Okay.
Yeah.
And
we do monitor.
yeah, and Dr. Manish, do intraoperatively also, do you need any drugs to maintain intraop?
Intraoperative will give
Do you
the-
need any drugs for sedation or if the child wakes up or, just
we
files?
usually provide him a propofol and make him
Sleep
with
for
deep
some time, right?
sleep for
Right.
some time.
In a diluted
Midazolam and
doses.
Propofol is the better agency.
Okay,
And
okay.
it helps in early recovery also.
Okay, okay.
So,
Thank you so much,
yes,
Dr. Dipali and Dr. Manish.
thank you.
What exactly we are, I think we are doing the exsanguination. I think tourniquet part also can be explained by the anesthetist if the surgeon is busy with that.
Yeah,
So are we doing it under tourniquet?
Yes, yes, we are giving the tourniquet. Usually the pressure what we keep is 2 times the systolic pressure. Usually now
This
it's,
is exactly, I
80
think
to
the
90
surgeon
pressure.
is doing the exsanguination of the limb.
Yeah.
So that's the whole blood in the limb we are putting back into the body, and then we'll be raising the tourniquet
Tourniquet.
pressure so that we
Pressure.
get the bloodless surgical field. Okay. So how much is the pressure?
One.
Mic hai?
Usually it is double the systolic pressure. So it's
Okay.
around 90. So we keep around 180
Hello.
pressure.
Okay.
Yeah,
Right,
yeah.
right. Okay.
Hello.
And
Meenakshi
it's for
madam,
some
can you-
time, up to 1 hour you can keep one to
You
one
can
and a half
keep that
hours.
tourniquet.
Yeah, 1 to
Okay.
1.5 hours. Okay. Yes.
Hello. Question to anesthetist.
Yes.
This girl is 8-year-old.
Right.
If how about the doses of anesthesia?
Mhm.
If the patient age is more like we are some adults. and
Anesthetic doses are always per weight by per
weight,
kg.
Yes, yes.
Yeah,
Right.
yeah.
Like she's
And the
15
type of
kilos.
surgery we are performing.
Yeah. Orthopedic surgeries is what I've told, they are all 6 types, and mostly they are limb surgeries, right? Either upper limb or lower limb. So we most of the time we don't need general anesthesia. The only indication for general anesthesia in orthopedics is torticollis. Otherwise, we do it in peripheral blocks. This is spinal is central neuraxial, and other for upper limbs it is brachial plexus, that is peripheral blocks. And doses are always according to the body weight. एक minute. Ketamine only sedative doses. Not, we are preferably using propofol and benzodiazepines, that is midazolam, because most of these patients are, most of them have history of convulsions, and propofol and midazolam, they are, they help you in that way. Ketamine in very low doses. Yeah, diazepam nowadays we are not using because it's long acting. Yeah. So.
माझा आवाज येतोय का?
हो.
Okay, right.
Respiratory depression also, and midazolam is very safe. You can go in higher doses also, till 5 milligrams you can give. In dilution and slowly we give in high doses also. The midazolam is very safe.
Midazolam is also now the drug of choice for a seizure disorder, for in case of convulsions. So, because it is rapid acting also. ऐकू येतंय का?
हो, आवाज
आवाज
येतोय?
येतोय का?
You heard what I said?
Yes, yes.
So first I'm going to
As
do
a
the
surgeon, acha, we are starting
hamstring-
with this. So
hamstring
it's over.
lengthening.
Okay.
So indication, as you have already demonstrated, we do the lengthening of the hamstring and then lengthening of the tendo achilis, so that we are correcting the deformity and then we are easing out the function for the child, so that the child can have better gait, better function. And very rarely when the severe contractures are there, if that is causing the pain, then that pain should also be relieved with the surgery. So I'm going to take the incision. Now, can you see? दिसतंय का? Right? थोडं तुम्हाला वरून घ्यावं लागेल
No,
camera.
it's very clear and absolutely nicely focused. Please go on.
Okay. So this is basically the hamstring lengthening. So this is inside the skin and then fascia. The first superficial muscle which is there.
Cameraman, to please focus on the incision
इथे
side.
तुम्हाला focus
Yes,
करावं
yes.
लागेल.
Yeah. Keep it steady.
आणि थोडं तुला असं व्हायला वेळ त्याला कॅमेरा त्यांना थोडं हे करायला थोडंसं. दमी.
But yeah, zoom out little bit, zoom out little bit. Yeah, that's fine.
So the first muscle or the tendon which we encounter is basically the semitendinosus, right?
This is absolutely bloodless field. You can see this is because of the tunicate.
So semitendinosus is the first muscle which we visualize in the surgical field, right? So this is semitendinosus. Are the delegates appreciate this?
Yes,
Are you
yes,
able to
we can.
appreciate?
We
Yeah.
can. Yes.
Then the second muscle which we are identifying here, we could see is a semimembranosus. Okay, it is
Okay.
little medial and it is little behind the semitendinosus. Again, it is very simple to identify. Semitendinosus is named because it is more of a tendinous,
Okay.
tendinous part, and this semimembranosus is more like a membrane, like a
Mhm.
spread out, and that is why it is a. Now these are the two very powerful knee flexors, and they causes the flexion deformity, and most of the time these are the two muscles which are the main culprit giving rise to contractures and deformity in the cerebral palsy. Okay.
Okay.
In addition to that, there is a gracilis which one can see here. I don't know. दाखवता येईल का? ह्या मसलला तिथे दाखवता येईल? दिसतंय का? नाही, थोडं वरून तुम्हाला घ्यावं लागेल कॅमेरा. थोडं जवळ घ्यावं लागेल, थोडंसं हलकसं. हां, सांभाळून. आणि इथे. So this is a gracilis actually. It is a muscle of the mainly medial compartment, but it is attached over here on the tibia, more on the posterior. So it is another, most of the
Yes,
time.
yes, we can appreciate this. Yeah.
So this is a gracilis. Okay.
Huh.
So gracilis, this is semimembranosus. This is semimembranosus.
Yes.
वरून focus करा.
Yes, yes, we can see it
आणि
nicely.
and this is semitendinosus.
Tendinosus.
So semitendinosus, membranosus, and gracilis. These are the important muscles which are going to tackle. Here is the biceps femoris. On the medial side, there will be, on this aspect, there will be biceps femoris. Now, in this case, it is not really contracted, and most of the times we don't touch it because by cutting it, again, there are chances that we may land up with the hyperextension at the knee joint. So unless until there are very severe contracture.
I mean, there's very severe form of spasticity
Yes,
only.
yes,
We
yes,
go
yes.
for femoral biceps.
Yeah, biceps
Okay.
femoris. So I am going to do the now Z lengthening for this semitendinous. इथे retractor लावा, इथे लावा बेटा. छोटा knife द्या. हां. त्या knife ला तिकडे ठेवून दे. या साईडला retractor द्या मला आता. So now, if you are able to appreciate, we are going to do the Z lengthening for the semitendinosus.
Okay,
So
it's
I am
very
going to
clear
take-
view.
yeah.
Very clear.
So
We
I am
can
going to
appreciate.
take a vertical cut like this. Okay.
Yeah.
I'm just demonstrating, and then one cut like this and one cut like this. So it is more of a Z. Are you
Okay.
getting?
Yes.
And then the muscle, I will slide the muscle so that. Okay. So this is a vertical cut I have taken. Okay.
Okay.
And then this is a. Now see, look at my knife. Yeah.
Mm-hmm.
So this is a horizontal cut. So vertical, then one horizontal, and here They'll be again
Going upwards.
upwards and then taking the
But
horizontal
lateral.
cut.
Okay.
Okay, so flex kara Neela flex kara. So one can see here. I'll be cutting it more again. Right?
Right.
So now the tendon has been cut, and you
Mhm.
can see this is a horizontal limb, and see
This is the vertical
it
one.
is lengthened now.
Right.
So the cut, which was, see, I have cut the tendon from here.
Mhm.
So because of the tension in the system, now it has directly come over here. So it is a, and this has slided like this. So I will switch it over here after
Okay,
once I
so almost
finish with
that
the-
much of part is lengthened now
Yeah,
with an
yeah,
extra
yeah,
length
yeah.
of
So-
that tendon.
Absolutely. So this is called as Z lengthening of the tendon. Okay.
Okay.
So
Okay.
like a Z.
Mhm.
इथे दिसतंय का थोडं तुला जागा द्यावं लागेल त्यांना कॅमेऱ्याला
No, no, it's absolutely clear. It's
one
absolutely clear.
horizontal, vertical, and again horizontal. Okay.
Yes.
So this
yes.
is a Z lengthening,
Okay.
and then I will go to the semimembranosus. Here we do the fractional lengthening of the muscle.
Okay.
Right. So fractional lengthening, or what we call as a aponeurotic release. So
Mhm.
where we are going to make the V like this. Okay.
Right.
You can see as soon as I complete the incision, because of the tension in the system,
Mhm.
this part is already slided. Right.
Right. Right.
So it is, the muscle is lengthened. So we are keeping the power of the muscle intact.
Hmm.
And keeping the power intact, I am lengthening the muscle. So now I have completed the aponeurosis on both the sides. I will take another V over here. So okay,
Yeah. Again, it is released. Yes.
and then I will complete the V like this. Okay.
Yeah.
So you can see it automatically slides because it is in contract. It is into contracture,
Okay.
and because once you release it immediately, you can see the lengthening of the
Yeah, it relaxes. the
Yeah.
muscle.
So I have demonstrated Z lengthening of the semitendinosus,
Yeah.
then the fractional lengthening of the or the aponeurotic release of the semimembranosus,
Semimembranosus.
and just I will demonstrate here tenotomy, what is called as tenotomy for the gracilis.
Okay.
Now gracilis, although it is a medial compartment muscle, but its insertion is on the posterior aspect.
Mhm.
So most of the times, it is one of the another important cause for the flexion deformity.
Okay.
So I will just do the tenotomy. So just इथे दिसतंय का? नाही दिसत आहे. थोडं आणखी इकडनं असं दाखवता येईल. थोडं लिंबला असं टर्न करा. हा. Now are able.
Yes, yes, we can see now.
Yeah. दिसतंय?
Yes.
नाही रिट्रॅक्टर मध्ये दिसत नाहीये थोडंसं. आता दिसतंय?
Oh, हो दिसतंय दिसतंय.
So right. So I'm just cutting this tendon. So like this.
Mhm.
And you can see immediately after cutting, see how it goes inside, So it has slided to a great extent. It has slided further, right?
Okay.
So this is called as a tenotomy.
Right.
Okay.
Hmm.
So I have kept the muscle intact, you can see,
Yes.
and I have released the tendon.
Tendon.
So this is called as tenotomy. So maybe
Okay.
it is beneficial for the audience. What is meant by the tenotomy? What is meant by the fractional lengthening,
and
or the muscle sliding?
Z-plasty.
And
the
then what is
Z-plasty.
Z-plasty? Okay.
Okay.
So I have done with the hamstring part. I will suture the semitendinosus now. There, ithilon there.
Okay. So the surgical part is done. Now you will be suturing this in the
Yes, yes.
elongated positions.
Yeah, yeah.
Okay. So we have done lengthening as well as tenotomy also. You have cut that and fractional lengthening.
Yeah, yeah.
Okay.
And now I am going to suture the.
Yeah, I mean,
Hmm.
is delegates, do you have any questions till now, whatever has been done, and you want to ask anything? You can ask now, because suturing will take, and suturing is also an art.
No, no, no.
So we have
Suturing will take around 15 to 20 minutes, and
Yeah.
then we'll move it for the tendo-achilles. Then we'll
Right,
move to the
right,
lower
right.
part. Dhara,
Okay. So what kind of suture material you are using for this?
It is a ethylon, 30 ethylon.
Right.
So it is a non-reactive type of material.
Okay.
It's a kind of a polyester material,
Okay.
which is supposed to be more of a inert, and then it doesn't causes much tissue reaction,
Right.
and then it's याला इथे hold करा. Hold करून ठेवा बेटा. And then it remains inside. It doesn't get dissolved, but it keeps the tendon into position so that the tendons are completely healed till the time they are held up. So
Yeah.
now you
So
can
how much
see
time it will maybe around 6 weeks?
around
this?
3 weeks is the adequate time. 3 weeks is adequate time where the
Okay.
tendons get healed.
Right.
धरून ठेव तिकडचं. End धरून ठेव बेटा.
So how much of extra length you got in this particular patient?
Maybe you can see around 3 centimeters, around 3 to 4 centimeter.
Okay. Okay.
Yeah.
That's a good
Okay.
length. 4
Yeah, yeah.
centimeter will make a
See,
big
I have cut the
difference.
tendon from here.
Mhm.
If you are able to appreciate, इथे focus करता येईल का?
Yeah,
See,
yeah, we
when
can
I-
see that.
Yeah. So I have cut the
Thinned
tendon.
out part we can see. Yes.
Yeah, and actually up to here. See, it was
Yes.
here. So
Okay.
this much amount of the length is almost around 4 to 5 centimeter.
Right.
I could
Right.
achieve, right? So
It's
it
a
will not-
good length, and then it
Yeah.
will, yeah.
Any questions by the time I'm suturing?
Right now, I mean, no questions right now.
Okay.
Mhm.
Now this is around, I think the age of the girl is, this girl is around 8.5, if I'm not wrong.
Yeah,
Alpana?
yeah.
So usually we don't jump for the surgical intervention. So this part is done now. I'm not going to suture this, the semi-membranosus or the gracilis.
Okay, that was just a release.
Yeah. So
Okay.
Vital there.
So this was ethylon, and now you'll be suturing with Vicryl.
This is a vicryl.
Okay.
This material is a vicryl.
Mhm.
It is absorbable. It
Right.
gets absorbed over a period of time.
Mhm.
Support करा थोडंसं.
Umanjali madam has to ask something.
Yeah, please. मला आवाज येत नाहीये ऍक्च्युली.
हॅलो.
या मॅडम.
सर आपण टोर्निकेट लावला आहे तर ब्लडलेस सर्जरी आहे. सो
हो.
आर देर एनी टिश्यू डॅमेजेस? आय मीन किती वेळपर्यंत आपण ते म्हणजे हाऊ मच टाइम
Time ना?
वी कॅन टेक आणि
On an average, around 2 hours we can keep safely for the lower limbs.
ओके.
Around 2 hours. And
90 minutes to 120 minutes is the ideal time for
Ideal.
lower limbs.
yeah. And for the upper limb, we usually keep for around 1 to 1.5 hour, not more than that, because that is a safe time where all the tissues like muscles and all the tissues, they can tolerate the ischemia. So we usually release the tourniquet in upper limbs, say around after 1 or 1.5 hours.
Okay. Only in patients of like sickle cell disease and all, we have to take extra care.
Yes.
For tourniquet. And otherwise, for all other patients, it's no
Cut करें ना?
problem. And
Any-
if the
any-
surgery,
any patients with any this arterial diseases, then are
Yeah.
there any proper precautions or
Uh,
contraindications?
We don't use if there are like hemolytic disorders or there are arterial disorder, or suppose we are contemplating any neurovascular injury or like something, or say nerve is
damage
injured.
and
In those cases we don't use tourniquet, because we don't
Okay,
bother
yeah,
for the blood loss then.
Yeah,
see,
yeah.
surgery can be done without tourniquet also.
Yeah.
Yes,
But
that's
then
why,
only it will be a
because-
bloody field,
Yeah.
and then you have to take, it will take time. There will be a lot of blood loss. But you can
Yes.
get it without tourniquet also.
Yeah.
But then
No,
this is the
because
safest thing.
I'm seeing it for the first time. So this
Right.
was the query, and especially with arterial diseases.
Ah,
Yes. You are absolutely right, madam. You are
Yeah.
absolutely right. Yeah.
And
Thank you,
if
sir.
the patient is for, sometimes if it's for bilateral surgery, so it is advisable to raise the tourniquet one at a time,
Okay.
not in the both the limbs, in one limb and then other limb. And then even the anesthetist has to look after the fluid things also very well.
So
Because
any
like-
Doppler or this also any time is needed, like?
No,
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 no.
but then for the fluid management, you have to see, like in pediatric patient, it won't be much a problem, but then in adult patients, the blood volume in one limb. So if
Yeah.
when we release it, So
Huh.
patient may go in sudden hypotension when we release, because
That's
that
what.
much of blood volume goes to the
Yeah,
limb.
yeah.
But pediatric population,
No
we don't
issues.
get that much of
And
problem.
any, if for an adult population, any considerations of any atherosclerosis also?
We have to see that. We have to
है ना?
take
हाँ.
care of all those things, because there are also, like in tunic, if it is more than 2 hours and all, we get even pressure sores and all. Other problems are also there. We have to take care of
Camera
it.
लो ना, मला
So
वाटतं
that's
थोडं
why there is
Precautions
a
like
precaution we
take
have
care
to
of the
ठेवावं लागेल.
precautions.
have
थोडं
to
oblique
be-
आहे camera.
Yeah.
असं
Thank
मला
you.
वाटतं थोडं.
Also.
We usually try to defer the surgery as far as maximum as possible in
Right,
cerebral
right.
palsy.
Yeah, that I had. I was coming to that point only. What is the ideal age to go for surgical correction in spastic kids?
See, I mean, there is no law that okay, you operate at this age, but it is usually said that you operate at such age that further subsequent surgeries are not required. So we
Okay.
try to delay the surgery for as maximum as possible.
Okay.
But we sometimes, if you are, I mean, contemplating a hip dislocation and all,
And
so
very severe cases of
yes, yes.
spasticity.
Yeah,
right?
so there you are, even we have to operate maybe at 3 or 4 years of age also. But preferably we use up to 4 or 5 years we don't operate. We try
Okay.
to use other modalities like intense therapy, then splintage, maybe plastering or Botox,
Acha, acha.
all these things we try.
Do we recommend Botox in spastic kids before surgery?
Not like that. If the spasticity is dynamic, then definitely the Botox is indicated.
Okay.
So the indication for the Botox are basically the dynamic spasticity and not fixed contractures. And
Okay.
secondly, I mean, if you are really thinking that the spasticity is coming in between for the function,
Right.
it will on there.
Prajakta madam has to ask something.
Yeah, yeah.
Ye-
Yeah, madam.
Yes, sir. Very nice and very active thing I'm feeling when I'm seeing it live. This is for the third time I'm seeing your surgery live.
Thank you, madam. Maybe next time we can involve you. For the
No,
surgery.
sorry. No, I
No,
would
no, I'm
just
just
like
kidding.
to refer my patients to you for this. That's all.
So nice of you. It will on there.
And one thing I just wanted, this is absolutely nice technique, applying tourniquet and getting bloodless filled. But
Yeah,
are
yeah.
there any complications you faced post-operative in such cases, irrespective of all the precautions you had taken?
Not usually because of tourniquet as such,
Yeah.
but in a spastic child, we have to be very careful for the pain and all, I mean,
Yes.
for the neurological, then
yes.
if the deformity is very severe, we don't try to correct at just by doing the soft tissue releases, because there can be neurovascular stretching, and
Yes.
that can cause so we are little spectacle and we are careful on that aspect. In those cases where there are very severe deformities, we may try to go ahead directly with the osteotomies. We try to correct the lever arm by doing the correction at the bone itself,
Okay.
so that we are not stretching out too much the neurovascular bundle. It is
Okay.
like that. And for the particularly for the, I mean, like adults or like adolescent age group, like 13, 14 years of the age group, if the deformities are very severe, or even for the children who are like hefty, we usually recommend to, I mean, but preferably to go ahead for the one limb at one time. Although there is a
Yes, that already you have mentioned.
quite popular like multi-level, you have to do at the same stage, and lot of,
There
because
is now a lot of fad about like doing bilateral TKRs in one sitting. But
See-
actually, it is not recommended because it's a lot of tissue damage. Really, like it's patients is one of the gimmicks of marketing nowadays. Get it done bilateral, go next day, go home and all. See, we have to respect the tissues. Okay, so it's, if there is an extensive thing, maybe patient will come for another limb some another time. Once let her recover from this. So because otherwise, if you do it bilateral, because nowadays even parents also pressurize. आम्हाला एकदाच ते एका ह्याच्यातच करून टाका, एकाच खर्चात होऊन जाईल वगैरे असं सगळं हे. Yeah. We don't go for this. We don't agree for this. It is one at a time. And once the patient recovers properly, maybe after 3-4 months, and she is completely recovered from the first trauma, then we won't go for the second limb. So that is the tissue respect is a must for a surgeon. Surgeon should respect the tissues, and it has to be. I mean, we do it always. So these are the cuticular stitches. So so these are not normally stitches, but so that kid won't get a scar for this. Okay, one more question coming. Wait.
Good morning, sir.
Good morning, madam.
Hemiplegics do have weakness in hamstring. So do you suggest pre-rehab before your surgery? Because
Yes, yes,
lengthening
yes.
process again will give that range where the patient needs to work on a larger range now.
Absolutely, absolutely. In fact, I would say any surgeon who is working in the field of cerebral palsy, he has to work as a team and not like an independent surgeon, like what most of the people do. We always work as a team. You know, for every patient, what we are operating programs, you know, and before jumping for the surgery, we always see to it that the other modalities has been already used. They have been already exhausted, you know.
Yes. So what should be the expected grade of muscle strength before you start? Before
at least grade 2++ or 3.
Okay.
Yeah, but many times what happens, suppose like if you are expecting the impending hip dislocation, you know,
Yes.
so I mean there is no choice, you know, because many times these are the spastic quadriplegics, say GMFCS 5 patients.
Yes.
So maybe in the session 2, we will be learning about what are the different scales. Maybe Meenakshi madam and Umanjali madam and Sophia madam can demonstrate you what are the different scales and how we are going to use them, how we are using them. So those 5 or 4 patients, GMFCS 5 or 4 patients, they are actually otherwise also bedridden or the wheelchair bound, you know.
Yes.
So they are the patients actually in whom rehabilitation part is very important. So we are not bothered about the independent ambulation, but we are bothered about the rehabilitation. So in those cases, even though the power is less, still we go ahead for the release of the contractures for the correction of the deformity. I think I am clear about your answer.
Yes, sir. Yes.
Yeah. Second point I would like to add for the bilateral, you know, there is we have to always remember that in Western countries, there are issues related with the insurance, you know. So insurance companies, they want to, you know, pay less, you know, so they want to finish up all the surgical interventions with the minimum expenses. So that is another part where for anyone the expenses, but then if you ask me, the rehabilitation part of one limb and then operating other limb at second stage is very easy for the parents to carry the child, you know. So this part is over. Hamstring part, it is like that. आता इथे फोकस करा, थोड़ा असं फोकस करा, म्हणजे obliquely करण्यापेक्षा.
So this was the first part of the surgery where the hamstrings were lengthened.
Absolutely.
Right.
Yeah.
The second part is TA.
Yeah.
Right. TA lengthening we are
इथे
doing.
focus करा. Now TA, now there could be different surgical techniques, you know. While showing the examination, I was showing that if in silver skewer test where you are relieving the tightness in the origin of the gastrocnemius, and if you are getting the dorsiflexion, then we may just release by taking the incision over here, we just aponeurotic release of the gastrocnemius part only. That is called as a gastrocnemius recession, and that is called as a Vulpius or the Strauss procedure. Now here in this case, since the soleus also is deeply involved, even anesthesia, you can see when I showed you, it was in anesthesia. Now also, see the severe contraction is there.
Yes,
So it is not moving at all. So these are the cases where you have to actually lengthen the tendo-Achilles. Okay,
Right,
so both the component we have to tackle. So I'll be demonstrating the Z lengthening for the tendo-Achilles.
For all the delegates who have come late, I would like to inform that the patient is in prone position, right?
Yeah.
He is anesthetized in a lateral position, then made
Tikadun
supine,
दाखवते?
and then for surgical intervention, the patient is in prone position right
जवळ
now.
घ्या ना तुमचा कॅमेरा जवळ घ्या. दिसतंय का?
नाही, एक मिनिट.
लाईट थोडं ऍडजस्ट करता येईल. लाईटला ऍडजस्ट करा थोडंसं. लाईटला ऍडजस्ट करा. लाईटला इकडनं घेता येईल ना.
Yeah, keep the surgical field in the center of the screen. Yes,
camera
yes,
इकडनं
yes.
घ्यायचा का?
That's
तुमचा
perfect.
screen?
That's
ठीक आहे.
perfect. We can see.
दिसतंय? Okay.
काय?
So-
Clinically, कल्पना मॅडम पुढे गेल्या. हा, मीनाक्षी मॅडम. एक मिनिट इकडे काही डेलिगेट्सला दे वॉन्ट सम क्लिनिकल आय मीन प्री ऑप इनपुट्स. तो मीनाक्षी मॅडम इज एक्सप्लेनिंग दॅट.
Okay.
Yeah, actually, she's 8-year-old. She's a right hemiplegic child with GMFCS 1. So she's able to walk independently. So she can move in and about society, indoor, outdoor work. So walking is not a concern for her. She can climb up stairs also. But cosmetic appearance that she is walking on her right toes, almost she was walking on, we have seen her gait. So she was with almost equinus gait, and on particular evaluation of that equinus, that was almost a contracture at the tendoachelis, and because of that, the hamstrings were getting shortened. So the intervention we needed for that, so hamstring as well as tendoachelis, looking at her deformity. Plus, because she was walking and why sir opted for surgery, the parents' concern was cosmetic. The therapist concern was she was disturbing most of her postural alignment because of the deformity. She was almost inclined with hip knee flexion with the lateral flexion. So her alignment was getting compromised, though she was walking independently. So in due course of time, with growth, puberty, growth spurts and all, she would be more deviated and her alignment would be a concern. So from therapist perspective, her alignment was concerned. From surgeon's perspective, her contracture was a concern. Over to sir, please.
Yeah.
Thank you.
And if you see the gait carefully, when she was trying to do the hyperextension in order to, so hyperextension can be because of two things. One is to compensate at the ankle, So if there is a severe equinus at the ankle, the patient will try to touch the heel to the ground by doing the hyperextension at the knee joint. Okay, agree? Do you agree? That is point number one. Secondly, she was tilting the pelvis anteriorly. If you see, while trying to compensate again for the equinus as well as the knee flexion deformity, in order to make the knee straight, she was tilting actually the pelvis anteriorly.
Achha, exactly what are you doing right now? This is the
So,
tendon you have exposed.
Yeah, this
the
is
tendon.
a tendoachelis. So
Okay.
one can see this is a tendoachelis.
Right.
Yeah, so it is attached to the calcaneum over here, right? So tendoachelis is formed by the two muscles, gastrocnemius as well as the soleus. हाथ काट एक मिनट करता. So gastrocnemius comes from the it originates from the lower end of the femur. Okay,
Yeah.
from here.
Okay.
It comes like that, and then it is joined again by the soleus, which is coming from the posterior part of the tibia, right?
Right.
And then it forms a tendon, and it is attached to the calcaneum.
Calcaneum.
Okay. So now it is one of the most powerful plantar flexor of the body. Rather, it is called as a peripheral pump or a body because it pumps most of the blood
Peripheral
to the
blood.
peripheral
Yeah.
blood. Okay. Now I am going to do the Z lengthening again.
Okay.
So you can see my knife is in mid between. So I am going to take the vertical cut like this.
Right.
And then one limb horizontal like this and one limb horizontal like this.
Okay.
So again, like a Z. Okay. And that is why it is called as
Z plastic.
Z length, Z plastic. Okay.
Yes.
So this is a vertical incision I am taking. Right.
Right.
And then this is a horizontal limb. Right.
Right.
And then the other horizontal part will be where, yeah. So we have to take quite a good amount of length because once the deformity is corrected, tendon is going to slide. So we should have some length for the overlapping and when we are going to suture it, right?
Right.
So this is another.
Yeah, we can see it clearly.
Can you see?
Yes. Yes.
Yeah. So now this is the horizontal part I am cutting.
Okay.
Right.
Right.
And one can see the sliding of the muscle also, right?
Yeah.
Okay.
Yeah.
So this muscle, which
That was a very clear demonstration. We
yeah.
could appreciate.
Yeah.
Yes.
So you can see it was like this.
Yes.
Yeah.
Yeah.
And from here it has now come like this.
Yeah.
Okay.
Yes.
Just like that. So I'm going to now suture this part, which is over there.
That will
And-
be side to side suturing, right?
Yeah, side to side suturing.
Okay.
Okay.
Yeah.
I'm just confirming the mobility at the
Ankle.
now.
Mhm.
So you can see now I have got a good amount of dorsiflexion.
Yes.
While
Yes.
suturing also, we see to it that we suture it around 10 to 15 degree of dorsiflexion and not beyond that, because
Right,
we
right.
don't want to suture it in the
Overcorrection.
overcorrection, which will
Yes.
again cause the crouch gait. You know, if there is overlending of the tendo Achilles, that will.
So all the dynamics you have to take into consideration, right?
Yes,
While
yes,
suturing
yes.
also. It's not just not like cutting and then suturing. It's it has to be dynamically thought of also.
Yeah, and that is why it is a reason that we don't usually advise the tenotomies for the tendo Achilles in cerebral palsy particularly,
Mhm.
because cerebral palsy is totally different, you know, for many of the orthopedic regular other.
Yeah, many the old school of thoughts, like they confuse it with polio corrections and all, and they just do
Yeah.
it tenotomies and just leave it. But
Yeah.
then you see the anatomical correction, but then the functional thing is compromised.
Yeah, it is in
Maybe a little bit of anatomical correction, I mean, under correction can be accepted,
yeah,
but
yes,
then the
yes.
function is more important, the power and the function.
Yes, it is very important, because people just do the CAM surgeries and they just cut the tendons and they just in hurry they do the surgeries, so that they are more bothered about doing the number of cases in that.
Number of cases in CAMs and all.
You
Yeah,
know,
yeah,
so and even it is not like that we don't conduct camps. We also do conduct a lot of camps.
Okay.
But we conduct camps with all our experts. You know, all the pediatric anesthesiologists are with us. The whole team is there, and we do operate them like just like operating any private case. You know, we're
Yes,
taking
yes.
all the precautions.
Yeah.
Then rehabilitation, post-surgery rehabilitation, follow-up, splintage, and everything.
Yes.
It is not like that. Just operate and forget about it. It is not like that.
Yes.
So that is
yes.
a basic difference, because they are also human being. You know, we have
Yeah,
to.
yeah.
Even if you are considering any camp and poor patient, but they are human being first, so you have to respect them, and we should do at least best for them,
Yes.
and not do the harm, right? Do no harm, that is do no harm.
Yeah,
that is what we-
Hippocrates oath we all take during our convocations.
Yeah,
So the first thing is do no harm.
yeah,
And
that is so
yes. This is side to side suturing what you are doing. Okay.
yes.
So this is again which suture it is? Ethylon it is?
Yeah, it is 30 ethylon.
Right.
I'm using. I have to keep this patient also immobilized for a certain period of time. Usually 3 to 4 weeks we keep them immobilized in a plaster cast also after suturing.
Right. Okay.
So that the tendon is healed, and then only we allow the ambulation, right, till the time. And then
till that time the passive physiotherapy do you?
yes, yes.
Okay.
Physiotherapy is very, very important.
Then you start at which day? Post-operative day?
Immediately second day we start.
But
once the
that will
pain
be
is-
painful, right? I mean,
Yeah, so second, third day when the pain is reduced, just
Okay.
gentle exercises.
okay.
So simply maybe toe movements, then quadriceps strengthening and all, you know, so
Mhm.
that the patient has they do not have the stiffness. They also have the power, you know, so they maintain the power, because in plaster there is some loosening of the power.
Deepak has one question.
Yeah, Deepak, good morning, welcome.
Good morning, sir.
After a long time,
Yes.
we miss you and we
Yeah.
remember you.
Yeah.
We are
Sir,
there for the Orange City workshop, you remember?
Yeah, sir.
Meenakshi madam, do you remember? 2006,
I
Alpana.
presented case also there.
Yeah. So,
Sir, I want to ask, is there any significance, importance in side-to-side suturing?
actually, it is giving you the additional benefit of the maximum length where the healing of the tendon will appear. You know, so that
Just
maintains
for
the
healing
strength.
of tendon,
Yes,
you are
yes,
going
yes.
for that.
Yeah, so as maximum as possible, but many times if the deformity is very, very severe, particularly hamstring,
Yeah.
they are under so much tension that once you release, immediately the tendon can just go in, you know, they can
Yeah.
just slide inside.
Yeah,
So we have to hold the tendon with the help of the LS forceps, and we have to protect it so that at least some length should be there. Because once
Yeah.
the child start moving and start using the muscle, you know, there
Yes,
can be
yes.
rupture of that whatever you have sutured.
So I think with side to side suturing, you
Yeah.
can adjust the length, actually,
Yes,
what
yes.
amount of correction you want.
Absolutely right.
So till and the correction and that corrected position you can suture.
Yes.
So I think that's the most important point in this.
Yeah. And
That-
you can see here the assistant is holding into that position.
Yeah,
no?
in that correct, that
In-
much
in
of
the
correction you
18-15.
need, and
Yeah,
she's
yeah.
maintaining that position, and that
Position.
position you are suturing it.
Yes, yes.
So this is possible in the side to side suturing, I think.
Yes, yes, yes.
Yeah, and very severe cases, as sir has told Deepak,
Yeah.
then that the upper part of the tendon, it just goes in. You have to search it sometimes, because if it's a very severe contracture,
Yeah.
the upper part,
Right,
once we
right.
release it, just go inside. Yeah.
Yeah.
So in that case, yeah. So in that case, you can do an end-to-end suturing also.
Yes, yes.
Yes, yes. And end-to-end suturing is also good. I mean, it's not that it won't heal or what, but then this is better. Okay.
So I've already sutured the tendons. So I will now suture the peritenon. There is something called as peritenon, you know?
Right.
Yeah, this is a peritenon. I'm suturing. Are you able to appreciate?
Yes, yes,
This
yes. We
is-
can. The
Yeah.
surgical field is absolutely clear, and I must appreciate the surgeon's hand is really gentle and clear. And
no,
yeah,
no.
yeah, we can appreciate
fine.
everything. Yes, yes.
So this is
The
key.
tendon, the muscles, and everything. Yes.
So this is skin, this is fascia, this is deep fascia, and then this is a peritenon. I'm going to suture it. Now the principle in tenotomy is also very clubfoot. We do a lot of clubfoot cases.
Yes.
So in those cases, we keep this peritenon intact, and then we do the tenotomy.
Yeah.
So that with this intact peritenon, the tendon actually regenerates inside.
Okay.
Yeah. So and it regenerates very nicely.
Okay.
But that is totally a different. I mean, ball game.
Different indication.
Yeah,
I
yeah,
mean,
yeah,
that's a
yeah. This
different
is
procedure.
Yeah, this in CP, you
Yes.
should try to keep the power of the muscle as far as possible intact.
Yes, yes.
You should not over lengthen the tissues.
Yes.
You should do the dissection very clean so that we are not causing much of the scarring.
I think in this surgical, I mean, in CP, what not to do is more important.
Yeah.
Yeah. What is like the patient is already in the problem,
Yeah,
and
yeah,
right, like to correct it anatomically and look it good cosmetically, we should not overcorrect and not do things which are not supposed to be done.
yeah.
So the power and the function is the foremost concern, I think.
Yeah. Like
Okay.
that. So after suturing this, I'm going to take the subcuticular sutures,
Right.
and then I will take the skin. Any questions by that time?
Yeah,
Or
then
maybe-
we can shift to the post-operative pain management, and then we can start with other. Achha, one more question is coming. Wait.
Yeah. इथे- इथे थोडंसं. बरोबर. ओढू नको जास्त. हा.
Hello,
Yes, madam. Good morning.
good morning, sir. I'm Prerna.
Yeah, Prerna madam. बोलिए, please बोलिए.
Sir, actually, this is she is 8-year-old girl, no,
Yeah.
and you are doing Z-plasty in this case.
Yes.
So, if the contractures, if we see in early ages,
Yeah.
so you are doing in that cases also the Z-plasty, or
No.
you will go for a Botox first.
Yeah. So actually, Prerna, actually we had discussed this when at beginning of the workshop, that we directly don't jump for the surgery. We usually first try the intense therapy programs, then Botox, then splintage, and if the child is not responding to all this treatment, then we usually go for the surgery.
But
Again-
sir, if the contracture is severe, then
If the contracture is severe, then there is no question of Botox. There is no, I mean, if the patient is not responding to therapy and the contractures are very severe, naturally there is indication, whatever is the age of the child, irrespective of the age, you have to go ahead for the surgical correction. It is like that.
okay.
And even for the younger population, if many times, or even for the elder, we try to do the gastrocnemius recession surgery, that is the vulpus or the striatus, so that in future, if it is required, we can always go ahead and do the tendon lengthening. So this area we usually keep the virgin, this area where I'm operating now, we usually go upstairs over here
Okay.
and we do the aponeurotic release. But in this particular case, the indication was very clear because there was a contracture in the gastrocnemius as well as the soleus. Okay. So silver skewer test, which I had demonstrated before surgery, is very important. I think that is a test which every therapist must know, that whether the culprit is gastrocnemius or the soleus or the purely gastrocnemius. And secondly, the tardive scale, which maybe Meenakshi madam and Umanjali madam and Sophia madam will be demonstrating to the delegates, I think is one of the very important scale where we actually look for the contracture where they are because if R1 and R2 are the same, that means the contractures are really very severe. If R1 and R2 are different, if there is a wide range, so then that indicates that there is still a more of a dynamic component and less contracture. So in this case, the R1 was -30 and R2 was -15 to -10 So there was not much range. Even the foot was not coming into neutral. So that is a clear-cut indication where we have to go ahead for the surgical correction.
Okay.
So I'm just now doing the subcuticular closure.
So that's the second stage which is completed. That is TA lengthening. Any questions still now here to any delegates? Is there any facility for the virtual delegates to ask any questions? Because
I
this
think
is,
there may be.
Do we have any messages in the box from the delegates? Any queries regarding surgical? Krati, please check. Krati, you can just put a message in the box for the virtual delegates if they have any queries regarding surgical part.
So post-operative.
Yeah, over to the. After the suturing, you will be applying cast, right?
Yeah. Yeah. So post-operative pain management.
Yeah,
again,
we
is very
can go to the
important.
to the
And then,
anesthetist.
Therapy part also is very important because I think post-surgery therapy is also very vital. So we have a case where we are going to discuss about the management of the post-surgical therapy protocols. So that
I think
delegate is
in
benefited.
case of CP management, I think therapy is the most important.
Yes, it is a main
All the
touch.
three modalities like medications, therapy, and surgery, I think therapy is the most important. And the main purpose of surgery is to make the CP more manageable.
Yes.
So ultimately, it's the therapy which, the most important thing which will show you the best results.
So all the therapists, including physiotherapists, occupational therapists, speech, they play the very important role,
Yeah, no question
So
about it. Yeah, no doubt. No doubt.
So they are the main, I will say, they are the main medicos, they are working for the cerebral palsy. So any surgeon who is just managing the CP, he has to consult a therapist. We usually consult our all therapists from whoever therapist the patient is coming.
Yes.
We discuss at a length and then which are the areas, because surgeon is seeing the patient only once or twice in the OPD, but therapists are the people who are looking
Almost
after
daily. Yeah.
daily, so they know
Better.
what are the practical difficulties the child is facing.
Right.
What are the parents' expectation? Again, it is very important. The parents' expectation.
Yeah.
It is not like that what I feel or what a surgeon feel or what a XYZ medical person feels. So parents' expectations are very important.
And it has to be very realistic counseling to parents as well. I mean, it's not going to be the normal child. That's the first thing.
Yeah.
Our main aim is to make him independent for his day-to-day activities.
Yeah.
So we have to be very clear in the counseling part also. Later, sometimes the patient feel, the parents feel कि अभी surgery हो गया तो आपका बच्चा एकदम से ठीक हो जाएगा, एकदम से चलने लग जाएगा.
Yeah.
But then you have to be very realistic in counseling also and very gentle and gradual also.
Yeah. It is very important.
Yeah.
So in fact, we always explain to all our kids and parents that we are not going to cause any magic. So,
Yes.
Because cerebral palsy is a disease from the brain.
Which cannot be cured, right?
Yeah. So they should be realistic.
And the sooner they accept, the better.
Yeah.
Okay. So after one more question. Okay, wait.
Good morning, sir. Mayuri Tizari here.
Yeah, Mary, good morning. Please go ahead.
Sir, are there any precautions we need to take when we start the physiotherapy post-op?
Actually, on plaster, you should not be very vigorous, so that they are not, cutting the tendons which we are sutured.
Okay.
So you have to be little gentle. If actually the patient is coming to therapist, if he's taking at a home, then it is fine. You can just simply ask them to just simple SLR or simple, toe movements, so quadriceps strengthening, simple exercises. You can suggest them. Limb mobilization, like maybe the joint which has been immobilized in the plaster, you can't of course mobilize, but the rest of the joints you can ask them to mobilize, so that we are not having the much weakness, because in plaster the power usually goes around half to 1 grade below, so they lose the power by half grade or maybe a 1 grade. Temporarily, it is temporarily losing of the power because of the immobilization, so that they can once the plaster is off, they can again have the intense therapy program. What is important is muscle strengthening. You know, I always stress a lot. Meenakshi madam and Alpana will agree with me that muscle strengthening, I mean, when we started our practice 25 years ago, the main crux was only on a, deformity correction and then just having the range of movement. But since the evolution, we also realized, the medical science also has realized that what is important is the power, So strengthening is very, very important and very vital in the cerebral palsy, because it is not a question of only contractures or dystonias or like other involuntary movements. It is a matter of strength also. If the child develops the strength, even if the coordination is not to a great extent from the brain, there's still with the power and some coordination also, the child can be, child is able to manage the gait, or the independent walking, or maybe assisted walking with the devices. But if there is no power, whatever you do, the child can't be ambulatory. So it is very, very important to work on the muscle strengthening. So I always give a lot of stress on the muscle strengthening. So whosoever therapists who are watching today's workshop, maybe even at home, they should always remember that they should learn certain protocols from the pediatric therapists, or those therapists who are practicing the pediatrics on a day-to-day management. They should learn certain techniques where actually how they are going to strengthen the muscles. And we have seen actually many patients, in those, even after working for 1, 2, and 3 years, still the strength is, the desired strength you may not get. So you have to continuously keep on working. But in most of them, at some day you will gain the power, you will get the range of movement you immediately get, that because once you release the contractures. But main is the strength in addition to correction of the deformity, and then that will help for the ambulation. It is very important.
Okay, so thank you so much.
Yeah. So I am almost through with this part, and after this, then I am going to release the.
Sir has already told for this, the internal healing for the tendons and all, it's minimum 4 weeks. So you have to take into account that also, you are not to be very vigorous with the exercises.
Tourniquet सोडायची तयारी करा.
So how much is the tourniquet time right now?
थोडे दाखवू शकता का? Can you focus on that? That is a tourniquet machine.
Yeah.
It actually.
It would be really good if you can focus it on.
तिथे focus करा ना.
Cameraman to please focus on tourniquet machine.
त्याला turn करा.
Okay, right. So this is the.
वैसे turn करो ना.
Right now, hold it. This is the tourniquet machine, and you can see the timer. It's 49 minutes and 54 seconds.
Can you release it? Now you can see how we release, deflate. There is something called as deflate.
Yeah.
So once you deflate,
Once the suture is done, so we deflate it. Okay.
Yeah. So
this is deflating.
So deflating, so air which is there in that it is just like a BP cuff.
BP cuff. Yeah.
Can you एखादा cuff दाखवता येईल ना? Cuff एखादा दाखवता येईल? तुम्ही तसं धरून ठेवा. Can you just show them the BP cuff? इथे focus करून ठेवा ना. Yeah. So I have released the tourniquet.
Yes. So it is completely deflated now.
You can see now the blood is coming now. You can see even.
Please focus the surgical side, cameraman. Please focus the surgical side.
Yeah. So this part which was looking like white, now you can see that it has become red. So all the blood which is, see, right? And eventually now I can even palpate the pulsation also here, right? So this is a hamstring and this is a tendinoachilles lengthening.
Okay.
I will just give the cast now. See the correction, right?
Yes.
Okay.
Can you appreciate this?
Yeah. So
yes.
There is a correction which is there, and even I'm getting a 10 to 15 degree of dorsiflexion. We usually don't give more than 10 to 15 degree of dorsiflexion, so that we are not having the crouch get further.
So next step is the plastering, right? After this.
Yeah.
So by that time, we'll discuss some post-operative pain management issues with the anesthetist. Dr. Manish, can you hear me?
इकडे धरा हे ठेवा
Hello. Can we go to anesthetist, please? Hello, Dr. Manish.
Hello. Yes.
Hello. Can you hear me?
Yeah.
Okay.
clearly.
So now the surgery is done, and I think the surgical time is just 49 minutes.
49
So
minutes.
it is possible only with the spinal anesthesia. So we don't need to top it up with the epidural. So
Yes.
what about the post-operative pain management now?
Actually, post-operative management, usually we do multimodal analgesia,
Yeah.
which means we give epidural top-ups. That is the regional anesthesia, what we have put a epidural catheter.
Okay.
From there, we'll give a dilute local anesthesia, that is bupivacaine,
So
Okay.
fast
0.25%.
Okay.
Usually normal dilution is 0.5%, so we make it 4 times
Right.
dilution.
And it is
And we'll
again, it
give-
is according to the body weight.
Yeah, as per the body weight,
Okay.
usually we give
हे
2 to 3
दाखवून
milligram per kg, but the
दाखवलं
dilution
का
is
तुम्ही?
very
कप दाखवलं
small.
ना?
It's just an analgesic dose.
Okay. Hey, but
Plus-
how painful is this surgery?
These
Yeah.
these
This
are
is a
very much-
tourniquet cuff, you know.
Yeah.
Acha, this
was
is
a
the tourniquet cuff. Okay.
It was like this on the thigh.
Please cover
This
the
was-
patient action.
Yeah,
Yeah.
yeah, yeah. Yeah.
These surgeries are really very painful.
Okay.
And so the
चला, काढून घ्या.
role of post-operative pain management is very important. So
Yes,
plus,
yes.
आता त्यांच्याकडे
plus
focus
we
करा ना.
usually give the rectal suppositories
Right.
like paracetamol up to
हाँ,
15 milligram per kg and
Okay.
diclofenac up to 1 to 1.5 milligram per kg.
Okay.
Plus this epidural top-ups. So this helps in
आराम-
better
आराम- मौसी,
pain
आराम से.
management.
Right.
चला, असं करा.
And
Yeah, for the delegates, I would like to add the epidural catheter
Catheter,
is same
yeah,
like as the spinal anesthesia is the intrathecal
थोडं इथे
space.
काहीतरी
It is
cover
in the
करून ठेवून द्या.
cerebrospinal
इथे
fluid.
काहीतरी cover
But
करून ठेवून द्या.
epidural space is just after the dura. So
the
it's a
dura.
vacuum. So there we put a small 18 gauge catheter in that. So
we like to
and
focus
that we
on
can
this
keep it for
epidural.
48 hours. And
We-
through that, it's a continuous thing. And through that, we can give top up. So
Yeah.
the same drug which we used for spinal anesthesia, the same drug in dilutions we can give for analgesia, that is pain relief. And it
This is an
gives
epidural
absolute.
catheter.
This is the
Epidural
catheter.
and with the
That's
syringe,
the port.
we
Yes.
will give the epidural drugs.
Okay.
Yeah.
So the patient has been made supine. It
Patient
was
has been
in prone position.
चला क्या plaster
You can
है?
see she is nicely sedated. She is conscious. She is breathing on her own, everything, but she is absolutely pain free and sedated. If we wake up, she'll wake up. But otherwise, she is sleeping. So that is what is sedation. It is conscious sedation is like she's sleeping, but if we try to wake her up, she'll wake up. Okay. And she's absolutely pain free. Deepali madam, what kind of monitoring you did for her intraoperatively?
Okay. So we have a pulse oximeter and a blood pressure,
Right.
NIBP. So it's a mainly pulse oximetry
Right.
and heart rate monitoring.
Okay.
Simple plaster of Paris. It is a rapid setting plaster so
Mhm.
that it sets up immediately, slap there.
Okay.
So this is a normal standard plaster of Paris cast.
Mhm.
Those patients in which we use inject the botulinum toxin,
Mhm.
there we many times we give the walking cast so that because there is nothing like a tendon healing or
Sunita
like
Maushi,
something.
thoda bazula होऊन जाईल. Sunita nahi, this side,
Kamal Maushi.
Kamal Maushi. Ha, now we can see that. Okay. Mhm.
So just maybe in those patients where we are not bothered about the tendon healing like procedures like Botox and all,
Mhm.
where we can give the walking cast also. So we make the patient walk at immediately after the procedure. I mean the second day or like something.
Yeah. Is there
So-
any position for casting also? I mean,
It's
any it's-
simple neutral. I
Neutral.
mean, not into hyperextension, not into too much of flexion.
Okay.
And otherwise also we are lengthen the tendon, so it is not going to make much difference, but simple functional position what we give.
Okay. Right,
like
right.
that. So it is not too much of flexion and too much of hyperextension also. It is like that. Support there, hello, sir, there, plus there.
Mhm.
So I think most of the part is clear.
Yes,
If-
yes.
If there are no
Any
questions,
about the plastering and all and delegates? No
so
questions.
if there are no questions, I think we can shift to the
Yes, yes.
cases because
Yeah, we have
already I think 10 o'clock. Yeah.
Yes.
So I think surgical part 1 hour we have already dedicated,
Yes.
and now people will be more interested for the cases.
Sir, Alpana here.
Haan, Alpana.
So
Please
what we
go
are
ahead.
thinking is for this case, we're just going to plan a post-op management. So
Yeah,
should
yeah.
we discuss with you
Yeah,
now?
yeah, sure. Please go ahead. Please go ahead.
Yeah, we would
So-
like your inputs in this.
Yeah, yeah, sure. So I will come up once I ship this patient.
Yeah.
I will come up. thank you all the delegates, and thank you Dr. Dipali Madam and Manish for joining for today's workshop. They are the backbone, and Dr. Rashmi, right? So anesthetists are always the backbone for all surgeons.
Thank you very much. Thank you very much.
We are. Thank you.
Dipali Madam, do you want to add anything? Or is it?
About
Please hold the mic close. We can't-
yeah. Add about what?
Anything else about anesthesia management which has been left out, or?
I think most of the points have been covered.
Okay.
Yeah. I mean, do you want to ask anything specific?
No, nothing. Okay, we'll go ahead with the post-operative management from the therapist point of view then. Right? Okay. Yeah. One question for Dr. Viraj.
Hello, sir.
Uh-huh.
Dr. Tejaswini here. For how many
Tejaswini,
days
yes.
cast will be there?
3 to 4 weeks is a minimum time. We safely keep it for the 4 weeks to be more on the safer side. But that is more than sufficient. 4 weeks is more than sufficient. Hello?
Yes, sir.
Yeah.
So till that time, we cannot have means we. No, we
patient-
have to do gentle exercises
Yes,
only.
yes.
We don't have to go for vigorous one.
No.
But 4 weeks are much means till that time again.
The child will be immobilized in a plaster by that time, but he'll be able to do the active SLR, side movements, then toe movements, and then quadriceps inside the plaster he can do.
So probably Tejaswini wants to say that it's probably a long time where the parents have to manage at
Yes,
home.
yes.
And
You're
even
right.
a lot of care needs to be taken
Yeah,
for the
yeah,
operated
yeah.
part,
Yes.
and without compromising on the power and range, like
Yes.
whatever is available. So, but as you said that 4 weeks are mandatory,
Yeah.
and from then
Multi-
onwards we can start.
Yes. Sure. Go ahead for the cases because there is lack of time, Alpana. So I think we should move to the cases now.
Good morning, sir. Sir, any derotation bar should be put over there?
No, derotation bar is required where you are actually anticipating, intorsion problems of intorsion, and where maybe in anticipating hip dislocation, you can put just the abduction bar, if it is a spastic diplegic or a spastic quadriplegic, then we may just put the just bar like this and keep both the feet rotated like this, right? Yeah.
Okay, thank you, sir.
Thank you.
So we plan to start the therapy part.
Sure,
if you,
sure.
with your permission, and you
Yeah,
can
yeah,
just
yeah.
join us.
Yeah. Thank you so much. Thank you.
Hello all. As we've seen the live surgical demonstration, and that was a part of a workshop which was surgeon's perspective. Sir would be joining us. The next session we plan to have a few cases where we all can discuss how we could go try to give the best possible care to the patient. For the session we are supposed to have 3 chairpersons. 2 are already with us. Dr. Umanjali Damke ma'am. She needs no introduction. She's a popular teacher and the principal head of the GMC College Physiotherapy. We have Dr. Sophia Azad ma'am, the head of the OT department, the OT school, GMC. Dr. Sheetal Mundara ma'am was supposed to join, a senior. Definitely, she lost her father, and I just हाँ जरूरत पड़ी तो yeah. Samir. Yeah, definitely. Yeah, actually I was waiting for that only because once we start then we can accordingly have a crowd and the space, right? I had to leave this halfway because I don't know how many of you had seen the cases. Ma'am, if you could just come here, Sophia. All those who joined late, the patient that was being operated, she's a 8-year-old female girl, spastic hemiparesis. She presented to our center. A brief history, she's one of the twins, full term born. Then both babies were born low birth weight. They have a history of an ICU admission for about 2 weeks immediately after birth. The parents, this is all has been reported by the parents. And the parents say that this child, this particular girl, she achieved most of her milestones a bit delayed compared to her sister. But she achieved most of them. The chief complaints that they came to us was she's 8 years. She walks with equinus gait with poor balance and coordination. Next slide. Her parental concerns are that she has poor gait. She's functionally, the gait is functionally as well as from cosmetic viewpoint. Like they say that functionally in the sense that she has a history of frequent falls that they complain. They are concerned about the future progress of the condition when she grows and eventually affect her performance in school, in day-to-day activities and recreational activities, etc., sports. About the contextual factors, we felt that she's a self-motivated girl with a caring and a supportive family. But her low socio-economic conditions, they deprived the child from getting proper, timely medical and rehabilitative intervention. That's what they said, that they were aware of the earlier interventions, but somehow because of the conditions, they couldn't. So when they were fortunate to come to Dr. Viraj Chingadi sir, and they decided with the further condition. Next slide. Brief evaluation, like because she's an ambulatory child walking independently, doing most of her activities independently. Her GMFCS level is 1. We performed the modified Tardieu scale right ankle, it was 4. Next. A brief manual muscle testing. Grossly, you can just see that she falls in the grade of 2 to 3, right and left, but more so we see weakness in the right ankle dorsiflexors, right hip abductors. The gait description, equinus gait, we have a compensatory knee hyperextension, exaggerated lumbar lordosis, anterior pelvic tilt. I'll play the video again for you all. Yeah. The side walking that we took. She has a kind of dragging also. And you see the lordosis exaggerated, anterior pelvic tilt. She goes in the right knee hyperextension, all the compensatory mechanisms. The next, this is a side view. Yeah, we have. Even the truncal side, she has a right side bend. Right upper limb doesn't, they do complain that she has clumsy activities. They do. Sometimes She has tightness, but it's mild adductor tightness. She's going internal rotation. Circumductory gait is also there. That's it. Should I play it again?
As we are looking at the gate from side view, she is walking straight. The view is from side. The gait analysis is usually done from anterior, posterior, as well as the side view plane, just to appreciate everything happening right from shoulder to her toes. So this view where the mirror is there, we can really very well appreciate her shoulder, her upper trunk, lower trunk, pelvis, hip, knee, ankle, foot, everything. So now as you appreciate, she's been operated for right equinus, for hamstring and TA. And on walking, what she is showing is right knee flexion and right static equinus. On the left also, she has some on evaluation with modified Ashworth scale or musculoskeletal evaluation. On the left hamstring also, she has tightness, that is to compensate what equinus contracture she is getting on the right. And that may be, she may be on a diaplegic side, we can say. And but her preference goes, her problems goes on one side. So asymmetric posture is been taken care with therapy and this thing. The other part about her hyperextension, which was commented during the presentation, it is when she stands, she has to stand to compensate this deformity. She has to compensate with knee hyperextension. So on static posture evaluation, when she is standing, she would be standing with knee hyperextension. And that is not much appreciated. Wherever you could see when she is walking, it is not most nicely seen, yeah. But I could remember that when she stands with knee hyperextension. And yes, right. And she it is mostly on the right side. She would hyperextend here and flex here on the left side, just to compensate, because she wants to take her heel to the ground. No, right. On right, she was showing. थोड़ा inclination रह सकता है, but what I remember for her evaluation, right? See, no, right, because she is walking this, and when she has to stand, she needs this length. To get this length, she has to go this. She has to get this length. Yes, see, she has right side tendoachilles tightness. Also, secondarily, she has hamstring tightness. Also, I would say she has left hamstring tightness to compensate this. When she is walking, she can use her ambulation mode to create that dynamic component of walking. She keeps on walking, but she is walking on her forefoot. She is showing good equinus, knee flexion. When she is equinus, she has to have knee flexion and some amount of hip flexion. But now when she is standing, and we ask her to stand, she stands like this. So with that context, you would say if she is going like this, why surgery has been done, that thing would may come in. But it is, कोई स्टैंडिंग का उसका है क्या अपने पास में? No, it is, I agree with you. It is not seen when she is walking. When she is standing, which we have seen, you could not appreciate. Your question is quite right. Yeah.
Related compensation, and then lordosis is also there. So because of that, the hyperextension will be.
Yeah, that is coming.
We have.
You want a standing that we have taken? Would you like to? Yeah. I'll have to just get, because this is a part of the PPT, no? I'll just get it.
Yeah, absolutely. There is, when there is equinus, that there is one terminology, that is two equinus and hidden equinus. One equinus which comes directly from your tender atelis, and then you have that range to compensate that, because its origin is near knee joint. Knee has to go into hyperextension to compensate that equinus. Two joint muscle, hamstrings being two joint muscle, when the hip goes into extension, the knee goes into extension, the hip will go in flexion, so she will compensate over there. And it would be, it can be possible if it is knee flexion contracture also. Like we have equinus contracture, then you may not see knee hyperextension, because her hamstrings are compensating for the sake of tender atelis. They have dynamic range and they compensated with extension. Yeah. But if it is purely with knee flexion, like not even we can sit down, but knee flexion contracture, where you cannot move knee to complete extension, there you could not see this compensation because they don't have range. Now they have some dynamic. Yeah.
So passive knee extension where it is restricted. Okay, then you will not see the hyperextension, but when the passive knee range of extension is zero, then almost a biomechanical hyperextension. Adjustment she is doing while walking. Yes.
One more point.
Hello. The question put up by madam is, I think so, quite relevant, right? Because the first and the most important thing that which did come to our mind is, when the patient is having a hams contracture, how can she go into hyperextension? Because normally it is a flexor at the knee joint, right? But then, as madam has explained, it is a two joint muscle, right? So when if the muscle is shortened and if she is hyperextending at the knee, then she has to bend at the hip. The muscle will have to get compensated at one of the joint. Okay, if it would have been a restricted range of motion of the knee joint, then we wouldn't have been able to see it. Is that clear? With a restricted range of motion at the knee, it wouldn't have been possible, because the range of motion of knee is complete. This is not a joint issue. This is a muscle issue. Active, what we can say, an active compensatory mechanism which is taking place, and thereby the knee is going into hyperextension, right?
Okay, now what post-operative plan you want to?
Just share the post-operative. Post-operative management is like, we can divide it in inpatient therapy, because normally post-operatively 4 to 5 days, depending on the requirements, the patient is in-house in plaster, post-op pain management, and depending on that, the parents are given a home exercise program. In this case, what we would be giving is the simple ankle toe exercises, hip movements, abduction, adduction, whatever, maintenance. And then they are given home care program, because that's most important, hygiene, then proper positioning of the patient to prevent any kind of bed sores if at all the child is in lying position for a long time. These are simple precautions that we need to give the parents.
Any don'ts that which we have to tell to the parents?
In this case, don'ts is something, first of all, non-weight bearing, because most of the time parents are tempted, because this child, of course, the child belongs to an educated family, but suppose if the parents are not aware, the parents have to carry the child for his day-to-day activities, for toileting or things like that. So they are tempted to make the child stand for a moment or so, and then that becomes a habit. So you must strictly avoid telling the parents, like, please do not make the child stand, because this age child, once he gains that habit, he'll start weight bearing. And in that case, we might disturb the tissue healing and etc. And even he doesn't have that much strength.
And
This
I
is
think
one-
so. The basic reason why we do not want the patient to stand is the moment the patient stands, weight bearing and the active muscular contraction, which we are
Will stop.
trying to prevent on weight bearing,
Yes.
because all the adjustments, the minor muscles, the TA as well as the hams at the knee and the hip will be happening.
Activated.
Plus, there is an altered biomechanics, right?
Yes,
So the
yes.
muscle will be working with an altered biomechanics
Yeah,
very early.
absolutely, absolutely.
And it will take up a wrong biomechanics, a wrong pattern before
course,
before the plaster is
Yeah.
taken off,
Absolutely.
which we do
ma'am.
not want. That is also an important implication. Otherwise, someone might say surgery bone to nahi toota hai na, so why not
Yeah,
weight
yeah.
bearing? But this has to be always remembered whenever there is a muscle or tendon which has been tempered in a surgery.
Yeah, especially in cases like CP where already there's an altered biomechanics where the kid has learned wrong movement patterns. So, madam, I think you made a very great point that we must teach the correct patterns post-operatively. So this is one home program, as I said, in plaster. Approximately, if all things go fine, if there are, and normally, if the parents are well educated, for up to 4 weeks or so, we see that they maintain the patients properly. Then after plaster removal, we start the next program. The first thing that we do is, in this case, we would be probably, and Dr. Viraj Chingade also will advise us, the type of orthosis. Most probably we would be going for a dynamic AFO for maintenance of the correction, for support. And that will help this child even in her gait. The parents
If you could just explain the biomechanics of the AFO for the students, I mean the interns and all who are there. Why a dynamic AFO? That would be better for them.
Yeah, we have orthosis
reasoning
is
out.
basically it maintains the joint position. We have static and dynamic AFOs. In this case, the child is already walking because so we will be using a dynamic AFO because there is a hinge joint available, and in that case, it will first prevent any kind of plantar flexion in that case. And again, we will be having during walking in that.
No, no.
No,
1+ will be no. No.
It was 1+, and she was not put on any AFOs, any orthosis rather, because they wouldn't solve any purpose. Now we might even actually we might go for a static AFO initially till the child goes for weight bearing.
I think she was zero dorsiflexion.
She was one.
No. Range was totally zero, no?
She had a flicker.
A flicker, but
Yeah, but
EHL she showed. So then,
It was an attempt to do the activity with equinus. So she just clicked with EHL. So that is only possible with her. So it was poor selective motor control, that we can say. It was not at all. So now after post-surgery, when she gets the alignment, this AFO would reinforce the proper neutral posture and initiation of proper gait pattern.
So I think so before we go in for a dynamic AFO, we will also have to go in for a muscle strength testing prior.
Yeah, absolutely.
Because now her strength status So only with the normal strength status now, then we will need to go in for a AFO, and the range of AFO also the control will have to be altered initially, and as she goes on strengthening and getting the range along with the strength.
Absolutely. If we want to be more specific on post, if we want to be very specific on post-operative regime, is equally important to get the post-operative results. So the training would be with push knee, maybe because that plaster wala effect will get pre-operatively and start re-educating the muscle, which is now with lower power, with more of tightness pre-operatively. And post-operatively, we have less of the tightness, and now we are now trying to build the power, right? So, they were after 7 or 8 days, the proper instructions to the parents by surgeon and therapist would go that it has to be done in this way to demonstrate them on a previously, or then we have to do it how the range is available. And once we gain that confidence that she is okay with the lower extremity ranges, then in plaster also we start to work for upper extremity and trunk, all other muscles, all other areas. So plaster time should be utilized for other parts to work, because once plaster comes out, our attention would go more on the strengthening part. So that way, your time of 4 weeks time should be cached for other things till the time we come out of plaster. Day one, sorry, should I? Day one, when the plaster comes out, gentle mobilization, sir's instruction always there, gentle mobilization, how the range and pain allows us. And subsequently, when she gets confidence that she can do it, so then we can start with the general mobilization exercises, and then the strengthening protocol would go. Strengthening would be less of more of repetition and more of ranges. Yeah. And the cardio part would Umanjali ma'am would be.
Isotonic will be more better. One thing I would like to emphasize over here is, like, when the patient is non-weight bearing and non-locomotive, I would say, this is the time when most of the disability is what is going into, because disuse atrophy thoda 4 वीक में हो ही जाता है पेशेंट को. So the day the patient is up and about for walks, he does not have the strength and he does not have the energy levels. His cardiac system and all the musculoskeletal system has already gone down. So this is the time where we need to keep the patient updated because he's not able to do lower extremity. We should work towards his upper extremity ergometry. So strength of the upper extremity and more exercises with the upper extremity and the extremity which is normal. So we can give him only one leg cycling, which should be emphasized. And this needs to be mediated because the moment he is going to stand, he is going to put up more weight onto the affected extremity. So strengthening of the normal extremity, endurance of the normal extremity, and cardio with the upper extremity is, I think so, an important exercise regime during the patient who is at on bed rest and healing with the normal, the affected extremity.
Thank you. I think that was a very important point because this girl definitely aims to go for some kind of sports, and she is probably her parents are waiting that once she's out of that surgical and rehab period, she is going to join something. So I think endurance part was.
And one more point I would emphasize is normally whenever we start with the exercises for a muscle strengthening regime, I always prefer starting from the eccentric range and then going to the concentric range. Because what happens is, like just say Madam had said, when we have spasticity, the muscle is weak because the other one is spastic, right? So thereby always when we work in the eccentric range of the muscle, strengthening from the eccentric range, that also gives a stretch to the the antagonistic muscle, and it also works towards the strength of this muscle. So plus functionally the patient improves faster. So strengthening from the eccentric range, then going on to the concentric range should be the, otherwise normally we go from neutral to concentric always. So this should change from eccentric to the concentric because functionally we use it that way. Yes.
After cast removal, and if strength allows, in how many days we can go for wet bearing?
That I think so we will leave with the surgeon.
Yeah, first of all, I would request all the audience who are participating, please take a mic because this is going live. So we are not only the people who are in the hall who are going to listen this, many people are, so please identify yourself. And then I would also request Dr. Sophia Madam and Dr. Deepak, who is they are occupational therapists, and they have excellent work. I have seen since last 20 years, they are working and they are doing excellent work in occupational therapy. So I think occupational therapy also is a very important part. As Meenakshi Madam and Umanjali Madam was telling, we can simultaneously work on, activity of daily living, ADL, then hand functioning. That is a very important aspect where most of the therapists, they live. Even I have seen many occupational therapists, they just concentrate on strengthening or the stretching. So I think this is a time when we are getting to make the patient used to for the activity of daily lying, hand functioning and all. So it is always a team, physiotherapy, occupational therapy, surgeon, neurologist, and everybody has to be involved. Your question as far as the plaster removal is concerned,
in how many days we can go
usually
for?
by 3 to 4 days we take out the plaster,
Right.
and we advise the range of movement to go a little more gradually, because what happens, there is little stiffness in the joint when the plaster is there. So if you try to mobilize it very forcefully, there are chances that the patient can develop the swelling, the synovial stretching can cause little edema, little pain. So little gently, maybe 10 degrees today, then 10 degrees afterward, 20, 30. So accordingly, you have to be gentle for the range of movement for the joint, and strengthening you can start immediately. Strengthening part you can start immediately. There is no question about it. And weight bearing also you can start, but weight bearing for again you require a power. Like hemiplegic, if you already ambulatory patient, and if you start immediately plaster, if the parents' expectations are there that mera bacha immediately chalna chahiye, it is not going to happen, because there is some intrinsic weakness, some stiffness, so the child will take some time. We usually advise them they can bear the weight. I mean, as far as the weight bearing is concerned, there is no contraindication, but till the time they develop some power, some range of movement, so we'll tell them that go little gradual. Maybe by a month, the child is very comfortable. It's like that.
Like just mention about when the wet bearing would start with her screen signal, we as a therapist have to check her AFOs. They are right in place. So first wet bearing would be with her AFOs, so that any strain or stress comes, that will be taken care by AFOs. So every wet bearing would start with proper orthosis she is wearing, and then she would go ahead.
Sir, I want to say something. When bed bearing begins, so that is the right time for a therapist, or especially for occupational therapist, to start the child with toilet training activities. I think that will be better if the bed bearing is not an issue for the child. So that will make child independent in his activities of daily living, I think.
I would like to just add one more point. I mean, whenever, as we said, as to pain, how much range of motion, you said range of motion, we will go gradually. I always follow that principle of P1 and P2. P1 where the pain starts, P2 is where the pain becomes unbearable. So the point where the pain starts, you just go 25% of that P1. And for these patients, not more than 25% of P1. If you follow that criteria, because everyday mobilization se wo P1 badhte jata hai, right? So the patient does not go into P2, the patient is not apprehensive. He or she allows the exercises properly, and we do keep on getting the ranges gradually.
केसेसला जायला हरकत नाहीये कारण की आता 3 केसेस
I guess most of the points I think we tried to cover here, I guess. So maybe we can wind up this case and we can start with the. Okay, the first case that we have is 18 months, 18 months old baby. Dr. Krati is going to present the case.
Good morning, everyone. I'm presenting here first case. So first case is Samarth. First case is Samarth Havas. He is 16-month-old male and informant by mother. This is family tree. Chief complaint was developmental delay and unable to sit and stand independently. Birth history, mother was 35 years old when she was pregnant with second child, and in prenatal history was insignificant. Perinatal history, preterm baby, 28 weeks of gestational age, C-section, very low birth weight, 850 gram. Birth cry was present. Postnatal history, admitted in NICU for 2 months. Yes. Developmental history. Developmental history, all developmental milestone was delayed. And past history, baby was admitted in NICU for 2 months because of prematurity and very low birth weight. Mother noticed that baby is unable to turning and holding his neck at 10 months of age. After that, mother took him to neurologist and MRI diagnosed with developmental delay. After that, baby started physiotherapy at 10 months of age. Currently, AFO and knee splint given to the baby. Then surgical history, bilateral herniatomy was done on 26/11/2020. On examination, this is stone, upper limb was grade 1 plus and lower limb grade 2. These are deep tendon reflexes. And according to gross motor function classification system expanded and revised, he is in level 4 because baby have head control, but trunk support is required for floor sitting. Infant can roll to supine and may roll to the prone. Attitude of child, lying on bed with right shoulder internally rotated, both elbow pronated, left shoulder was relaxed, bilateral knee extended. Sitting on bed with support in cross leg, right shoulder internally rotated, right elbow pronated, palm closed in fist, left shoulder relaxed, palm closed in fist. Standing with support, right shoulder internally rotated, right elbow pronated, palm closed in fist, knee extended, foot touched on ground. Attitude of child can change according to his comfortable level and environmental factor. And parent concern is his mother complained that during sitting, child needs support and use left hand for playing activity more than right hand. His mother complained also that he crossed his leg during support standing and palm closed in fistula. So these are our short-term goals. He will sit on chair with 90-90 position, foot making base of support and maintain correct alignment posture, and will play on cutout table in front of him for 5 to 10 minutes. And he will sit on chair with 90-90 position, foot making base of support and maintain correct alignment posture, and will eat food using right hand on cutout table in front of him. These are our short-term goals, and long-term goals is Samarth will sit on chair with 90-90 position, foot making base of support and maintain correct alignment posture, and will transfer the objects on cutout table in front of him. So these are, he is our case. मैं जाऊँ क्या?
Actually, what she has briefed us is very well presented. You have given us brief idea about this 15-month-old baby who shows on examination. Please, camera on the child. There is increased tone and some components of dystonia on his left side, which I will try to demonstrate. The increased tightness in both lower extremities and upper extremities.
Hi.
Say hi to everyone. So now, this is my bonding with him first, because he is in crowd and I am new for him. I will try to demonstrate you lower extremity stiffness and tightness, which we do usually with the babies. Very simple way. तुला काय झालं? तू कुठे गेला होता? तू मम्मा सोबत आला? तू मम्मा सोबत आला? Hams that I'm trying to demonstrate. TA, which is also tight. Adductor group, which is also tight on the right side. Now on the opposite side, मोबाईल चे टॉर्च ऑन करून दे ना एकदा. इसमें से दिखाते जाओ इसको. Just try. इसको लाइट दिखाते जाइए. On the left side, again, we have hamstring tightness and TA tightness. Bilateral adductors as well as hamstrings are tight. Here also we can appreciate some tightness. Okay. 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 So we have examined that there is increased tone in both lower extremities. इसमें से उसको थोड़ा चेंज करते रहिए, तो वो उसका अटेंशन स्पैन स्विच नहीं होना चाहिए. So what we have seen is TA with Ashworth scale. Just hold. Kritik, आप ये पैर एक बार पकड़ लीजिए. With the Ashworth scale, I am trying to assess what should be the tightness level. So Ashworth scale gives you how much is the tightness. So 0 to 4 we have gradings, and here the range is possible, but the terminal range is tight. So that may be 1 plus. 0, 1, 1 plus. The range is possible, but at the end of the range, I am getting tightness. So that is 1 plus with modified Ashworth scale. Now, just to identify why I want to check with the Tardieu scale, whether this is dynamic or static, which has been demonstrated previously on the other case. So to differentiate whether this is static or dynamic, modified Tardieu scale has been given, which gives two components, R1 and R2. It is velocity dependent test. The R1 is the first fast catch, which tells where the spasticity is emerging. And second, R2 is the slow stretch, whereby you know how much is the component. The difference between R1 and R2 is the window of opportunity as a therapist to work. If it is more of static range, the surgeon goes for corrective surgeries or other intervention. And what a therapist can do, this would be the scale. So now I am trying to demonstrate you a modified Tardieu scale for hamstring. Thereby, I am giving first catch here. So this is, if this is 90, this is 95 or 100. Again, I am demonstrating. This is almost coming 100. The R1 is 100 and R2 is almost 160, 170 degrees. So 100 R1, 160 R2, around 50 degrees of range we have. So which is a good dynamic hamstring tightness. So this is tightness, but this is dynamic. No intervention. Therapeutically, we can manage this child. But this child is this is about the musculoskeletal evaluation that this child is showing. The other test where we have to check for rectus femoris, the even I haven't seen. Sir. Here, yeah. So here, I would like to check whether rectus, yeah, I am getting here tightness. I could get first catch only, but the resistance muscle is offering. So I would say this must be one, right? So full range is possible, but the resistance is there at the initial range. So rectus is also coming in picture, but presently it is at the lower grade.
So this is the Duncan Allied test, what has performed, which actually gives you the level of contraction or tightness in the rectus femoris muscle. So if the pelvis is raising, that means the muscle is really into contraction or tight. So that is why the pelvis is getting up.
And hip flexor, sauce test. For hip flexors, then we have to take on surface. Check hip flexors. Hip at the edge of the bed. Yeah. See, I am neutralizing lumbar lordosis just to get hip in action and just to check whether iliopsoas is coming into picture. So he is showing, sir. There is some resistance. Sir, he is showing. On the right side also, see, this is not coming. So this is hip flexors.
So unless until you take the patient to the edge of the crouch, you will not be able to actually relax the iliopsoas muscle. That is why it is important, because the opposite side also can give the compensatory movement. And that is why you have to take the patient to the side of the crouch. Yeah.
So these are about the orthopedic assessment, which this baby may not require, but we demonstrated because this child has few components which could be demonstrated on this child. From early intervention point of view, like for this child, the therapeutic program, what queries you have, I would like to answer according to that. We have Sophia ma'am, Omanjali ma'am together. So whatever concerns are coming to you, the case is very well presented. Musculoskeletal evaluation is being done. Now, what things are coming in your mind, and as per the goal, ma'am, what you would like to comment, so we can proceed that way. The discussion would be more healthy.
So this child that we are seeing has a global developmental delay, and besides that, lower extremity is definitely affected, but upper extremity is as much involved. So at the same time, while giving him the proper developmental positions and giving the child some kind of assistive devices also for seating, for proper maintenance of the posture, we have to give him that, and then we have to start with the activities, so that bilateral integration or crossing the midline and holding activities be started, and hand to mouth activities, because that will be the mainly the children are doing hand to mouth activities at this time.
Absolutely.
So plus we have to also once the cognitive aspect and the vision and the hearing, all these needs to be evaluated properly, and taken concern about that, so that we can see the contextual part, the participation in this thing, and activity limitations, what are they, according to the 18 months of age. So at this time, the child is probably not doing, he's only going to the sideline position, isn't it? Not going to the prone position.
Rolling and prone play, I think.
Prone is
play
not there.
present. He recently started. He sits with support, and he stands with support.
But he's not coming to the sitting position on his own.
absolutely
No?
not.
Coming. And neck control is also, I think, quite good. Only.
It is
neck control is good. Yeah.
Yeah.
Special educator. She understands a lot, but still there are a lot of areas where she needs to be guided, like that.
So from that point, which Sir has emphasized on speech therapy, we as a therapist need to work on the trunk aspect, because it would be a preparation for her oromotor and speech and communication. So the trunk working would be one important aspect from all physio, occupational and speech therapy point of view.
Sir, I want to say something.
Yes.
As Madam Sophia Ma'am, he told ki child needs various activities. So I would suggest ki proper corner chair should be given to the child, so that she can sit properly and do bilateral activities in front of tabletop.
Exactly.
So that is the best option.
Yeah.
Okay. That will develop his sitting tolerance also.
Exactly.
And one more thing, as she was telling me ki some milestones are not achieved, and still she is achieving that milestone. So we should go for developmental therapy.
Yeah.
Okay. Child should be taught how to come to sit, how to come to stand from kneeling, half kneeling. So this should be gone simultaneously along with the physiotherapy part. Yeah. I would.
How you would do those developmental techniques on him?
I will demonstrate few techniques.
You can come here. I. I'll hand over child to Dr. Deepak. Thank you.
What are the developmental milestones she is not achieved? Which milestone she has not achieved?
He's not achieved independent sitting.
Sitting, okay. So I'm going to teach coming to sitting, how you are going to teach the child and her mother to make child how to sit from supine position. See, neck control, I think partial neck control is there, but she needs full neck control before teaching this. See, I have made her sit on his own. Okay. See, okay.
Yeah. Neck control, yes. And one more thing you can do, Deepak, is that while you're bringing the child to the sideline and then
Yeah.
halfway you just leave him there with
Yeah.
the forearm weight
Forearm
bearing,
weight bearing.
so that this causes also joint compression.
Compression.
And
Right.
then the lateral muscles which are there, abdominal.
Lateral abdominal muscle will
they
develop.
will develop,
Hmm.
and that will help to develop the core.
Hmm.
So this activity which you just make the child bear weight on the forearm for a period of time, and with the other hand you can give
Before-
some activity so that the child crosses the midline. So
See,
that is a good.
So one more important thing is both the knees should be straight. Then only you can make child to sit from coming supine position. Otherwise, if knees bend, she will not be able to come to sit. So proper sitting posture, proper controlling of the child is very important before teaching developmental therapy. Okay? So this was a coming to
new
sitting.
method which has come now. Not a new method, but QS, I think you all must have heard about it. QS MEDEC method. No. So in that they are giving more of resistive kind, and like this child, the child which you have operated will be very, that method will help that child very much. In that they are giving lot of obstacles for the child to overcome, so that the balance and the core muscles are mainly developed. So that QS MEDEC method is a very good method for CP children, especially for CP children.
Okay, right. For developmental milestones, whatever Deepak is advising on that ground is like he is trying to suggest us that this child should be taken through the developmental milestones, which our therapy signifies. So in that context, what my experience tells is that working on core muscles, like what madam has explained, going to one sideline and then coming up. In that context, what on examination we have found that he has partial neck control, that on from supine to sitting, he is showing some head bobbing. So in that, for that aspect, we may use the towel roll to support his neck, so that whatever they want to facilitate his obliques. Why they want to take him to the sideline? Because they want to facilitate obliques muscles, because that is the muscles which is postural muscle. And if you take the child straight like this, that would encourage his rectus abdominis, which is a strong flexor, like that would give more of kyphotic posture. So from postural alignment point of view, activation of oblique muscles, which is being shown, is truly needed. And this would go as a posture and trunk control regime for this child, along with the goal what we have sitting. Madam has said, or Deepak has just now mentioned, that he should be taken for age appropriate goal. If we give our time for just abdominal, 2.5 years, we would be just working on abdominals. So his functional status in his family, like what ICF International Classification System tells us, the participation of the child at 16 months should be in-house for play. So his participation in the home level as far ICF goes would be according to the goal we have decided that he should be sitting. So though we are working on the therapy areas here, we are also giving him the goal components, and for that also our therapy would be decided. Right, ma'am?
Very true, madam. And we नको तसं नको होल्ड कर. नेहमी असं होल्ड करायचं. इकडनं होल्ड So like handling is a very important aspect for this child.
Ma'am, you say something about handling, how child should be handled. It's very important, especially for CP child, how to handle in various positions. So that madam is going to tell.
Always the mother, always the mothers should be advised for the handling aspect, because many times we see that there may be some subluxations or also because of poor handling, and that's why holding at the chest level instead of holding at the arm level or at the shoulder, and always carrying the child कडावर घ्या असं पण म्हणतात ना, तो मतलब child has to be put in कडावर घ्या, so that one side, so that the adductor spasticity and all can be also treated.
That
And also the child can be, held like this in front so that the mother and the child's interaction with the face-to-face interaction is there. And that is lot of security to the child also.
yeah. Just now, madam, to age appropriate milestones. So every therapist should know the milestone, how the child is going to develop all the milestones within 1 year. Okay. So that time period is very important. So if you are knowing the time period, then you can catch the child at the right time and you can go ahead from that. So age appropriate milestone should be very important for therapists to know.
Age appropriate functional activities should be incorporated during your goals.
Ma'am, if anyone can explain about the visual rehab we need to start for this child. If anyone can explain us the visual rehabilitation which has to be started for this child. Yes.
Okay.
We think the child has squinting. So he has some visual impairments also.
Yeah. So for visual special needs from therapeutic point of view, first, so we need to be tested by pediatric ophthalmologist what exactly is the status. And if it is like he has vision, he showing some imbalance in the eye muscles that squinting is seen. So for that matter, with the age, it goes on improving. That's what we have witnessed, and there are some papers which proves that. But still, from therapist point of view, if we could if we want to really work, may not be in the therapy. At home care plan, the good eye should be patched up, and the eye with the problem should be given some visual toys to track, to fix, like that. So participation of correct eye muscles. So if the squinting is towards right or left, you have to identify, and accordingly the diversion and conversion exercises what are needed should be explained to parent, because this is not very extensive part of therapy presently now, because we have to emphasize on other milestones. So that may be taken care at home care.
Ma'am, do you suggest eye patching within the therapy sessions also?
Yeah,
that
we
will
do that.
moreover participation of the child would
yeah, we do that, because therapy is a holistic approach to everything: auditory, visual, proprioceptive, sensory, all everything should be taken care during therapy. And that our 45 minute session means a holistic approach. So we as a therapist, though treating his TA equinus, but complete child is into consideration when we are treating for that 45 minutes of session. Anything else from students' perspective? Any queries you have?
Ma'am, what are your goals for him for because the child is 16 months and by 3 to 4 months he has to go for his schools. What are your goals for his schooling, for his education?
Yeah, a good question. And so same question parents have, that where to start the education, because they are more concerned onto the education part. But we have to be realistically, we have to explain parents what exactly. His mom is already a special educator. She is dealing with so many students every day. So she knows to some extent, but if at all the parents are not aware what exactly they have to do, as a therapist, we have a strong say on what therapy means to this child. His therapy is for achieving his milestones presently, and achieving a function which is indoor now for his 16 months or 2-year-old child. Education can still wait. If at all we prioritize education and get him deprived of therapy, so we are not justifying as a therapist. So we have to prioritize what exactly means as a therapist to you and to the parents, and taking parents into this concern. This would be with their concern that we are working for this goal. He should sit. When he will sit, then only his school will allow him to give him a chair in the group of 4 and 5 or kindergarten. So he can participate in a group eventually when he starts sitting. So first training should start at therapy, practiced at home, and applied in the nursery level. for smaller duration. आधा घंटे के लिए भी बच्चा गया, 1 घंटे के लिए भी बच्चा गया. So that participation would be encouraging, not for his education ABCD, but for his participation and acknowledging his group therapy. So I would suggest that way.
Maybe this is out of question. Maybe my next question is, ma'am, how many schools in Nagpur itself allow a disabled child to be in their play school or maybe in the kindergarten? Kindergarten won't be a problem, I suppose. But according to IQ also, along with the child, if the caregiver is going and staying with the child, they allow, especially in tiny tots and small schools like kindergartens and all, they usually allow. Okay, for the initial period, just to make the child, I mean, be in a group like what madam has said, and to interact with the other children. At least he will sit and see the other children playing. So that is also a big thing. And maybe start, the child will then start doing some physical activities or with, after seeing the other children. So they allow, usually you have to just see that one of the caregivers is along there with the child. Also.
Yes. And what I think so is we also need to visualize the capacity and the performance. What is the capacity and what is the performance of the child, to what limit he can go? Because if he can sit and play with the other kids, then definitely he should be promoted. And it is very necessary that the teachers also should be told as to what is his performance level and what is his capacity, so that at the school also the other kids are promoting the child along with the caregiver. But if a child does not have that capacity or is not going to go to that performance level, then that also needs to be spoken to the teacher, that you do not try and take him beyond, because then that is a frustration to the parents, frustration to the teachers, and to the kids as well. So this outlining, I think so, before going to the school is the most important aspect of schooling, where I think so RTE comes into picture and into an and this is an important aspect, I think so, where we need to put up a performance and capacity before we enter the child to the school.
Yeah. Any questions from our audience? So we should go to next case.
Next goal is like sitting with support. That's it. Yeah, supported sitting, proper alignment with adaptive chair, like presently with support, and then gradually he should be taken for play, like for. So to gain that goal for sitting in upright chair.
सोनल इनके शूज है ना वहाँ पे रख दी हूँ मैंने, एक मिनट.
What Dr. Prerna asked me, what should be the goal, what all things I would work for this child. If my goal is sitting in 90-90 alignment with for play, so with that context, I would prefer to work on his trunk and posture. Ball can be a medium of working for me. Why I chose ball? I would choose a 100 centimeter or 120 centimeter ball to get a big platform, dynamic platform with my height. And then I would work for his obliques, his rolling transitions, his prone posture, his forearm weight bearing, his prone to sitting and prone to standing. All these 5 components I can work on the dynamic surface of ball, and even on a big grandfather bolster we have. So big areas of dynamic areas would be helping me. Instead of mat, I am going down. I have taken child up because I want to work more on dynamic surface so that he gets all those weight shifts, weight bearings, alignment, and correct transitions. So I would be working on like that. And after every transition, at the end of the therapy session, I would check for his sitting control under supervision. Ma'am.
Dissociation of the shoulder and scapular dissociation and hip and lower extremity like pelvis. And listen, see, we don't keep waiting for the child to develop the milestones also, because the age is, so instead of that, we start giving them assistive devices and we make them independent in that manner, okay, so that he can start, involving the other activities. So if we keep waiting for the milestone to develop, then we are losing out on the other aspects of the child. So participation and what madam said के participation में फिर वो कैसे आएगा ना, अगर हम उसके लिए वेट करते रहेंगे कि वो जब चलेगा तब हम स्कूल में डालेंगे या जब वो बैठेगा तब हम ये करेंगे, तो ऐसे नहीं कर सकते. So what madam said के 90-90 में उस सेट करना चाहिए, that is a very good goal which the child.
Can anybody think why it is only 90-90, not any other position? Can anybody think of it?
Upright posture and knee, hip is in good position. Knees is right.
Right,
Yes,
right.
hip knee dissociation is there.
Exactly. So when now you all are sitting on chair, you just correct yourself, be straight. Now you think of your base of support, your back support and foot support. So everywhere you are getting a input to your body. So this is the right posture. You sit like this. So when you sit like slouch, you tend to go into flexion. So you are inactive here. So most activity comes when you are at most maximum length of the muscle in that proper position. So it is always said that your upright position or your alignment matters a lot. Why base of support? Unless I don't know where I am, where my psychosomatic or proprioceptive input would go. So from sensory perspective, my weight bearing areas I should know. Otherwise, you have seen kids like sitting like this, and they are not aware. They are drooling, they are not aware. So every time we have to make aware that you are sitting like this. So conscious effort, conscious command would help them. Right, Sophia ma'am?
Yeah, because if you are sitting wrongly, then channelization of spasticity is there. And so at every weight bearing point, the weight bearing has to be absolutely proper onto both the hips. When the weight bearing is proper onto both the hips, your spine will be straight. The lordosis is obliterated, and then there is prevention of channelization of spasticity, thereby decreases the spasticity. The child is able to move his hands more open out, because if he's slouching, then the pectorals are also coming into picture. Pectorals are also always tight and spastic. So what happens is the child is not able to play with an open chest. The child needs to play with an open chest. So always, that is why we always put up a pressure onto the child anteriorly, then stretch out his shoulders, right? So that the moment you stretch out the shoulders, the posture which comes to play is the right posture.
So we will forward for second case. He is Samir Tekam, 6-year-old male, lives in Ajni, informed by mother. Chief complaint is global developmental delay, unable to stand and walk independently, unable to maintain himself against gravity. Birth history, mother was 27 years old when she was pregnant with his first child. Prenatal history insignificant. Perinatal history normal vaginal delivery. No history of any instrumentation or prolonged labor. Full-term baby with low birth weight. Birth cry was present. Postnatal history insignificant except fever after 3 days of birth, but no history of any hospitalization. These are developmental history.
And within 2 or 3 months, they have found that
Past history. Child's mother brought him to the hospital 2 years back with complaint of delayed developmental notice since 1 year of age. And that time he was unable to get up from bed and unable to stand and support. His mother complained that when she tried to make him stand, he flexed his both knee and stand fearful with toes. He continued with physiotherapy. Surgical history, he had surgery, first surgery procedure was done, right hamstring lengthening, adductor release, and Volpius procedure for right tibialis posterior release. Second surgery was left hamstring lengthening, Volpius, and adductor release. On examination, these are tone assessment, deep tendon reflexes, manual muscle testing. Range of motion was normal except supination was restricted. Parental concern, he cannot stand independently and shows fearful standing and walking during anti-gravity movement. He is fearful in unknown environment, difficulty in communication and learning problem. Attitude of child, in sitting on bed, bilateral shoulder and trunk relaxed, bilateral fingers flexed, lower limb downward towards the floor, but he is very fearful on stool, even under mother guidance. Kneeling possible with hand put on thigh and trunk goes little bit forward to make himself comfortable. Standing possible with support on wall, with hand trunk goes forward, bilateral knee extended, bilateral foot inverted. Mode of ambulation, walking with help of walker and wearing static AFO, walking along with wall support, both knee extension, trunk forward flexion. Short-term goals, these are, he will play ball activity in standing wearing AFO, maintaining upright trunk. He will walk with walker wearing AFO, maintaining upright trunk and learn to propel it. He will do indoor mobility with walker 10 to 15 steps. And long-term goals, he will play indoor games with cousins. He will go outside the house with help of walker wearing AFO.
He is walking.
Walking with support wala hai na?
Independent. Acha. Okay. What Kriti has given us the brief history of this child is his post-operative diaplegia. His pre-operative picture was he had deformities and sir operated him, and since then he is on therapy. One leg and after another has been done. Now we have to concentrate on this child about the post-therapy protocol, which we at the center is being followed, and we have to continue with this. Parents concerned that he should be able to walk independently or play in his surrounding areas. Presently, he is, as per the gross motor functional scale evaluation, he is GMFCS 3. He is walking with walker. He is being now presently trained for walking with walker, and he can walk along the wall, that is cruising. So he is on GMFCS level 3, walking with some walking aid. So when planning a rehabilitation strategies for GMFCS 3, we are not going to change his GMFCS level, but the quality of GMFCS can improve. The way he is walking indoor, now he has phobia of walking with the walker. He cannot propel his walker. Maybe with therapy, we can see that he is participating with his own walker in the playground or in the society. So within that GMFCS level, we can improvise. We cannot change really the GMFCS grading. That's what the important message about the sir has given you all the scales with you. So this is very, very important as a perspective. And we all as a team, rehab team, should be on a same page. So everybody has to go through all the scales given by sir, all three important scales. GMFCS tells you gross motor, MAC tells you upper extremity participation, and CFCS gives you about the communication ability of the child. When you, and EDAC, EDAC gives you the ability for this thing, eating and drinking, and one more visual scale has also been given, which is also equally important. So on a same platform or same page we can work. Regarding planning his post-operative treatments, post-operative treatment strategy, 1 year na, 1 साल हुआ है ना इसका. So now his status is he is walking with walker. So your protocol as a therapist that he should be trained for propelling his walker. So what strategies I would plan for his treatment, like postural control in upright position, various transition where he can be trained to change his planes to get acquainted with the surrounding, because he has great amount of phobia with him. Sophia ma'am, please guide us on this aspect, because this is a big sensory issue which we face with this child I have checked with this child. And propelling a walker needs a good your visual and your anticipation power, your motor planning. So that is also a sensory part. About the strength training for this child, in though we are working on the wet cuffs and the conventional methods of strengthening, for a child, conventional methods of strengthening would help halfway, and transition would help you halfway. More of that, my experience tells it's more of your transition. The way you train the child to be upright and use his surrounding, train him to climb a chair or a bolster, to get down a bolster, from a bolster to a stool. So just imagine two transition from mat to bolster, bolster to a stool or a chair under your supervision, only on your mat area. How much he is using? He is using his core, he is using his proximal stability, he is using his wet shift, he is using his propelling, he is using again upright posture, he is using transfer, he is using then his abductors. So all these mixed transitions should be planned along with your conventional therapy, because whatever we are practicing in conventional therapy should be used in front of you, not at home, because they are not trained. You are trained, you know how alignment and posture should go on the different equipments. So my plan for this child would be, I would do lot of transition with the child, and 20% of the things. Okay, you can give me a bolster. बड़ा वाला इसके ऊपर मैं ट्राई करती हूँ, पर मुझे बड़ा पोस्टर चाहिए रहेगा। एकदम बड़ा वाला तुम्ही आता ना आपण त्या मोठ्या वाल्या पोस्टरवर चढायचंय, ठीक आहे? आता मी तुला इथे बसवलं, ठीक आहे? इथे बसलाय आणि माझ्यासोबत करायचं आता, आई इथेच आहे, ठीक आहे? माझ्यासोबत त्या पोस्टरवर तुला जायचंय, ठीक आहे? ओके, याच्यावर माहिती का कसं जायचंय? तू असा बसलाय ना, कसा बसलाय ना तू, असं मी तुला चढवणार आहे, मग तू असं उभं राहणार आहे आणि मग असं पाय टाकून इथे बसणार आहे, ठीक आहे? असं करून बघू आपण. हा चालेल, आता बघ आपण असं करूया. ये आता हळूहळू ये, थांब, असं कर, पाय दोन्ही पाय असे कर. हा आता माझ्याकडे हात दे, माझ्याकडे हात दे. मी कांट सी. हा आय एम ब्लॉकिंग. No. Is it okay? Yeah. Now I am trying to get him to the kneeling. Wait. Kneeling. Now he is on to half kneeling. Okay? हात घे इथे बरोबर. असंच थांब. इथेच थांब. थांब इथे. Don't hold. इथेच थांब. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. थोडं सरळ ठेव. आता बेटा तू सरळ येऊन बरोबर बाजूला उभा राहा. उठ, हातावर भार ठेव, बरोबर ये समोर ये, हातावर भार ठेव, ये समोर ये, बस असंच उभं राहा, असंच उभं राहा, असं ठेव हात. आता असं कर, असं बस इथे बसला बघ. कसा बसला तू? इथे बस इथे. कसा बसला समीर तू? उठ. कसा बसला बेटा तू? कसा बसला? Head shift. Okay. Again. Up. Till the time he is not getting friendly, we may have to go. Now use this lower extremity range. Samir, आता हा पाय उचल. आणि इकडे आण. समीर and पाय इकडे आण बेटा. उचल 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 आण अजून आण अजून आण. He is using dorsiflexors. He is using actually.
तुम्ही मागे सरका थोडं त्या बाजूला मॅडमच्या साईडला ब्लॉक होत आहे तुम्ही थोडं बाजूला इकडे इकडे
ओके.
हा
हा आहे मम्मा इकडे.
मम्मी तुम सामने
मामाकडे जायचंय तुला आता. मामाकडे जायचंय. मामा इकडे बघ. चल आता मामाकडे जायचंय. हा पाय उचल. हा पाय उचल उचल उचल.
Meenakshi,
उचल
Meenakshi,
उचल
can we
उचल.
just do in this position hand activities can be done?
Yeah, sure, definitely.
So
Here, when he is sitting in a straight position, when his pelvis is at good base of support, maybe somewhat large base of support presently.
Yes.
So any activities, the rings can come here, stand can come here, and he would go for his hand activities. मम्माच्या हातात घे.
समीर बघ
मम्माच्या हाताने
घे हाताने घे हे बघ समीर घे बेटा कोणता आहे तर कलर सांग बरं.
हे आईकडून घे. आईकडून घे. When he is doing this, what I am doing, I am trying to, I kept my one hand on his pelvis to keep him activated at his base of support, and I am supporting his rib cage so that he is much more aligned and he is trying to reach. So visual eye hand coordination also we are trying.
And also like when he's reaching out, then he is using all these side muscles also. So, you know, and plus crossing the midline also we can do in this position. So
Reaching, crossing the midline, getting hands to midline, the rotations, those can be planned. This would work your trunk, your upper extremity. Plus one more cue that if you are on a dynamic surface, like he is on a bolster, he is going to the right side, I am going to the left side, I am keeping my bolster. So he is most elongated on the bed bearing side, like he has to reach. So that will be the most typical reach. When you reach, you elongate. So that typical reach you are teaching. So it's in the therapist hand how you handle your object and your child and your command at the same time, right? And I may try, like now this is a demonstration session. He is not at all, I am not a friend for him. So maybe I'll use his mother every time I want to use. Go to mama, because he is afraid of other person. So mama can sit on another bolster, he will try on another bolster. So again, transition, I would keep him transiting from higher surface to lower surface to middle surface, depending on how exactly he is performing. And keeping in mind his alignment and his active participation and active transition. It should not be a force कि ऐसा करके डाल दिया, उठा के खड़ा कर दिया, इधर जाके बैठ जा, इधर जाके आ जा. This should not happen. Ma'am, हाँ, ma'am, आप वो sensory part का.
Ma'am, one more thing. While doing this, just Meenakshi madam, Sophia ma'am was telling about activities to be done. So before starting any activity, the posture, as madam told, should be proper. So you should work in 4 points. Teach the child to reach for the object. For few sessions, just teach the child to reach. Then for grasping skill, then child should transfer that object from left to right. Then she should release the object. So reach, grasp, transfer and release. These 4 things should be worked while doing any activity for the child.
He has moros actually.
Yeah.
He has moros still.
Okay.
He's getting so that fear is there in the child, and that moro reflex is also there. So we have to do reflex integration also for this child. And like what we are saying about transitions, so we can do that in small steps, one by one, and in each step you have to fix the child in that position, and then you do the next step. Because if you do the breakdown of the activity, then and if the child is accomplishing that one step of that activity, then go to the next step and then the third step. So in that case, the child will be more able to concentrate upon the things, or the fear factor will go away from the child. Okay, so like now this activity, what we are doing, chhod do aap, haath chodo beta, Sameer, haath chodo. See now, see, did he go into, like he has that fear of falling. So he just going into, see that, okay. And in this position, very slow, rocking movement or vestibular stimulations can be given to the child.
Your handling has to be very firm. The proprioceptive input he should get. Light touch, he would be afraid. Firm touch, he would be okay. So firm touch at the joints with your handling should be encouraged for such kids who have phobia for new places and new transitions. And what ma'am has told you, it should be a closed place, a small transition, छोटा छोटा dose देते हुए फिर उसको transit करा सकता है. Absolutely, I agree.
And also you have to keep, having control at the lower lumbar region so that you can go into the crouching.
Yeah.
समीर आता बसते तू सरळ हा मी सोडते तुला आता हा मी सोडणार आहे बेटा ठीक आहे आणि you have to see that the point of control, okay, should be at the you cannot hold the child completely like that. You have to one finger control key points of control should be remembered, okay, so that you are not giving excessive support to the child. You have to see that the child himself is doing. Now see, I am only holding it at the shoulder with one finger control and the child is maintaining, okay, but still I'm not satisfied with that because he's going into one side, okay. So you have to see that now earlier the child, when he started sitting, he was holding the hand in front of him, and if the child stabilizes with the hand in front, then the hands are not free to do any activity. So then what you are achieving, you are not achieving much. So now here, if the child has lifted his hand and now he is able to, if I'm controlling him with one finger, then the hands are free for the child to do the activity. So now you can make him do reach outs in different planes, but not very much. The child should not fail also in doing that activity. Agar failure ज़्यादा हो रहा है, तो again the child will get उसका motivation चला जाएगा और फिर वो नहीं करेगा. Okay? Good. You're looking smart. Smart boy.
When it comes in your mind, you have
Smart
any
boy.
queries about the protocol we have like planned, but not work much.
He's sitting in such good position.
Thank you, man. तुझ्यासाठी क्लॅप केलं ना.
Apart from all these functional transitions, your conventional therapy will be also a part of your therapy regime. Conventional therapy, which gives you the individualized components for lower extremity, upper extremity, and trunk. That should go on.
I think everything has been taken care of. What's important is the weight bearing of the child. I think so. The weight bearing, if his weight bearing properly on both the buttocks, then alignment will be okay if he's going on to one side. So because bolsters are movable, there is when looking at his upper extremity is very necessary that you look at the base of support. So it's very mandatory that you keep on rolling him while treating him so that he is shifting his base of support from right to left while giving the upper extremity activities. And I think so that when you are shifting him onto the right buttock, then left upper arm extremity is a better option rather than going on to the right upper extremity option when you are tilting, when you are trying to rotate him onto the, or trying to move the bolster or weight shift onto the right side. Because when you have the weight shift onto the right side and upper extremity movement of the same side, the child will have a tendency to fall. So this is very important that when you're trying to give him a weight shift onto the right side, an activity of the left upper extremity has to be activated to keep the balance of the child, and that will give him more confidence.
The concept behind that exercise is that to keep on a dynamic surface and keep on working. So that is also a part of that. And along with that, what you said, the elongation part. Absolutely.
That is what stability with mobility, mobility with stability.
Yeah. Yeah. What madam is trying to tell us that his pectorals are shortened position. So we may need to give him input for opening up his pectorals and getting a scapulo shoulder dissociation when he is working, so that he gets correct pattern of working. As an okay, the orthosis part, that is the adjunct, like the things which we as a therapist use as a part of to carry over our therapy. For such cases, I would prefer to use a spio or a tight garment, which would always give him a tight proprioception at his upper trunk. So that spio is a specialized garment which is like available in the market. There are so many adjuncts available. So if at all they cannot afford the spio, even a swimming suit which is of lycra material, that should be worn, so that he gets a complete compression. And you know that compression with the proprioceptive input gives you a courage to control yourself. Your muscles are contracted and your alignment is better and you work better. That is one adjunct that is a part of upper trunk. Please make him walk now. We can check for his orthosis part. The other important aspect is our orthosis. Huh. Special. So now presently he is using the walker which has wheels. So right choice of the equipment is very important. So he is getting a help from the walker wheel that he can propel it very well, and he can initiate his stepping under supervision. So he can walk a distance of like in a hall, he can walk like this. I think he walks at home. Turning is a problem. Tala turn karala. So maybe in the walker training or gait training, we have to train him for the turnings. So for turnings, again, your trunk rotations would come, propelling would come, and then initiation would come. So always check what is your goal and what are the components you need to plan for it, and accordingly incorporate those components in your therapy: rotation, derotation, propelling, all those functions, and then subsequently you can go ahead. So if you achieve with rotation part of this, you can increase the distance and take him outside. So indoor and outdoor environment, change of environment, how he cope up with that. So maybe in the society towards evening hours, he could walk. So sensitizing about the environment, he can learn. And gradually in the therapy clinic, you can start with walker, the stepping on different small step. So he would be learning to dissociate and like initiate stepping on a higher or lower level. So that would give him the strength part. Yeah.
अभी युग को ले जाइएगा थोड़ी देर
Can we take him back again? There is one point we can again discuss. There is the knee hyperextension and right missing in this child. But we have to reason out why this knee hyperextension comes. It's not equal. Why these fixing? Maybe this comes from area can also fix his joint. Or I will check for his TA. उसका TA टाइट है क्या? उसका TA टाइट है क्या? So that the component of hyperextension is coming from what? So that we have to find out. Maybe, yeah. He is trying to fix, correct. Correct.
So the quadriceps are weak, so he's trying to put the way or the other way by doing the hyperextension. So we need to work on the quadriceps.
Yeah.
So hyperextension could be either because of the gross dorsiflexion at the ankle. So overleveraging of the tendon is one of the commonest cause. Then secondly, complete transaction of the muscles, the hamstring group of muscles, what we have demonstrated. So complete transaction of the hamstring muscle is another cause for hyperextension. So commonest cause is basically hyperextension, hyperdorsiflexion. Second is the transaction of the muscles completely, so that there is no control on the back, and then the knee is going down. And the third commonest cause is a weakness in the quadriceps. So if there is no power in the quadriceps, so this is not being used. So he will try to take everything weight on the hamstring group of muscle, and then he will have to try. So I think in this child, it is mainly the weakness in the quadriceps which is causing the hyperextension. So we need to work a lot on that. Yeah.
Make him walk again. So the snapping, last degree of snapping, that which is happening with the hyperextension and the compensation at the hip, basically.
Yeah.
What we were discussing in that child as well. This basic mechanism we can now see in him. What we had discussed, although that child had hyper equinus.
So the first child, what we have seen during the surgery. So if you have seen the gait of the first child, so it is mainly the equinus,
Yeah.
So in order to compensate for that equinus and in order to touch the heel to the ground, what the child will do? Try will hyperextend, right? So like that, and he will tilt the pelvis anteriorly. So the first case, what we have seen, there was a compensatory anterior tilting of the pelvis, hyperextension, although there was
So the
severe
compensation
contractures.
was being done at the hip when he was hyperextending at the knee by compensating at the hip with flexion.
Right.
And now that is seen over here. Again, he is doing the same, but he has a foot flat. That child had an equinus.
So as a therapist, you have to assess, what is the exactly cause. Crouch can be because of many reasons, right? It could be simple equinus. Simple equinus also can cause a flexion at the knee. So there are many times the hamstring may be just absolutely fine. But because there is equinus, or maybe sometimes limb shortening also can cause the equinus. So actually the TM is not tight, no problem, but the limb is short. So the child will walk like this. So you have to assess what is the cause of crouch, what is the cause of equinus, what is the cause of knee flexion, what is the cause of, so then accordingly you have to work on the therapy part.
So always looking at the muscle as a two-joint muscle, not just one joint. Very necessary. And muscle as a elastic component, and looking at the limb completely, not at one joint, is, I think so, what is the most important point when we are dealing with the patients. Next case we can take up.
You were talking about orthosis for the hyperextension.
During just now, even Dr. Sophia ma'am commented that can we help him somewhere with the type of orthosis he is using. I think he is using presently dynamic AFO. Am I right? Please correct me. Dynamic AFO. So what we have observed that this hyperextension is coming from the quadriceps weakness as well. So to compensate that like weakness, it would take time until the time your knee is into hyperextension. So we may need to make some modification at the AFOs that we usually see, and that there is evidence to some extent for that. If you increase some height of the AFO, that posterior lift, by 2 fingers, so you are supporting more part of the tibia, which is going behind. So it would be into the flexion, and that would give some amount of flexion, but it should be done very judiciously, taking concern and just checking it again and again how exactly it is being done. So it is mostly seen with the mild cases that I have witnessed, that it do help when you increase the height of the AFO to only by 2 fingers, just below the crease of your knee joint. So that is one modification which is possible in case of that. And the right type of equipment. In the therapy center, they were like using a walker which needs to be lifted. Then we like changed that piece of equipment. It should not be lifted because he's already having that. So that right type of equipment is again a second part of it. Now we have this third child. You just
you gram take 5 years old male. Chief complaint is poor society participation and can't go and play with friends because of falling and obstacles restrictions. Birth history, mother was 34 years old when she was pregnant with second child. Prenatal history insignificant. Perinatal history full-term baby with C-section. Birth weight was 3 kg. Birth cry was not present immediately. Postnatal history insignificant. These are developmental history. Developmental was delay. Past history, child parent noticed developmental delay since 1 year of age. Immediately, he took him to neurologist and CT scan shows early cerebral atrophy and developmental milestone was diagnosed. After that, child continued with physiotherapy sessions. AFO was recommended at 4.5 years of age to maintain foot position. On examination, these are tone assessment according to modified Ashworth scales, deep tendon reflexes, manual muscle testing, and range of motion, normal range of motion were present except dorsiflexion was restricted. Parental concern, his father complained that he is not maintaining proper balance during walk. His father complained that he is walking independently but difficulty in stair climbing. Sitting on a stool with the upper body relaxed and hand was placed on a stool, foot touch on ground, kneeling on bed with upper body slouched and hand supported on thigh, standing. Upper body was slouched, hand put on thigh, bilateral knee extended and left knee internally rotated, bilateral flat foot. Gait, walking with wearing static AFO, both knee flexion and internally rotated, flat foot and everted. Short-term goals are you will climb short height few stairs without support under supervision. He will play ball activity, catch and throw on ground with his friends. And long-term goals is he will participate in academic and sports activity as well. He will improve society participation.
Thank you, Kriti. Well, very well presented. Now I would like to observe you his gait, ma'am. Please observe. चल के बताओ. ये युग है क्या? हाँ, युग. आप चल के दिखाओ. ऐसे ऐसे चलकर आना. Please comment on his GMFCS. उसका वो वीडियो दिखाओ ना उसका. हाँ, उसका वो बहुत सारे वीडियोस दिखाओ. 1 मिनट. हाँ, आप चलते रहो यू, फिर सब मैम लोग आपको देख रहे हैं. जस्ट ऑब्जर्व हिज फुट, नी. Just appreciate his video. He's stair climbing with support. So what you observe? Yes, absolutely. He is GMFCS2. He has difficulty in climbing, but he can walk independently. About his gait, Prerna?
Ma'am, he is in crouch gait. Not anterior pelvic tilt is there. Hip flexion, knee flexion is there, and make panovalide.
Left TA is more tight than right. Yeah.
That is very important. Why I think Madam will discuss. Again, on those GMFCS, given that this is true. So, according to the recommendation, it should be over 6 years. But roughly, we can even assess, even if the child is 3 or 4 years of age, we can assess, we can have a rough idea about all your own assessment that okay, GMFCS 1 or 2 or 3, you can use it. It is not mandatory that you should not use it, I mean, for 6 years. Ideally, yes. But for your own assessment, you can have in mind, okay, just on looking at the child, you can say, okay, he's in GMFCS like that.
Yes,
So
yes,
that is very
absolutely. The standard GMFCS is given between 6 to 12 years. Now in 2001, I suppose extended and expanded and revised GMFCS has come, which comments on 2, 4 till 6 years. So that you can check on CanChild website, and you should really learn that, because GMFCS 5 grades we know, but this is about the child. We have seen that dystonic child, and Kriti has explained how GMFCS we have found out from that between age group of 2. So this is a new version of GMFCS. Sorry. About his
yeah.
Man can do it.
Okay. She's also a special educator. Ma'am, her mother is also special educator.
Acha. Now I want PGs to come forward. Mayuri or Prerna, somebody. Just try to help yourself, and anything you need, we are here.
Yog?
Yog.
नीचे उतरो अपने मन से. Very good.
We are just checking his flexors.
Yes, hamstring. He has hamstring tightness, and stadio is almost. He has full ham. He has almost all the range. Hamstring is okay, but still I'm feeling resistance.
About the foot, you can see cardio.
Okay.
Cardio at the foot.
R1. R1 is 90. And
R2 is plus 10.
Plus 10.
So what Prerna has examined his stadio at his ankle, but we have to really appreciate his midfoot break and the valgoid. So the connection between hind foot and forefoot is lost. So we may make mistake as a therapist when we are stretching him for dorsiflexion. So we may not touch tendoachelis, and it would work only on the upper part. So we have to correct this by dorsiflexion and inversion to take the foot into neutral, and then when I would stretch it, it would go in that way. So because of his medial weight bearing started initially, and then he subsequently developed that attitude, this mid-foot break has occurred, and that has given him more of his TA tightness. So though there is TA tightness, he is landing with the mid-foot break. Am I right, sir? And how to evaluate Sherwood?
Why it is important, why this point I specially mentioned, because when you get the child, many of the child, they are just lying either with the pediatrician or just with the surgeon or with the therapist. Why the teamwork is important? Because had this child would have been presented little earlier, and see what madam was telling, I think मागची लोक बसले त्यांना बऱ्याच लोकांना कळलं नाही what madam was saying. See, there is a tightness in the tendo Achilles, right? This is सगळ्यांना, everybody appreciating. So because of this tightness, the calcaneum is locked. Now, we being a human being, we have to bear weight on the calcaneum. God has made us to bear the weight on the calcaneum, and now the calcaneum is not touching to the ground. So what child will do in the compensation? He will break the foot in between, and the foot will go like that. Are you appreciating? So this is a compensatory mechanism by which the valgus deformity has happened. So when you get the child little earlier age group, you should try to use maximum your method so that you are able to get the unlocking of the calcaneum, either by stretching or whatever way. Now you are getting the child at this age, when already there is a locking of the calcaneum, already there is a contracture, and the foot is already breaking and going into the valgus posture, midfoot. So in this case, when you want to really stretch the TA, you have to take the foot into varus. Put your thumb into the head of the talus. This is the talus, right? So you put your thumb on the head of the talus, do the inversion, then only you will be able to stretch it and actually unlock the calcaneum. Otherwise, you won't, you will never. Many of the, even the planovalgus foot, many therapists you must be getting in your clinic, So you should tell your juniors that you have to first bring the calcaneum and the foot into the varus, and then only you are able to actually stretch the tendo Achilles. Otherwise, you will never. Okay. So even many of the flexible flat feet, they are flexible flat feet, and eventually because of the tightness or the contraction, the gastrocnemius, they develop the midfoot break, and they are actually the pathological flat feet. So in those cases, you have to stretch the TA by doing the inversion of the foot. It is very important, because I've seen so many cases the mistake is done. जैसे मैडम ने भी आपको मीनाक्षी मैडम ने बताया, the commonest mistake is we just keep on dorsiflexing. So the dorsiflexion should not be like that. This will never cause the unlocking of the calcaneum. So you have to do like this, and then only you have to stretch it. Okay, clear? And if this is not tackled, if this is not tackled, it will keep on going into valgus. And by that stage, it will reach to such an state, whatever even surgeries you do, but it will not be helpful. So the whole lateral column goes into short. So what we do, the Moskowitz procedure, where we actually lengthen the lateral column. But by that time, the bones have dearranged so much that even after surgical correction, you will not be able to get the foot with the arch. It is like that. Okay.
Orthosis. Now, planning about the orthosis for this child, he is using a simple AFO. So, what we really can incorporate is the valgoid strap or medial pulling strap that we can give him, so that
what madam is telling about, this strap is from here. So this strap, if it is from the middle aspect, from the inner aspect, so that can actually take the pull that talus inside, so that there's again.
So we can correct it with the orthosis with the correct strapping methods, which would take his foot to maximum neutral with the use of somewhat broad strap, and medial arch is already there. So correct planning of this orthosis would be again helpful for his proper alignment or proper base of support. The other part, you were examining the hamstring now. So he has very less of that hamstring. So apply TARDU when you see whether this is dynamic or static component. So if you see knee flexion more coming in, so from that point you can see. So just to comment on that part, so that it should be useful when you are planning to check with the TARDU and Ashworth scale.
Maybe this child, if you would have intervened a little earlier, maybe Botox or like something, so maybe we would have prevented this valvular amount of food. Right? So that is why it is important to Actually, periodical assessment by the surgeon, by the neurologist, by the occupational therapist, and by the physiotherapist. Why this is very important? Because it is not a question of only. Sometimes there is a fear. मेरे पास से patient कहीं और चला जाएगा. But I think that should not be your goal. One or two patients may go, but once the parents realize that this is a comprehensive approach which is required, it will give benefit to the child. We could have prevented this severe valgoid. It is like that, right?
My question would be, in due course of time, how this valgoid would come into picture, and what should be the planning as a therapist and as a orthopedic point of view?
Yeah, if we keep on, this deformity keep on increasing, eventually they will develop the very painful callosity on the head of the talus, and the navicular. And maybe that, and sometimes even the toes, they have a tendency to go into severe valgus. I'm not saying that is a primary cause, but that will add on to that to the toe to go into the severe valgoid posture. And then the rehabilitation will be very difficult, because whatever you develop over here, ultimately the sensation of the foot is very important. The weight bearing is very important. If that is not proper, whatever you do upstairs, it is not going to help to much extent. And that is why this correction is very important. We understand that there are a lot of problems like finances in our country. So not every child we can inject the Botox, in the early stages. But at least we can increase the intense therapy protocol to just work on that. Not at this stage when there are already contractures which has been developed.
So from therapy point of view, how you would be working for his active inversion? So we as a therapist, now orthosis is done, orthopedic part is done. Now it's in our hand how we really going to strengthen or prevent his deformity going further. So for that context, any treatment strategies coming in your mind? Prerna, Mayuri, Alpana, you want to comment? Yeah.
Yeah, we can use different surfaces. Then we can use, as I said, footwear when we incorporate AFOs. Then active inversion in that, yeah, active inversion cases. I don't know, actually, I'm not sure, because we also don't use stimulation so often because there's not so much of evidence, but still that functional electrical stimulation could be one of the options. I don't know, because yeah, we could use that. We do. But then again, there's less evidence on that. But that's one of the suggested treatment modalities. Yeah, but that really needs a lot of precision when we are using the type of current. Yeah, absolutely. Yeah.
So we will first need to stabilize the foot or bring it into the neutral position and then apply the
Yes, absolutely.
And ma'am,
the muscle is rehabilitated onto a normal pose, not an abnormal pose.
And ma'am, post Botox, it will be more helpful.
Yeah, but then we can also start with Botox because it will get that alignment normal. Will stimulate to normal movement.
Oh, sorry. Yeah, I would like to just add one point what Umanjali ma'am and Prerna has commented. So I may work, if I have to work very actively for his dorsiflexors and inverters, because he is showing some contraction and I want to use it. Maybe one simple strategy which is coming here at this moment in my mind, that he is sitting on a higher surface. This ball is bit higher for me, but maybe propelling the ball and asking him just asking, hey, pie worker, beta, up, keep it up, up. So this way you can ask him to push a ball, making foot more neutral with your thumb, as sir has advised, and push the ball, la dhakka maar, and pie worker. So I am trying to initiate this. Same way, I have to initiate his inverters. The ball la ikade didi kade घेऊन जाशील. असा घेऊन जाशील. हां, असं कर. असा ball la धक्का मार. He is using inverters. कर. But presently he is not in correct alignment. Please mind that he is on a surface which is giving him more of kyphosis. So this is lack of equipment at this moment, but he should be on a flat 90-90 surface with, I don't want this much of hip flexion also, right? So this should be appropriately at this height, the ball should be. So bolster should be used in this plane then. For inversion, this would go this way. For dorsiflexion, this would go this way. See, if I have to use proper, right? Prerna, asas म्हणत होती ना तू. For dorsiflexion, you can use this. Yeah. Up, 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 up. Right? Up.
Yes.
And I can change this because I want inversion. So I would ask him to roll the bolster inward. So even that is possible. So this is one of the active exercise and which we can really work and ask parents to do at home because only 10-15 repetitions may not help. So he has to learn it, right?
I mean, keeping some wedge or something on the side and then making squat.
Yeah,
so
yeah.
that
What madam is trying to tell us that stand up. We have एक मिनट याला पकड़ प्रेरणा असं. I have just this equipment maybe. I can use just this to make this neutral.
Yes.
Presently, this is very crude method. It should be, he is properly knocking. Just to make this neutral, what madam is trying to say is this, to make this, yeah, even at this point, bilaterally, as a hold, and then slowly he would go down.
Yes,
Am I right, ma'am?
yes.
Yes. थोड़ा सा खाली बस.
Thoda means you have to raise
Bus.
the medial
So this
side.
would be mid-range
Medial
work,
support.
standing to squatting, taking care with a small wedge or small firm surface, not a sponge or something.
Also,
Something.
yeah. Also, what we can do is we can ask him to pick up marbles with the toes. Okay. So that he can just pick it up and place it in him. So that also gives the inner with the great toe and the second toe. You can ask the patient to pick up the marbles. We can change the size of the marbles. Or initially you can take a bigger one, then go to smaller ones. Also, you can ask the child to. You can keep a cloth or any even the bed sheet and ask him to, bring it towards him. मतलब उसको ऐसे toes से पकड़ के उसको अपनी तरफ लाइए. So all the intrinsic muscle exercises will also improve the. What do you say, ma'am?
To some extent, definitely it would help us.
Better work on the wedge. Will it going to be a help?
Wedge, then when he is
Wedge, I
taken
mean,
on a wedge.
like this wedge.
वो अपना
45 degree angle में wedge है.
wedge रहता है.
हाँ.
On
So
that also we can work.
wedge track रहता है, तो we can ask the child to walk on that track. So that will help the child to.
There's a 45 degree angle.
And
then
so here foot goes into correction itself on the wedge.
yeah.
Okay. So inclined surface of the
Inclined
wedge.
surface. Two inclined surface joined together.
Two inclined surfaces joined together at a 45 degree angle. And then the patient can place either foot on this side and then you can walk.
Okay, got it.
Sand walking also is a very
Sand walking
good,
is also best
activity.
option.
Yeah.
Sand walking, is it possible to correct the deformity? No, it's not possible to correct the deformity, but because in sand the child will require more of
Initially, we will train the child to walk on that. We will help the child to properly place the foot.
Deformity is in bone level. We are working on muscle level. Yeah, but sand walking won't give that support.
To some extent, maybe sand walking can be come into the long-term program.
Somewhat support. Go for sand.
Sand. Yes. With the correction, my taping, yeah, we can go.
So onto a socks, because socks is going to be like flexible. Then we can give him, with that we can make him walk on a surface which is sand. We can also make him walk up a hill. We can also make him walk down the hill, but with a maybe not an AFO, because AFO में वो अगर medial arch लगाए तो वो पूरा उसका बाकी कंट्रोल पूरा नहीं आ पाता है. सो एक सॉक्स में अगर अंदर हम कुछ प्लेस कर पाए, उसको चिपका के थोड़ा जैसा ये जेल का जो मीडियल आर्च आता है.
Ma'am, but if it is increasing on wet bearing, so we have to really check whether it is giving correction. Socks may
No,
we
only
use-
after, no. Why I'm trying to say a socks, this is what I'm trying to say is we are going to try it. I'm not
Yeah,
saying
yeah.
this is an option.
Yeah.
Why? Because if we are giving it in a socks, his rest of the foot is there to act. When
Yeah,
we are
yeah.
giving him an AFO, और अगर firm surface पे हम उसको
Yeah.
middle arch दे रहे हैं, तो उसको स्कोप ही नहीं है कहीं पे कुछ एक्टिविटी फूट का करने
Yeah,
के
yeah,
लिए.
absolutely.
मसल्स एक्टिविटी जो हम करना चाह रहे हैं वो नहीं हो
Correct,
रहा है.
correct.
विदाउट द आर्च वो फॉल हो जा रहा है, एंड जो हम करना चाह रहे हैं वो हो नहीं पा रहा है.
Correct, correct.
So rest of the this
Foot
has
should
to
be activated
that
equally.
is why a socks with a medial arch, जिसमें
Yeah.
हम, can we do this? If we are able to do
Yeah,
this, it
we have
will
to
give,
check it, and then
this
we
will be
can-
a very good option
ठीक है.
for. This is basically a community based rehab which we really do,
Yeah, yeah, yeah.
isn't it?
So for the people who cannot really afford, this is the madam has advised on a CBR level how the people at low villages should be advised by the therapist when these people go for camp and then they don't have anybody. So these people can really work on that aspect. So that is one strategy we want to try on this wedge. I haven't tried it. I am just going to try. What ma'am is trying to say is he should walk like this. So his weight bearing would go on a lateral aspect. So such two parallel wedges would be helpful, keeping them at 45 degrees. Right, Deepak? Barobar hai?
Same way.
Yeah.
You have to place here.
Yeah,
Then
yeah.
the child has to walk on this. Right.
Yeah, yeah. Pakad beta, एक minute. अच्छा उभा रहा. Like suppose we are thinking about his left and right here there is some other
Yes.
leg. And then he is on this inclined surface and his weight bearing.
That too have to check the weight bearing which is on which side.
Sponge bag. We have to use wooden one. We have to
Yes,
use
we have to
wooden bag.
check where is the weight bearing, where is the weight shift of the patient. Yes.
Right, yes, yes,
Ma'am, in any case, we have to support him with the wedge also or on the bolster also. We have to give him support. Patient won't be able to walk on his own. Yes, yes, yes. हाँ.
That will not do.
No.
Your pillow.
I think, ma'am, he needs a more वो ज़्यादा angle चाहिए उसे. Yes. Exercises on lateral side or maybe his left side would also help him.
Yeah, firm base is very important. And wooden surface will be the best.
Yeah, weight shifting
works
by
on
giving
flat foot
activities
also.
on his lateral side, that would also help him.
It is also works on flat. Yeah. Anyway, we have to keep thinking of how we are going to.
Yes, every patient would act differently and
Yeah.
every biomechanics would be different for every patient. युग तुला मजा आली का? तुला मजा नाही आली ना? आली?
Summarize. Okay. Okay.
Okay. Now this child is pretty much independent by himself because he's walking. But the things we have to need to understand is about the corrections of the deformities which are setting in, and at the same time the posture. So like now when he's sitting over there, he is taking weight on both the hands. And again, as I say earlier also, that weights hands are not free to do the activity. So what we need to do is over here is, can anybody tell me at this point what you need to do more on? Trunk control, isn't it? Trunk control is important. और अभी उसको एक proper seating arrangement for like a chair in which the child can have an erect posture so that he can use the hands also. Or always, even if the child is diplegic, you have to see the hands because some amount of upper extremity functions are compromised. And obviously, if the cognitive level is good, then we can start with the schooling of the child, and he can go ahead with all his education without any hindrance, I believe. Is he toilet trained? Toilet trained hai bacha? Huh? So he tells about the thing and और clean करता है खुद से सब करता है
खुद से वो टॉयलेट क्लीन नहीं कर पाता
Clean
we
नहीं
need
कर
to
पाता
help
है।
actually
Okay, okay.
by standing he does all
अच्छा
these things,
he
yeah.
cannot squat
No,
है ना
yeah.
तो वो भी एक थोड़ा concern रहेगा when he is going to school तो
Before some years he was able to sit properly over there in
Okay.
toilet, but I don't know what's happened after. Actually, he fell down actually two
अच्छा,
times over
okay,
there, so
okay,
that's
that
why he
must
had
be the
fear.
fear,
Yeah,
right.
he's having fear about
Fear
that one.
about
Yeah.
it. Okay, okay. So participation of the child in all the school activities like the sports activities, his classroom activities, that will be our next goal of concern. And we have to see, is he enrolled in any school?
Yeah, yeah. He's in KG2 actually.
Acha,
He does
okay.
his all the homework properly.
Properly,
Yeah, yeah.
okay,
He's
good.
active in all the things.
Yeah, he needs a big round of applause. He's doing
And he
online.
promptly answers of every question actually.
Okay,
If you
good,
ask
good.
something him, he actually promptly give answer. Not my daughter actually, but he gives.
Okay, so that's very encouraging, and we wish you all the very best, Yog. Thank you. Thank you. You're welcome.
Okay. Is it? Fine.
I think at this moment the child looks quite intelligent the way the mother has put it up. So to such a child, definitely as a therapist, our concern is, as you said, the difficulty that which he has is climbing and coming down the stairs. So most important is climbing up, coming downstairs, and as we suggested, thoda uska the foot needs to be taken care of. Once the foot is taken care of, his balance above also will improve, because one of the major concerns is foot as well. So alterations into the footwears and training should help him gaining a proper ground onto the school and maneuvering himself into a better way. Plus a strengthening. Yeah. That's what we are discussing about. And that's what we want to train him.
Okay. Okay, ma'am. Okay.
Yeah.
Okay.
Schooling is most important.
From the foot correction point of view, that belt would be helpful. Exercises twice, thrice, जितना आप repeat कर सकते हैं, and it is not you doing. He should understand because cognitively the child is sharp.
Yeah.
So we can train him that he has to perform his duties of exercising.
Actually, sometimes if he
And-
forget, actually he does himself.
Yeah,
Mom,
yeah.
you just
So-
forgot. I just wanted to exercise. Okay.
So that
That
motivation
properly,
part.
Pie pude kar.
And one part which I had planned for him, absolutely, I support Umanjali ma'am, that we have to plan as a therapist is get obstacle training. His mother concern is stair climbing. So its preparation would start with obstacle training, keeping different objects of different height and different direction, and walking in that constrained area would give him a motor planning. Motor planning may not be an issue, just negotiating the different places and different height, and that should be the part of therapy instead of doing other things. So maybe on daily basis obstacle training, and on alternate basis the conventional strength training would help him so that he gets good strength to cross the obstacles. So that would be one more suggestion from therapist point of view.
But the strength training part, like you can try with the TheraBand against his abdominal or little lower level, and then ask him to walk against that, against the resistance of the TheraBand. So that will help to improve the crouching also, and it will direct posture uska aayega. Or at this stage, if you start, it will be really helpful. In the next 2-3 months, you may see the results also.
Right. So what madam is trying to give. Huh. So this hypertech extension could be the reason of TA tightness, na sir? Yeah. 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 Yeah.
So he will need some intervention.
Yeah.
We are just enrolled. Big gap of around 1.5 to 2 years for many of the children now. Because that is the topic of this discussion of today's workshop. So I think many of this, they have gone into contractures because they could not receive the therapy. So once he is on the therapy, so I'm not making any hurry decision for any intervention at this stage, but he is going to require, no doubt about it. Namita madam, you want to add something? Yeah, you already spoken. Yeah.
For that knee hyperextension, also I have tried one belt on my level, which has a thigh band and a calf band and a crisscross behind, which is sturdy. So which one goes, I can demonstrate on him. Even that works for mild to moderate deformities. The one band comes here, and that band is being connected by cross belt, which is stiff to keep back like this. The taping technique one. So the taping would be a dynamic support. This would be a static strong support. So I have tried few cases that sometime in my mind came, and I just wanted to work for knee hyperextension. So in my experience, I could work for mild cases of knee hyperextension for that belt, which I use. I can ask some orthotists to make, and they make according to me. And that alters the alignment. No. It doesn't. It is a very small piece which just controls that hyperextension coming in stance space. So it has to be very mild, but ma'am, absolutely it has to be very mild. If it beyond that also, it can go back. So if the back support, I don't have right now the belt out of the picture. If the back support is very strong, we can stop him. Exactly that area. And then I did so many trial and error with that. So for few cases I could do that. For few cases I couldn't do that. Yeah, you want to take the tibia forward. With that padding, you are trying to take the tibia forward, and that would give him some flexion. So here also we are trying to give some flexion. You are absolutely.
In adult cases, what we tried to give the knee range of motion or long knee brace. In that, we can restrict the hyperextension, and we wanted to work on certain. That too, we don't want too heavy weight. Otherwise, that plastic thing would.
We have to really think.
Yes.
They are emerging with their muscle power. So too much of bracing also.
Yes. No, it's a dynamic orthosis. It's a dynamic brace. Yes. Yes.
You are right on that.
Yes.
So one you change at one other joint has to compensate. And what compensation the child come up with, we don't know.
So it's just a trial and error method with that.
Absolutely. Many times it's a trial. With me, I am putting myself so many times wrong, and then trying with some new ideas. So it is your own trial and error which helps you.
Because in adults, the control is good. Whatever they have, it is fixed, whether it is 1 year, 2 year, 3 months, 4 months. He's already undergoing therapy. So he is already emerging with his, as madam has said, emerging with his exercises. So anything that which we give has to be monitored on a day-to-day basis. Because today what is right for him, tomorrow that may not be right for him in a week's time or 15 days. So that's very tricky with these kids, I think.
So should I give take-home message?
Yeah.
So at the end of this workshop, which was prime importance of this conference because this was offline. So the objective of our workshop mainly was to emphasize the therapist and surgical perspective on cases. So the cases we opted were all unique and they gave so much of learning by simple points. Even sir's demonstration was so fruitful that we could really imagine what a therapist can do when the surgeon goes inside and what exactly we have to do. So post-care plan, immediate, and after we had two cases. One was 1 year post-op and one would be fresh post-op. The post-op care, how judiciously you have to be very careful in planning and explaining about the cases. One case about the choice of equipment and the transitions we need to encourage apart from the daily routine therapy. And one case about the orthosis, the type of adjuncts we are using. So to sum up, as a therapist, always try to come on a page with the rehab team so that your message is very clear to your colleagues or your orthopedic person or your orthotist, what you want to see. So for that matter, we have to be very strong with our own assessment, and our own assessment should go in every 15 days. You have to assess and reassess, and again, because every time there are changes happening, especially with the 16 months baby. Early intervention needs lot of again and again they're handling at home, handling in the clinic. So assessment, reassessment, and why I am doing therapy. Ask always or print that sentence in your clinic. Why I am doing TA stretching, why I am doing this exercise, why I am doing this exercise. Always ask yourself so that your next generation would ask you more questions and you will be more answerable. Otherwise, you just give them guidance. Am I right, ma'am?
Very rightly said by madam. It is very necessary that you ask these questions. The 6 honest serving men, which Dina Gardina always tells us. So it's very mandatory that we carry them along with us whenever we are assessing and whenever we are treating our patient. And this was also very good that their next generation needs to come up with more questions. And I would request, sir, because quite a lot of students have come late, can we show them the surgical procedures? Because can we repeat that?
We have
Okay, we have
recorded
already
link.
put up. Okay.
Yeah, so I think that link we can give them because I think 1 o'clock they are going to start the main conference program again. So we have a time limitations.
Okay,
I wish that.
so all of you have the link already. Open it up because that was the most important part for which I had called you up at 8 o'clock in the morning. So you missed a very important part, but go to the link and go through the surgery procedures.
Probably we'll form a group of all the delegates today, and then whatever those who couldn't access, we can share the link.
That would be good. That would be
So
good. Yeah.
I request before, first of all, any more questions or anything else, or can we just end it? We have circulated the feedback forms. I request all of you to kindly fill up, send your suggestions, give us the inputs, and please leave the forms before you disperse.
I would just like to speak a few words. Today was a very dynamic session, very good session. We could learn so many things. It was a real knowledge feast. I mean, as a therapist, when we take up a patient, inputs from the other therapist, they mean so much. Sometimes we miss so many points we miss, and then we learn at a place like this workshop. So definitely we are going home from here enlightened with so many new techniques. And as a therapist, I think, yes, we have definitely evolved today. So thank you for the workshop. Thank you, sir.
I guess it
And
was
thank you to all the learned therapists who have been over here imparting so much of knowledge and giving us so much of knowledge. Thank you.
Yeah, just adding to the Manjali madam's discussion, I think those who are budding therapists, I think it is very important take-home message other than clinical message what Meenakshi madam is going to tell you, that we have to always work as a team. You know, that is the best message from this today's workshop, that you have to always work as a team. No matter however big therapist you are, no matter however big occupational therapist or surgeon or a neurologist you are, but you have to work as a team because we want to ultimately give result to this child. Yeah. So always Send the patient to your colleagues, have their regular evaluation, maybe a neurologist, maybe neurosurgeon, maybe a pediatric orthopedic surgeon, maybe a orthotist, maybe a occupational therapist, or maybe a speech therapist. Just have the regular evaluation by them, because everybody has a very important role to play in cerebral palsy. It is a very, very important, right? And in fact, I was discussing with Umanjali madam and Sophia madam and Meenakshi madam that we should every year we should plan some kind of a good academical session where maybe 30 people are sufficient for us. If they learn, 30 people even good, go with a good, yeah, yes. Monthly once I think is not possible for anyone, but at least, yeah, we have a good association आप लोगों का. Absolutely. So we have a good pediatric therapy and neurotherapy group which is there. So we have already conducted such kind of workshop. I think this is the 5th workshop we are conducting, if I'm not wrong. So I wish we could continue with this, but I think we need more participation. Today's participation, I personally feel, was little less. Maybe whatever people are here, they will go with good message. I think that is sufficient. So Meenakshi madam, please, you just summarize. You want to add something, and then vote of thanks by Alpana. I think that is because we have to end by 1 o'clock. Okay, so Alpana, please.
I must say that this was a very interesting workshop, and truly it was interesting because it was a multidisciplinary interactive session. So that was the highlight of it. And at the outset, I would like to thank COMHAD and BAPIO for giving us this opportunity to organize this workshop. Secondly, Dr. Viraj Chingadi sir and his foundation NNM, who took the initiative and took all the efforts to give us a platform where we could share. And definitely all the learned people, my seniors, my colleagues, Dr. Manjali ma'am, Dr. Sophia ma'am, Dr. Meenakshi ma'am, Deepak, Prerna, Amita, Tejaswini, you people have made it very interesting. You have contributed. And I think being multidisciplinary helped us because each one had his own contribution. So I think that kept the ball rolling. All the students who are enthusiastic and took time out to attend this, and please spread the message. And last but not the least, I think the staff of Pravira Hospital, who have toiled this whole week to give us a very comfortable, smooth outgoing of this workshop. And again, I must not forget the patients and the parents, because it's because of them that we are able to, keep learning things. So I thank all of them. Yes, audiovisual. Thank you so much. Yeah, this is the great example how technology can take us to different levels. So thank you, Yash Audiology.
Last but not the least, I would like to just add one. Am I audible?
Yes.
One word. Thanks to Alpana and Krati for enthusiastically working for patients and workshop. And thank you, sir and madam, for giving me this opportunity to be part of your workshop. So I'm very thankful to you. Thank you.
From the last point is most important. We want suggestions for future workshops.
Yes. Sophia madam is suggesting that maybe for upper limbs we can have a workshop on botulinum toxin or like something. So maybe we'll work on that. Ideally, the previous workshops, whatever we have conducted, were full day workshops. So morning used to be the demonstration and then cases, and the whole day we used to discuss the cases. But here we have time limitations because we have to 1 o'clock, they have to start the main conference. So we have time limitations. Maybe we can keep a full day workshop next time with therapy association and all medical colleges, and combinedly we can have the full day workshop like that. And I'm really thankful to all delegates. In spite of COVID, you have gathered in such a large number. Thank you so much for being here. I will request you to please come and join for the group photograph. It is possible. आएगा group photograph शक्य है क्या? Yeah.
नाही मी ग्रुप फोटो घेऊन मग करा ग्रुप फोटो घ्या
ते तिकडे जाईल.
Good morning, Dr. Patil.
Yeah, good morning, sir. Good
Hi,
morning.
good morning. Good morning.
Good morning, Veena. Good
Yeah.
to hear from you. Arvind Shah here from London.
Hello, good morning, Dr.
Good morning, Bodankar sir.
How are you? Good morning.
Bodankar sir, I am audible.
Yeah, you are audible.
Okay.
Morning, Uday sir.
Good morning. How are you?
Morning,
I'm
everybody.
fine. Very good. Good to hear you.
Regard to Madam Padke.
Good morning, Dr. Bodankar, Dr. Patil, Mr. Mehta, Dr. R.J. Patil. Namaskar.
Namaskar, sir.
And all of you all.
Yeah.
Good afternoon,
morning,
everybody.
Good morning, Dr. Padke.
Good afternoon, Pratita.
I'm BJ8. I will
Yes,
use a D.
I remember, of course.
Arvind Shah, nice to
Davolkar was
see you.
Dean.
Correct, correct.
Good to see you.
Very pleased to meet you too. Good morning, Dr. Pramila Menon.
It's raining there, Madam Padke, Madam, in Mumbai.
नाही हो पण इतकं ढगाळ आहे काय सांगावं.
I like that. Terrible.
हो ना.
Miserable.
It's cloudy.
Actually, it is bright in London. London is not bad.
Really? That's what.
Cold but nice. It's a clear sky.
इकडे नागपूरला खूप थंडी आहे मॅडम आज.
हो आता पुढची कॉन्फरन्स लंडन मध्येच घ्या.
You're most welcome, Dr. You're most welcome. Love to see you.
Uday and Yashwan will decide.
I thought you're Punekar. Why you moved?
I am a Punekar, पण माझ्या दोघी मुली लंडनला आणि साऊथहॅम्प्टनला आहेत म्हणून मी तिकडेच असते.
Oh wow! So we must catch up certainly.
Yeah.
Oh, lovely.
Good morning, Arvind Shah.
Good morning, Uday sir. Good to see you. Good to hear your voice.
Yeah, after a gap, yeah.
After a gap, I think we need to restart.
Yeah, thank you, thank you. Regard to Madam Padke. Okay.
Dr. Yashwant Patil is there, sir.
I am very well here.
Yeah. Good morning, sir. Good morning.
Good morning.
Morning, Manish.
Morning.
Morning, Biju sir.
Good morning, Arvindji.
Morning, Manish.
Morning.
Morning, everyone.
Good morning, Biju.
Morning.
Patil sir, let me know when to start. Okay.
In just
My
1
watch
minute we
is
can.
1 p.m.
Yes, we can start at 1.
Start. Can
Yes.
start. Arjun? Radhika?
Yes, sir.
Time is there now. We should start.
Yes.
We should start, sir.
Yes,
Yeah,
it's
Should
1.
we start? Am I audible?
Yes, sir, you are audible.
Okay, fine.
Please continue.
Yeah. Good afternoon. Myself, Dr. R.J. Patil, in charge of this session, vaccinology. And I welcome all of you on this very important session on vaccinology. And first of all, I would like to thank President of the COMHAD, Dr. Yashwant Patil, sir, Dr. Uday Bodankar, sir. He is the Executive Director. Yesterday, he received a Lifetime Achievement Award. Congratulations, you, sir. Dr. Murdula Fatke, Madam, Advisor, COMHAD. Dr. Rawat, sir, he is ex-HOD, Pediatrics Department of GMC, Nagpur. Dr. Ramesh Mehta, President of the BAPO UK, and Dr. Prajakta Kaduskar, Co-Organizing Secretary, COMHAD. Before starting this session, I call upon Dr. Yashwant Patil, sir, to give his welcome address. Sir, Patil, sir.
you, Arjun. Good morning, good afternoon to all on the virtual platform. On behalf of the organizing committee of International Conference of COMHAD and Jeffrey UK 2021, I welcome you all for this August virtual gathering of third and final day of the conference. I recognize the very well presence of our Executive Director, Dr. Uday Bodankar sir, respected Madam Phadke, Scientific Chairperson of this conference, Dr. Ramesh Mehta, Dr. B. Simon, Dr. Arvind Shah, who is the Treasurer of BPO and our Chairperson of today's session, and Dr. Rawat sir, and all other respected dignitaries and esteemed delegates. Yesterday we had a wonderful scientific session, a good attendance, and we expect today also the same. In today's program, we will do 3 scientific sessions, 1 panel discussion, and 1 oration. Out of these 3 scientific sessions, first will be on vaccinology, sponsored by Serum Institute of India, Pune. Hats up to them for the sponsorship for the COMHAD. Followed by, it will be a late Dr. V.R. Pandurangi oration, which will be delivered by none other than our organizing chairperson and vice president of COMHAD and president BPO, Dr. Ramesh Mehta sir. It will be followed by panel discussion on recent advances in specially challenged children. Then will be followed by special BPO session, and last will be a mixed session. So for this session, our learned speakers are going to deliberate various topics related to the theme of this conference. I request you, please enjoy this scientific feast, update your knowledge for the welfare of community, especially for the special community. Thank you very much.
Thank you, Dr. Patil sir. Now I request Dr. Uday Bodankar sir. He's a executive director of the COMHAD, to address the gathering. Bodankar sir.
Ask them to unmute. Hello.
You are audible.
Hello.
Audible, sir. You are audible, sir.
Yeah, I'm joining from my mobile, because in PC they are not allowing me to unmute. Anyway, good morning to all of you. I will not take much time. With regard to Madam Phadke, Arvind Shah, and Biju Simon, Ramesh Mehta, I want to welcome Dr. Yashan Patil, RG Patil, Kayata Karuskar, everybody, Kamila Menon, for this very important session. Manish Parikh is there, Shivangi Banwal, almost all the faculty are there, chairpersons are there. Without wasting much time, we are going to have an academic feast related to vaccinology, which is very important subject to our art. So, without wasting, I welcome respected faculty and chairperson. Over to you, Dr. Patil.
Yeah, thank you, sir. Thank you. May I invite Dr. Ramesh Mehta, sir? He is the president of the BPO, to give his welcome address. Welcome, sir.
Hello, good morning, everybody.
Good morning.
7:30 in the morning in UK.
Good morning.
It is still very cold and cloudy and dark, but welcome to Sunshine of India. On behalf of BPO, I'm absolutely delighted to have this session today. And I know this is going to be very exciting and informative session. All the sessions yesterday were absolutely brilliant. And all our people in UK enjoyed it, and I'm sure friends all over the globe had good time. So welcome again, and thank you very much. Look forward to the vaccination.
Thank you, sir. Thank you. As all of you know, we are living in the corona since 2 years, and there are 2 ways to avoid this corona infection. One is to follow the corona appropriate behavior, and second is the vaccinology. So we are having important topics on vaccinology, how we should follow the vaccination schedule, and how vaccines are important to protect from the diseases. So we are having the eminent chairpersons to chair this session. Dr. Arvind Shah, he's the best at UK. He's a treasurer of BPO. And Dr. Anil Kurane, he's a professor and head of the departments of DY Medical College, Kolhapur. And he was a past chairperson of National COMHAD at Kolhapur. And third eminent personality is Dr. G.I.G. Rao. He's a leading pediatrician at Bangalore. He was a past national president of COMHAD, was an originating chairperson of COMHAD International 2018, and he is a chief of advisory committee COMHAD India chapter. I welcome all the three chairpersons.
Thank you.
Now I hand over the further proceeding to all the chairpersons. Welcome you, sir. Dr. Anil Kurane, Dr. Arvind Shah, and Dr. G.I.G. Rao. They will chair this session.
Thank you so much. It's a privilege to be on this platform with very eminent people. And I think I'm grateful to COMHAD for inviting me to chair the session with esteemed colleagues from India. I think we are at the crossroad where, the Omicron infection variant is causing havoc all over world. And I think this is very appropriate and very important session in terms of how we go forward, and vaccine plays major role. So I think I will introduce the first speaker, or Dr. R.J. Patel going to introduce first speaker.
Dr. Fadila Madam.
So it is my great pleasure to introduce Dr. Mudula Fadke, Scientific Chairperson for International Conference for COMRAD 2021. She's Senior Advisor for NMH UNICEF COMRAD. And she's also Consultant UNICEF Independent Director for Serum Institute of India, Pune. And I have a more connection with her because she used to be Dean of BJ Medical College, where I graduated from. So, and she's Punekar. So welcome you, madam, and look forward for your session. Thank you so much.
Good morning, good afternoon, all of you. Honorable Chairperson for today's session on vaccines, Dr. Arvind Shah, Dr. Kurane, Dr. R.G. Patil. It is so nice that we are gathering again today on the third and the ultimate day of the most wonderful conference of COMHAD and BPO in conjunction with the UNICEF and DMER and IAP and so many fora, that this is a multi-platform, multi-tasked, multi-sectoral conference that Dr. Uday Bodankar and Dr. Yashwant Patil have very jointly and very ably handled. I must put on record Dr. Yashwant Patil and Dr. Bodankar's great work. They toiled day and night, and we are happy to say that Dr. Yashwant Patil conferred, and the COMHAD and BPO conferred, the Lifetime Achievement Award, very rightly so, on Dr. Uday Bodankar. He receives special congratulations from all of us. Now I begin taking the thread of Dr. Arvind Shah telling us that Omicron is going to make us feel we don't know still, we are really at crossroads. Today, COVID vaccines is forming the backbone. Why is it so? We are just wondering if Omicron is going to add fuel to the fire of COVID scenario, or they are just going to be two small wood chips. Now, time is going to tell us in the next 2-3 weeks, but we are all here along with my MPH nutrition students to talk on COVID vaccines. Could I have the next slide, please? Next slide, please. Yeah. COVID-19 vaccines are the biggest discovery of the 21st century. And I would think without them, things would have been absolutely difficult for the world to go ahead. And why do I say that? The lockdowns, the job losses, the supply chain distribution, and all that was making things really difficult when the pandemic started. But two things that survived the whole humanity, besides being human, is CAB and JAB. What do I mean by CAB and JAB? One thing is the COVID appropriate behavior, that is CAB, with masking, social distancing, and use of sanitizer. So one CAB, and second one is the JAB, that is the COVID vaccines. And because of the enormous work of the scientists in the last 1 year, from 2019 onwards, that vaccines were discovered. And how many vaccines got discovered? Let me say that 173 vaccines are in the preclinical stages of development. We are talking only of COVID vaccines. Well, today we are also going to have a session on routine vaccines, because we know that in COVID times, the normal DPT, the BCG, the polio, the penta, and the hexavalent, all vaccines have gone for a toss. So in this conference, in COMHAD conference, let us focus on vaccinology. And one such vaccine is the COVID vaccine. And one can imagine that 173 vaccines in preclinical stages, 64 vaccines in clinical evaluation as of today, and 8 COVID vaccines are fully developed and are being used in the world from December 2020 onwards. The first vaccine of those is the Pfizer-BioNTech vaccine. The second one is the Moderna vaccine, both being used in the USA and UK. The third one is the AstraZeneca or the Oxford vaccine, developed and being used in UK. And through AstraZeneca, the Serum Institute of India has taken the vaccine under the name of Covishield, and we are using that in India. Can I have the next slide, please? So these are the first 4 vaccines, the Moderna, the Pfizer, the AstraZeneca, and the Covishield. Soon after that, Covaxin was developed by the government of India under Bharat Biotech, a private company, and that came into being, that is Covaxin. The next vaccine is the Sputnik from Russia. Then we have the Johnson & Johnson vaccine from USA, Sinovac, which is being used in China. And now in India, in Pune, Mumbai, and Nagpur, Zykov-D trials are going on. The Zydus Cadila Ahmedabad vaccine made by Zydus Cadila is the Zykov-D vaccine. And then we have the Covovax, prepared by the Serum Institute of India. They are on the verge of completion of phase 3 trials, and soon they will get EUA, that is Emergency Use Authorization. So these are the most important 8 vaccines that we have, the biggest armamentarium at our disposal to tackle COVID today. The next slide, please. And what have we been doing in the last 1 year? Let us know a little bit on how the vaccines have generally got developed and how they got developed right from Jenner's experience or Jenner's experiments that he did. And he performed those experiments, and we realized that cowpox vaccine helped in smallpox. We eradicated that, polio, and so on and so forth. So we have various types of vaccines. One of them is the inactivated vaccine or the whole virion vaccine. The virus, the whole virus is killed, or we can say the whole cell virion of the virus, inactivated virus. The second one is the live attenuated virus. The virus is alive, but it has been weakened. The classical example is measles vaccine. Then we have what is called as viral vector vaccines. Simple enough to understand. We take a vector. The vector can be another virus, like say the chimpanzee adenovirus. And on that vector, you put the spike protein gene of the COVID virus, and you make that whole assembly replication deficient, means it can't multiply fast. And then only the spike protein is released from the virus, and our body reacts to it, and antibodies are developed. Or it can be a completely replication competent virus. That means the adenovirus that we are using as a vector can be replication competent, but we don't have those scenarios. So the only viral vector vaccine we know of on chimpanzee adenovirus is of course the AstraZeneca or the Oxford vaccine, or in India, the Covishield vaccine. And then we have the mRNA vaccine, the DNA vaccine, and the recombinant protein vaccine. mRNA vaccines are the Pfizer and the Moderna, well known to all of us. So it is the messenger RNA, which is going to carry the glycoproteinated nanoparticled envelope. And the virus particle goes on, the spike protein goes on multiplying. And then the DNA virus vaccine, which is the ZyCoV-D, and the recombinant protein virus vaccine, which is made now in India by Biological Evans, and the Covovax also by the Serum Institute. So 2 vaccines going on in India today, 2 vaccines in the US mainly, and 2 vaccines in the UK. That is the scenario. All over the world, all these vaccines are being used. And one can remember or imagine that there is a COVAX facility by the WHO, wherein all these vaccines are donated by various governments, and that is supplied to the poorer countries. And we know that unless all people in the world, the eligible people, are vaccinated, nobody is safe. And that's how probably Omicron has got generated. The next slide, please. So these are the type of vaccines that we know of. And let us see one by one which vaccines would be good and what is the difference between these two. I'm going to restrict myself to India in particular because the next speakers are going to talk on the other vaccines. So Pfizer-BioNTech vaccine, it's interesting to know. I'm quite aware of the fact that these 2 scientists, husband and wife, Sahin and Turesi, they were the ones who developed this vaccine in conjunction with Pfizer's from the USA and Germany, the BioNTech company. And what they did was just take the messenger RNA and put a lipid nanoparticle coating on it and put the spike protein of the coronavirus into it. And what happens? The body reacts to it. Now, we may all the time get worried. What is going to happen to the messenger RNA? Because those who are pediatricians would think in this audience, that messenger RNA will go back into the DNA and the DNA in the cell will be destroyed, or something will happen, or a mutation will occur. Now, it's important to remember that this messenger RNA does not get incorporated into the DNA because there is no reverse transcriptase enzyme in us, and we are very, very safe. So the human race is safe and nothing happens with the messenger RNA as the vaccine. And what did Pfizer people do? They conducted a wonderful clinical trial on 43,538 patients, and they found that the vaccine efficacy is 95%. Here we have to remember the difference between vaccine efficacy and vaccine effectiveness. Vaccine efficacy is in controlled clinical trials, and vaccine effectiveness occurs in real life. That means what has happened in actuality. And I'm going to talk about that in a short while. We have to know that the vaccine efficacy of Pfizer vaccine is 95%. How do you give it? 0.5 ml intramuscularly, 2 doses, 21 days apart. The main disadvantage of Pfizer vaccine, to my mind, for Indian scenarios is that you have to store it at -70 degrees centigrade. And we don't have so many refrigerators who can store at -70. It's only in veterinary medicine when animal semen is stored for in vitro fertilization of animals at -70. So we don't have that. Still, Pfizer could provide us with the vaccine. The only side effect, which are going to be again discussed in the next slot, are the usual pain, redness, nodule occurring, or a small fever that comes for a day, or headache, and so on. But one important side effect of Pfizer vaccine, important to consider, occurs in young males, and that is myocarditis. And that's why in UK and USA, especially in children, only single dose of Pfizer vaccine is given. You don't give 2 doses. And particularly in the pediatric age group, that is a slight bit of worry. We have to think about it, but it is rare. And therefore, Pfizer vaccine, wonderful, safe to use. The next slide, please. Next is the Moderna vaccine. Moderna vaccine, could I have the next slide, please? Moderna vaccine is also as good as Pfizer's. No, little before that, Moderna vaccine, slide before that, it is as safe, very good, made by Moderna in the US. And again, it uses mRNA platform, and the vaccine generated is again 95% effective. Moderna has the same side effects, and in USA, both are nearly being used interchangeably. The advantage of both vaccines is that it is on mRNA platform, and Moderna vaccine, as against Pfizer vaccine, requires minus 20 degrees storage, so maybe slightly more efficient. And that is how it is kept. Side effects, Moderna vaccine, just like Pfizer vaccine, the trial was done on 30,000 individuals, and the vaccine is found to be 94.1% effective. The next slide, please. Then comes the Sputnik vaccine in Russia, with the highest regards to all the countries and highest regards to all vaccine manufacturers. This Russian vaccine was made by the Gamaleya Institute in Russia. And like the AstraZeneca vaccine, it has a adenovirus as the platform. But instead of chimpanzee adenovirus, the Sputnik vaccine uses human adenovirus. Now imagine if you have had an infection by human adenovirus, say 2 years ago, and we give you this human adenovirus vector, what will happen? The antibodies which are present in our blood are going to destroy the adenovirus itself. And therefore, the immune response to Sputnik vaccine can be doubtful because we are using the human adenovirus. And what did they find in Sputnik vaccine, in Russian vaccine? They used two types of vectors. One is adenovirus vector 26 in the first dose and adenovirus vector 5 in the second dose. And 2 doses were given intramuscularly. This was all done in Russia. And they found that it was 90% effective. They did the study on 33,758 patients. And so the vaccine is being given very free.
Looks like we lost the
virus. But human adenovirus we are used to. And if I have had a human adeno infection 2 years ago, then if I'm given the vaccine is neutralized. So it is ineffective. And second one is, it is a replicating adenovirus. So it can replicate itself. And we know that adenovirus itself can produce infections, brain infection, myocardial infection, and so on. So that's the worry. And therefore, people found that is this data right? And somewhere, some data discrepancies have occurred. I do not know, and I don't wish to go into details, but these are the facts which are in the public domain as regards Sputnik vaccine. Storage of this vaccine is at 18 degrees. So we dealt with Pfizer, we dealt with Moderna, we dealt with Sputnik. Can I have the next slide? Next slide, please. And then next we come to the AstraZeneca vaccine, most popular vaccine. 2 scientists again from the UK, Dr. Arvind Shah is here and Dr. Ramesh Mehta is here. The UK scientists, they get all the credit. Andrew Pollock and Sarah, both of them were responsible for the development of this vaccine in the Oxford laboratory, taken over by AstraZeneca, and came to India via the Serum Institute of India. They all joined hands and Covishield was produced. AstraZeneca is being used in the UK, and the studies done by Oxford group of scientists were extrapolated to India, and those bridging studies were allowed, and Government of India approved the Covishield vaccine to be distributed and to be given in India. And today 90% of Indian vaccination program has been on by Covishield. Covishield is cheap, effective, and safe. Everybody knows that. And what is the platform used? It is the adenovirus vector, what is called as the chimpanzee adenovirus vector. It is replication deficient, means it does not multiply. And this virus has a small spike gene protein of the coronavirus. So when the virus enters our cells, the spike protein, it produces immunobodies, both antibodies against the T cells and the B cells. So we get antibodies, neutralizing antibodies in the blood, and T cells in the bone marrow are activated. It is given as 2 doses, 0.5 ml. AstraZeneca is given in an interval of 28 days and it gave 70% protection. In India, the gap from 28 days is increased to 84 days. And they believe that the antibody production of AstraZeneca Indian variant, that is the Covishield, that vaccine works better when the second dose is given at 12 weeks, that is 84 days. So the gap in Covishield for 2 doses is 84 days. Storage conditions excellent for this vaccine, and we store it at 2 to 8 degrees centigrade. The only problem with AstraZeneca, particularly in women below 40 years, especially found in Europe and UK, was blood clots occurring. They may occur in the heart, they may occur in the brain, or they may occur in the deep veins, and you may get a deep vein thrombosis even in the legs. You may have DVT, and therefore it has been used with caution, especially in younger population. The next slide, please.
Ma'am, sorry to intervene. We have 2 more minutes for the presentation.
Yes, surely. I'm nearly finishing. Next one is the Johnson & Johnson vaccine. It is given as a single dose. It is replication deficient adenovirus, and it is used in many countries, in the USA as well, and the storage is at -2. Can I have the next slide, please? The next slide, please. And then we have the Indian vaccine, the Covaxin, which is an important vaccine used in India, indigenous Indian vaccine and made by Bharat Biotech. And this vaccine is being done in collaboration with the Indian Council of Medical Research, Government of India, and it is a killed vaccine. And it is as good because it is given 70% immunity, 77% immunity, and 93% against severe disease. This is important, that immunity against getting an infection and immunity getting against hospitalization and severe disease. Covaxin has given 93% immunity. Can I have the next slide? So both the vaccines are very good. But what is the major difference between Covishield and Covaxin? I think, Dr. R.G. Patil, may I request you to give me 2 minutes? The efficacy of this vaccine, Covishield is 66%. Covaxin is 77%. In the US studies, the efficacy of Covishield is 70%. So both are acting in the same way. Both have similar kind of immunity, but the effectiveness data of Covaxin is much worse than that of Covishield. So Covaxin produces 50% immunity, big study done by AIIMS professors, and it showed that it gives only 50% immunity. So we have to remember that Covaxin is slightly less effective when seen in real life. Hospitalization, both prevent in Covishield, 100% no hospitalization. I would think that it is around 97, 98%. Covaxin, 93%. Adverse events, we have to remember, are many, many more in Covishield as compared to Covaxin. So 27% with Covaxin, 27% with Covishield, and only 11% in Covaxin. So the Bharat Biotech's vaccine has much less adverse events. Anaphylaxis is not seen in any of them. And in all the vaccines used world over, occasionally cases of Guillain-Barré syndrome, cases of myelitis, and cases of facial palsy, about which you are going to learn in the next slide, are seen world over. The next slide, please. Only a word on strains. Yeah, only a word on strains of vaccines. Alpha, beta, gamma, delta. Delta created havoc. And now we have the Omicron. These are all variants of concern. By VOC, we mean variant of concern. Omicron is also a variant of concern. Kappa, lambda, epsilon, eta, and zeta are all various variants of interest. So they don't bother us. We are worried and we are seeing, or we are observing how Omicron is behaving. The next slide, please.
Lovely.
The next slide, please. Now only one slide. What are breakthrough infections and what are we going to do? We are seeing 4% cases of breakthrough infections. Many of us have taken 2 doses of vaccine. US and UK have straight away started giving booster doses. My personal opinion is booster dose is required. And India, it is time that we give booster dose. 4% of the population gets breakthrough infections and they get COVID in spite of following all the COVID appropriate behavior. they get it 15 days after the second dose, and that has to be considered by us. Vaccination in pregnancy, 80,000 women world over have got vaccines, and they are safe in pregnancy, no teratogenic effects. And in fact, if a woman gets COVID, she's going to have low birth weight babies and all. So please advocate all vaccines in pregnancy, vaccination in immunocompromised hosts, and vaccination of challenged children. To my mind, breakthrough infections and vaccinations in specialized situations is the need of the hour. And therefore, I would end by saying, the next slide, please, that we have 8 COVID vaccines. We have saved the world because of the COVID vaccines, and other vaccines, Covovax, Zycov-D, are in the pipeline. The next slide, please.
Thank you. I think we
Yeah,
need to finish.
the next slide, please. And therefore, friends, I end by concluding that COVID vaccines is the need of the hour, and we have to vaccinate, promote vaccination. The next session is going to tell you how we have to do the IEC. Thank you, Dr. R.G. Patil. Thank you very much for a patient listening.
Thank you so much, Dr. Phadke. Fantastic, your talk with a beautiful clarity, and really enjoyed, reminded my days in BGM Medical. You're still strong as ever. Thank you so much. I think there are some questions, because of the time constraint, I think we need to move on for the next session. I know Uday sir wanted to ask some question, but we need to move on. So, Dr. Patil, or you want me to introduce Dr. Parikh? Hello. Hi. May I introduce Dr. Parikh? He is, Manish Parikh is Associate Clinical Professor in Infectious Diseases, Department of Respiratory Medicine, and University of Leicester. And he also honorary consultant in Infectious Diseases, Department of Infectious Diseases, Leicester. He also led the big study on UK REACH study in recently, and he has a lot of inclination about talking on the effect of COVID-19 on BAME population. So, Dr. Manish.
Thank you very much. I'm just going to share my screen, so it may stop you. If you could just tell me if you can see my slides.
You can.
Yeah,
if you want to borrow.
So, perfect. So I'm going to spend the next 10, 15 minutes just giving you a very quick overview about vaccine issues in adults during COVID-19. And I'll start by just thanking the organizer, particularly from COMHAD and Bapia, for this wonderful session. I think, I've learned a huge amount from the previous speaker, and some of what I say will have a little bit of overlap, but hopefully, things change on a minute by minute basis in COVID and vaccination. So there will be something new coming up, hopefully. So I'm going to talk a little bit about vaccine efficacy and effectiveness, and then also a little bit about vaccine safety. I'm not going to focus on all aspects, but I'll focus a little bit on the key issues around vaccine safety. And then I will finish by talking about boosters, which are an increasingly used area of work, particularly in terms of the Omicron, as we know. So just to talk about the vaccine approval process, many of you will be aware that we start with very small scale studies, and we go through non-clinical studies, and then we have obviously phase 1 to 3 clinical trials, which are looking at vaccine efficacy. And then those will then be adjudicated on, so evaluated by either in the US by FDA or in Europe by the EMA, and others around the country, around the world. But the main thing is we have at the moment emergency use applications so that vaccines can be used very rapidly. Vaccine scale up of production happens very rapidly thereafter, and then we go on to safety monitoring. And safety monitoring historically has been looking at what are the side effects of vaccines, particularly once we're in a wider population. But also now, because of the way that data has been accumulated, we're also looking at effectiveness. So I'm going to talk a little bit about vaccine effectiveness first, and then focus on safety. So vaccine effectiveness, just to, and I'm sorry, this is just going over what the previous speaker mentioned. Vaccine efficacy, just to remind you, is under trial, in ideal trial conditions, it's performance of the vaccine in ideal situation vaccine effectiveness is real world conditions and often differs, as we saw, very significantly from the trial performance. Now, I'm going to focus a little bit on Israel because Israel have been far and ahead, one of the countries which were very rapid to take up vaccination, particularly with Pfizer. And as you can see, this is data back in February, they were way ahead in terms of vaccine coverage of their population. But that also allows you to look at vaccine effectiveness and also safety in some good, both across a whole population cohort. So this was the first study. This was published in the New England Journal of Medicine by the Israeli group, which looked at vaccine effectiveness in a nationwide mass vaccination program. And what we're doing, just to orientate you here, what they were looking at was what was the impact of the vaccine against infection, symptomatic illness, hospitalization, or severe disease. And it depended on the time period. So if we focus on this bottom row, this was 7 days after the second vaccine. We've already heard you need to have 2 vaccines. And what you can see is that essentially you had about 92% effectiveness against infection, 94% against symptomatic illness, 87% against hospitalization, and 92% against severe disease. Now, this is Pfizer, 2-dose Pfizer in the Israeli setting. So, of course, each country will have slightly different data, but this shows very early how effective the Pfizer vaccine was. If we think a little bit about infection, because we need to differentiate infection and also severity of disease. Infection and protection against infection has been really very good in Pfizer generally, but also for symptomatic illness, hospitalization, and severity of disease. And actually, severity of disease, particularly in older age groups, is particularly important. And this is just graphing it. This is from the same paper, but you can see the red graph is individuals who are unvaccinated versus the blue lines, which are vaccinated. And you can see the lines, the curves separate very early on after the second dose of vaccine. So very effective in the Israeli setting. In the UK, we have been looking at this. So this is Scottish data, which also looked at both Pfizer and the Oxford AstraZeneca vaccine against the Delta variant. And I won't get into all the data, but just the main things that you wanted that are important are the vaccine effectiveness against death, because death obviously is a very bad outcome. Again, in Delta was 90% for Pfizer and about 91% for Oxford AstraZeneca. So very effective against very severe outcomes. And these vaccines are very, very effective. But what about safety? So safety is, as we know, is always a concern and will impact on people's concerns and vaccine hesitancy. And I think that the next session or the session after, we'll talk about vaccine hesitancy. But safety is one of those things that people get concerned about with new vaccines and new medicines. Now, up front, it's important, as a previous speaker said, in general, the COVID vaccines are very safe, and they've been safe both in trial and in post-marketing surveillance. And I think it's very clear that we need to make that point very, very clearly, because there is a lot of misinformation out there around vaccines at the moment. Common side effects are as you would expect in a vaccination. So you get in the arm, you'll often get pain and redness, sometimes swelling, sometimes around more systemic symptoms. So for example, tiredness, headache, myalgia, so muscle pain, chills and fever. Sometimes individuals will get isolated lymphadenopathy in their axilla, for example, post-vaccination. But these are usually self-limiting without any serious consequences. Anaphylaxis was touched on a little bit by the previous speaker. And in general, anaphylaxis can occur. And this is data from Pfizer and Moderna. I think the previous speaker spoke very well about the Oxford vaccine and actually the rates of anaphylaxis were very low. As we know, anaphylaxis is a severe and potentially life-threatening reaction. But actually, if you look at data from the US up until kind of January of this year, the rates per million aren't particularly high. So for just under 5 per million for Pfizer and 2.5. And this is from published data in the US. So it does occur. but it's a relatively rare occurrence. The other issue around Oxford AstraZeneca or the ChAdOx vaccine is around this issue thrombotic thrombocytopenia. And this was first identified in Europe, particularly in Germany, by colleagues. And this is a very rare clinical picture, which is seen usually in young people. And it's characterized by clots, and these clots, as we've heard, can occur anywhere, but often in odd places. For example, cerebral sinus vein thrombosis associated with thrombocytopenia, so also with low platelets. And this is usually after the first dose of the AstraZeneca vaccine. Now, this has been looked at in the UK, where we have sort of data linkage, and we can link data from what we call our primary care or GP records, and then link to diagnoses over time. And essentially, you can see, just to orientate you, the blue or purplish dots are the ChAdOx vaccine. And if we focus on the cerebral venous sinus thrombosis, you can see that the ratio is around 2.5 times the people who are not vaccinated by AZ. But it does occur also with with COVID itself, and that's important to make that point. And it can occur, but to a lesser extent, with other vaccines. So these are rare events, but they do occur in a very small proportion of people. So in the UK, this is data from the UK, the risk of cerebral venous sinus thrombosis is thought to be around 15 per million doses in the post-first dose. And in the second dose, it's much lower, it's around 2 cases per million. And those 2 cases often aren't related to the vaccine itself. We unfortunately also see some death related to cerebral venous thrombosis or thrombosis generally. And those cases often unfortunately occur in younger people, and therefore they're more seen in the media and in the press. But overall, considering the number of doses of vaccine that have been given in the many millions, the number of fatalities is small. But it has led to a change in the vaccination program, particularly in Europe and in the UK. And this is a graph just showing you the risks, the harms of the vaccine versus the benefits. And if the benefits are smaller than the harms, then it's not thought to vaccinate. You shouldn't give AZ in that age group. So you can see up until in the under 40s, essentially, the benefits are less than the harms. So the harms are greater, and therefore we do not vaccinate our under 40s any longer with AZ, and they're offered Pfizer proactively or Moderna. The other side effect that's of importance is myocarditis, which is an inflammatory disorder of the heart muscle. And you'll be aware that it's characterized by lymphocytic, monocytic infiltrates within the myocardium. And then you also get sometimes non-ischemic necrosis. Now, this is a rare occurrence. And I'm coming back to the Israeli data because they have obviously had Pfizer in arms and in the population for a much longer period of time. 2 papers from Israel. And the first paper here, what it shows you essentially is that this occurrence is rare and it occurs usually more commonly in men, and it usually occurs in men under the age of 30 broadly. So, and hence the use of 1 dose of vaccine of Pfizer in certain populations. The other thing to say is that broadly, if we look at this other study, which is using, again, electronic health records, that generally the outcomes around myocarditis are usually a mild occurrence. It doesn't usually occur in any severity of illness or fatalities. In the UK, we have the data is reported routinely into the regulators so they can monitor what's happening. And broadly, what you see is that it occurs in people up to kind of the age of 30 to 40, really. But it's usually with the Pfizer or Moderna, really. But again, important to stress, mild and self-limiting, usually in younger groups and males more than females. And we don't know exactly why. And that drove the JCVI, which is the UK's vaccination advisory group, to advise only 1 dose of Pfizer initially for children. So I'm going to go on to talk about boosters, and this is, and I, you know, up front, I want us to be clear that, you know, how inequitous vaccination delivery is around the world, and how, you know, I feel slightly embarrassed to talk about boosters in the UK when many parts of the world are still not even had first or second doses of vaccine. And this just shows you how much inequity there is in the vaccination programs around the world. In Europe, particularly in the UK, US, Israel, vaccine, you know, has been distributed through most of the population, and other parts of the world are still, unfortunately, not had vaccine, enough vaccine to get even the initial first 2 doses. So I just want to make sure that people understand that that is the background to all of this. But, you know, when you're thinking about COVID-19 vaccines, we need to think about a few things. One is about the magnitude of the effect, so how much of an effect it has. And we know that in effectiveness data, the severity, protection against severity of illness is definitely there. The second thing is about the duration of benefit. How long does it last? And then the third issue is around efficacy or effectiveness against variants of concern. And we've heard about Omicron, and that, I think, will become, unfortunately, over the coming weeks, a real concern for not just the UK and India, but other parts of the world. But again, because of the Israeli performance, we know very early on, because they had vaccinated most of their population, that even individuals who were vaccinated were starting to get breakthrough infections very early on. And this was both in terms of confirmed infections, but also in terms of severity of illness. And from that same paper, what you can see essentially is that if you, across all age groups, the longer it's been since your first 2 doses of vaccine, that you're starting to get increased risk of infection. And particularly in the older age group, above 60, you are also starting to see increases in rates of severity of illness. So the natural question, therefore, is what's happening, and is there a waning of immunity? And this is the data from that same paper. And I'm just, to orientate you to this table, this shows you time across the top. And these are each column is a vaccination period. And January was quite early on. So if you're vaccinated quite early on in January versus May, which is quite recent, you can see that the rates of COVID infection were, in people who were vaccinated back in January, were much higher, almost double those people who were vaccinated in May. And that was across all age groups. So basically, the longer it's been since your vaccination, the more likely you are to get infection. And that also stood when you looked at severity of illness. And it's not just Israel. We started to see this also in the UK, both for AstraZeneca and for Pfizer, but also for Moderna to a lesser extent. We don't use quite as much Moderna. But it's also being seen in the US and as well. And you can see that it occurs across all, we didn't have Omicron in this bottom right panel, but you can see it occurs for about Delta as well as other variants. So the sum total of what that tells us is that the longer it's been since your first 2 doses, you're going to get some waning of immunity. These are epidemiological studies, and you're starting to get increased risks of infection. So what's actually happening in the immune response, and I'm not going to go into it in any detail today, really, but what we're seeing is that over time, you start to get a waning of the humoral or the antibody response, and you can see that this occurs over time. And there is as we all know, there's natural waning anyway in terms of antibody, but when it's resulting in increased risk of infection, that makes you think about boosters. And there's studies ongoing to understand how does that tally with the T cell response. And we've spoken, the colleague previously spoke about T cell responses, and we don't know enough yet about how the T cell response and the duration of benefit of the T cell response. So we get a waning response, and therefore we need boosters. And so Pfizer and BioNTech have done those booster trials. And if you look at people who've had 2 doses versus 3-dose individuals have basically a relative vaccine efficacy of almost 96%. So 3 doses gives you a real boost to the immune system. And in Israel, where they've again been able to boost their population much earlier than anywhere else in the world, you can already see that the blue line is people who've had 3 doses versus the red line, people who've had 2 doses, that basically, if you've had 3 doses, you're not becoming infected or having severe illness or death. So 3 doses are really very beneficial. And in the UK, there's a study that's just been published in the Lancet in the last week called COV Boost, which it was a large and very complex study, but the key point here is that irrespective of the initial vaccines that were given, whether it was AZ or Pfizer or Moderna, that a 3rd dose will boost your antibody and T-cell responses. So really that's what's driven the UK's response to boosters. And then just to finish, I'm going to talk about, so Omicron obviously is on everyone's lips at the moment. And this is data from only, maybe the last couple of days now from the UK. The big question is about what Omicron will do to the vaccine immune response. And these are, just to say that these are very preliminary data, but the circles are Omicron. And what you can see is that essentially people who've had 2 doses of Oxford AstraZeneca and a Pfizer booster in the UK, actually, in some respects, the AstraZeneca that almost has very minimal benefit against the Omicron. Whereas if you've had 2 doses of Pfizer and a Pfizer booster, you probably around 75% effectiveness or efficacy. So this is early data. I think further data is needed, but those initial data are quite concerning because AstraZeneca was given very sharply in the UK and obviously was used in other parts of the world, in India as well. So just to finish, I think I would echo what I've heard already, that vaccines are really key and are important in ending the pandemic. We have huge inequity in the distribution of vaccines, and we need to rapidly work out a more equitable system, because otherwise we're going to be in this issue around variants of concern will continue. The vaccines that we have work really very well. They're very effective and they have been developed at speed, and it's been remarkable, really. And they're safe, actually. They're very safe. There are some adverse effects with specific types of vaccine, but the risks overall are very low and can be managed by using alternative vaccines in risk groups. I think it's increasingly clear that the immune response after 2 doses will wane. And my increasing view, and my view actually quite early on had always been that we needed boosters. And I think maybe that in the end, when we look back on this, 3 doses is what you need rather than 2. But we'd really need to understand further the data around the duration of effect, and also the impact on variants of concern. Thank you very much.
Dr. Manish Parikh, thank you very much for a brilliant talk, talking about the efficacy and also the side effects, and also alerting where boosters have really the message for getting top of this Omicron infection. I'm waiting for update from my team, but I think Dr. Naveen Tucker is not here. So if there are no questions, I would like to ask some questions to Dr. Parikh. Is that possible? Yeah. I just want to have your view about, is Omicron is a blessing or disguise? Because the data from South Africa shows it's mild illness, and I know we've been cautious about it because NHS will be overwhelmed if the infection is not, we are not put all the rules and plan B in place, all that, mask and booster dosaging and all that. But do you think this will create immunological response in the community in a way that it will be like flu-like illness? Will you be able to speculate on that?
Yeah, it's a very good question. I think one of the slight difficulties that we have is that South Africa is a younger population, like India, for example, whereas in the UK, as an example, we have an aging population with more comorbidities like diabetes, etc. If it is a mild illness, then theoretically you would get better antibody and T-cell responses, and therefore you should perhaps get up to a more population benefit in terms of immunity. My slight concern in the UK, because we're starting to see it, is that London cases have gone up by 30% in the last few days. And there's a concern that even if you don't get the same severity of illness, the sheer numbers of cases will result in even if you have a much lower severity, just because of the sheer numbers, it will still result in quite a lot of cases. That's the concern. I think it's too early to say. I think it will take another 3 weeks, really. And the problem, as we know, Arvind, is that if you wait 3 weeks, by then it's always too late. So
absolutely, you're right. I agree truly. I'm just wondering any other questions. Otherwise, I have Biju, any questions? And otherwise, I would like to also ask about
Arvind. Yeah.
Biju, any questions? Or I would like to ask more about where do we stand? We talk about boosters in England and all that. And as you write, the vaccine inequality is distressing. Where Africa, where we are with 1 or 5% population being vaccinated, we are very grateful. India is almost done 50% population vaccinated. But where do we stand going down to younger children, 12 and 16, and now we're talking about 5 and above, really to contain and avoid prolongation of this pandemic. So what are your views on that?
yeah, so I'm not a pediatrician, but my view about this is my view about this remains that we have to see the end of the pandemic, and to do that we have to get immunity. Now, the personal experience is that a lot of transmission occurs via schools, and there's a lot or by children. Now, of course, children in general often have milder illness generally, but they still do get severity of illness. And the other thing is, as we know with other respiratory viruses, children often have much higher respiratory viral loads than adults, and therefore are able to transmit more. Now, if, for example, Omicron results in a higher rate of reinfection, then that may be a concern. So in that population, then, vaccination into a younger age group is probably going to be needed. The question about whether you give 1 or 2 doses is still to be discussed. But, in the UK, we've taken a much more, I think, conservative approach than other parts of the world. Other countries are now vaccinating 5 and above because they want to get, through the pandemic as much as they can.
No, that's very.
Dr. Arvind.
Dr. Arvind Shah, Dr. Apesha is on stage now.
Yeah, can I ask
Dr.
Apesha.
Oh, is he on?
Yeah, he's on.
Dr. Anil Kurane is there.
Yeah.
Dr. Anil Kurane?
Yeah.
Yes, sir.
Yeah. You can introduce.
Yeah, please. Dr. Manish Parikh, thank you very much.
Can I ask one question?
Yeah. Sure, sir. Sure.
Yeah. Doctor, thank you, respected Phadke Madam. Dr. Manish. Manish, I would like to ask you one question. You are dealing with adult maybe with corona variant. So tell me 2 or 3 things which differentiate these Omicron cases from Delta variant. One. Secondly, which vaccine do you think I know it's very too early to say, which vaccine among the 3 or 4 which are using? In India, we are using Covaxin and we are using Covishield. I think you have got Pfizer, Moderna, both the things are. So do you think as per efficacy and distinct safety is concerned, I don't want to go with the company, but your own experience and data suggested. Thank you.
Yeah, so I think in terms of the clinical presentation, it's too early to say in the UK. In South Africa, it's still causing mild illness. In the UK, we're not seeing enough. The number of cases is still relatively small, actually. So we're not seeing a lot in hospital yet. So it's still a community respiratory virus illness. In terms of vaccine type, today I think the data is very early, but the data so far would indicate that AZ, Oxford AstraZeneca, which I guess is Covishield in India, is not as effective, but it's still too early to say. I suspect when the data becomes more filled up, as we get more information, it'll become clearer that all vaccines are effective, but just not quite, and they'll be effective against severity of illness. So I don't think people should worry at the moment because it's very early stages.
Thank you. And what about booster?
I just don't think 2 doses is enough. I think you need 3 doses. I think to boost, I think in the end we'll look back and it will be a 3-dose vaccine program like hepatitis B, for example. Thank you.
RJ Korane, take over. Oh, Jayajira is not there. Dr. Abhay Shah is there, welcoming. Just now I got a message from Dr. Naveen Thakkar. I think he is busy with some meeting. So I think we go ahead with Dr. Abhay Shah. Over to Dr. Patil. Dr. Korane, please. And Dr. Arvind
Dr. Anil Kurane. Sir, can you introduce our next speaker, Dr. Abhay Shah? Dr. Kurane?
Sanjay.
If not, I can do that.
Yeah, if he's not there, then I think
Okay.
Dr. Jijajira?
I'll go
Yeah.
ahead then. Hi. Is Dr. Kurani here, or I'll introduce otherwise?
Yeah, you go ahead.
Okay, Dr.
Okay,
Abhay
okay,
Shah,
sir.
thank you very much. Welcome to you on the, thank you very much for giving us time. Dr. Abhay Shah is the pediatrician neonatologist based in Ahmedabad, and he was ex-IIP lead for infectious disease and has got the biggest infectious disease pediatric outpatient clinic in Ahmedabad. So thank you very much. And you're going to talk more about routine vaccination in children during COVID-19. So welcome you, sir.
Yeah, thank you, sir. Let me share my slides. Yeah. So, good afternoon, everybody. The topic is given to me, I think is very pertinent in our current era, and that is immunization during COVID pandemic. Can you hear me properly?
Yes, sir. Go ahead.
So, ever since on the 11th of the March 2020, WHO declared this pandemic caused by this monstrous virus COVID-19. There has been a heavy toll. As far as India is concerned, there were 3.46 crore cases and 4.75 lakhs. And to contain, and as far as the world is concerned, nearly there were 26.9 crore cases and 53 lakhs deaths world over. So I think the mortality is huge. At the same time, the human suffering is very, very unparalleled with any of the past experience. And there were two different waves that we observed, that is wave 1 and wave 2. And to contain this pandemic was a Herculean task. There was all over crisis and catastrophe. There was stressed public health system. There was collapse of the global solidarity, and people were standing in queue for the oxygen and other important health facilities. And the most of the mitigation efforts were mainly diverted to COVID-19 and nothing else. So there were lockdowns, there were curfew. We were asked to stay at the home, shelter in places. There was only prioritization of the urgent care. There is delay in the elective care. The physical visits to the health infrastructure were avoided, and we were asked to encourage the teleconsultations, and rightly so. But this has resulted into a very negative impact in all the fronts of our daily life. There was an economic impact, negative impact on the economics. The tourism and travel were hit badly, and it is at the lowest ebb of the century. The educational and industrial institutes and trade has been stopped. And along with this, the worst affected part is our health infrastructure. Number of chronic cases have gone rise, and one of the most important disruption that's been taken place is the immunization disruption. And if you look at the quote from the WHO Director General, the avoidable suffering and death caused by children missing out routine immunization could be far greater than COVID-19 itself. So yes, this immunization disruption during the COVID time is an unnoticed side effect, or let's say adverse effect of the COVID-19 is concerned, and we need to address this issue in a great detail. And if you look at the data, more than half, that is 53% of the 129 countries where data were available reported moderate to severe disruption in the immunization since April 2020. and nearly 80 million children under the age of 1 were at risk of the vaccine preventable disease, one or the other. This is a multifactorial. Because there was parents were reluctant to leave the home because of the fear of catching COVID. There was lack of transport. There are some finance issues there. At the same time, there is lack of information about the facilities which are available or not available. At the same time, there was scarcity of the health workers. Health workers were not available either because of sickness or exposure. There is lack of protective equipment. The staff was redeployed to a COVID duty, and there was restriction on the travel as well. Because the travel and transport affected, the vaccine delivery was also not there, so there was delay in the transport of the vaccine. And the most important, lack of the guideline, closed health facility, and all outreach immunization sessions were stopped. So because of these multiple factors, the immunization was greatly affected and there was a great disruption. If you look at the figure, the infant immunization coverage dropped nearly 83%. As far as the DPT third dose is concerned in 2020, and that has left nearly 22.7 million children vulnerable to vaccine preventable disease. And if you look at the data, that is 3.7 million more children compared to 2019. Similarly, the zero dose children, means the those who lack even a single dose of DTP, has also gone up as far as in the 2020 compared to 2019. So there was a reduction in the DPT3 coverage and it dropped to 83%. As far as the measles containing vaccine XGV is concerned, the coverage dropped to 84% in 2020, leaving 3 million more children potentially unvaccinated than in 2019. So that is also very, very important. So DPT3 and measles containing vaccine 2, they are the two important parameters that will tell us how effective the immunization program is going on in any country globally. As far as the disruption is concerned, nearly 10 countries account this 62% of the unprotected children, and it includes mainly in 2019 Nigeria, India, and here we can say that India is a leading in the 2020 because of these unprotected children. That is nearly 62% of them are from the various countries. Now, as far as the new vaccine is concerned, and as far as underutilized vaccine is concerned, you can see that there is a marked reduction in the use of the new vaccine as well as in the underutilized vaccine. And in 2020, after the COVID pandemic has taken place, only 19 vaccine introductions were reported in 2020, which is less than half of any year in the past 2 decades. So the vaccine development has also gone down for the various vaccine producers except of the COVID vaccine. The entire focus was on the COVID-19, its prevention strategy, as well as the development of the vaccine. As far as the COVID is concerned, other vaccine development were also reduced to nearly half, 50%. As far as the global HPV cover is concerned, only 1.6 million more girls were not fully protected against HPV virus in 20 compared to previous year, and HPV vaccine coverage was affected by COVID-19 pandemic, and only 13% of the girls are fully protected. So as far as the newer vaccine, HPV vaccine is concerned, the take-up of that vaccine was also very, very slow. However, there is always a ray of hope, and this disruption was also followed by a recovery. As far as the immunization disruption is concerned, a relatively larger impact was observed in the Eastern Mediterranean region, in the Southeast Asia, and in the region of Americas. But out of them, the recovery is maximum in the Eastern Mediterranean region, in the Southeast Asia, as well as in the region of America. So here, the impact, immunization disruption was great. At the same time, the recovery of the immunization program was also faster compared to other regions. In not only the routine immunization, but the mass vaccination was also affected badly during this pandemic. WHO in 2020 mentioned that countries utilizing mass vaccination program should temporarily suspend the conduct of the mass program because of the increased risk of promoting the community circulation. And if you look at this impact of this, The pandemic not only disrupted this routine immunization in 2020, but even the special immunization activity were also badly affected. And it is pity to say that in May 2020, nearly 66 countries had postponed at least one mass special activity as a direct consequence of the COVID-19. So not only the routine immunization, but even the outreach session, the mass vaccination program were also badly affected during COVID-19. And if you look at the various programs, I would like to make a special emphasis on three important diseases. Number one is the measles or measles-containing vaccine, polio vaccine, either IPV or oral. In oral, we have got the bivalent as well as monovalent vaccine. Out of the countries with postponed campaign, the postponement of the 27, nearly this much of the country they postponed have this measles vaccination program, polio vaccination program. So polio is worst affected. Polio vaccination program is worst affected, followed by measles vaccination program worst affected. So even the mass vaccination program was badly affected. And if you look at the data as of the 2018, 19, and 20, you can see that the wild polio virus as of May 21, the wild polio cases in 2020 was nearly 140. If you look at the CVDPV, the cases has gone up in 2020 compared to 2019, that is what was 364, which has gone to 3 times higher, that is more than 1,000. So polio is worstly affected, followed by measles because of the disruption in the mass vaccination campaign. And it is very important to know that this national and international decline in the routine immunization has placed a global community at significant risk of outbreak of the various vaccine preventable diseases, including measles, polio, and pertussis. Why? Because these are the diseases which has got a high reproductive number, R naught is higher compared to the R naught of the COVID-19. So these are though in the containment, in the prevention of the COVID-19, we have applied all the resources to only COVID-19, and that is why there is an immunization disruption taking place in the various vaccine preventable diseases, which are actually having a more RO, that is more transmissibility and potential to cause more morbidity and mortality compared to COVID-19. So let us look at this table, that if we look at the COVID-19, which has a reproductive factor of 2 to 7, the case fatality rate is 0.1 in children. If you look at the adult, it is 28.8, but average is 4.9%. So the case fatality is only 0.1% as far as children is concerned. If you look at the measles, you can see the RO very high, 12 to 18. It causes acute respiratory media, pneumonia, and encephalitis. And in a lower middle income country, it has got the case fatality rate of 2 to 15%. And if the child is severely malnourished, immunocompromised, this can be as high as 60%. I repeat, as high as 60%. If you look at the pertussis, again the RO is 12 to 17. It causes failure to thrive, seizures, encephalopathy, pulmonary hypertension, and affects 1% of the infant. And the last one, the dreaded one, polio, with an RO of 5 to 7, which causes meningitis, encephalitis, paralysis, and it can have in the adolescent age group case fatality as high as 57%. So I think the case fatality in children is just 0.1 because the RO is just 2 to 7, but the reproductive factor, which is very high for the other vaccine preventable diseases, have not been properly addressed because of our efforts, which have diverted only to the COVID and nothing else but COVID. And if you look at this, the measles mortality in children living in developing world is roughly 10% and can approach 60% for the malnourished children. Pertussis remains one of the top 10 causes of infant mortality worldwide, with an estimated 24 million cases and 1.6 lakh deaths annually in children.
Doctor,
already told that the unvaccinated adolescent can. So it is very, very important that the RO of the vaccine preventable disease is also very, very there. Out of this, the 25 countries reinstituted at least one campaign. That is very heartening to see that vaccination program has started. As far as India is concerned, we have got 2 programs. One is Mission Indradhanush and intensified Mission Indradhanush. But because of the COVID, I think that you can see the dent the vaccine coverage in the April, that is first dose of pentavalent vaccine, third dose of pentavalent vaccine, which has gone to 60% of the basic 2019, and you could measles containing vaccine too. Again, that there is a dent in the immunization as well is there. As far as the immunized coverage, there is fully immunized children are concerned. There is again a lot of disruption ranging from 3% to 20% in the different states of India. So immunization disruption has also taken place in country like India as well. As our IAP, we have got the organization of more than 30,000 pediatricians and has given the guideline, and it mainly emphasizes on the missed opportunity. We have got our own website where you can read this guideline, how to immunize the children during COVID time. And it is very important that a birth dose vaccination should be given to all the health facility, irrespective of the zone, what is buffer zone, red zone, whatever is done, birth dose should be given. Secondly, a child who reports to health facility to any reason should not be denied immunization. So you can continue immunization during COVID time. Third, health facility-based immunization services should be provided only on demand to walk-in beneficiaries. So it is very, very important. And the outreach immunization should not be undertaken in this area. And last one, the immunization facility can be restarted after 2 weeks of the delisting of the area. So previously there were, in the early part, there were different zones were there, zones of containment there, and we have to follow that guideline. Luckily now the pandemic is receding. Probably we are living in the, entering in the endemic state, and probably this zone, this recommendation for the different zone may not be there. The message is that any child who visits to a healthcare facility due to any reason should not be denied the vaccination, that is this. So if there are a number of missed doses because of the immunization, because of the travel, transport, migration, the records may not be there. So there are no missed doses. But remember that our immune system is that you need not resume the dose of fresh. You have to continue from where the child has left the immunization. So repetition of the entire schedule is not required. That is more important. Second, a catch-up vaccination is a must, where you can have to give multiple antigens at a time, and you can have a minimum desired interval between the doses. So more and more vaccination, more and more antigen can be given to the child at a single visit, so the child can be benefited, and that is how you can increase the immunization coverage. And so, friends, what can be done? The most important thing that a person accompanying a child in healthcare must obey the various transmission prevention measures, sanitation measures, and should use various protective measures. Similarly, peripheral health workers should not be engaged in a COVID-19 surveillance. There will be a separate staff. A special focus should be given on the first dose of measles and pertussis vaccine, as well as the polio vaccine. And children of the migrant labor or any person who does not have their immunization record should be given age-appropriate vaccination. That is very important. So, because the child does not have the immunization card, because the child has no record, he should not be denied vaccination. At least you should give the age-appropriate doses, especially the pertussis, polio, measles. All these vaccines are very, very important. And the most important, the surveillance should be very vigilant about the early detection of the vaccine preventable diseases. If these diseases can be detected early, the child can be isolated, and the outbreak in the community of that particular vaccine preventable disease can be prevented. Good use of the electronic media, that utilizing email, text message, and other communication systems should be used to inform the parents that their child has left the immunization. And provision of the vaccine either in the park or as a drive-up window is also very, very important, so that the child is not exposed to the COVID-19 patient when they visit the health facility, so that phobia and their fever can be addressed by giving the vaccine in the park, in the garden, or as a drive-through window. And when COVID-19 vaccine becomes available for children, this opportunity should be grabbed up to simultaneously co-administer other missed doses of the other various vaccine preventable diseases. So,
sorry to intervene. We have 3 more minutes for the session.
Okay, I'll finish by that. Yeah. Provision of the vaccine opportunity during all healthcare facilities must be encouraged. So, any reason where the child or his brother or a sister visits the healthcare facility, that opportunity should be grabbed up to cover the lapsed immunization, and public service announcement through television, digital media, platform to educate the parents about the critical importance of the vaccine and health risk of the disease is very, very important. So education of parents, that they should not have only phobia about the COVID. They should know what is the basic requirement, which are the diseases can be prevented vaccination and how they are lethal and how more dangerous than COVID. We need to explain to the community as well as to the parents. So in the last sentence, in the 21st century, we have made so much progress in preventing the childhood death from the various infectious diseases through various immunization program. Let us not permit this COVID-19 pandemic to reverse this progress and allow various vaccine preventable infections to research. So thank you very much for giving me this opportunity. If you have got any question, I will be very happy to answer. Thank you so much, sir.
Thank you very much, Dr. Abhay Shah. Fantastic lecture. And I think it's eye-opener for me and it's scary, but you put it on with the solution is so remarkable. And I think this is one of the big collateral damage we're seeing because of COVID-19 pandemic. And I remember last year, Royal College of Pediatric and Child Health put the note out saying, do not be afraid to take your child to A&E if he's unwell. And I think, and you have highlighted important part of preventable diseases. And this one of the things which I would like to ask, take a privilege asking a question about, have you seen, and we have been scared of resurgence of RSV, respiratory syncytial virus diseases. Since summer months, we are getting alerts and we are seeing that massively going up in A&E. Have you seen anything like that? Or have you seen surge?
So during what happens that since the pandemic is receding, we are seeing a lot of cases of dengue. As far as respiratory infection is concerned, we are seeing a lot of RSV and influenza type B. I agree with you. And third is pertussis. And because now we also do a lot of PCR also. So that is why we find out what is a positive organism. So I agree with you. We see a lot of resurgence of RSV.
Okay, no, that's very helpful. And also I think I'm going to ask same question to you and also Dr. Phadke, madam, about immunization of COVID-19 for children. And I think I would like to have your view and also Dr. Phadke, madam's view on how we go about. And, of course, we got a big gap to vaccinate those who have not been vaccinated. And on the top, we are worried about Omicron and we are not under control. So may I ask Abhay and also Dr. Phadke, madam, their view about how we should proceed? Yeah.
May I go, madam?
Unmute.
Madam, unmute yourself. I thought in India, the first point is that we have just completed around 50% of the adult population with 2-dose vaccines. We do not have a pediatric trial done in India fully recognized by the DCGA, which has got an authorization. Trials are done all over. Trials are done in Nagpur, Pune, Mumbai on number 1 on Covishield, number 2 on Covaxin, number 3 on Zydus-Cov, Zycov-D. All these 3 vaccines trials are done in children. They've got good results. But yet, Government of India is waiting to get an approval. My personal opinion is that many of the speakers here have voiced, children are getting a mild disease, but they are getting the disease and they are giving the viral load. So if they bring that heavy viral load from the school to the grandparents, maybe it may be worthwhile. Whether they should be given only single dose, like Pfizer vaccine in the UK, they are giving single dose to children. Now, with Covishield and Covaxin, we'll have to see. Probably Covaxin is the safest and they have done trials in children and they say it is good. But we'll have to wait till all these results come. Zycov-D have said that they have got excellent results. And Dr. Bodhankar and Dr. Yashwant Patil will add that in Nagpur only trials of Zycov-D are going on.
No. Thank you so much. Brilliant. Thank you. That's brilliant. Any comment from Dr. Patil?
Yeah, so I agree with madam that though disease is, in children is mild, but children must be vaccinated. There are two important things. If we want to end the pandemic, and when the endemic status comes, it is very important for all of us to sustain that endemicity. And remember that children and adolescents constitute 1/3 of the entire population of India. there is a large cohort of children. So if these children or if this age group remains unvaccinated or unprotected, probably the endemicity will not be sustained. Number one. Second, children, because COVID happens or no COVID, they are under psychological trauma. So it is very, very important. So once they get the vaccine shot, I think the parents and children both are secured. So it will help in their psychological health as well. And third one, they will not transmit the disease to the school teacher, the school staff, as well as the parents and grandparents. So I think there are multifactorial advantage, and one should go for the vaccine, even if the disease is mild in the children.
Well, thank you very much. I think that's
Dr.
brilliant. Dr. Bodankar. Uday sir?
Yeah, sorry, Dr. Arvind, I agree with respected Madam Phadke, Abhay Shah. Covaxin trial was done in Nagpur because, and in last 3 months, more than 3 months have passed, we have not seen any side effect measures or mild in age group 2 to 6, 6 to 12, and 12 to 18, around 50. So at present, I personally feel that Covaxin can be safely advocated for even more than 2 years. I can't say about less than 2 years. About other vaccine which respected Madam has said, I'm not very much aware of the vaccine result in Nagpur being conducted, but at present we can definitely say to the government that vaccine is safer more than 2 years age in children. Thank you.
Any other questions, sir?
Over.
Yeah, there is a question in chat box.
Only 4 minutes left.
Yeah. So are we going to?
Can I just mention about vaccine hesitancy?
Yes, sir. Actually, I was about to ask about that.
Yeah, please.
You may ask a question, but I felt it was necessary. More so, it was last year when there was a mega issue about vaccine hesitancy, especially in England. And I think Dr. Phadke Madam also touched on that. There was concern about this vaccine may change your DNA. There's concern about it is fetal cell vaccine. There's concern about it may cause long-term damage, and also. There was a lot of fake news and WhatsApp messages going across, not giving healthy information. And I think I was part of the Jain Health Initiative Group, and we have to do a lot of work to convert people's perception about and to make sure that they're taking the vaccine. And at the moment, 75 to 80% of hospital admission in UK are unvaccinated people. But now with the plan B in place in UK, people are now going in for booster vaccination because they cannot socialize. They're saying that unless you're COVID pass, you'll not be able to socialize. So it is turning on in a different way, but it's a mega issue. And I don't know how is the issue in India. I don't know. Are you facing similar issue? Maybe.
Okay.
Yeah.
Thank you, Phadke Madam, Dr. Manish, Dr. Abhay Shah. And it's really a great honor, Dr. Avinash Shah, if you felicitate our faculties, Dr. Phadke Madam, on the virtual platform.
Yeah.
And Dr. Manish and Dr. Abhay Shah.
Okay. Hi, Dr. Phadke. A brilliant speak, also Dr. Manish, and also Dr. Abhay Shah. Thank you so much. Brilliant speaker. Thoroughly.
Thank you, sir.
You're obliged. Thank you.
Thank you, Arvind Shah, for chairing the session. And we'll switch on to next session. I think Dr. Jaiswal is there. Dr. Jaiswal, Pradeep Jaiswal?
Yeah, take over.
Yes, sir.
Okay.
I'm here.
Okay, sir.
Yeah, take over, Pradeep.
So I request to conduct the further proceedings.
Okay. I welcome everybody for the next session. Am I audible?
Yes. Go ahead.
So I welcome you all. I am Dr. Pradeep Jaiswal, the Honorary Secretary General of COMHAD. And after so much discussion and deliberation, on vaccinology, I think these deliberations are eye-opener to everybody. I am sure that after this, you will surely be able to enjoy our next and dear to all, the much awaited late Dr. Pandurangi oration. So I will now request Dr. Yashwant Patil, International President, COMHAD, to introduce about the oration. Dr. Yashwant Patil, sir, please.
About this oration of International Organization COMHAD. COMHAD has started this Dr. V.R. Pandurangi oration in 2018. During our international conference, COMHAD held in Bangalore in December 2018. And this was as per the decision of GBM of COMHAD held in 2015 at Nagpur. This oration is held every 3 years during international conferences. His honor as a founder of this organization and to pay respect towards his human services for the welfare of mankind among the Commonwealth countries. Made this organization known to all 54 Commonwealth countries by traveling and visiting almost all states of Commonwealth countries. Today, we are having this second oration in his honor. About the biography of Dr. late Pandurangi. Late Dr. Pandurangi was the founder and patron Commonwealth Association for Mentally Handicapped and Developmental Disabilities, COMHAD. The name COMHAD had been changed to COMHAD in 2008 when the office came to India in the presence of the then Director General of Commonwealth Foundation, Mark Collins. Dr. Pandurangi was Managing Trustee of Commonwealth Trust for Public Health Cooperation and Director of Bangalore Health City Initiative. Late Dr. Pandurangi was born on 6th of January 1930 at Rane Benur in Karnataka state. He did his MBBS in October 1954 and MD Obstetrics Gynecology in October 1968 from Bombay University. Later on, he shifted to United Kingdom and settled in Sheffield. He was Fellow of Royal Society of Medicine and Secretary General COMHAD from 1985 to 1996. He retired from National Health Services, United Kingdom in 1987. He was founder member and committee member of many national and international associations and organizations mostly related to the mental deficiency. He had been honored by many institutions and had been recipient of Bharat Gaurav Award by International Society for Global Friendship. He had many publications in his honor.
Yes.
In his life, he met many respectable dignitaries all over the world, such as late Honorable President Gyanis Zail Singh, late Srimati Indira Gandhi ji, Prime Minister of Zambia, Shri Narendra Modi ji, the then Chief Minister of Gujarat. He met Honorable Her Majesty, the Queen Elizabeth II, so many times.
Okay.
He has participated as a speaker in about 33 international conferences and visited 37 countries to promote prevention of brain damage as an educational tool. After a dedicated life for health and handicap, he left for his heavenly abode on 10th May 2017 after wonderful innings for mental health. Thank you.
Thank you.
Over to Pradeep.
Pradeep.
Sir Uday Budhankar, the Executive Director, COMHAD, to introduce our today's speaker for the oration, Dr. Ramesh Mehta, who is also the organizing chairperson of this international conference and president of BPO, UK.
Okay.
Dr. Uday Budhankar, sir, please.
Thank you, Pradeep. With respected, my salutation to Dr. Pandurangi, sir, whom I was knowing since inception of COMHAD, 1994. Conference was there when I was the patient, and there was the first interaction with him. After that, we in 2008, he made me Secretary General in COMHAD in Pondicherry with the under the leadership of late Dr. Dr. Pandungi, and also guided by Dr. Rajaram Pagdala. After that, it journey went on. So I will not go much. Dr. Patil has already told Pandungi. My association with Pandungi more than 2 decades. Now coming to my most respected Professor Ramesh Mehta, sir, MD, FRCP, FRCPCH, FHE, DCH. Very few degrees I am taking. Well, it will take 1 hour if I read his real biodata, which in pages. I will say shortly. He is the patient and the founder of British Association of Physicians from Indian origin. For your information of all those who have joined today, it is an association of more than 65,000 physicians of Indian origin and since working more than 25 years for the welfare of this. So I think he needs to be complimented from all of us globally. After that, he took over as the patient of the Global Association of Physicians of Indian origin. Global means more than 145 countries of the world where our Indian origin physicians are there. And it is more than 1.2 million Indian doctors who are practicing. And he was the patient global, and I had the opportunity to work closely with him, even in BPO, in RCPC at London, and even GAPI also. I think he was installed in the presence of Honorable President of India, President President of India, Honorable Govind sir in Bombay, in Taj Hotel when I was witnessing. Further, he is a consultant pediatrician at Bedford Hospital, UK, more than 2 decades. He is a strategic lead for South Asia, Royal College of Pediatric and Child RCPC office, where, sir, I must mention it for the knowledge of all people that RCPC, the main person who is behind success of bringing him to India is none other than respected Ramesh Mehta. Give a big hand to him. Even in more than 8 centers are there in India where DCH, MRCPC is there. Even in Nagpur, because one thing, his love to not to me, but to Nagpur Vidarbha, you know, I don't know whether you people know. He is a alumni of GMC, Government Medical College Nagpur, where I am from GMC, and he had a brilliant career as a graduate MBBS, also had a MD pediatric. Dr. Rawat sir, his teacher, is also here. I salute him. So such a brilliant man who is a good human being, astute clinician, excellent human being, and full of empathy, sympathy, and whatnot. And such a person, I'm really honored to introduce him in short word. In addition, Dr. Mehta's keen interest in medical education, his clinical interest, era in pediatric rheumatology and childhood asthma, he has presented several papers national and international level. He is the recipient of many international awards. Let me only I will say one, but I know that is not possible for any Indian. Only India, know about you. He received the OBE equivalent to more than Padma Shri of India. So at the hands of Honorable Her Majesty the Queen Elizabeth. So give a big hand to him. OBE is not a joke. I think, sir, you are the jewel in the crown of her. So that was the. I think he is married. I must mention him. Behind every successful man, there is a woman. So my respected regard to Ritu Bhabi. I had an opportunity to enjoy hospitality at his house more than 4 or 5 times. Ritu Bhabi enjoyed traveling. Another thing, he enjoyed traveling and gardening in addition to academic teacher. So I think rest of the thing we are written in citation. So paying my tribute to Pandungi sir and my salutation to Dr. Ramesh Mehta sir, I hand over. He is going to tell us about global impact of COVID-19 on child health. Over to you, sir. My regards, sir.
Can you see the screen?
We are not able to see the screen. Are you sharing or it is sharing from the team? You can share also, but the team, okay, yeah? Prayata?
Sir, probably sir has not shared his PPT.
Okay, you have not shared your PPT.
Yeah.
Sir, then sir, you have to share. See, there is a
Sir,
share.
you have to share the screen.
Sir, there is a button here, sir. See my
Yeah,
share
yeah.
green.
There is green
There you
button,
click.
green button, share screen.
But first you have to download on your desktop, and then you go to share screen. Otherwise, it will not be possible. First, you download your all PPT on your desktop, and then you go to share screen, and from there share, and then go to slide. Sorry, sir.
Just a second.
Yeah. No. In the meantime, I think we are going to talk a lot about his achievement in the citation. Dr. Yashwant Patil has got a great job to do. Itu madam, my regard to her, sir. If she is there, would like to pay her. Have you downloaded, sir?
Just 1 second.
Yeah. Take your time. We are much ahead in the time. Don't worry. Okay.
Biju, what's happening?
Yeah, we are sharing. They are sharing.
Okay.
Achha, Biju has got.
Just a second, we are sharing your presentation.
Okay, it was with Biju.
Can you hear me?
Yes.
This is called technology. And you can see that I've been around for too long to keep myself updated with technology. So the team, central team, thank you very much. I await coming up of my presentation. But, you know, it's been such a pleasure to work with Uday and Yashwant over the last so many years. And Uday, of course, congratulations for the Lifetime Award, which is very, very appropriate. I have personally noticed you working so hard for benefit of not only children, not only the population, but also the colleagues. Yesterday, Yashwant also mentioned how you saved yourself from jaws of death. That's amazing. And I have read your book.
Thank you.
You know, you are absolutely amazing person. And I think there is no doubt that we are very proud of association with you. And Yashwant is such a good soldier with you.
Thank you. I know. I'm proud to have it. Madam Padke, Rawat sir, everybody.
Yes.
And
Rawat sir, of course, has been my teacher, and
yeah.
salute to him as well.
And young team of Prayata, RG, Pradeep, they are all helping me a lot.
Absolutely. And you know, this is first time that Bapio is working along with COMHAD. So although I'm personally...
I'm sorry, apology for delay. Don't worry. We are all here. Nobody is guest outside. We are all one family.
Due to the organizer.
Yeah. COMHAD Bapio is one family.
But you know, this conference has been an eye-opener.
Yes.
And I'm sure we will have to have many more conferences similar jointly for the benefit of...
slide is there, sir. Slide is there.
Okay, so I will kick off with this.
Yeah. So can you see yourself, sir?
Yeah, I can.
Yeah, thank you. Over to you, sir.
So thank you very much. Thanks for that very kind introduction, Uday Rao. My salutation and tribute to Dr. Pandurangi, and it is an honor and privilege for me to give this oration. I'm not sure if I'm the right person for this huge, prestigious job, but thank you very much. So I've been asked to speak about global impact of COVID-19 on child health. Can I have next slide, please? 4.3 million deaths have been confirmed by day before yesterday, by Friday, because of COVID. 4.3 million people dying just is crazy. This pandemic is one of the deadliest in the history. It has also caused anxiety. It has led to disturbed supply chains. It has overwhelmed the health systems. It has triggered geopolitical changes. 500 million people could be pushed into poverty because of this. And although vaccines are widely available, we have seen in the previous discussions that there is inequality and there are poor countries mostly are gone without vaccination. Next slide, please. The impact in general has been on health, on economy, on education, especially for children, on tourism, ecology, as well as politics. Next slide, please. Now, fortunately, over last 2 days and today, we've been hearing a lot about what COVID-19 has done to child health. We have had amazing presentations. There were talks on education and child protection. There was talk from Professor Yagnik about nutrition, amazing. There was discussion about mental health. There was discussion, general discussion, and I know Professor Parmesh is going to come later on that. And of course, fantastic presentation on vaccination. So we already know quite a lot about global impact. And what I plan to do is to just give an overview and touch on some other topics which have not been discussed. Next slide, please. So we know that compared to adults, children are much less likely to become severely ill. This is very clear. We also know that fatal infections in children are rare. Some children do develop complications and comorbidities, very, very few though. And we know that small number develop a significant systemic inflammatory response known as pediatric inflammatory multisystem syndrome. This is like a Kawasaki disease. Although recovery rate from that infection is pretty good. Now, the impact of COVID-19 on child health is a universal crisis with lifelong impact on some children. Now, it's very interesting that although these children are not getting the infection, the impact on them is going to be such a severe impact. So they are not the face of pandemic. Children are not the face of pandemic. But they are likely to be the biggest victims. Children of all ages and in all countries are affected. The harmful effect of this pandemic are most damaging for children in the poorest countries, the poorest neighborhood, and already disadvantaged or vulnerable situation. Next slide, please. Now, children in poor households, they are the invisible victims of this pandemic. The socio-economic consequences of COVID-19 pandemic on children's ability to access health, education, nutrition, water, sanitation, and housing, all this matters and it impacts on the survival of these children. Now, Save the Children and UNICEF have estimated that between 122 to 142 million additional children will live in households that cannot make ends meet due to the impact of coronavirus pandemic. This is terrible. Next slide, please. So let's see one by one the impact, how it affects the children. The nutrition, of course, is very important. Wasting, during my days in medical school, this was called marasmus. And then it was called kwashiorkor, and then it was called protein calorie malnutrition. So wasting is basically severe malnutrition. And it is expected that additional, so on the top of what's already happening, in addition to that, 6 to 7 million children under 5 may have suffered from wasting or acute malnutrition in last year, 2020. Stunting of growth, and this is very important for Indian circumstances, that, large number of children are affected, and thus there is stunting of growth, they get poor diet. Vitamin A deficiency was mentioned by Dr. Shah during vaccination. And 160 million children under 5 are missing a crucial dose of vitamin A. Women and girls are affected more. Hunger, of course, we talked about. There is food insecurity and school meals. I think school meals are very important. Let's talk about it in the next slide. So malnutrition, the fonts have been changed. In 2019, 47 million children under 5 were suffering from wasting, and 14.3 million were severely wasted. Now, of course, this lowers the children's immunity. It leads to long-term developmental delays, and of course, it can be life-threatening. These children require urgent care to survive. Household poverty has increased, supply chains have been disrupted, and food prices have soared. So UNICEF has said that it's increasingly clear that the repercussions of the pandemic are causing more harm to children than the disease itself, as we have already mentioned. Now, it's important. Can we go back to that slide, please? If you look at the next one. If you look at the chart on the top right-hand side and see India is in red, so Southern Asia is the sub-region with highest wasting prevalence in the world. Next slide. Now, free school meals we talked about. For many children, school meals represent the only food they would have each day. At the peak of pandemic, school closures around the world meant 370 million children missed out on free school meals. Guided by the World Food Programme and UNICEF, governments in 68 countries are providing take-home rations, vouchers, and cash transfers for children. However, that's obviously not enough, especially in very, very poor countries. Next slide, please. Now, it's very interesting that on one hand, the children are suffering from wasting, but on the other hand, there are a lot of children who are actually putting on weight and becoming obese. So obesogenic behavior in children is not uncommon in middle class and upper class families. And this is because of lack of structure during the day, increase of screen time, watching television, cartoons, change in sleeping routine need to be taken seriously. it can have profound consequences which are not easily reversible. So these are the children who are likely to have diabetes, heart disease, and so on in later life. So how can you prevent this? So you have to have structured routine. And I think most of the doctors watching this, probably your children, you need to be watched for this. Playtime and exercise time has to be given more. There has to be regular sleep pattern, monitor the screen time, give them a bit of exercise, and manage the weight management. Next slide. Now, here I think I feel very proud that when there was a crisis situation in India during March, April time, and there was huge shortage of even oxygen and respiratory equipments, we tried to rise to the occasion. Uday and Yashwant will know that we send a lot of equipment to Nagpur as well as the rest of the world.
Yes, sir.
We managed to send 130 ventilators, 300 oxygen concentrators, 5,000 pulse oximeters, and interestingly, we managed to send it to 50 centers. What is very important to note that we were sending this equipment not to big cities and big hospitals. We picked up our contacts in remote areas like Amte's place and a lot of other very, very small, remote tribal areas, and 50 centers in India, starting from Rajasthan to Mizoram and to Kerala and to Chennai, everywhere, all over the India. But we knew that people were starving, so we also were organizing sending of food packets and rations to daily wage earners. And also, interestingly, we used telemedicine because we knew that many doctors were so busy looking after severely ill patients that they had no time to do especially ward rounds to step down areas. And we provided virtual ward rounds, which was conducted by junior doctors or nurses, but supervised by senior people from UK. We also assisted with backlog of radiological investigations, so various CT scans, MRI, etc. were reported from here because the radiologists there didn't have time to do that. We also had virtual hub for tele-triaging with colleagues in India. Friends, we raised more than £500,000 worth of resources for Indian crisis. Next slide, please. Now, impact on education is very important. So on March 20, there were more than 1.5 billion children who were out of school, and 99% of low and lower income countries, the school children had no place to go. Now, the impact of school shutdown it could be really bad. More children could be recruited in militias. They could be sexually exploited. I think the previous speakers have mentioned this, especially I think Shekhar Seshadri had mentioned this important aspect, forced child marriage and child labor. All this is increasing. So United Nations, UNESCO has mentioned that when education system collapse, peaceful, prosperous, and productive societies cannot be sustained. Next slide, please. Psychological impact. There was discussion about this yesterday, and Dr. Ananta Dave had really explained a lot of important information about this. Now, we know from previous pandemics, and we have had nothing as bad as this, but severe pandemics in the past, like SARS and so on, that early childhood trauma is a major risk for developing a mental illness. It can delay the developmental progress of children as well. But the manifestations of this trauma can come later in the life. And it includes increase in substance abuse. It can cause problems with relationships. Of course, it can impact on the quality of education. It also increases chronic diseases such as asthma and obesity. It can lead to attention deficit hyperactivity disorder, ADHD. And it is well known that they can suffer from post-traumatic stress disorders. Of course, anxiety disorders and adjustment disorders are very common. Next slide, please. I thought I would put this poem from this 14-year-old girl called Purity from Nigeria. You have become a thorn in our flesh. Our fears keep us awake at night, seeing and hearing new cases every day, putting us in a state of total confusion, not knowing what is going to happen next. We were to have to support each other. We have to support each other. As children, we can lead our own capacity. Now, this shows, how are the feelings of children, what they feel. Next slide, please. And how stressful the situation can be on these children. And there is no doubt that there is a complex link between mental health and the social background. So children coming from poorer houses are likely to have a lot more stresses. Because they already have problem with food, clothing, heating, they are less able to give priority to mental health to their children and themselves, the parents. So the poor physical health can lead to comorbid mental illness. The children between 5 and teenage are likely to have a lot more impact. And also it can affect the parental mental health. Next slide, please. Next slide. Oh, we are getting normal fonts again now. Now, another impact of COVID has been change in the healthcare delivery and prevention of infection. Fortunately, the modern life is very different than what was during the Spanish pandemic early in the century. So we have been having the use of telemedicine. This is one big positive out of the pandemic. There has been a dramatic increase in the use of remote consultations. It does protect and safeguard patients and healthcare professionals because you are not meeting directly with the infected patients. Many routine reviews and some acute consultation can be successfully managed remotely. Next slide, please. So there are a lot of advantages of remote consultations. There is continuity of care. There can be diagnosis and management, seeing them on videos and so on. There are various communication means can be employed. Social media has become very important, although fake news was mentioned by Arvind. And accessibility of patients to doctor has increased. And also, of course, the low cost once the setup is done. But there are some disadvantages. So the emergencies cannot be prioritized. Follow-up reschedules can be difficult. Access is unequal. confidentiality is at risk, and setup can be high cost, especially in situations like India. Next slide, please. Now, the children with chronic disease and shielding has been a point of discussion. So children who had problems like cerebral palsy or immune deficiency or cancer, what was happening to these children during COVID times when everything is only COVID and COVID? So one good thing was, which we have now realized, that these children with comorbidities were not at increased risk of severe COVID-19 disease. And it was important, especially in UK, but I hope similar thing happened in India, that there was communication was maintained with the families, advice on hygiene measures, hand washing especially was given, and education about COVID-19. It was also found that shielding had a severe impact on children's physical and mental health. So I don't know how important shielding was in Indian circumstances, but in UK, these children were completely segregated and had no access to outside at all. And it did cause a psychological impact on these children. And now in UK, children, especially who do not have immune deficiency and have more of physical issues like cerebral palsy and similar problems, are encouraged to go to school. Because at the school they can get therapies, they can get some social contact and so on. Next slide, please. There has been excellent discussion about immunization delays, and I compliment Dr. Abhay Shah for giving us amazing information as to the impact of the delay with normal immunization. So we know now that incomplete immunization exposes communities at risk of an outbreak of vaccine preventable diseases. WHO has declared immunization as a core health service that should be safeguarded and conducted under safe conditions. Routine immunization services against disease, including polio and diphtheria, had been affected in at least 68 countries, and since March 19, risking the resurgence of diseases like measles and polio. This has been aptly described by Dr. Shah, so we'll move on to the next slide. Safeguarding. Dr. Sheshadri yesterday discussed about safeguarding. This is an important issue. It is given a lot of importance in developed countries, but I know that in India, it doesn't get as much importance which is required. Now, we know that vulnerable children are at increased risk of maltreatment and neglect at home. When there is a lockdown, long home confinement, the adults get frustrated, agitated, and may become aggressive. This happens all over the world. This is a normal human reaction. Also, there is a loss of safety net, which is normally provided by schools, social care, and health professionals. Disappears during the lockdown. And without spotting signs of abuse, home then becomes a very dangerous place. There is a trend of increasing incidences of domestic violence, very well known in UK. Children exposed to violence, either as witness or victims, experience detrimental effect on their physical and mental health. Next slide. There was mention about nurturing yesterday by one of the speakers, and nurturing care in early childhood is very important. But this was adversely impacted during the COVID, really when COVID was bad last year and early this year. The importance of nurturing is it outlines the conditions necessary for children to survive and thrive developmentally. Nurturing care outlines the conditions necessary for children to survive and thrive developmentally, for good health, adequate nutrition, responsive caregiving, security and safety, and opportunity for early learning. Nurturing care thus refers to the environment parents and caregivers provide to children through emotionally supportive and responsive interactions. Next slide, please. The International Labour Organization and UNICEF have warned that the pandemic is fueling child labor. I think child labor, I need to mention, we have always been worried about child labor. But COVID-19 has made really things much worse. Millions of children are at risk of sickness, injury, and even death to produce goods and services for the global economy. Now, many poor countries use children to do all these jobs, and these are hazardous jobs. Child labor in agriculture, mining, the leather and apparel industry, and other sectors. Next slide, please. I need to just make a mention of children orphaned or bereaved of their caregivers. Again, this was mentioned yesterday. So globally, from March 1, 2020 to April 30, 21, 1.1 million children experienced the death of primary caregivers. So they became orphaned. Such children often face adverse consequences, including poverty, abuse, and institutionalization. In April 21, in India, the researchers estimate an 8.5-fold increase in the number of children newly orphaned compared to March 21. So, orphan children is going to be an important lasting impact of the COVID-19 pandemic. What about race? Now, especially in developed countries where the white population is in majority and colored skin population are smaller in numbers, there is a race impact. On the other hand, this is similar to poorer people in Indian context, for example, have similar effect. So it's not just the race, but it's also the poverty. So in the context of European and America, the people of color and other marginalized communities convey disproportionately higher burden. They have effect of overcrowding, housing, frontlines. They are in frontline survey jobs. They are in low paid jobs, and there is limited safety nets. Inequality has been mentioned several times in different contexts, and they also have unequal access to medical treatment. I think this is similar to poor people in India. So they also have disparities in rates of infection, the harshness of symptoms. They're likely to die more often. The vaccine distribution we have already mentioned. There are job losses and of course leading to hunger. The shocking toll of pandemic has undeservedly the critical importance of connecting what science is telling us to the lived experience of people and communities. Ladies and gentlemen, I just need to give an example of what happened in UK during the first wave and also during second wave. The number of people with color, so ethnic minority, doctors, nurses, as well as general population were dying in a lot bigger numbers as compared to the white population. Now, whether the poverty itself was an issue, we are not clear, because well-earning doctors were also dying of color. So this is still being investigated, but there has been definitely impact of race. In a way, it was an awakening call for white people who have really appreciated the work done by Indian doctors in specific during COVID times in UK.
Yeah, thank you.
Impact of race, again, we mentioned about marginalized communities. I think we have done this slide. Next slide.
Yes, sir. Sir, 5 minutes left, sir. Sorry to interrupt.
Okay, or is it 5 minutes? Okay,
yeah.
I can carry on a bit faster.
No. Sorry.
Obesity, hypertension, we know that all these diseases which expose to COVID morbidity can also affect the children if, now this is an important point, these chronic diseases are also known to have an association with hardship beginning in the prenatal period. Now, yesterday, Professor Chittaranjan Yagnik mentioned the Barker hypothesis, where mothers who were not properly, who were malnourished, and how their children as they grew had more issues of obesity, hypertension, and so on. Next slide. So what is the future of children after COVID? Projections suggest that over 1 million preventable child deaths might occur due to decreased access to food and disruption of essential health services. Children risk missing out on growth monitoring, preventive care, and timely management of acute disease and injuries, and some children are suffering from domestic violence. Next slide. Children's future, especially those who are poor, female, disabled, indigenous, from racial, ethnic, and sexual minorities, is at risk. It is important to note that what is good for children is good for societies. Investment in children's well-being provides benefits that are immediate, long-term, and intergenerational. Next slide. So we are coming to the end of my presentation. This is what we need to do. Only with concerted efforts from parents, teachers, social workers, psychiatrists, and politicians can we be sure that children of all classes can emerge from the crisis ready to cope and thrive in the post-COVID-19 world. Next slide. So this is the last slide, and fake news was mentioned by Arvind Shah. And I think it's very important. And I noticed that since the social media has become so easily accessible, the fake news travels so quickly. Yes. So what do we need to do? So don't send the rumor to the group chat. This person double check your facts before sending forwarding. Forwarding has become so common. Just ensure that you get the news from trusted sources, and ensure that if you're not sure, just ask the question, is it true? Next slide. Thank you very much. I'm grateful to you, Uday, Patil Sahib, Yashwant Rao, and all the COMHAD group and Bapio for giving me this prestigious opportunity for the oration. Thank you very much.
Thank you, sir. Now, we recognize the presence of Dr. Swati Bhai, madam. You know Mehta sir very well. She is here. The more dynamic national president of IPA and founder of AH in India. So we recognize, madam. Please welcome you. Over to Yashwant Patil, please. For citation reading. Biju Simon is giving me this thing. You have to be in time.
It was an excellent oration.
Yeah.
As it is an oration,
yeah.
There is no comments and no question and answer. Now, I think, Ajay, you have to say something.
Yeah. Yes, yes.
So on this occasion, we are going to give citation, this block of this date, Dr. V.R. Pandurungi oration of COMHAD UK. Oration given by dear Dr. Ramesh Mehta sir. As a renowned pediatrician of national and international repute, you have been rendering excellent health services to the children of the world for more than 4 decades. You have been a consultant in the National Health Service of the United Kingdom for 36 years and consultant in pediatric rheumatology at the prestigious Bedford Hospital, London. Teaching has been your passion, and your work as a pediatric postgraduate clinical tutor at Cambridge, Diné, undergraduate specialty tutor at Cambridge University, instructor for advanced pediatric life support, lab examiner, General Medical Council and Regional Examiner for Royal College of Pediatric Health has been truly exemplary. You have held several important positions in your illustrious career, such as National and Overseas Examiner for MRCPCH, right from 2004 to 2009, and Vice Chair, MRCPCH Part 2 Board, and elected member of Council of RCPCH, and Chair Pediatric Development Group, Eastern Region, and Strategic Lead for South Asia for RCPCH from 2014 to 2020. As a Fellow of Higher Education Academy, United Kingdom, member of Standard Setting Group for Pediatrics and Neonatology, CMC UK, and Reviewer of Healthcare Commission UK, your immense contribution to education and research has been widely acclaimed, sir. You have been a recipient of several awards, including the prestigious Clinical Excellence Awards. You were HSJ Top 50 BME leaders in the National Health Services for 2 consecutive years and HSJ Top 100 Clinical Leaders in the National Health Services for 2014. You have also been honored with the Honorary Fellowship of RCPCH. Sir, you have been honored with highest recognition during Her Majesty, the Queen of England, Elizabeth II, Birthday Honours List 2017, with appointment as Officer of Order of British Empire, that is OBE, for your services to the National Health Services. Third, you being the founder president of BAPIO, that is British Association of Physicians of Indian Origin, one of the most influential organizations of doctors of ethnic minority in the United Kingdom, and as immediate past president of GAPIO, that is Global Association of Physicians of Indian Origin, representing 4 million Indian doctors practicing worldwide. You have emerged as a global leader in child health. May you bless with many more honors and your hands be strengthened to create a difference in the lives of children all over the world. We, the Organizing Committee of International Conference of COMHAD and BAPIO UK, hereby feel privileged to felicitate you, Dr. Ramesh Mehta sir, for delivering late Dr. V.R. Pandurangi oration with scroll of honor on this 12th day of December 2021. Undersigned by Dr. Mrs. Mridula Phadke Madam, Dr. Yashwant Patil, and Dr. Uday Bodhan sir. So this we hand over to you, sir. I have already instructed your office that this scroll of honor will be handed over by Ritu Madam at your place. I don't know what had happened.
Ritu Madam is there because we occasion can you focus on the I have got his scroll of honor here with me. So can you focus in front of instead of me? Sir, this is an honor for us in COMHAD BAPIO to honor this prestigious oration in the name of late Pandurangi. So
Thank you very much.
Can you see this?
Yes, yes, we can see it.
Yeah.
No, that's
It's
very
our honor
kind.
to accept this, sir.
I am certainly honored. Thank you very much.
Yeah. So sir, instead of me, I think it is better to see the citation. So this is for you, sir. And I think if Ritu Madam is there, we'll like to hear from you, from her. Is she there, sir, Bhavi?
No, she didn't know that she was wanted. So
We in fact conveyed to your secretary,
I have
Deshpande.
conveyed to Sneha Deshpande
Yeah.
that
Yes.
you take a color copy, laminate it, and hand over to Ritu Madam
Yeah.
to felicitate you at that time.
Even we told to Ashok Khanda. Anyway, sir, this is another same topic, but this both will be carried to in UK by Ashok Khandelwal. So this is
thank you.
Thank
This is very kind and this is unexpected. So thank you
I-
very much.
Thank you.
You are too nice. You are too good.
Oration.
Yeah, before I conclude, Yashwant Patil, can we ask Dr. Swati Bhai Madam, because she is there for to say a few words. She knows Ramesh Mehta very well in Delhi. Madam, over to Swati Bhai Madam.
I request Swati Madam.
Please.
Please.
She is an expert in adult and whatnot. She is on IPA.
Veena, please unmute, madam.
Yes.
Yeah, yeah.
Swati Bhai Madam.
So unmute yourself, sir.
Thank you, Ramesh Mehta sir. Wonderful celebration. Mind blowing.
Thank you very much. And thank you. It's good to see Swati. She is such a good hospitality. She
Veena, can you unmute Dr. Swati Madam?
Swati
Just make her
Bhave.
co-host.
Yeah, make her co-host or Swati Bhave. It is written here. She is next to second day. Let me second day.
Swati Bhave, madam.
हाँ स्वाति भावे स्वाति
Yes.
भाई भावे
Yes.
yeah no she is there so yeah madam you are unmute if I'm not no you are not
Madam, please unmute yourself.
Swati try to unmute
Yeah, thank you so much. Yes, Dr. Mehta, such a pleasure to see you virtually after such a long time. I
Sorry, carry on.
I heard the last part of your oration. It was fantastic. I wish I had come earlier.
I know yeah
I can't forget the wonderful whiskey that was given to me by your good husband.
Yes, he remember you.
few words of blessing greeting from Swati bhai. You are an expert in adult in COVID. Two lines something you know better than us.
No, I love what Ramesh Mehta spoke, and what he said about UK is also true in India. And this digital, we did a lot of programs on challenges of e-learning. And in the COVID situation, we had a big digital divide of the haves and the have-nots. Those children who did not have internet access and those children who did not have their own smartphone devices really suffered a lot in their learning process during the COVID. And now from pediatrics, I switched to adolescent medicine. And I do a lot of teleconsultation for families and teenagers during the COVID period. And this e-learning has been very, very challenging. And now that the schools are opening, now children are finding it equally difficult to go back to school because for so many months now they have become used to e-learning. They have overcome the challenges and now they have to go and face the real world again. But I would also like to say a few words that we all talk about the bad effects of the COVID pandemic. The American Academy of Pediatrics has declared the pediatric situation as a mental health emergency. But a lot of things also have come out from COVID. I think people have realized the difference between what we need and what we want. And our needs are so few and our wants are so many. And the families which I have counseled, those who had resilience, those who had coping capacity, those who were very harmonious with each other, have sailed through the COVID with a much positive mental health. On the other hand, those families who are dysfunctional, who already had marital discord or lack of communication between parents and teenagers, and those who had a lot of financial crisis, they suffered much more. So I think what the COVID has brought out is the resilience which is needed in a human mind. And those who are resilient will always come through any crisis. And as I tell all the teenagers, don't look at the negativity of what you have suffered. You have suffered a crisis, a global crisis in your teenage. So you are much, much stronger than our generation. And you look back upon this time and say, we are strong enough. We came out through COVID. We can face any situation. So I always end this with a positive note that COVID has taught us a lot, has made us face a lot of disasters, but COVID has also made us more resilient human beings and more spiritual now because we know what is need and wants. Thank you.
Thank you. Wonderful. Over to Patil.
So,
Word of blessing from Swati. Wonderful.
Thank you very much for your blessings, madam. Thank you very much. So here is the end of our oration. I hand over the mic to the Pradeep Jaiswal. Pradeep? Okay, Pradeep, sir.
thanks a lot. Great oration, great orator. Blessings from all the dignitaries.
Yeah.
Thank you so much, sir, madam. And we will move to next session now. That is the most awaited valedictory function. So I would like to call Dr. Urmila Dahake and Alpana Mure,
Also,
who are MOC.
Prayata, sorry, tell them that this is not the end of the session.
Yes, of course. We have got interesting sessions later on.
Please mention the session name before.
I'll just mention names of the sessions. That is, one is rehabilitations, these recent advances in spatially challenged, then BAPIO session, and then mixed session. So 3 sessions we are await are in line after this valedictory function. So please be there.
Ramesh Kumar has come here. He has raised a question. Yeah.
Dr. Urmila and Alpana, please take it.
A warm good evening to all. Am I audible?
Yes.
A warm good evening to all. I'm Dr. Alpana Mue, anchor for today's valedictory function of the International Conference of COMHAD and BAPIO UK 2021. I'm indeed humbled to welcome such a wonderful gathering today, a galaxy of intellectuals, passionate professionals from across the world working for the cause of disability. For the last 3 days, we have witnessed an academic extravaganza, making us richer and more determined to work for the cause of disability. Now, may I request Dr. Ramesh Kumar, National President-elect IB 2022, to address the gathering. Can you please, sir? You need to unmute, yeah.
Unmute Dr. Ramesh Kumar.
Yeah.
Yes, sir. Welcome, sir.
1 minute, sir. So, good afternoon, all this esteemed dignitaries on board the COMHAD conference. Dr. Uday Bodhankar, Dr. Yashwant Patil, the international president, Bodhankar sir, the backbone, the all in all of the COMHAD, and all our mentor for the majority amongst us. Dr. Yashwant Patil and Dr. Swati Bhave ma'am is here, and all the Dr. Santosh Sons, my president for 2018, and all the faculty and the senior members here. It's quite a privilege to join you with the COMHAD conference, and it's quite heartening to see that 3 days of great scientifics has happened here today, and it's still continuing. And a lot of innovative topics, sessions on the mental, the disability and other aspects have been discussed. And of course, this has given an opportunity for us to the members, especially the EAPNs and other members of the pediatric fraternity, to hear from the Indian diaspora, especially in UK, and because it's being held in association with our compatriots in the UK, our British BAPIO. So it's all good to see a lot of information being shared and exchanged and disseminated across the fraternity on all aspects. And it's COMHAD has been doing a wonderful service on this aspect over the years with Bodanga sir, the ever passionate man at the helm, and always leading from the front, and a great team joining them, Dr. Ramesh Mehta from BAPIO, Dr. Sanjay Gupta, Dr. Biju Simon, Dr. Renu Jainar. We have got a lot many stalwarts from BAPIO who take this collaboration forward. And I wish and hope that this listening between COMHAD and BAPIO will continue to disseminate, empower the IAPNs or the pediatricians of our country with more and more scientific wisdom on the disability, on this, especially on the disability aspect. And we would always love to hear from you, and always Indian Academy of Pediatrics will always be obliged to you for equipping our members with more scientific knowledge on this domain. My best wishes, and this is actually on behalf of the team of 2022 of Indian Academy of Pediatrics as the president, incoming president. I promise and assure all-hearted support to the activities of COMHAD and BAPIO, and we would like to always to be associated with you and your activities, and would always like to have joined, work jointly together on all platforms wherever available. Now that the virtual platform is there, we will always be a pleasure moving ahead on all aspects. So once again, my congratulations and my best wishes. And it's right now I am in the IAP office, Central IAP office, so addressing you from the IAP office, and well, working with my boys in the IAP office, going ahead, marching ahead to the year ahead. So thank you once again for the opportunity, Bodanga sir, and all my teachers, mentors, seniors, Santosh sir and Swati Bhave ma'am, as well as Yashwant Patil sir, all in BAPIO, and great to hear you and great to be with you on this afternoon. Thank you very much, and wish you the very best. Thank you.
Honored, sir. Honored by you.
Honored, sir. Honored, sir.
Thank you.
Over to Urmila or Alpa.
Thank you, sir. Thank you, Dr. Ramesh Kumar, sir, for your encouraging words. Now may I request Dr. Santosh Sohan, sir, Professor and HOD, Department of Pediatrics, AJ Institute of Medical Sciences and Research Center, Mangalore. He is the past National President of IAP. May I request you, sir, to kindly address the gathering?
Paita, can you see him? I'm not able to see.
Is there?
Yes, sir, he's there. He's there.
Okay.
Sir,
Unmute.
Dr. Santosh, sir, could you?
Since he is muted, please.
Yeah, I'll just see. Veena, please, would you make Dr. Sohan's co-host so that he can unmute himself?
Yeah. Right. It's unmuted. Unmuted.
Yes. Unmuted. Yes. Welcome.
Thank you.
Yeah. Good afternoon, everybody. It's a great privilege.
He's not audible.
He's not audible.
Not audible.
He mentioned me. He was traveling to Bangalore to be the chief guest in IB function.
He might be in the transit. So
yeah,
that's why.
Just see it. Yashwant sir, can you phone in? In the meantime, if it is not there, Is Patanjali
who is the general of COMHAD for a long time. The COMHAD has done a.
He's here, sir, again.
Yeah. Yeah, it is here. He is here.
He's here, sir.
Yeah.
Again, he is muted.
Sir, please unmute yourself. We are not able to hear you.
Has been there.
Unmute. Unmute yourself, Santosh.
Akhilesh, kindly unmute.
Yeah, is okay.
Yeah.
So, yeah, sorry for this thing. See, now has changed. There's lot of disruption has happened. If you see, these are quite things which happen in the centuries. If you see, the disruption was so much. I think a lot of people lost at least somebody from their family, and some of the whole villages or towns were wiped out. But we humans are so resilient. We try to come back to the normalcy. So last 2 years has been a disruption, but somehow we couldn't meet, we couldn't have the conference, but somehow the Zoom came in and we are all on this platform trying to sort of. So I just remember there are going to be a lot of hurdles. When I talk about hurdles, I remember because we have in our Indian Medical Association, every year we have a cricket match between the college team and the private practitioners. Because after the cricket match, what happens is that it's happened in the morning, only about 10 hours, by about 12:30 we finish the match. And usually what they do is they serve the beer. And there's a long queue because students come, so many of almost about 1,000 people come and this thing. So there's a queue. So my close friend was there. He was a batsman. I was a bowler in that our college team. So I said, they are offering free beer. So he said, there's a long line. Whereas I said, it's a free beer. Let's go and have it. But he was saying it's a long queue. I don't mind going. I don't want to go there with such a long line. And this sort of shows you what perspective it is. I was seeing the free beer and he was seeing the long queue. Same way, I think Dr. Bodhankar, Yashwant Patil, even during this disruptive time, saw that what they want, they would not see the hurdle. They wanted to have this conference and make it into a successful business. And we have a lot of dance. I just heard Dr. Ramesh also, and the whole team from BAPIO. BAPIO has been in the forefront for arranging this conference and giving the Indian medical fraternity a regular input from abroad. And we have Dr. Swati Bave herself. I think she is one of the gems of our Indian Academy of Pediatric, who's been in IPA, and so many innovative things she has brought in. And I'm sure with all of you there, this last 3 days has been an academic feast for all of us. And I'm sure this disruption will never last. It's going to be there, and we are all going to meet again, and the life is going to be same in maybe in 6 months or 1 year, we don't know. If you look at the past history, I think as humans, we are such a resilient animals. I think this is not at all a big hurdle for us. And as I said, when you look at the opportunity, not the hurdle, everything is possible. And with these few words, I congratulate the whole COMHAD team for making this as a grand success. And I think even after the valedictory function, we are going to have a long time of thing. I have actually come for another valedictory function from Bangalore to Bangalore.
I know.
Bangalore golf course with Dr. Georgie, who is one of your friends who's here. You can see Dr. Georgie. Say hello to them. Dr. Hello to them. And who was an office bearer of COMHAD. And with I wish you all the best. Thank you so much. And Dr. Mallikarjun also is there with me. So all the COMHAD members only. So with these few words, I wish you all the best and for the further thing, and congratulations and almost completing the 3 days program. Thank you so much for inviting me. It's a great pleasure and honor to be with you. Thank you so much.
Thank you, Santosh. You have kidnapped our people. Jai Jura Mallikarjun. Thank you. Honored by your presence. Over to Alpana. Thank you for making it.
Thank you, sir, for your kind words. May I now request Dr. Patanjali Nair, sir, Regional Advisor, Disability and Injury Prevention and Rehabilitation, Department of Healthier Populations and Non-Communicable Diseases, WHO Regional Office for Southeast Asia. May I request you, sir, to address the gathering?
Are you on the platform?
Is he on the platform?
I'm not able to see him on the platform, sir. Probably.
Notice whether he is or not.
If he is not there, then we request Honorable Dr. Swati Bhai, and in the meantime, we wait for before I take over. So we can. I will introduce. I think Urmila, would you like to introduce the great, or I will request Patil sir to introduce Swati Bhai. Patil sir. Acha, I will introduce. She was the most dynamic, only lady national president of IAP. IAP is a body of Indian Academy of Pediatrics, which is more than 35,000 pediatricians. And she was not only national president, but she brought many changes, like what you are seeing, adolescent, which was we were seeing the children up to 12 years. But from 12 to 21 was brought by during her regime, 2000. And I'm thankful to Swati Bhai. We brought her emergency as the chief guest. So, but she said, Uday, when you said, I will come. So thank you for honoring your invitation. She was also on the highest global body of IPA, International Pediatric Association, as the standing committee member, as the executive director, which is a body of more than 145 countries of the world. She is the founder and chairman of AHA, the Adolescent Health Academy, which is the main, which is growing like anything in India. I think I will not talk much. I will hand over to Dr. Swati Bhai, Honorable, to say few words of blessings and greetings on this occasion of International Conference of COMHAD and BAPIO. And our theme, Madam, you know, is post-COVID-19 challenges of the challenge. Over to you, Swati.
Thank you. Then it's a real honor to be invited to this August COMHAD and BAPIO conference. And I've been really admiring you, how you have kept this COMHAD going over the years and how you got into the younger people, mentoring them and continuing this organization over years. And I still remember you sharing your photos with Queen Elizabeth when you had gone to London and met her during one of the conferences. And I'm so glad you have joined with BAPIO, with Dr. Ramesh Mehta, who is also a pioneer in many things. And with Yashwant Patil now at the helm of affairs, I'm sure COMHAD will do a lot of good things in the coming years. Talking about the COVID challenges, it has been really devastating. And if you see the mental health situation, the anxiety, the depression, the OCDs, the flag signs, all have come up. A lot of internet, in the past, we used to tell adolescents to have reduced screen timing. We used to also tell the parents to monitor the screen timing. And during the COVID, screen has been the only way we can communicate. And as we all are there again on the screen, it becomes so difficult not to get screen addicted. And hence, just as we give healthy diet and we give prescription of the right amount of protein, carbohydrate, and a balanced, nutritious diet, last 2 years, I have been doing what is known as healthy media diet prescription. So I have to talk to the adolescents, I have to talk to the parents and tell them what is healthy media and what is healthy screen. And it was not easy, but we have convinced parents and the adolescent that since screen is the only time for communication now and e-learning is taking away 8 hours of your screen time, learn as a family to have entertainment, relaxation, which is non-screen. And we have encouraged a lot of families how to do yoga together, how to put a tape and do aerobics and dancing together, how to do creative painting, sculpting together, and how to cook together. You know, Indians are so used to having servants, especially the affluent families, that children are not used to doing any household work. And COVID situation, we had to teach the parents that household is everybody's responsibility and not the mother alone washing utensils and clothes, etc. So in the COVID situation, many of our families now understand that running a household is everybody's responsibility. And all have worked together jointly. So the mother is no more bearing the burden of running the household. So I think just as COVID has devastated people, they have lost jobs, they have been having mental health issues, the division between the poor and the rich has increased, and the malnutrition in children has tremendously increased because of the school stoppages and midday school programs not being able to provide the meals. But at the same time, I think that we all will emerge stronger from the COVID situation. And hopefully the science will prevail. Hopefully newer vaccines will come. Hopefully people will understand the importance of continuing the COVID appropriate behavior. And if you see all the photos of the Spanish flu and how people overcame that time, we have this hope and the strength. And I think as a country, India should be very, very proud. The way we have overcome this, the way we had vaccination, and some of our pediatricians like Vasant Khalatkar doing the trial of the vaccine, and we are much ahead in pediatric vaccine as compared to others. So I think every calamity teaches us something. Every cloud has a silver lining. And though we are going through a very bad phase, I'm sure we all will emerge stronger, and our children will emerge even stronger than us because they are undergoing this crisis in their formative years. The children below 10, the children, the teenagers, all in their formative years are learning how to cope up with the crisis. All of us in India were very fortunate. We are a democratic country. We are not seeing wars. We are not having civil wars like other countries. We don't have these extensive famines. So I think as a country, we were very, very complacent because everything was so good. And now we'll all learn that you have to have crisis. But of course, we have to take a lot of care of the marginalized people, the poor people, the ones who have undergone malnourishment, the ones who have lost their jobs. And as the affluent society, it is our job to take care of all these people along with the government. Thank you so much for all of you for inviting me. And it's a happy occasion that these 3 days have been wonderful and so much learning.
Thank you, Swati, to be the chief guest of this function. Concluded. Over to Partha. Is Nair there?
Sir, I'm not able to see.
Okay. Then
Shall we move forward, sir?
Yeah, please.
Yeah.
Thank you, Swati.
Thank you, sir.
Honored by your August.
Madam.
Now that I've joined, I'll listen to the other academic deliberations also.
Yeah, there is academic after 5 minutes of thanking me.
Yeah, so I will continue on that.
Yes, thank you.
Thank you, madam, for your encouraging words. May I now request Dr. Uday Bodhan, sir, the Deputy Chairperson of Commonwealth Health Professions Alliance, to virtually felicitate the committee members. Sir, we have you.
Thank you, Alpana. Thank you, Urmila Dake. Thank you, Yashwant and Prayakta, for giving very difficult job of thanking everybody. Please excuse me in the beginning if I miss somebody. But before going for the exercising my gratitude, as usual, I know, I would like to say a few women with the permission of Madam Phadke and Yashwant. Gratitude is more than being thankful when the emotion is expressed. It is about giving more than handful and yet feeling blessed. Gratitude is being grateful for whatever we achieve, because more we are faithful, the better we conceive. Gratitude is being humble to the world we see. Caring for one another and appreciation is the key. Gratitude is an acknowledgement which you are doing to all of all the wonderful deeds which you all people did from COMHAD and BAPIO. A feeling of gratitude should be shown because that is all we need. I think with this few words, I will go on one by one. We would like to express our gratitude first because we are the host. BAPIO UK is the organization of Swati, you know very well, more than 65,000 medical professional UK, and it has been founded by respected Dr. Ramesh Shweta. So grateful to you, sir. Dr. Biju Simon, a very silent worker, organized secretary, joint secretary of BAPIO UK. Dr. Renu Jenner from UK. Dr. Sanjay Gupta has been always there. Ramesh Shweta, sir, you were not there yesterday. Sanjay Gupta has announced donation of 25,000 for the Swarananda Orchestra yesterday. Thank you for your generosity, Sanjay Gupta. Also, I would like to mention one name, Dr. Ajan Gupta, who is the chairman of BAPIO, which we miss. Next, please. So this is the team of BAPIO. Now coming over to UNICEF. As you all know, our mother figure, most beloved, respected Dr. Madhula Phadke, without whose blessing, greetings, and financial this thing, we could not have UNICEF. She is the senior advisor of UNICEF, also advisor of we, and also former vice chancellor, where I was the pro vice chancellor. Thank you, madam, for blessing. Now, Dr. UNICEF chief, Dr. Rajeshwari madam, Chandrasekhar, chief of UNICEF Mumbai. But we don't contact her because we are having a contact person, Dr. Rajalakshmi Nair, very good friend of mine, very humble, thoroughly helping all. उदय सर आप जाइए करिए यूनिवर्सिटी, मतलब मैडम पैसा नहीं है तो पैसे की फिक्र मत करो, आप करिए, आप यशवंत पटेल करिए, हम देते. So I think Mehta sir, since last more than 1 decade, we are having so many UNICEF workshops with COMHAD, with MOH, all everything funded by Rajal. So thank you, Rajalakshmi. Next. Now coming to, this is not UNICEF, this is DMAR, so wrongly written. Our partner always, our partner has been always DMAR. Honorable Dr. Dilip Mahsekar, who is a DMAR, he was Vice Chancellor MHR. Vivek Pakmode, he is a joint DMAR, dental surgeon. His child was looked after me. And I must mention, it is not Dr. Srikant Savalkar who are doing Yemen job of compiling everything. So we are grateful to DMAR, is Director Medical Education Research in Bombay. Next. Now coming to COMHAD body, I'm grateful to Honorable Dr. Sirajul Islam, the patron from Bangladesh, my teacher, my mentor, Professor Rajaram Pagdala, who is in USA, always had been helping. He was Director General of India. And yeah, to tell you, Ramesh Mehta, I was National President of IP in 1994. He was DGHR. I said pediatric was not major. He said, Uday, come on. As a DGHS, I will write to all universities. He wrote to all universities. 5 universities introduced pediatric as major subject. Thank you, Rajan Pagdala sir. Dr. Prakash Sangvi, you know, very dynamic from Kolhapur, always helping. And Rawat sir, what to say? He's my teacher, mentor. Sir, always your blessings are there. I'm grateful to you. Sunil Khapade, who is a advisor, Minister of Health, Government of India. My friend, he's from Nagpur, GMC. He was the person who was instrumental in bringing down COVID cases in Dharavi, and which was the topic in WHO. Thank you. Dr. Parmesh sir, who is the president of COMHAD India chapter, always helping, and my friend, my philosopher, always his family, almost all of them, I owe to you, sir. Next. Now come on, my team, working team, if you say, Jayajira is from Bangalore, he is always there. You have seen him now. He was kidnapped by Santoshon. Then, of course, Secretary General Pradeep Jaiswal is always there. Okay, Finance Minister, Treasurer, always there. And Avinash Gawande, he was the person who is responsible for bringing COMHAD to publicity. You will be surprised with Avinash Gawande's 1 day notice, more than 60 publicity people, media, and 10 TV were there for the case conference. Thank you, Avinash. Of course, Dr. Viraj Shingade, today morning we inaugurated. He is a pediatric orthopedic surgeon. We had one workshop going on. He is busy. He is not free. Thank you, Viraj. Of course, I will fail in my duty. If I don't mention our main source of inspiration and work, who is working day and night, Dr. Payata Kaduskar, I would like to mention in that, but now Dr. Payata, thanks to your, you know, I used to phone her after 12 midnight, 11, 12, 1 a.m., 2 a.m. She is working. Thank you, Payata, for your dedication, devotion, and everything for the success of this conference. Next. Now, here are other people like Dr. Jaya Shivalkar. She was the sole person who single-handedly deal our souvenir, which is more than 150 wear. Thank you. She never took any help, even not my help, Dr. Patil. So she did with the help of our printer, Monal Malji. Dr. Vijay Dhote, very photo. He is a joint secretary and COMHAD, also president of AOP Nagpur. Thank you for your support, logistic and technical support. Dr. Urmila Dhake, Joint Secretary, and she is the professor in AIMS Nagpur. She was Joint Secretary, her helping hand as a chairperson. Of course, I will fail in my duty if I don't mention Dr. Pankaj Agrawal, who is the dynamic secretary of AOP Nagpur. He has, sir, Pankaj ये करना है, यशवंत ने बोला, हाँ सर कैंटीन सर बिल्कुल हॉल भी करना है, ठीक है यश को लाना सर. For everything he says was yes. Every event management. I think he should have been pediatrician. He should have been best event manager. Next. No, I cannot forget all respected therapists, madam. Actually, I wanted to photograph, but because of the constraint of time, Honorable Dr. Sophia Azad, HOD of OT department, GMC Nagpur, which is very close to my heart. Thankful to Dr. Umaji Damke madam. Both of them were there in the morning also and every day. She is the director of physiotherapy, Medical College Nagpur. Manisha Deshpande, HOD of physiotherapy, Lata Mahesh Hospital. Meenakshi Vantikade, pediatric physiotherapy, Alpanamay therapy. Amita Vandari, she is the chief of neuron. Priyanka Raikar from Goa, she is doing Yemen services. Sheetal Mundara, So I think all these therapies which are seeing, I'm subject to therapy every day. So it's in last 12 years. I know importance of them. Then coming to supporting team, occasion event team, they are there with Rahul Bodanga team. They are doing wonders. Printer, I must not forget Dr. Monal Malji, day and night he is there. Paliwal Caterers, Yash Computer, Shubham Kale, IP, Print and Media. Yeah. In addition to that, I think another person who we are missing is Deputy Director of Health Services, Dr. Jaiswal sir and his team. We should not miss them. All the print media which were there. I think anybody, IMA staff, IMA team, the drivers, the peons, the attendants, everybody, we are grateful to them for working day and night. I must mention 3 people in the end. Coming to the end, I left the most important man here. Get the next slide. Yeah. So that's why I kept it in the end. You can't imagine how much stressful he has gone after even bypass, his family issue, losing it better up. But since 3 years, he has been working day and night. Even to yesterday, even last 1 month, I trouble him after 11 p.m. because that is the time I am free. So he's working relentlessly as a secretary, as a joint secretary, as a treasurer, even as a whatever you say. So Yashwan, salute to you. And this is in recognition of you. I will like to read the citation which were prepared. One word, so all the citation, whether mine or Yashwan or even Mehta was formed by Dr. Shobhara Kirwadkar. I must mention it, that his name was not there. She is behind every citation. She is very good author, orator and everything. So Shobhara, thank you very much for reading every citation. I will leave the citation. Special Appreciation Award of COMHAD UK to Dr. Yashwan Patil, MD, DCH, FIP, FIC, MCH, International Patient. Sir, as a dazzling diamond, you sparkle. I know he is not aware of this award. As a dazzling diamond, your sparkle has spread far and wide in the arena of child health and Divyangajan. That's the word he told. Being impactful in every field, you have tried hard to build a holistic health for the children. Sir, you have been closely associated with COMHAD along with me and along with Pagdala, Madam Parke for more than 2 decades, working with full dedication and devotion for the welfare of specially challenged community. As the President of International COMHAD of UK from 2019, you have rendered immense services to the organization with utmost devotion, dedication, and sincerity. Your matchless effort to make a difference in the lives of differently able children and people are truly exemplary. May God bless you to carry forward your dream of helping the Divyangan children. We, the organizing committee of International Conference of COMHAD and BAPIA UK, hereby feel privileged to felicitate Dr. Yashwan Patil, International President of COMHAD. He is going to be there for 1 year. We began to him. We don't want to leave him. With this call of honor, Special Appreciation Award of COMHAD UK on this 12th day, December 2021, signed by Honorable Mudula Phadke Madam, our advisor, UNICEF chairperson and advisor, by me, and of course, respected Professor Ramesh Mehta, President of BAPIO, GAPIO, and organizing chairperson. I think I would like to show if you can focus on, can you make, so I wanted to keep it as a secret. That's why I never wanted to give. Can you focus even on this slide, please, here in my hand? So, yeah. So Yashwan, sorry, I know you are not aware of this. I kept it a secret. Only me and Prayakta were knowing. So kindly accept this. I will come to your house and accept this, and also accept both the things I made, like I made for Mehta. So with this, I think if anybody is remaining, kindly excuse me. I tried to make most of the people, including the hour, everybody working, everybody. So if anybody is remaining, it is only out of some distinct, but don't, everybody who is working for the success of BAPIO and COMHAD Conference, UNICEF, DMR, my salute to, I request Yashwan Patil to say a few words in the end, and then we close. Biju Saman, only 5 minutes late, sorry. I know it's over to Patil sir.
You have performed my duties to felicitate all our workers in the COMHAD, which were respected people and everybody. I express my views that I don't deserve this felicitation because I am just a worker of COMHAD. But it's all because of under your guidance and my guidance, these people they have worked, the respected seniors, they guided us. That's why we could achieve. And I could work for 2 decades along with you for the COMHAD. So, great heart I accept. But this award goes to all the people, those who are with me since I inserted in COMHAD, like Dr. Vasant Thadatkar, Dr. R.G. Patil, Dr. Bagade, and Dr. Saraf also. Saraf was also with me.
Yeah, he was with us.
Yeah. Then now Dr. Prajakta, Dr. Jay Shivalkar, and Dr. Pradeep Jaiswal and Dr. Uke. These are my team members. These were the working heads with me since 2008. So the credit goes to all of them, not only me. Thank you very much.
Thank you, Patil sir. I think I forgot to mention all the faculty members, all chairperson, MOC, all these things by name. I think we will have big function in Nagpur. We will invite you also. To all chief guests, including Swati Bhai, guest present today, and all chief guests, all past president of IB, and also all the WHO fellow, UNICEF fellow. Thank you. Over to Payatha, please.
Urmila, would you like to just give a word?
Yeah.
To say thank you, because almost all the duties have been done by Dr. Bodhankar.
Yes, that's so much true, Dr. Prajakta, and thank you, respected guests, dignitaries on the virtual platform. I, Dr. Urmila Dahake, Joint Secretary, COMHAD UK. I'm honored to propose the formal vote of thanks for this validatory function. More than half of my work has already been performed by respected Dr. Bodhankar sir, who is the most young and dynamic personality, I would say, from COMHAD, under whose leadership we all are working. And other than Dr. Bodhankar sir, Dr. Patil sir, Dr. Yashwant Patil sir, and as sir has already mentioned his vote of thanks and his gratitude towards all the chief guests of today's valedictory function, Dr. Santosh Sons, Dr. Ramesh Kumar, Dr. Swati Bhave, for accepting this last moment invitation and addressing all the gathering, all the speakers of from the day one, from the workshop, of all the 3 days speakers, all the chairpersons, and last but not least, all the participants, without whom this success of this conference wouldn't have reached the heights of the success which we are seeing. And I would also like to mention here of the specific Paranan, who performed beautifully yesterday in the cultural event, and which was very nicely moderated by Dr. Shubhra Khirvatkar, Madam, past president of AOP Nagpur. And definitely all those people with the support of whom we have unintentionally have kind of forgot to mention your names, all the support staff and of IMA House, the printer, the caterers. Sir has already mentioned their names. So thanking all these people, I would like to stop here, and I request all the participants to remain with us for the next very interesting academic feast, which is still there, I mean, today. So please join us for that, the next session. Thank you so much. Thank you all. Jai Hind, Jai Bharat.
Yeah, thank you.
Sorry. One thing I forgot to mention the names of Dr. Urmila Dahake. She was my joint secretary.
No, I have mentioned that. Don't worry.
Also.
Already I have mentioned. Don't worry. Urmila, thank you for covering all the delegates.
On our part, you did the job. Thank you.
Thank you.
Thank you, sir. Thank you.
Yeah. Thank you for covering all delegates, medical officer, Divyang people, everybody. Thank you. Over to next session, please.
Yes, and
I request all to stay up to 8 p.m. Not less than 8 p.m. All sessions are going to be very mind-blowing. Please stay. Don't leave. You can have tea, coffee on the desk, but we cannot over to Payatha.
So I cannot forget the facilitator team also, because now their work starts for the scientific sessions. So thank you. Yes, thank you all the facilitated team with Jeanette, Parveen, Abhijit and all. So I will directly start the next session. that is a session on recent advances in specially challenged. So thank you so much, Urmila and Alpana. I would like to tell event persons, make co-host to Dr. Vijay Suple, Dr. Shefali Gulati, Dr. Amita Vanzari, Dr. Priyanka Raikar, and our chairpersons, Dr. Rajiv Gupta, Dr. Sujata Kanhere, and Dr. Praful Shinde. So, welcome. I would like to welcome Dr. Rajiv Gupta, consultant pediatrician and from UK, and Dr. Sujata Kanhere and Dr. Praful Shinde as chair the session, and would like them to take over. Veena, did you get them? Veena? Veena, stop sharing and please make them co-hosts so that they can unmute themselves and talk. Shall I repeat the names?
Yes, ma'am, please.
Yeah, Dr. Rajiv Gupta.
Yes.
Then Dr. Sujata Kanhere. Yes, she is there. Sujata Kanhere. Yes. Dr. Vijay Suple.
UK.
Kind information, he is not getting connection with the laptop.
Okay. So, okay. Now then Dr. Praful Shinde. Then Dr.
Professor is not there.
Okay. Dr. Shefali Gulati.
Yes.
Then Dr. Priyanka Raikar. And Dr. Amita Vanzari.
He is online, but please unmute him. Dr. Vijay Suple.
So I think, welcome all the chairpersons. Sujata Kanhere, madam, she is a professor HOD, Department of Pediatrics, Neonatology, and Chief Pediatric Neurology in the field of pediatric neurology since 25 years. And she has achieved her PhD in pediatric neurology. Welcome, madam, and please take over for the further proceeding as a chairperson.
Thank you so much. Thank you so much, Dr. Prajakta. I'd like to begin with thanking Dr. Fadke, madam, Dr. Bodhankar, sir, Dr. Yashwant Patil, sir, and all of you for inviting me to chair this very important session on recent advances in specially challenged in this International COMHAD and BAPIO conference. May I begin with introducing our moderator?
Yeah, just ma'am, short.
Yeah. Dr. Prajakta Kaduskar, all of you know very well for the last 3 days. She is a consultant adolescent pediatrician and psychologist. She's a dynamic pediatrician who's done her PG DAP at CDC Trivandrum, and she's a clinical psychologist, rare combination. She's attached to many centers in Nagpur. She's been treasurer of Adolescent Health Academy and past secretary. She is currently that and past secretary AHA, and she's contributed to research projects of adolescent obesity, academic achievement of children, and development of self-concept in adolescents. So I now hand it over back to you.
Thank you, madam. Thank you for kind words. And so I would like to invite our first panelist, Dr. Vijay Suple, who is an occupational therapist, and he is also a psychologist, and he is attached. He's working for Closing the Gap healthcare group in Canada. So he'll be talking on driving assessment in functionally impaired adults. So I welcome you, sir. And Veena, please share his slides.
Thanks, Prajakta. Can you hear me?
You can hear me?
Yes, sir. Yes, please.
Okay. Yeah, something wrong with my video option, so you won't see my picture, but you can hear me. So that's I think that should be okay. First of all, let me thank COMHAD team, Dr. Patil, Dr. Uday Bodhankar, and BAPIO President Dr. Mehta for arranging such a nice conference and giving me an opportunity to be here today. Also, thank to Dr. Prajakta. We've been talking back and forth before this conference, and I attended yesterday's session also, and it is going very well. Yeah, only because of the time constraint, I couldn't be here all the time, right? You know, because 1 o'clock is like 2:30 in the morning, and right now it's 5 o'clock here, 5:45. So. Saying that, let's begin with my presentation. And driving assessment is not the new concept here in Canada. Maybe some part of the world, some countries, it's something new now, but it is being done here since mid-50s. Can you imagine? Almost like 70 years. Yeah? And it started with is at the Hugh Macmillan Center in Toronto. That center is doing a treatment for the developmentally delayed children, actually. And the way it started, when the kids go through rehabilitation, and people with children with kind of acceptable kind of cognitive status functions, they are ready for driving. So because they need to get the job. Yeah? And in these Western countries, if you need to get the job, you need to drive the car. So that was the beginning, how the driving assessment started in Canada. And that modest kind of start of training the patient to drive and assessing their driving capacity to operate the motor vehicle was a good beginning. And it opened new area for occupational therapy practice, actually. I have no record of ministry's involvement at that point, but I'm sure they were working with the collaboration with the hospitals, rehab centers, and the Ministry of Transportation. Another thing I want to stress here, and yesterday I was listening to all the sessions, collaboration, communicating, and discussing each other, and every little point is a key in this culture, and that's how we function here. The assessment program, driving assessment program, further expanded to the patient with some kind of medical condition, like people with progressive neurological diseases, like multiple sclerosis, Parkinson's, and dementia, Alzheimer's. So that program expanded to those clients, and now is it accepted fact? Like it's almost like becoming like a pathological, now the pathological test basically. If I think that my mom or dad is, I'm not happy the way they were driving, I can go to the driving assessment center and get my father, mother assessed whether they are. Yeah, yes.
Sir, kindly instruct us for moving slides.
Okay, yeah, so go ahead. Okay, next slide, please. Okay, next one. Okay, next one. We are just kind of party. Okay, so driving assessment therapies, big OTs are doing driving assessment because they have unique skills of physical assessment. So we do the assessment of the range of motion, strength, dexterity, good kind of hand functions, and that kind of stuff. Psychological assessment also, the OTs are equipped with that kind of knowledge. Visual perceptual scales, that's another part of the assessment. So that's a part of OT training. The next slide, please. And cognitive assessment. So the cognitive assessment, like it's composite assessment. So all these skills are advantages when we do the assessment for the person who is, whether he is capable of driving or not. Next slide, please. Driving is a complex task involving integration of visual, cognitive, physical, motor, and perceptual skills. When we don't have any condition, we don't think about it. Actually, we just get in the car, we put the keys in, and then we start driving because we don't have any issues. So, but if you have some conditions, some symptoms, then driving becomes a challenge. So, because it needs all that complex task that you need to, capacity that you need to for driving. Yeah. So occupational therapy, I have been driving. I spoke about that already. So next slide, please. That's the Sunnybrook Center. That's where the driving assessment is done. The Ministry of Transport is very organized. The MTO, we call it here, and they have recognized some centers. They have some requirements like you have to have the clinic to do the assessment. You have to have the dual control vehicle. So you do the assessment like after clinical assessment, you do on-the-road assessment. So they are their requirement for that assessment. So based on that, they recognize the centers for driving assessment. Next slide, please. Okay, we talked about that. Okay, next one. The clinical assessment is done in the clinic, and it takes about almost like 2.5 hours to do all the testing. We will talk about the test that is involved in the assessment later on. 2.5 hours assessment in the clinic setting, and then after that we take client on the road in a car which is modified. Modified means patient will be driving the car, and next to the patient is the driving instructor. He has a control brakes on his side, and I, as a OT, sit at the back of the car.
Sorry to interrupt, Dr. Suple. You've got 2 minutes left to conclude.
Okay. Oh, okay. Next week. Next one, please. Yeah, it's a long topic to complete in 15 minutes. So we'll try to do the visual test is done in the clinic, and we use that ophthalmic instrument. So the distant vision, near vision, peripheral vision, all these areas are very important for the driving. Next one, please. These are the tests that we use for the perceptual assessment. They're very common tests used by the neurologist and the people working in that area actually. Okay, next one, please. And what happened next is all this after this result on the road evaluation and my report. I prepared the report. That report is about like 5 pages long report. It goes to the Ministry of Transportation, and I send a copy to the family physician. Next slide, please. Brake reaction timer. That's another test that we use. Next one. Okay, we don't have time to discuss all those things, but there's more to this. Is very standard test they use in pediatrics also. Probably pediatrician must be using these tests also. OT, occupational therapy, they use this very famous MVPT test. Next one, please. We can go to skip. We can skip that one. That's a bill cancellation. Next one, please. Next one. That's a picture of the recall. Yeah. On the road evaluation is pretty important one for driving instructor job is to see whether the patient is following road signs, and my job is to see whether any clinical symptoms is interfering with his driving. And believe me, I can from my experience, I can tell you, I can predict how.
Sorry to interrupt again. It is time, sir.
Okay, and like just to 10 seconds. My report will go to the Ministry of Transportation. Ministry of Transportation has 15 specialists of each discipline. They're like and then they would read the report. They will get information from the family physician. Based on that, the driving license will be revoked or reinstated, depending on the case and why they were asking the driving assessment. So, in a nutshell, it's a good way of kind of judging whether a person can drive or not, and driving is such an activity that you can kill somebody basically. Yeah. So here it's so strenuous process to get the license as well as maintain your license. So I think with that one, I will conclude my the presentation, and I'm sorry that we had to rush a little bit because of the short of time. But again, I appreciate everybody, and thank you very much and for giving me opportunity. Bye-bye. Thanks.
Thank you, Vijay Suple, sir. This is the step towards equalization of opportunities. Our next panelist is, we shall take question answers later on, madam. Is that okay? Sujata, madam? Yeah. So next panelist is Dr. Shefali Gulati. She is Professor Coordinator, DM Pediatric Neurology Program, Faculty, IC Center of Excellence and Advanced Research for Childhood in Neurodevelopmental Disorders. She is Chief Child Neurology Division, Departments of Pediatrics, AIMS, New Delhi, India, and INSAR, the Global Senior Leader for India. So Madam is going to discuss advanced early interventional strategies and therapy in autism. So Madam, over to you.
Thank you. I thank the organizers for giving me the opportunity. Dr. Prajakta, I have 9 minutes.
Yes, possibly, but it will be skillful if you present in 7 minutes.
Okay, I'm putting my timer for 9, but I will try.
Yes.
Okay. Okay. Yeah. So basically, so the font has changed actually. Okay, it's fine. So basically, we can I have the next slide, please? So basically, we'll be talking about use of technology in diagnosis and management of neurodevelopmental disorders with a special focus on autism, CP, and SLD. Next, please. Yeah, next. I think the fonts have all changed, you know, something is wrong, but it's okay. So basically, now we have to look at the capability of a child, not only the disability. Next, please. Next. Yeah. So this was the paper we had published in which we had seen the, INCLIN study in which I was a network coordinator. We had seen, next please, we had seen the prevalence of neurodevelopmental disorders in India. I just want you to know that 12% of children in the age group of 2 to 9 years had one or more neurodevelopmental disorder, and 1/5 of them had more than one neurodevelopmental disorder. This was the first study of its kind, which had given the prevalence data of each condition, and we found autism as 1 in 89. And that year, we had collected data in 2011, and that year there was a census. When we extrapolated the children with neurodevelopmental disorders, it came as 23.7 million. I just want you to understand the mammoth task we have. Next, please. So basically what we need is we have to early identify and then have correct institution of early intervention. And we have to have culture sensitive tools. You have to have technology aids and empowering the parents as well as professional and looking after intervention, the prevention. Sorry. Next, please. So basically what is here, we have some new tools which we have. We have a neurodevelopment screening tool from 2 to 9 years, and ages and stages questionnaire, social culture adaptation for India for less than 2 years, diagnostic tools for autism, ADHD, epilepsy, and neuromotor impairment, which includes cerebral palsy, neuromuscular disorders, and post-stroke sequelae. You need these tools for screening to pick up from the general population and diagnostic to correctly diagnose them. Next, please. It is very, this was a neurodevelopment screening tool. Next. So this was an 11 question screen. Next, please. It was an 11 question screen. Next, please. So this is the social culture adaptation of the ASQ. I'm very sorry, something happened to the font when I transferred it. So, but in any case, we'll go through. So this is, we've done a validation and it's got good psychometric properties and it's in Hindi and English. Next. Next, please. Yeah, then this is the autism based tool, which is DSM-5 based. Next. It also has very good, next please, it has good psychometric properties and it also has a scoring. That is from 1 to 14 years. This autism tool we have also developed for less than 18 months. This is still a question which is debatable whether we want to label anybody, but we can identify them early for early intervention. So this is another tool which is available now, social culture adapted. Next, please. Next, please. Yeah, this is an ADHD tool. Next. This has also got good psychometric properties and a scoring. Next. Even the autism school had a score in between. This similarly you have for epilepsy. Again, next, please. Next. For neuromotor impairments. All the previous INCLIN tools which were used for the study are involved in the Rashtriya Bharat Swasthya Karyakram, the neurodevelopment screening tool at the peripheral level, and the other tools diagnostic at the district early intervention center. Next. So basically we have to pick them up early. We converted the AIMS modified tools, which I've mentioned to you about, which are all published internationally, into mobile app. Next. So Ped Neuro AIMS Diagnostic is the name of the mobile app in which you can download for epilepsy, autism, ADHD, and neuromotor impairment. Next, please. So basically, how else can technology be used? Next. So basically coming into, next, please. So we can, Yeah, we have new novel techniques, in which you can have this sensors for the hand, then you can have some electrocaps, then you can have motion sensors to pick up early diagnosis of abnormalities for assessing neurodevelopmental disorders. Next. So basically, you can have, I'm really sorry for the bad font. I don't know why it has come when they downloaded there from Google Drive. So in any case, for the diagnostic part, you can use quantitative EEG, in which we have found in quantitative EEG, we have found some abnormalities as a biomarker, and then fMRI, then eye movement tracking, then, basically, and use for artificial intelligence. Therapeutically also, we can use in many of the situations, you can use from virtual reality, augmented reality to artificial intelligence. Next, please. Next. For CP also, you can have basically for general movements, you can have, then you can also have brain mapping caps are there, then you can have transcranial magnetic stimulation and all, which can take place. I'll just be going through them very fast. Please, next, please. Just giving them a priming thing that what all is available. So basically, you can use augmented reality and virtual reality in autism, in which you can give for the joint attention task and virtual reality has also been used for, modified. We have done virtual reality assist for modified constant induced movement therapy in CP, and web-based application for early intervention of dyslexia has also been done. We are doing it right now. Basically, what we had done, next please, we had done one study in which we have developed a remedial, next slide, remedial intervention program, and which this is the fMRI showing post minus pre, and then we found significant benefit, and this same thing has been converted into a web-based thing. Next please. So you can have, we are also trying to develop prediction skills by robotic toys for autism. Next. And regarding CP, a diagnostic algorithm can be based to pick these children early, and have AI-based mobility devices who can adapt according to the navigation, and also for the optimal speech generation. Next. Just a priming thing, what all can be done. For neuromodulation, you have, you can have transcranial magnetic stimulation. We have used it in hemiplegic CP and found to be beneficial. We have also used in focal epilepsy. We are doing in electrical status epilepticus in sleep, which can be a mimicker of autism. They have also been using in autism spectrum disorder and dystonia, all in trial modes currently. Next. And textile-based technology can be developed. We developed a weighted compression vest for hyperactivity in ASD and saw the beneficial results, trying to develop more compression garments for sensory issues in CP, and drooling scarves also for CP. Next, please. So basically we can use, because we have tried to develop with international collaboration with UK and India, we have trying to develop a screening tool for autism risk, which is there with the University of Reading. Next, please. Similarly, now with the Berwick, we are doing eye tracking assessment for children with autism. Next, please. We also, along with Manchester and Sangat, there is a communication center, patient mediated treatment for autism.
Sorry to interrupt. You've got 2 minutes left.
Sure. Thank you. Next. I also put my mark. And then you can have various devices to help feeding devices. Next, please. Next. And then your writing aids. Keep going next. And then you also have to think about augmentative alternative communication strategies. We are developing a mobile app for autism. Similarly, for CP also, it has to be taken into account. Next, please. Next. Yeah, ambulatory aid, which can be walkers, can be robotic crawlers, can be next, please. And then also for, depending on whether you're going to augment or you have to substitute, depending on the child's problems, we are developing them as a part of COE, a Center of Excellence, next with IIT. Next, there are a lot of technology based for text to speech and, many other things for dyslexia, dysgraphia, dyscalculia. Next, just priming you all. Next, please. Next. And in ADHD also, there are many devices which have been developed, digital interventions to reduce hyperactivity. Next. And for visually impaired also. And next, hearing impaired. Can you just keep going down, bus? Keep going down. I will not say next. You just keep going down. Yeah. So we're also developing an AI-based BCI network and with the CDAC. And 1 second, precision medicine was very important. Just 1 second. Precision medicine was important so as to see from environmental and genetic factors, you identify the genotype and give a specific intervention. And then also right now, something is for stem cell research. We have developed iPSCs, and we are trying to study from exosomes from mesenchymal stem cells in ASD mice, and also trying to study long non-coding RNAs. Next, please. in autism spectrum disorder. Next. There's also something at the gut-brain axis, and we found out some difference in the children with their gut microbiome. We're doing a probiotics trial because of that. Next, please, ma'am. Next. Yeah. So there's a study in which we're trying to study the sperm epigenome of the fathers. Next. The next thing is pre-implantation genetic diagnosis, something which is coming of the future. Now, you keep going down because I have only 11 seconds. Yeah, please going down.
Sorry to
And now
interrupt.
just for 6 seconds. Yeah, just keep going down. Just finish it off. This is a web-based platform we have developed for empowering parents and professionals. And next, keep going down. That's one. Just keep going down. Yeah. So that is also, you have to empower the parents and professionals. You can use digital technology to do that. Keep going down. Just keep going down. This is to empower the parents. You need to empower the parents, and that is there. Just keep going down. Yeah, just keep going down. Yeah, so you have to provide them. And with the Center of Excellence, we are developing a national registry, National Knowledge Training Center, doing advanced diagnostics of genomics and advanced neurorehabilitation, and this telehelpline. And it is something very important that we should remember, that we have the next slide, please. Next. Complete. My last slide. Last message is on the last slide. Yeah, please go to the last slide. Yeah. So when the world says give up hope, whispers, try one more time, and we have the differently abled can challenge the word, and we have to make the differently able not only count but also capable. My idea was just to prime you that so many things have advanced in technology, and they are not just there in the books. They are facts of life, and we are all working and need the collaboration to go ahead. Thank you so much.
Thank you so much, madam. You're really skillful work. You are skillful work at even you are a great orator also. So our next recent advances are always welcome. And our next speaker is Dr. Amita Vanzari, who is Director of Physiotherapy Unit in Neuron Hospital. And she is using robotics in her physiotherapy. So she'll be talking. And before that, just share the slides, Veena. And I would like to acknowledge the presence of our next another chairperson, Dr. Rajiv Gupta sir. So I think we will be taking concluding comments from our chairpersons, and if question answers, if any. Veena, share the slides. Veena, yes. Amita.
Yeah, very good afternoon to all. Please, next slide. I think my introduction is well introduced. I usually work on robotics. What is robotics? Robotic rehabs is young and rapidly developing growing field. Vast developments of robotic rehabs have been done to improve the disability. For recovery, we need to exploit neuroplasticity plus focus on rehab of movements, which requires muscle activation through functional exercises as well as activation of peripheral receptor. All these considerations led to development of robotic rehab. Indications: almost all the neurological cases can be used on robotics, be it adult, be it a peds, restricted lung functions on the endoprosthesis can be used on robotics. Next slide, please. What are the benefits? Rehab usually involves 4 steps: assessment, set goals, intervention, reassessment. All the 4 goals can be done by robotics. It increases the efficiency as well, gives you consistent training, gives you greater repetitions, greater intensity, highly motivating. It has game-like fun exercises, data collection, it is automatized and gives you better outcomes. Next slide, please. Continuum of gait rehabilitation: in early stage, we go for Erigo. In the middle stage, we go for the Locomat, and in the later stage, we go for Endago. These are the robotic devices. For upper limb, it is Armio Power, which comes for 0 to 2 Power, Armio Spring, which comes for 1 to 3, and Armio Sensor for 2 to 5. Next slide, please. I want someone to click the video as well. Yeah, Erigo. It is a robotic device for early mobilization. It gives you gradual verticalization and continuous step-like movements, which can be seen in the video. It gives a cyclic loading to the lower limb, and it uses FES. FES is functional electrical stimulation, which can be used for larger muscle, larger volume of muscle, so that cyclic loading will improve. Even the cardiovascular stability would be there. Next slide, please. Primary aim of Erigo is to increase the cardiovascular stability, which will be done by verticalization as well as lower limb movements as well as the FES system. The continuous step-like movement will prepare the patient for the gait. improve muscle pumping, and prevents complications like DVT, orthostatic hypotension, bed sores. Cyclic loading will give you afferent stimulus to the CNS, which will give you muscle activation, muscle strengthening, and prepares the patient for gait. Please click on the video. The last slide, please click on the video. FES system, which is shown on the video itself, will give you muscle strengthening as well as increase the cardiovascular stability. Next slide, please. Please go on clicking the videos as we go on to the next slide. Yeah, Erigo also improves the alertness, consciousness, body awareness, and intestinal activity. It will again increase the participation for combination therapy, which will give you help in communication, cooperative skill, which are prerequisite to rehab. It will decrease the acute care time. It decrease the cost efficiency. It will decrease the stay in ICU, hospital, and rehab. It has excellent clinical usability as shown in the video. It can be taken out from room to room and next to the bed. COMHAD, it is a gait trainer. It has 4 parts, mainly the unweighing system, then the treadmill, the orthosis, the white portion which is attached to the leg of the patient is the orthosis, which is a motorized thing. The visual feedback, a computer like a screen in front of the patient. Next slide, please. Its aim is to improve the walking function. Secondary aim is to improve the walking speed and endurance, spatio temporal and biomechanical parameters like step length and step width. It improves balance, works on muscle tone regulation, lower limb muscle strain, cardiovascular status, and improves the quality of life of the patient. Next slide, please. It is effective in gait training. Please click on the videos. Yeah, it is effective in gait training, as we can see in the video. This was a patient we have seen after 4 to 5 days of his RTA, and the next video was seen after 10 days of what we have done on COMHAD. So it has benefited severely disabled patient. It has been intensively researched, and this is my personal experience what I'm sharing with you. Next slide, please. Right. It gives you most physiological gait as seen in both the videos. The patient came with this hemiplegic gait. We wanted him to practice most physiological gait, which can be adjusted by exoskeleton, dynamic weight bearing system, the vertical system, the natural plantar pressure distribution it gives, and we can also adjust the hip and knee joint can be tailored at specific need to of the patient. Next slide, please. It gives you optimal challenge to the patient. As we can see in the video, the patient has to work on the screen to reach the goals. He has to collect the coins. Every games give you different goals. So speed, loading, support will adjust the intensity of the therapy. Motivational games will reach goals with a game like exercise. Level of activity will influence the performance of task, the gait pattern, and the speed. Next slide, please. Yeah. Endago, this is the next when we want to train the patient to walk on ground. So this is safe and intensive gait training. Yes, it bridges the gap between the treadmill training and the overground walking. It's used for gait and balance training. Next slide, please. It is self-directed plus body weight support is there to improve functional mobility and balance tasks. Accessories can be used like conical task as shown in the videos, or balance platform or balance board can be used. Hands adjustable training modes are there. We can give the patient itself can drive the Endago, or the therapist can use it to train the patient. Task specific Endago is there. Starting, turning, stopping, avoiding obstacle is possible. So it's very good for Parkinson patient also, where we want to train the patient for fall protection. Next slide, please. It enables door-to-door transfer from room to room transfers. Upright and hands-free gait is possible. Hence, hands can also use for balance reaction. Left and right body weight support is there, so lateral shift is possible. Asymmetric body weight support is there, so we can use for hemiplegic patients or patients having pusher syndrome. No infrastructure as such modification is required for this, and no dedicated space is required. Next slide, please. Armio spring. Armio spring is for upper limb. When there is there is loss of upper limb function, we can use the Armio spring. It provides upper arm weight support.
Dr. Vanjari, you've got 2 minutes to conclude.
Yeah, that's it. Provide upper arm support as well as resistance. It is used when the patient has residual power of grade 1. Goal is to improve motor function. Task specific exercises to increase the muscle strength or range of motion or functions are there. We can use one joint, two joint, or 3D movements. It encourages reach and grasp as well. Next slide. It is a self-initiated movement therapy plus repetitive training, which gives you better, faster, and improved outcomes. Motivating game-like exercise again, motor and cognitive abilities are improved, which will again give patient independence in ADLs and improve the quality of life. There is always a possibility of supervising patient, more than one patient when we use robotics. Next slide, please. Thank you. I always say man is never going to take place of machine and machine is never going to take place of man. It is the combination of both which will give you the best results for the patient. Thank you.
Thank you, Amita. Fantastic. I'm really overwhelmed with this unit in Nagpur. So our next speaker is going to focus on ability and not disability. So she is Dr. Priyanka Raikar, who is a pediatric occupational therapist and specialist sensory integration and handwriting without tears. So she is the first Indian to attain HWT certification. So she's going to discuss learning disability testing tools, treatment, and interventions. So over to you, Dr. Priyanka. Veena, please share the screen. Priyanka, unmute yourself.
Hello.
Yes, you're audible.
Hello. Okay, can you see me?
Yes, you're audible, visible.
Hello.
Your slides are visible. Continue.
Hello.
Yes, you're audible, visible, and slides are, we are able to see slides. Continue.
Okay, hello, good evening, everybody. I would like to thank COMHAD and Bapio for this opportunity. Let's start with learning disability. Can you move to slides? So different types of learning disability, the primary dyslexia, dysgraphia, and dyscalculia, what we know in India, but American Learning Disability Association also classifies dyspraxia, non-verbal learning disability, language processing, ADHD, and other different types. Next one. So this is how a child with dyslexia, what is called reading disability, would read. Like it can affect the reading fluency, decoding, reading comprehension, recall, writing, spelling, and sometimes speech, and can exist along with other related disorders. So this is referred as a language-based learning disability. Next. This is what is dysgraphia or writing disability. It's a specific type of learning disability in which the child may have problems with illegible writing, inconsistent spacing, poor spatial planning on the paper, poor spelling, difficulty composing writing, as well as thinking and writing at the same time. Next. So that dyscalculia is again a maths disability where there is difficulty with math symbols or memorizing or difficulty understanding the concept of time, whereas the dyspraxia is more related to the muscle control or coordination. So there are different types. Like you have to identify what is the problem with your child. Is like child is not able to focus. Or there are other siblings which are kind of bullying or affecting the child's functioning. A child has a physical disability, or maybe a child is just hyperactive. Next. So child may have problems with no concentration, distracted, slow speed, incomplete work, reversals, misplacement of letters, alignment of letters, and difficulty with holding a tool. Next. So yelling to a child doesn't increase the child's brain for learning, but parental support is a very crucial element which will help. Next. So let's start from the basics. Next. So first you have to look at the child. Does our child have a good posture? What you see in the first picture, child feet are supported, has a good backrest, table is inclined at an angle of 20 degrees. Is supposed to be a best posture. Next. So these are some of the abnormal grasp patterns which you will see around you. Next. So these are the correct, at different ages, different types of grasp patterns are required, from cylindrical grasp to tripod grasp. So what we consider after 4 years, a tripod or even a quadruped grasp is a correct grasp. So you need an assessment with a pediatric occupational therapist if you see a child having abnormal grasp to correct. Next. Also, other evaluations like visual assessment, even Dr. Vijay Suple mentioned about the visual perceptual skills that we assess, the physical strength, the fine motor skills. Next. Also, we focus on the handedness, the dominance, which occurs at what age, where is the helper hand, the posture, the paper placement, the pencil pressure, pencil grip. All these areas are assessed by an occupational therapist. Next. So writing is just not like the physical writing, which involves a fine motor, but it's a multitude of tasks which the brain is involved, right from the intellect to what you have to write to be able to form a judgment or, convey your thoughts on the paper, including the frontal motor cortex, occipital lobe with the visual, as well as the cerebellum for the coordination. Next. So how can you help a child? The only answers is through intervention and remediation. Next. You start with pre-writing skills with the tracing or, tracing with the finger, then using a pencil or using a tool like a Play-Doh or a shaving cream or some sensory equipment. Next. You could start with the fine motor activities using simple shape sorter to, turning different types of knobs, or you cutting a specific pattern using a scissor. Next. You could also try using like misplacement to understand. You can help the child with dyslexia to read these numbers loudly, so you'll understand where is the child getting wrong to get a better understanding. Or for a visual for a child with visual perceptual problem, we'll also have. You can tell him to just circle the word cat, so he has to cross from left to right. So there's a visual scanning and the formation of pattern, how he's going to write his sentences. Next. You could also help them to organize in order and by circling numbers 1 to 50 in a random sequence to a specific sequence, or finding letters which are given from the statement, like a hot, tap, cap, man, then from the sentences given. Next. So as I mentioned about sensory writing, tracing, using textures, a lot of sand, a lot of tracing on the borders. Next. You can also give something like this, which would help to identify a child from dyslexia versus a dysgraphia. So a child with dyslexia will find it very hard to read. Like he might say the color green instead of red. Next. Even counting the B, P, D, and V, where is the most common, and they can put it in the slots where how many B's are there, how many P's are there, or circle them accordingly. Next. You could also teach them sight words using different tools like the AM words, and words, because usually these children tend to by heart rather than focusing on the phonics. Next. Also questions like which you use in a daily routine, the yes/no questions, because sometimes answering a question is very difficult and it might be very important for the emergency situation. Next. Concepts of preposition in, out, up, down, above, between, etc. Next. We also use like different forms like comma, full stop, question mark. Teach them what is the meaning of each letter in detail. Next. They help them at the later stage with opinion writing, like do you like cupcakes or birthday cakes, and explain them why like this, because, and they help them to elaborate, so they will be able to write over a period of like a paragraph writing. Okay. Next. Even we help them to self-inculcate their mistakes by identifying what is the capitalization, like the 5-star rating. What you have to understand is 5 things. The first thing is where the first letter is capital, second is where the punctuation marks, third is there's the finger spacing, is the neat handwriting, or does your sentence make a sense? Next. And we also use different tools like the virtual reality, look to speak app, or text to speak, audible, a lot of this app, but we prevent from children much more for a longer duration because they get hooked to the apps rather than to actually physically do the fine motor coordination thing. So these are some of the writing samples of my patient. You could see like, the child is just beginning to write alphabets, or picking up, was able to write in sentences within, you could see that like within 3 to 4 months, he was able to write cursive. Next.
Sorry to interrupt, Dr. Raika, you've got 2 minutes left.
Yeah. Then there's a child, this is an 8-year-old child with learning disabilities. If you try to read, it's like, hey, my father's name is Konur Aptesha. I am a good player in cricket. Like he was going to write, I'm a good player in my room, and then he forgot it was in cricket. Like, this is the way they cannot organize, and he was able to write in cursive and in the pen. Next. This is a child who is 10-year-old with a right stroke with high visual impairment. This is where poor spacing is there, lack of orientation is there, and he is able to write in cursive with the pen with clarity of thoughts. Next. This is another child with left-sided neglect. You could see in the first picture where it's just written on the right side, complete left-side neglect, and then he was able to progress. This is a child, 14-year-old with tunnel vision. He's a very smart child, 14-year-old, and good cognitive skills, but he could not focus. We tried using the computer. This is the same way he was writing, and this is the progress he's made. That's it. This is next. All right, next. Thank you. I believe that if we can change the beginning of the story, we can change the whole story. So I feel we are not in the age where learning disability cannot be treated. We are definitely in an age which can be treated to much far extent, and children can be competent and independent in much more life. That's what we are looking for in COMHAD and otherwise. So thank you so much for giving me this opportunity. Thank you, Dr. Uday Bodankar, Dr. Yashwant Patil, sir, Dr. Mridula Phadke, and everybody at COMHAD. Thank you so much.
Thank you, Priyanka, for such a lucid talk. And I request Dr. Rajiv Gupta to give concluding comments along with Dr. Sujata Kandi.
Thank you so much. I'm delighted that we had such brilliant presentations. And I always remember that specialty challenge or especially challenged people are our inspiration. Remember Helen Keller, who was blind and deaf. And she has a mark much more than any of us able people have done. And we have this combined conference, and we have presentations which actually highlighted how different aspects we had aspect on, and driving aspect on the physical ability, we had aspect on the mental ability, including dysgraphia, dyscalculia, etc. And they were different aspects of the human being. And we must remember that human beings have been either born with or have come into a position where their abilities are limited in one aspect, but they gain the ability in some other aspect. And all our achievements come outside our zone of comfort. So I think I would congratulate all the panelists and speakers to really demonstrate such a brilliant thing. I can ask one question. I'm conscious of the time. Particularly Amita, she mentioned about the prediction skills by robotic toys and the optimal speech. If she can, in a very brief, explain that. Otherwise, I'm conscious of time. We move, and I'm thankful Uday Budankar, and he might not remember. I and RN Singh have organized a IAP conference in Jodhpur, and in Umid Palace we had the dinner. And this was the IAP. I was in India at that time, working at the Regional Institute of Maternal Child Health in Jodhpur, and old time.
Thank you, Rajesh. Thank you.
So it was a great time. I think we had a Swati there as well, Swati Bhave. So I think it was a great time. I still have good memories of that. I have been in UK for 25, almost 30 years now. And it's a great time to really reconnect and relive, to work together. And this conference of COMHAD with BAPIO together, I chair the Yorkshire division of BAPIO, and I have worked with Ramesh Mehta for 23 years now. And I think it's really good that the two parts have come together. Such a brilliant conference over past 3 days. I have been listening, and also Dr. Pandurangi, Oration Pandurangi was in Sheffield. I live in Whitfield. Both are parts of Yorkshire, and we had a good conversation. So again, thank you so much to everyone. And I will hand over back to Pajka. If there is anything else, unless there is a comment from Amita. Thank you much.
Thank you, sir. Sujata Madam, would you like to comment or shall we go ahead?
I would like to just say, I want to thank all the speakers for the excellent presentations of the wonderful work that they are doing using recent advances, including technology for specially challenged. Actually, we all have learned so much today in this session. Thank you so much, and thank you, Dr. Prajakta.
Thank you very much, all the speakers and our chairpersons for bearing with us. We are having time constraints. So we express our gratitude on virtual platform to all the speakers and chairpersons. Thank you so much. So we will move.
One word, Pratap, if you allow.
Yes, yes, sir. Yes,
You
sir.
know, I am a witness to robotic rehabilitation
Yes,
management.
yes.
And Anita Vandari, she had been taken. Rajivji, Sujata, I am witness because I undergo rehab since last 12 years. And there is a fantastic, which is within 5 minutes of my registration, a very updated robotic available in Nagpur. So I thank Anita, I thank Sophia, I thank everybody who has told about, this was my idea to know about recent advances. Dr. Vijay Suple, my friend, is there. Shepali Gulati madam, I salute you, HOD, Anita Vandari and Priyanka Raikar. So thank you, just to tell.
Thank you very much.
I would love to visit it. There, it looks like wonderful center for all the.
We are lucky to have in Nagpur. I've seen in Bombay. After that, Nagpur.
Yes,
thank
perfect.
You. Over to Bhagat.
Thank you. Thank you very much. So the next session is Babio session. Yes, sir.
Just before going to next session,
yes,
I would like to express my sincere thanks.
Yes, sir.
Just a minute. We are extremely sorry to mention our event management team in valedictory function, because they have all given the arrangements and everything, whatever they have given for this virtual platform. They are the backbone of this virtual conference. So I express my sincere thanks, and I'm grateful to Bodankar Events LLP from Aurangabad and their team members, as we know, especially Veena and Gokul, Vijay, and other names I don't know, but all other people, those who were working for day and night, I know. I used to discuss them till 2 a.m. night also. Veena was working all the time. She used to wait for me. Whenever sir will call, I will get the corrections done. So especially Veena, she had done tremendous job for the success of this virtual event. And we should not forget the facilitator team from United Kingdom, which they have worked under the able guidance of Dr. Biju Simon sir. So our sincere thanks goes to all these team members. Thanks to them for their time-to-time changes they have made, time-to-time changes they have accepted to make in the program. Thank you very much. Thank you very much.
Thank you. Thank you, Ishan. We meet something. Over to Bhagat.
Thank you, Ishwan sir.
15 minutes late.
Yes. We'll move to the next session, Babio, where we have got chairperson. As chairpersons, we have got Dr. Rishi Arora, who is consultant pediatrician, Bedford Hospital, UK. Dr. Sanjay Gupta, University Hospitals consultant, University Hospital, Birmingham, UK. And Dr. Rajesh Chokhani, who is consultant pediatrician in Hinduja Hospital, Mumbai. So I would like to give the control to Dr. Sanjay Gupta, Dr. Rishi Arora, and Dr. Rajesh Chokhani. Over to you, sir.
Thank you, Dr. Prajakta. Can everybody hear me? I'm Rishi Arora.
Yes, sir.
Thank you. I think without wasting more time, can I just invite Dr. Michael Plunkett? He works is a very senior and experienced consultant pediatrician, and he works in University Hospital of Birmingham. He is not only a good pediatrician, he has got a lot of experience in diabetes and neonatology as well. And he has been, as far as I know, more than 10 years in safeguarding world as well. So if you work in West Midlands and the Midlands area, you would know who Dr. Michael Plunkett is. Can I just invite Dr. Plunkett to come and start his presentation? I know we are running late, so we'll try to cover. And we'll do the questions at the end of those 4 presentations. So if you don't mind keeping your questions till later. Thank you. Dr. Plunkett, are you here?
Thank you very much, Rishi, for that very kind introduction. Can you all see
We can see you. Yeah.
My slides? Can you see my slides as well?
Very clearly.
Yes. Thank you very much. Also, thank you to Dr. Sanjay Gupta, friend and colleague that I work closely with, and someone who I've had long and complex safeguarding conversations with as we try and work out what is the right thing to do for a particular child in need of safeguarding. Now, you rightly pointed out that I'm also a diabetologist, and in that role, I find the decisions that I'm called upon to make quite logical, supported by evidence, and generally they don't cause any upset or harm. This is very different to the thorny subject of safeguarding vulnerable children during COVID-19 times. Now, I'm just going to leave my sort of title slide up there for a little bit longer, because straight away you'll see that I've, I suppose, pointed out to myself a tautology in the title that I was given, because all children are by definition vulnerable. It's the support that society gives to families and children that goes a long way to reducing that vulnerability and helps to protect children from harm. And it's our actions as paediatricians and professionals that should enhance that support. The title also doesn't include the term pandemic. Now, I'm not sure whether this was deliberate, but it is apt, as it is the experience of children in the United Kingdom that COVID-19 has been for the most part a mild disease. And what's more, the experience of acute paediatricians such as myself is that the initial effects of the COVID-19 pandemic was to markedly reduce the number of presentations of ill children to our local district general hospitals. In fact, in clinical terms, by avoiding the worst of the ravages of this pandemic, it appeared that children were neither seen nor heard in our National Health Service at the outset of this pandemic during those first months of 2020. Now, usually this wouldn't be seen as a particular problem by us as paediatricians because we're happiest when children don't come to hospital. We regard reduced attendance as a crude indicator of improved health. And hospitals are not regarded as necessarily offering the best environment for children. I'll ask us, though, to consider how this reduced visibility became a major welfare issue for many children in the United Kingdom. So, of course, you're all going to be aware that, when COVID-19 arrived in the United Kingdom, as infections and the death rates among adults rose, we had that mantra that was promoted each day by briefings from our Prime Minister and his medical and scientific advisors. Stay at home, protect the NHS, and save lives. It was generally viewed as appropriate that the scientific and medical advice to reduce mixing between family units was translated into this rapid lockdown of society in general. And of course, what this caused all of us to have to do was to keep our children off school, where possible to work from home. But for many in society, that meant they simply didn't work. And everybody remained within the family bubble. A bubble, of course, is a great name to give to that capsule that encompassed the family. But I think we would all accept that there were a lot of children that didn't feel it as a very protective capsule. We also recognise that it was important to, I suppose, protect the NHS as we refocused the frontline care, if you like, on adults. Now, for children, this meant not attending school and being confined to the family home with a garden or other outdoor space an option only for the lucky few. It meant being oh, yes?
We can't see your slides moving.
Right, apologies. Let me...
Because we could see the first slide.
Yes. Can you see that?
No, or if you okay.
Yes, so I've got my slides up and they're moving for me. Let me, Still
you
no
sharing?
movement for you?
No, if you leave them, I think have you sent them to admin team?
I can send them.
No, don't send them now.
Right, there must be something simple I can do here, Sanjay, to help them
Does
to
it
move.
share on the top, your screen sharing or stop sharing on the top?
Right, how's that? Can you?
No. Okay,
let me see.
I would
So
say don't worry about the slides, just carry on with your talk. Don't worry.
Right.
Yeah, we can see them now.
We can see
Can you
now.
see them now?
Yeah.
Okay.
We can't, we can see them
we
moving.
can see a second.
You can see them. All right. Okay. Thank you.
Thank you very much.
All right. So stay home for many children meant not attending school, being confined to a family home with garden or outdoor space just an option for a lucky few. It meant also being confined with parents. And for happy, well-functioning families, this shouldn't create a problem. But where parental mental health, parental over-reliance on alcohol, parental drug and substance misuse, or domestic violence was part of the lived experience of the child, life could suddenly become very much more difficult. There is emerging data supporting the very sorry deteriorating position of vulnerable adults and children, with a worrying cumulative effect on the child, and domestic violence that might previously been at a level that was tolerable for the adult had now become much more risky. And we can see some of this data that's come from the Metropolitan Police in London indicates increase in call-outs. There's also, there was a welcome reduction in violence against ex-partners as people had to remain within their family bubble, but there was a significant drop-off in the availability of services that were very necessary to support women who suffered domestic abuse. Poverty for many families is rarely limited to simple economic poverty. The poverty cycle often includes a poverty of access to services, poverty of internal resource or resilience, and a poverty of opportunity to escape their position. And we can see here that we have 35% of children in Birmingham live in poverty. We can see that there was a significant increase in households that were claiming a tax advantage that was given to those with the lowest income. And we could also see that a significant proportion of our workforce had to stay at home. And the coronavirus job retention scheme didn't provide for a full pay. It simply provided for up to 80% of the minimum or the average wage. So many people, many families had to take a significant pay cut. There's also emerging data that there was a significant increase in alcohol sales in off licenses, although it is also recognized that there was no significant increase in the total intake of alcohol. Everyone dialed into this conference will have their own family experience of what this lockdown meant for their own loved ones. I've got 3 school-aged children, and for them, it felt great. It was like an extra extended and very much unearned holiday, at least initially. But even they recognized after a while that life was getting a little bit boring. Now, if we'd not thought about it before, it became evident that schools were doing an awful lot more than simply providing a sound education to children in the United Kingdom. They ensured all children were seen. They enabled children to socialize and play and feel safe. And they enabled a level of surveillance and around the mental health and the physical health of children. Now, after the initial lockdown, when schools were closed, there followed a call to provide a safe place for vulnerable children and also the not so vulnerable children of frontline workers. And certainly colleagues here may know of other colleagues or even their own children who are allowed to go to school because both parents had to go to work on the front line. With this initial relaxation, though, it became clear that many of the most vulnerable children were remaining unseen and potentially unprotected. Because although primary schools and secondary schools were open, In the first weeks and months of the COVID pandemic, very few children were actually getting to school. We then experienced a second nationwide lockdown in January this year, where schools were again opened to vulnerable children and the children of frontline workers. And by that stage, there was a significant improvement in the attendance of those children who really did need to get to school. We can see also that of those children that did attend, 2/3 or more were actually the children of critical workers rather than of the vulnerable. As another measure of vulnerability, we can see that only 3/4 of children who were recognized to have a social worker by the school were regularly accessing education. And this was in December 2020, a time when schools were fully open and the expectation would have been that everyone went to school. In January, when we had our second lockdown and schools were again closed for many, but open for the vulnerable, we can see that there was a significant drop-off in children who had a social worker being able to be observed where their safety could be in some way assured. We also know from government figures that schools were probably underreporting the number of children that they felt had a social worker by as much as 30%. Right, I'm sorry, I'm yes. Schools also had been ensuring that children had access to a nutritious meal. We can see that we have a very, we think, fairly good scheme within the United Kingdom. Children in the first years at primary school all have access to a free meal. We also know that there were 1.4 million children prior to the pandemic who were receiving free meals in school. We could be pretty sure that many of those children, when schools were closed, were not getting the same nutritional support at home. We also know that 45% increase in the number of households requiring extra money through this universal credit was another indication of the economic poverty that exists in our country. And as just a crude estimate, we believe that there are 4.1 million children in the United Kingdom living in poverty. Schools in the United Kingdom have a statutory role in safeguarding children. In this role, they provide the eyes and ears, observing and understanding children and their vulnerabilities. They may be the only professionals to truly observe injuries in those children they've got direct contact with, and also through direct conversations with the children. They're able to hear from the children about maltreatment that they're possibly suffering at home. We all know that they've got a professional responsibility to report those concerns to children's social care, and they do this on a regular basis. When the observation of an injury with an explanation from a child or parent that does not allay concern comes forward, the subsequent reporting to children's social care triggers, in most cases, a request for a child protection medical examination. And this is to allow a clinical expert to assess the likelihood that the observed injury may be non-accidental. The loss of this important observatory function during lockdown correlates with a reduction in children with concerning injuries being recognized and protected, just at the time that one might expect more children to suffer non-accidental injury. And there's been a very recent and very good paper by colleagues, community pediatricians within Birmingham, who have clearly mapped out how a significant reduction in calls for child protection medical examination is really very concerning. And there was no increase in those referrals after partial reopening of school, suggesting that schools were not in a position to observe whether children were having further injuries.
Dr. Plunkett, I'm so sorry to intervene. We have 3 more minutes to close the presentation. Thank you.
Thank you. So we come to then protecting the NHS, and we know as clinicians working within the NHS in the United Kingdom, the services for children were significantly adapted as staff were redirected to COVID-19 services. Those of us who were able to do outpatients, we found many of them were cancelled and then they became virtual. And that was a challenge to us because we were trying to assess vulnerabilities of children when we couldn't actually see them. We also found that many of the basic screening services were suspended. So the big question, to which I don't have all the answers, is what do we do next time? When all else is closing down, I would ask, what can we try and keep? I would suggest that we fight harder to retain services, maybe looking to adopt a more flexible working model. I think we need to all retain a focus on the vulnerable child. We need to retain relationships, and I think that also involves strengthening interagency working.
Hi, I'm going to
But
have
really,
a Zoom meeting.
in advance of the next pandemic, we need to think about how we can prepare. And I think we should consider how we can do it better next time. And this first part of that is admitting what didn't work this time. I think we've got to ask more questions. I think it's great that we've got colleagues internationally who will have their own experiences. We've got colleagues hopefully dialing in from around the United Kingdom. And I think that the more those that are part of a conversation seeking answers, the closer we will come to getting it right for children next time. And I would also like to thank COMHAD and the British Association of Physicians of Indian Origin for allowing us to use this platform to engage more brains and hopefully enlarge the sphere of influence on this subject. Many thanks.
Thank you, Michael. It was quite interesting, and I believe must have been very interesting for our counterparts in India. I think, can we just leave the questions till the end? Actually, we are running late. Thank you. Dr. Sanjay, can I hand over the baton to you now?
So good afternoon, friends, and welcome to the next session of the next talk of this session. I now invite Professor Sunny Philip, who is a consultant pediatric neurologist at Mediclinic City Hospital, Dubai, to speak on the next topic. Dr. Sunny Philip, please.
Thank you so much, Dr. Rajesh, and thank you to the chairperson and to the scientific committee for inviting me. It's a great pleasure to speak at this conference. I know it has been a very hectic and very great conference, been running for the last couple of days. I'm going to try and share my screen. What I'm going to speak about in the next is it 25 minutes, is it? It's about use of CBD in children with special needs, with an overview of CBD use in neurological disorder. The objectives in the next 25 minutes is really to understand cannabinoid terminology and the basic mechanism of action for cannabinoids in the nervous system, to describe the potential benefits.
Sorry, just a reminder, we have got about 18 to 19 minutes, not 25. Sure. So
okay. To describe the potential benefits of cannabinoids in neurological disorders, particularly epilepsy and multiple sclerosis, and neurological symptoms like neuropathic pain, sleep, nausea, and appetite. And to review briefly the clinical evidence as possible in time and guidelines for use of cannabinoids in neurological disorders, and talk about a little bit about the side effects. So the history of cannabis use is really very long. We've known and used cannabis, as human beings used cannabis for over 6,000 years, starting back as way back as 2737, when the Chinese emperors used to use cannabis as tea for easing ailments. And then by 1940, there was the discovery of CBD and the recognition that that was a compound in cannabis which didn't have the psychoactive effects. further on, going on to 1996, legalization of marijuana in California, and then brings about the modern era of use of medical marijuana, particularly in pediatrics in 2004 with the Charlotte Figi case with severe epileptic encephalopathy, where this child had a marked reduction of seizures because of CBD, and that brought on a wave of discussion about CBD. Nowadays, clearly there is more and more research in effect on the benefits of CBD, and there's less stigma about talking about CBD and use in medical sphere. Globally, use of marijuana is very common. Over 180 million people use that self-administered cannabis at least once. 13 million people are dependent, and there's a common use in neurological disease, particularly in epilepsy, in the younger period people, and in certain regions where cannabis is allowed. What is cannabis? It is a genus of flowering plants, predominantly three main types: the sativa, the indica, and the ruderalis. The ones concerning CNS are mainly indica and ruderalis. And the cannabinoids, the phytocannabinoids are the compounds which come out from the plant, and any compound which acts on the cannabinoid receptors in the nervous system are called cannabinoids, which can be both synthetic or endogenous. That means they are produced within our own body system. The two main ones we recognize nowadays, and they're well characterized, are THC and CBD. THC is a good analgesic, antispasmodic, anti-tremor, anti-inflammatory, appetite stimulant, and has antiemetic properties, but also is psychoactive. While CBD is anti-inflammatory, anticonvulsant, antipsychotic, antioxidant, neuroprotective, and has immune modulatory effect, and is non-intoxicating. If you look at these phytocannabinoids, the THC works on the CB1 receptor and is a strong agonist, and the cannabinoids the cannabinol tend to work on the CB2 receptors, while the cannabidiol generally has a calming effect on the nervous system. There's a significant amount of interest in medical research nowadays on cannabidiol in epilepsy, as well as in other neurological conditions. And it may work through the cannabinoid receptors and may have other mode of action which we don't understand quite as yet. Clearly, there are other medical cannabinoids which we are aware of. The synthetic ones, like the dronabinol, which is a THC compound, and nabilon, which are primarily used in cancer for increasing appetite and dealing with nausea. And then Sativex, which is an extracted cannabinoid, which has both THC and CBD, and mainly used for spasticity in multiple sclerosis, and Epidiolex, which is predominantly CBD and is approved by FDA for use in Dravet syndrome and Lennox-Gastaut syndrome, which are two severe epileptic encephalopathies seen in young children. We have endocannabinoids within our body systems, and they are abundant in our brain and body. And there are some natural substances which also have endocannabinoids, like chocolates have the anandamide and the 2-AG seen in bovine and human milk as well. The endocannabinoid systems consist of two types of receptors, the CB1 and CB2 receptor. CB1 is what we are primarily interested in neurology, as it works, it's there in CNS, and CB2 is in the immune system. The effect of the stimulation of CB1 receptor is to increase the GABA compounds within the brain and decrease glutamate and dopamine. So basically increase the suppressive effect within the brain and decrease the excitatory neurotransmitters. The CB1 receptors are widely distributed, as you can see within this cartoon, throughout the brain itself, so it has wide-ranging effects. And cannabis is prevalent in medical use in various conditions. As you can see from this slide from GW Pharma, which is the predominant manufacturer for extracted cannabinoids nowadays, There is use and trials going on in multiple conditions, and particular conditions like multiple sclerosis. There's been obviously approved use, and epilepsy also. There's been orphan designation for Dravet syndrome and Lennox-Gastaut syndrome. But saying that, there are studies going on actively, phase 1, phase 2, phase 3, in a number of other conditions for use of cannabinoids and cannabidiol. We don't clearly understand the mechanisms. It's safe to say that the cannabidiols within the brain have a role to increase the inhibitory neurotransmitters and decrease the excitatory transmitters. There may be some neuroprotective properties which have been seen in animal models. Epilepsy, of course, as you know, is a frequent indication for use of medical marijuana in the United States in many medical programs. And FDA has approved Epidiolex in Lennox-Gastaut in 2018 and Dravet in 2019. The studies where this use is based on Devinsky in 2016, which was an open label study of children and adolescents with refractory epilepsy, showed a 36.5% reduction in seizures. But there was a big variability in the dose range, up to 25 milligrams per kilogram. The 2017 Devinsky study recruited 120 patients and randomized them to receive placebo or CBD 20 milligrams per kilogram. And comparing the seizure frequency reduction, particularly the convulsive seizures, was from 12.4 to 5.9 in the Epidiolex group, compared to almost no reduction, 14.9 to 14.1 in the control group. Therefore, it was evident that CBD is effective, particularly in convulsive seizures, though there was no real change overall if you took all the seizure types when you compare the placebo and the control group. Elizabeth Thiel and group also studied Epidiolex, recruiting 171 patients with LGS to receive CBD or placebo. Again, this group showed that the atonic seizures were markedly reduced compared to the placebo group, and that was significant. And the total amount of seizures was also reduced, which was also significant. So, and then there was one further study of cannabis oil preparations where there was CBD plus THC done in 2016, which also showed effectiveness, but with quite variable doses. So overall, what the studies have to show us that cannabidiol or CBD is effective in epilepsy compared to control group and compared to other anticonvulsants, and it's safe in terms of discussing side effects. But there are a number of questions which remain. Why do some children respond better than the others? What is the appropriate dose? What is the pharmacokinetics? Is there benefit of acting small amount of THC and how much of it? What about other cannabidiols? And what do you correlate efficacy with a dose or therapeutic level? So a number of these unanswered questions really still have to be addressed by larger systematic trials. Cannabis is also frequently used in multiple sclerosis, and there's good evidence for its use in painful spasms of pain in multiple sclerosis, bladder dysfunction, as well as spasticity. Overall, if you look at pain apart from multiple sclerosis, the evidence for pain or response to pain with cannabis is not that strong. And the recommendation is not to use it as first or second line, but maybe used as third or fourth line based on the Cochrane reviews. In cancer, nausea and vomiting and increasing appetite, cannabis has been used, particularly dronabinol has been recommended. Number of other conditions like Parkinson's disease, dystonia, Tourette syndrome, and Huntington's have had a number of short, randomized, non-randomized, double-controlled trials. But overall, it is quite clear that the guidelines say that there is insufficient evidence or the study is under par to provide evidence of any concrete benefits of use of cannabis in these conditions. Cannabis is relatively safe compared to many other conditions, and the common side effects are drowsiness, dizziness, dysarthria, cognitive suppression, fatigue, mood disturbance, psychosis, irritability, and driving impairments. The problem with cannabis is potential. Those the side effects are common, but the potential interaction with other medications are not fully understood. And we certainly know that in epilepsy, there is very significant interaction with phenytoin and clobazam. And some, in fact, say that the efficacy of CBD may be due to potentiation or accentuation of the levels of clobazam within the blood. So we're all in a very brief run through about use of CBD in neurological practice. The interest and use of cannabis products is increasing among patients with neurological disease. There is some evidence to support the use for certain epilepsy syndromes, particularly Lennox-Gastaut syndrome and Dravet syndrome, and multiple sclerosis spasticity management. There is evidence outside of neurology to suggest some potential benefit in pain and sleep. But we do have to caution our patients and their families regarding the potential side effects and lack of product regulations or effects which are not completely understood just as yet. Thank you so much.
Thank you, Dr. Philip, for that brilliant overview about a new field of therapeutics in pediatric neurology and related fields. As we said, we will wait for questions at the end, and I hand over to Dr. Sanjay Gupta to carry on.
Hi, it is now my pleasure to introduce Dr. Renu Jaina to give our next talk. Dr. Jaina is a consultant pediatrician at University Hospitals of Birmingham, which is one of the largest hospitals in UK. She's a very good friend and who specializes in neurodisability, developmental pediatrics, autism, and ADHD. She's a chair of the Pediatric Forum of BAPIO and lots of other professional organizations. She works very closely with RCPCH. She has received several awards for her contribution to children's health, and autistic spectrum is her passion. And what we are hoping to hear from her is her experience about dealing with ADHD in UK and what are the new updates about medical management for ADHD. Over to you, Renu. Thank you.
Thank you, Sanjay. I'm honored to be hearing this from you because I don't think I've sent you that biography, but it's lovely to meet virtually Sunny Philip today and Mike Plunkett. I'm in India, and I think I can't thank Sanjay Gupta and also P.G. Simon, who've actually made this possible from UK. And today I'll be talking about ADHD, which is my passion rather than autism, but there are a lot of them have both. So it will be over the next few minutes.
Renu, we can't hear you very well. If you just bring the mic closer to you, mic just.
1 second. Is it better now? 1 second, let me just try and see if I can. I don't even know where the mic in this computer is. You can't hear me still?
No, it is better. This is better. Carry on.
Sorry, I think I've lost most of it, but I'll try. Okay, is that better now? If I'm a bit closer.
It is better. Carry on.
Right. So I'll be talking over the next 15, 20 minutes or whatever you all allow me to on ADHD. And I think Dr. Uday wanted me to focus on mainly the medical management, but I thought if I do it without COVID, I think it will be incomplete, my talk. So I'll try and share my screen. And Sanjay, I have sent you my slides as well. If I can't, but hopefully it should work. Is it working? Can you see my slides?
Yeah, we can just open up the presentation by clicking on the wine glass.
Right. I think it's better now.
Yeah, we can see them.
Okay.
Brilliant. Thank you.
Just a little update on ADHD. I understand that a lot of you are from different backgrounds. Some of you are not even pediatricians in the audience group. Thank you to all of you for staying that late. It's the third day of the conference, and for some reason or the other, it's always pediatrics which comes last. But attention deficit hyperactivity disorder is a very common condition, probably still in infancy in India. Some of the medical management is not even available in India. Forget about India, it's not even available in Australia. But I thought I'll touch a bit on it to ensure that we have some awareness of what's happening in different parts of the world. And I will share my practice in UK mainly, and which of course is evidence-based. So it's going to be ADHD and its impact due to COVID. What we need to know as pediatricians, whether you're working with neurodisability patients or without them, medical options versus other options which are available, challenges of working across lifespan. I think it's important to understand that it's not only for children. ADHD is very well known as going across lifespan from childhood to adulthood. I would give you a splash of teenage with clinical scenario. If you remember what Mike Plunkett said, that a lot of them were struggling with social impact of COVID, closure of schools, etc. So we've already got lots of challenges with teenagers. And then I've got a couple of scenarios about how hard it was, even which got worse with the COVID. Ways forward, how do we move things from here? So just in a nutshell, the core symptoms which any one of us need to look for, or if any one of you comes across with these things, make sure you make a referral to somebody who has experience and expertise in ADHD, who understands how to manage it, how to assess it. So impulsivity is not always seen, but it's seen in a lot of, especially the boys, in which they will do things without even realizing what the consequences are. They will jump to conclusions and say, oops, what did I do? Younger kids could run off, they leave the parents and run off on the road, more prone to accidents. So they tend to be visiting A&E very often. Inattention or short attention span, this is usually seen in most of the people, most of the patients, especially the girls. It's much more commonly seen in girls. And I think what's important to understand is our attention span is not very long. And I think that's how we agreed that we'll have a 20-minute session, because that's what an adult's attention span is. Usually a rule of thumb is if you go by 1 minute per year. So if you have like a child who's 10 years old, about 10 minutes he'll be able to focus. So if you can read or complete an activity for 10 minutes, and make sure you don't include anything which they do on computers or mobile phones or watch videos, because they're changing constantly. So they're not actually, they don't have a long attention span, even if they're watching movies for 3 hours. Hyperactivity is again more commonly seen in boys, where they'll be jumping around, running, fidgety, constantly on the go. I think it's moved on its own. And these are the kids who actually need to be assessed and treated. And as they get older, you'll see that they're more impatient, more restless, take longer to work because they're moving from one thing to another. So epidemiology and facts, I think unless we have facts, we can't actually look at things. It's a neurodevelopmental disorder, we all know that. More common in males. Most of my patients are boys, and it is about 4:1 is the ratio. Girls have higher comorbidity and poorer prognosis. That's quite important to understand. Girls get easily missed. One is because the comorbid condition takes priority, and because they are missed and they've been missed for a long time. And also when they do take the medication, because of the issues with compliance and other factors, the prognosis is not as good. Prevalence is in up to 5% of it's worldwide. That's what I'm saying is in UK as well. It's lower, reported to be lower in Scandinavian countries, higher in US. 2/3 of them will continue with symptoms to adulthood, and that's why what I was saying. You can't just say that it's a condition of childhood. It's actually, it does move into adulthood. It's just the way it presents changes. Role of epigenetics, we can't ignore that, but this is something which you must have heard of. The way we behave, our environment, it will influence, but it does not get transcripted onto our DNA. So it can be changed. It's something which we can change. And it's commonly seen in children who move into care because moms had been using alcohol or pregnancy, or children have moved into a different environment, and actually their results are better. So missed diagnosis, I think that is what my focus is. A lot of people who have ADHD have been missed into adulthood. And a lot of the people who are in prison also have ADHD. So it is very much underdiagnosed, very often missed. So do think of it if you come across a person with the core symptoms, which I had in my second slide. Next one. This is the criteria which we use in UK. ADHD if you have anybody with persistent symptoms for 6 months or more in different settings. So you could have like a family breakdown, a bereavement, that could affect your attention span, that could affect your sleep, and also impact on your learning, but that is not ADHD. So you have to make sure that this is seen across and there's been no change in family or environment. If the symptoms appear before 12 years of age, so before they just about they start the senior school, what's important to think is that they may have symptoms before 12 years of age, but they may still be not diagnosed till they move into adulthood, and ensure it's a comprehensive assessment. We don't have a blood test which can pick it up, so you have to make sure that your assessment is comprehensive. It's a long-term diagnosis, it's a lifelong diagnosis. We tend to use rating scales of Corners and Vanderbilts because Vanderbilts is free and Corners you have to pay, it's longer. But this is again a screening tool. What's important to understand is it's not something which you actually use for diagnosis. It's just one part of the total jigsaw. Another important thing to understand is the condition we have, the diagnosis, the symptoms are not explained by any other mental health disorder like schizophrenia or psychotic disorder, bipolar, depression or anything. For example, anxiety is a typical condition in which they'll be restless, they'll be fidgety, they'll be anxious, they'll be struggling to focus. So ensure they don't have anxiety disorder because the symptoms will be similar. Now, this is an old slide, but I like to put it up because you can actually see the difficulties change across the lifespan. On the right-hand side of the children, where you'll see that they struggle with forming relationships, they'll have a low self-esteem because they're struggling at school, they have academic limitations, but so they're not very popular. They're often called as the naughty boy or the girl who's not doing well, a bit dumb, which is so a lot of bullying can happen in that. But as they get older, they are more prone to injuries, they have more risk-taking behavior, so more motor vehicle accidents, and a lot of them will start taking cannabis or smoking and substance misuse is common. So they are actually self-medicating themselves without a diagnosis. And the difficulty is we do not know the substance, what long-term impact it will have. So immediately they'll feel it's working for them, they can focus better, they feel good, but long-term they will be coming to harm. And as they go into adulthood, they're unable to perform, unable to complete the task, they get into legal difficulties, they struggle with, and they're often referred to occupational therapists, and then the diagnosis happens. Again, adult ADHD service is still very sketchy in different parts of the world, but it is better than where it was 20 years ago. Comorbidity, if I say ADHD is seen on its own, I think I would be lying because it never comes as a vanilla flavor. You always have something with it. Up to 80% has been reported, or even 85% will have some other diagnosis. Autism is one, which is always it's a co-occurring disorder. Conduct disorder and oppositional defiant disorder. They're known as disruptive behavioral disorder in the US. Sleep disorder, they always go hand in hand. Also, what's important with sleep disorder, make sure the medication you're using to treat ADHD is not causing the sleep disorder. So you're not bringing the child to any harm. Recently, I had one of my colleagues who was just working for a short time. He actually gave a dose of stimulant in the evening, and the mother said that the child is not sleeping. And especially the long-acting ones, make sure you don't give anything after 5 o'clock. It's not going to help them. Epilepsy, very commonly seen. In fact, epilepsy, absence epilepsy is actually a differential diagnosis for ADHD, especially amongst girls. These are girls who are daydreaming, and they often are reported misdiagnosed as ADHD. So if you suspect absences, make sure you investigate them, and it's very simple. You get an EEG done, and you will be able to diagnose and treat it. It's very easily done. Fetal alcohol syndrome, again, I did put this up because a lot of children who move into care or foster care in UK, a lot of the kids are exposed to alcohol in utero, and they present, especially if they have been exposed to alcohol in the second and third trimester, they may not have the dysmorphic features we're looking for, but these are kids who have learning and behavior difficulties and often referred as, is it ADHD? Make sure we get the diagnosis right, otherwise you will be treating something which is, the medications for ADHD are very specific. You can only treat ADHD with it. If you treat anything else, you'll actually struggle with them because they will not improve and you'll get the side effects. Developmental coordination disorder is often seen, dyspraxia. We've had a talk earlier from an occupational therapist, somebody with occupational, about how we use fine finger movements, motor planning, coordination. Again, that is very, very commonly seen. So and these kids could struggle with attention. Learning difficulties very common, 10 times much more common in ADHD. Also, what's important to understand is if you have ADHD, you're missing out on your learning. So you will fall behind in your learning ability. But that's different to learning difficulties when you are programmed to, your IQ is lower. Now, sensory integration difficulties, again, very common. Again, that can make you fidgety, anxious, restless. Anxiety disorder, I've talked about. Attachment disorder. Tourette's syndrome, tic disorder, very common. Some of the medications even make the tic disorder worse. So be selective with what you use for them. Substance and alcohol misuse, I've talked about it earlier. Comorbidity, as I said earlier, it's this says 75 to 80, but now it's even up to 85%. A comprehensive management, we've had a nice guidance in 2018, which is just about a year before the pandemic. Environmental modification, as I said earlier about epigenetics, if you have the right support for the child, you can easily manage mild to moderate ADHD with support for the child. So parenting courses online, and in pandemic, it was mainly online. We could rarely have face-to-face ones. Psychological interventions can work, but again, if you can engage them. So for example, if a child is struggling with attention span, he's not going to engage in any of your behavior therapy. So you actually need to increase the support, one-to-one support for them, if you can. Medical options, they work very good. There's enough evidence that up to 80% of them will respond to the treatment, the first-line treatment. So make sure you actually assess them. If you have got the diagnosis right, it will work. And some of them, I've even used a trial of medication as a diagnosis if I can't get the right evidence. And if it's working for 2-3 months, then you can give them a diagnosis safely. The typical websites we tend to advise parents is ADHD. It's an American website, weblink, but it gives a lot of information to the families. In UK, we have addis.org.uk. Again, it is a good one, but we can update it even more. Pharmacological intervention is for moderate to severe ADHD. This is the mainstay of medication. If you have got the diagnosis wrong, make sure you rethink, and actually you can say, I'm sorry, I have started the medication, but I don't think the child will fulfill the criteria of diagnosis. So in 1 or 2 cases, when I've had to give a second opinion, I've said, symptoms are there which are similar to ADHD, but it's not ADHD. So it will take time, but eventually you will get it right. Mindfulness medication does works better for older children because they can work on it, especially the mindfulness technique. But even for smaller children, especially the ones who have autism, if you actually give them a YouTube video which tells them how to breathe and think and stay calm, it works for them. STEM 4, calm harm, self-harm, and high anxiety. Calm harm is quite good for self-harm and anxiety. Shredder app is very good, where they put down their thoughts and feelings and worries and see them disappear. But for younger children, we've also used like Worry Monster or Worry Box or things like that. And it helps with sleep, because if they're anxious, they wouldn't sleep. And most of my patients will have ADHD and sleep disorder together. Sorry. Management, stimulants is the first line of treatment. We use the methylphenidate group and the long-acting dexamphetamine. We call it Elvance in UK, or it's known by different names in US. I'm not sure if we have it in India, but we do have methylphenidate, and we do have the long-acting one in India as well. Definitely, I've seen Excel here, and usually the dose, the treatment therapeutic dose works out to be 0.8 to 1.2. So quite often we actually don't treat them. I often say that if you've got a child with asthma or if you've got a child with diabetes, you won't say, let's give him a bit of the inhaler, he'll feel a bit better. Or you won't say, I've given him a bit of insulin, he'll be okay. I say, make sure you get the right dose if you want the good effect. And as also ensure that if they've got comorbid condition, you treat the comorbid condition as well, because otherwise you could go on increasing the medication and the improvement will not happen. In fact, you'll get side effects. So mood changes, appetite loss, especially in the day, slight increase in heart rate, similar to what exercise does to us. So a bit of rise in heart rate, a bit of rise in blood pressure will happen. How much time do I have, Sanjay? Am I okay?
Dr. Jam, sorry to intervene. We have 2 more minutes.
2 more minutes. Okay, I'll try and wrap it up. Non-stimulants, amoxicillin and guanfacine are the mainstay. They take longer to work, but I use them in kids if they're not contraindicated. If the stimulants are contraindicated, they're not tolerated, they're not effective. If it is a long acting, they're long acting, so you have to give them every single day. It could take up to 8 to 13 weeks for atomoxetine and 3 to 4 weeks for guanfacine to work. But once it works wonders. So have the patience. I think what I'll do is I've just talk a bit on the slide and I'll miss the case studies. Hidden harm, we had to modify our ways of working. We had to do reviews by telephone, which had its limitations, but was better than not doing one. It took us a longer time for clinical review because of the cleaning things in between. Challenging for new patients as school observation was not possible, it was limited. Both parameters, we had to set up clinical support worker-led clinics. And I think it worked better in terms of working with parents, primary care workers. It was our relationship with them strengthened. Risk of safeguarding for children was there, as we could only see on the video or the telephone here what they wanted to tell us. Social interaction challenges continued. I think I'll skip the teenage challenges, which is mainly peer pressure, bullying. I think I've talked a bit about it, electronic media impact, and missing comorbid diagnosis, compliance issues. Risk-taking behavior is again very common in older children, driving, accidents, alcohol. We've talked a bit about it. Career options, I think I'll have to skip all these and the case studies because we've got the next speaker lined up. I think it's Nicola J. Make sure that they're taking the medication. It is the right amount. Does it last long enough? Make sure they have a good routine and breakfast. Talk to them. It's a window of opportunity, especially when you see them in the clinic or if you talk to them on the phone. And early screening, the earlier you treat ADHD, the better the outcome. Early intervention, raising awareness. It's never too late. Even if somebody's moved into adulthood, make sure you assess them and diagnose them and treat them. And you will make a difference, believe it or not. I've had lots of parents saying that it just changes the outcome. It just improves their school performance and the long-term outcome. Thank you so much.
Thank you very much, Renu. It was an excellent presentation and I was fully awake and fully attentive. I did not lose the attention. Great. I think we will leave the questions to the end. So I will now invite Dr. Nicola J. And just give me 1 second. Dr. Nicola J is a consultant pediatrician at Sheffield Children's Hospital. She specializes in allergy, but she has also got a degree in BSc in physiology, postgraduate qualification in healthcare leadership, MSc, as well as a postgraduate diploma in ethics and law. She also leads a clinical network in South Yorkshire and is a council member of the Clinical Senate in the region. She gives impartial advice to clinicians. She's been an officer for workforce planning and health services at RCPCH and is passionate about creating a healthcare that breaks the currently recognized boundaries to provide high quality care to children. I think we have shared so much of knowledge and experience in the last 2 days, and we can see and relate that healthcare services are different in different setups, and we have all had to make adjustments in our how we treat children, how we provide those services, and experiences are different but similar at the same time. In the UK, the public healthcare is fully dependent on publicly funded service provided by NHS with lots of governance in place, and it has had to make a lot of adjustments. And I invite Dr. Nicola J to share her experience. How has the COVID affected our healthcare service in UK? Over to you, Nicola. Thank you.
Thank you, Dr. Gupta, for that introduction. It's a great pleasure to be here today. The data that I'm going to present is on behalf of the Royal College of Paediatrics and Child Health. So there were 2 different projects that took part over the first lockdown and the second lockdown. And so I'm going to share that data with you today. Also, the first lockdown, April to July 2020, the data has been published in archives, and the second lot of data will be published later on. And if anyone's got any questions about any of this, then please do ask or email me. I don't have any problem with that. So I'll share my screen. Or are you going to? Have you got the presentation there that you're going to?
No, we can see your presentation, Nicola. You can manage
it. Okay, good too. Great stuff. Can you see those slides?
Yes, we can.
Good. Okay. So as I said, we surveyed all the paediatricians in the UK during COVID lockdowns to try and understand what the impact was on children and services. There was a huge concern when COVID first hit that the children were disappearing. And you've heard a little bit of that already from Michael this morning. And what happened was that the activity related to paediatric healthcare completely disappeared within our hospitals. And there were a number of reasons for that. The main reason was there was a lot of emphasis on adults and adult care, because the perception was that the adults were being affected by COVID and children weren't. And whilst that's true that the virus itself in the first lockdown wasn't particularly disadvantaged in children in terms of infections, there was a huge consequence in terms of those unintended consequences. And what we saw was that the hospital inpatients basically completely disappeared. And so the blue is decrease, the pink is increase. And most places saw a dramatic reduction in paediatric inpatients. Where it says there's an increase, then often that's due to service reconfiguration. So a good example for you there would be that in Northwest London, many of the district general hospitals stopped taking inpatient paediatrics. And what happened was that all those children were diverted to Great Ormond Street instead. And so the increase is a kind of misperception in terms of what happened. We had a little bit of that in South Yorkshire and Bassetlaw as well, where some of the children were diverted to different hospitals. And I'll talk about that a little bit later on. You can also see in terms of hospital outpatients that activity just stopped. And so if you think about this in terms of what we didn't see, then here you can see 60–70% of children were not seen in hospital outpatients. This is still the capacity that we need to regain. And all the people who've been trying really hard to do this, there's a huge worry about those children that still we haven't seen in terms of their routine follow-ups, but also the new patients that we're struggling to get into our hospitals. The biggest concern around Easter time of 2020 was around the emergency care. So suddenly children stopped coming to ED departments. And here you can see 92% of people reported they had a decrease in children coming to their EDs. And we knew that some of that would be that children weren't mixing, so consequently they weren't coming across some of the common viruses, but actually there was a significant worry about the harm coming to children because parents were keeping them at home. And they were keeping them at home because they were worried about paediatricians being available, but also because of the fact that COVID was around, they didn't want their children to get COVID in the hospitals. So the message around stopping coming to see us was just too profound. And I think that's one of the huge learning points that we have to take forward. There was a lot of negotiation at the time between the college and the different government organisations, but the messaging that we need to get out for children to say that we're still here, we're still open, we're still delivering care for your children. And that's something that happened around Easter 2020. We were worried about children presenting late to ED, and during this survey we saw that some children actually had delayed new presentations, but also exacerbations of old presentations. This is difficult data to collect because what do you actually mean by a delay in presentation? So it's around normally about somebody coming to harm. And so the kind of new presentations were things such as DKA, and I'll show you some more in the following slide, and the kind of the exacerbations of long-term conditions such as asthma as well, and diabetes. So people not actually having access to the medication, having exacerbations and not seeking healthcare. The exacerbating factor was also that the majority of GPs in the UK put an answer machine message on for people phoning in, and the message very much said, if you have any symptoms such as cough, cold, etc., please do not come to our GP practice. And if you think of the common conditions that children have, particularly around the winter time, it is those symptoms. And so children were staying away from primary care as well because they were being told to by a very mixed message approach. So late presentations are identified with things such as DKA, self-harm, sepsis, diabetes, malignancy. So a good example is a child who lived in London who had an increasing abdominal swelling, and those parents actually came to visit family in Derbyshire so they could access services, because in London everything was completely shut down, and that's something that we can't do again. Because of the worry about the delayed presentations and the right messaging getting to parents, then there was a COVID response group at the Royal College, and that was hugely effective in terms of trying to change the public behaviour around this. And so Dr. Sanjay Patel, who's a consultant immunologist at Southampton, he was central to developing resources that we could send out to parents. And this here, this red, amber, green sort of symptom checker on here is something that was produced by that COVID response group, and it circulated quite widely on social media. So it was all over Facebook, all over Twitter, and what we started to see after this was sent out, as well as some messaging on the national news stations, was that children started to come back to EDs again because they were being reassured that actually they needed to be seen. We also had a huge concern over staffing, paediatric staffing and capacity in the first lockdown. And so what you can see here is that there were staff who weren't available due to redeployment, and there were staff who were not available due to isolating. And that was because of the vulnerability of themselves, also if they were pregnant. If you look at who was moved onto different rotas, then we can see that it was the tier 1 doctors. So in the UK, the more junior doctors are called tier 1. The tier 2 are the registrar equivalents, and then tier 3 are the consultants. So it was the junior doctors that were being moved, and they were being moved over to ITU, to anaesthesia, to medicine to actually help support the adult response. There's also a concern over which types of paediatricians were being moved. And so you heard a lot this morning about some of the vulnerable children and some of the conditions such as ADHD. And actually the service impact was much greater on those types of children, because actually what we found was it was the community child health trainees who were being moved rather than the subspecialty paediatric staff. And so this is something that, again, that we need to be really careful of in the next, in any further COVID responses. Actually, it has to be equitable. And I would suggest to you that actually we need to move less paediatric trainees. And I'll show you the data from the second lockdown in a minute, which in comparison. So in terms of the staffing response, then we developed some kind of ideas about how we could make sure that we had safe staffing, how we could make sure that doctors who were acting up were safe to do so, making sure that those small, remote and rural services that are particularly vulnerable had the staffing that they needed. We also looked at redeployment of paediatric trainees and what we should be thinking of in terms of who should be redeployed and when they should be redeployed. And Dr. Will Carroll at University Hospital North Staffordshire was instrumental in developing those alongside his trainees. Did our staff have enough PPE and testing? So they seemed to very quickly. So initially there was a concern that only 80% were getting access, and the concern arose about the thought that paediatricians didn't need this because actually children weren't getting bad COVID. That actually, to be able to deliver our services and keep our staff protected, we had to have access to testing, we had to have access to good PPE. So very quickly this resolved and it got up against the high hundreds. But what this tells me is that us as paediatricians, no matter where in the world we are, we have to shout up to tell people how important the services are that we deliver, rather than being thought as kind of a second level service. In terms of investigations, then we can see that planned admissions reduced significantly, and also the routine statutory work, such as the special educational needs assessment, the looked after children, the safeguarding reviews, peer reviews, they all decreased. And so these children were disappearing. They're disappearing from schools, they were disappearing from health visitor home visits, they were disappearing from social services. And that's very much what Michael was talking about earlier, about that kind of socially vulnerable and complex child that needs to be protected. So I've just mentioned this, I won't go into this in great detail, but we also know that poverty has increased significantly over the last 18 months. And there's a huge north-south divide in the United Kingdom. So if you look at the poorest regions, they're in the northwest and the northeast and the Midlands, and the south is relatively protected. But obviously there are pockets of vulnerability in all these areas. In the south, it's particular in the coastal regions and also in some areas of London. We also know that a lot more children were living at home with domestic violence, and that domestic violence increased significantly during COVID-19. In terms of innovation and what people were trying to do, and obviously the virtual consultations increased significantly, which was helpful in seeing some children. But again, there were concerns around children being seen in the home environment, about their visibility, about them being able to communicate. So the fact that they had parents around and they wanted to talk about things such as their mental health or their sexual health or their kind of thoughts, other thoughts and feelings, then that's something they find very difficult when they're in an environment where they might be overheard. We saw changes in service development and service reconfigurations, and some of that was really good, but actually some of it's been really bad too. And we need to have our hands up to say when things haven't gone well, and make sure that we kind of regain those services for children. In terms of the impact on patient safety, and we've talked a little bit about this already, and we'll talk some more in the next set of slides. When the first lockdown ended, then there was a concern over those services being regained. So we'd given up quite a lot of our capacity to adults, we'd given up our outpatient areas, we'd given up our inpatient areas so that the adults could be seen appropriately. But then it became time to actually get those places back. And again, it's about that voice of paediatricians. I think as a group, we tend to be quite nice people, and we don't like sometimes speaking in terms of being quite authoritarian and saying we need this, we have to have this for our children. But so that's something that we really need to do if we have any more phases of COVID-19. So moving on to the phase 2 report, which was for the winter of earlier on this year. So again, we saw redeployment of staff to adult services. We saw redeployment of consultants this time. Our junior doctors were getting tired, and so we saw much greater impact on consultants in this next phase. Thinking about the compound effect of the first wave, the second wave, any future waves we have on children. Again, we saw areas of redeployment. The redeployment this time was much sharper and much shorter. So in the first wave, it was a prolonged effect, but in the second wave, it was different. And that will be different in subsequent waves too. We saw consultants acting down and covering the junior doctor rota. And again, we need to think about the impact on the different staffing groups in terms of the workforce wellbeing. Outpatient services were cancelled, but not quite as many as in the first wave. And that's probably because a lot of them were switched virtually very quickly. And so, yes, we have outpatient appointments. Yes, we're seeing children, but is the way that we're offering those appointments as effective as seeing children face to face? And for some people, the answer will be yes. So some of my consultations are actually much quicker in terms of a virtual consultation, but actually for 80% of them, that face-to-face contact is very much still needed. And when we're talking to managers, we need to make sure that we again voice our concerns about making sure that we have that face-to-face contact. Lots of managers see this in terms of funding. Actually, we see this in terms of patient outcomes. We also looked at testing availability and PPE availability. We wanted to make sure that all staff were tested, the availability for paediatricians again, because still the worry was about the kind of the preferential effect of the adults getting all the testing, all the PPE that was required, and access to vaccination as well. And so we wanted to make sure that paediatricians had access to a vaccination, and they did. By and large, that was absolutely fine. We were worried about future absences of staff because of the compound effect of COVID-19 during 2 different episodes. And we saw that actually 15% of clinical leads who respond to this survey were worried about staff who were currently off due to stress, but also the future worry that 50%, up to 50% will be off in the future due to stress and the impact of COVID. At this point in time, we knew very much that there was a more significant impact of the COVID virus on different groups, and particularly the non-white population. And we wanted to make sure that those staff who were extremely vulnerable got the assessments that they needed. And this is something that was quite a fight at times. And again, because paediatricians are a group that weren't thought to have had a significant effect because of children not getting the virus or not getting the virus badly, our staff were being left behind in terms of those risk assessments. And because actually we know 45% of our staffing groups are from overseas or from a non-white community, this is something that we fought really hard for, to make sure that paediatricians were not kind of the bottom of the barrel in terms of what they had access to. You've talked a little bit, I know, during the conference about children, young people, and mental health. We did a survey in 2019 around the mental health aspects of inpatients in children, and then we did it in December 2020. And after the first lockdown, when schools were reopened, we saw a significant increase in children who'd had mental health problems. And there was a doubling of those in inpatient beds. And this was predominantly around the eating disorders, the suicidal ideation, and much more significant mental health problems. So a significant problem that happened during COVID. We also had concerns over virtual consultations. I'm not going to go into that slide in detail because I know that we're behind. Paediatric surgery, so loads of cases were cancelled. We found out that 35% of those operations that were cancelled were in paediatrics, which is a phenomenal amount when you think about the number of surgery that actually happens in children compared with adults. So we're way behind in our surgical catch-up. In terms of priority levels, in the UK, we have these priority levels, and 1A, 1B, and level 2 are the ones that we're trying to get through really quickly. But now, even in those level 3 cases where you've got children who've had kind of spinal corrections, who need to have pins removed because of orthopedic procedures. All of these children may be having overcorrection of their deformities due to not being able to access theatre capacity. And again, this is all that we need to take into consideration as we move forward. So the aftermath.
Sorry for the interruption. We have 2 more minutes to.
That's fine. I've got 2 slides, I think. So the aftermath is the reset, the restore, the recover. So it's about making sure that we ensure that any health inequalities that have been increased during COVID are addressed, and actually we reduce them. We need to have new models of care to make sure this happens, and we need to make sure that those people who seek health do so in an appropriate way. And it's that child being seen at the right place in the right time by the right person. So onwards into 2020, and please do look after each other. And I'll just put the names down of the group at the RCPCH have helped me gather this data. And thank you very much for your attention. Stop sharing.
Thank you very much, Nicola. And I'm sure we will all agree that we have had such excellent presentations from all the speakers, which gives us such a insight into the healthcare in UK, which I think some people may find it difficult to kind of imagine that, that we, even in UK, we have had to go through so many changes and so many difficulties. And anybody from watching from UK can relate to that, including me, who is still waiting for a service recovery in my hospital. And we heard from Michael about safeguarding children, about what families have gone through in those difficult times. And we heard kind of very lovely, very much excellent insight into comorbidities in children with ADHD from Dr. Jainer, and the role of CBD in different medical conditions. So it's been excellent presentations. I do have some questions if I'm allowed. So I think first question is, I think we talked about the changing the way we deliver healthcare. So a lot of us are now doing virtual consultations and video consultations. And I think what we're looking at is in future, what's going to stay and what's going to go when we have a full recovery. Do you have any view about, and I think we looked at earlier this year in the RCPCH conference, we heard the children and young people's voice about preferring a face-to-face contact. So kind of what should be the future of these consultations, if you can if you share any ideas?
So I think children and young people have asked for many years about being seen for their outpatient appointments in schools. And I think that's something that we need to think about. I think we need to think about which ones need to be seen face-to-face and which ones can we deliver virtually. And there are certainly some advantages to delivering virtual consultations, but we need to make sure that we get it right. And it took us 20 years to actually learn how to do a face-to-face kind of, clinic appointment correctly with all the kind of learning that we have around that. And we really haven't done that with virtual consultations yet. And so we need to make sure that we have outcome measures. So are the outcome measures for virtual consultations as good as the face-to-face? And what are the advantages and disadvantages of that? Which is the right patient population to actually see virtually and not virtually? And so for a quick catch-up, it's really good. But actually, for an in-depth conversation and you want to examine a child and see a child and do investigations, then it's pretty useless, isn't it, really?
Well, thank you very much. I'm told we don't have time for more questions. So on behalf of COMHAD and BAPIO, I thank all the speakers for their time and their sharing their insight. Thank you very much. And we also thank COMHAD team for giving us this opportunity to be here. Thank you very much. Have a lovely day. Thank you very much.
Thank you.
Thank you, everyone.
Thank you all.
Thank you.
We would like to express our gratitude towards all the chairpersons who have chaired the session and moderated this session very nicely, and all the speakers for their excellent deliberation, and that too in time limit. Thank you so much. And we will move to the next session.
So we now pass the baton to next session with Dr. Vijay Dhote.
Yes, sir.
Yes.
Thank you, Sanjay. I have been listening to all faculty chairpersons. Last session, Vijay Dhote, please. Dhote is going to be joined by Dr. Vineet Gupta, chairperson, and Dr. Elizabeth Cherian and Prakash Sanghvi.
Yes, being a president, I also thank the BAPIO team for arranging their session. Thank you very much for the faculties Thanks for their gracious presence and presentation.
Should I start the session? Hello, am I audible?
Audible. Yes, you are audible. Please start the session, sir.
Uday, good evening.
So, good evening, everybody. I am Dr. Vijay Dhote, Joint Secretary, COMHAD International, President UOP Nagpur, India, and MOC and session in charge. Today's session, mixed bag. First of all, I am thankful to all the previous MOCs and session in charges who had conducted the sessions excellently and on the time. Thank you. Respected dignitaries, respected chairpersons, respected speakers, audience, delegates, very, very good evening to all. This is the last session of the conference which was successfully held since 3 days. The session is on mixed one, and in most of the conferences, this session is quite interesting. Lot of things we learn from this session, and very types of things are taught by the expert speakers. For this session, we are having eminent chairpersons. Dr. Vinit Gupta is the chairman. He is one of the chairman for this session. He is consultant in pediatrics and neonatology. He is pediatrician with expertise in cardiology, clinical lead, neonatal services, Southern University Hospital. His lead pediatric medical workforce, MSc group, Essex, United Kingdom. Our second chairman is Professor Dr. Elizabeth Cherian P. Madam. She is Vice President, Alliance for Health Promotion, Geneva. She is Assistant Governor, Rotary International, District 3190. She is International Coordinator for COMHAD. She has received Karnataka State Rajyotsav Award, Times Power Woman Award, and Women Changemaker Award 2020 for her constructive educational and social services. Our next chairperson is Dr. Prakash Sanghvi, a well-known figure in the field of pediatrics as well as COMHAD. He is a renowned pediatrician and neonatologist practicing in Kolhapur, India. A well-known personality in Indian Academy of Pediatrics for his excellent work in academics and social services. He has major contribution in imparting social services in COMHAD and many social organizations. Now, to begin with the session, the first speaker will be Dr. H. Parmesh. She will be talking on COVID-19, airway allergies, predictions versus realities. I request Chairperson Dr. Vinit Gupta to introduce Dr. H. Parmesh. Dr.
Thank
Vinit
you so much. Yeah, thank you so much, Dr. Dote, for giving me this opportunity to introduce the eminent speaker. So good evening to all my friends in India and good afternoon to those in UK. It is my pleasure to introduce Professor Parmesh, who is the National President of COMHAD India and a visiting professor at Devecha Center for Climatic Changes, Indian Institute of Science at Bengaluru. So welcome, Professor Parmesh, and we are looking forward to hearing your wisdom. Thank you.
Thank you, Vinit. Very nice of you. Can we have the slides, please? Yes. I think I take this opportunity, sincerely thanks the COMHAD and BAPIO for extending invitation for me to be a speaker in this international conference. Very important conference indeed, and give a talk on the airway allergies and prediction versus reality. And I sincerely thanks our international president, Yashwant Patil, recommending my name in this context. I bring greetings from the institution which I've been attached to. And I would like to dedicate my talk to the global COVID warriors. Let's move forward. Next slide, please. Next slide, please. Next slide, please. Okay. The flow of thoughts would be the brief about the pandemic, about COVID-19. I don't want to detail because the whole day we discussed about it. A brief about the pediatric allergy airway diseases in our country. The viral-induced trigger, how it starts, what's the mechanism involved in this one. What is really predicted, the COVID, what's going to happen, allergic children, asthmatic children, respiratory allergy people all over the world, and what is the reality, and what are the long-term effects of the COVID, and a take-home message. Next slide, please. Now, you all know all the pandemics have got a phases, various phases. The first to fourth, third phase is animal to animal, animal to more animal, animal to human being. So then comes the phase where a human to human spreading. Then comes the phase 5 and 6 is a pandemic all over the world. After the peak comes down, there are multiple waves will be there with the drifting of the genetic, not shifting, drifting of the genetic changes. And maybe second, third, fourth, fifth, and then we have to live with the virus because that will be annual activity of the seasonal level. This is the one we prepared in H1N1 10 years ago with the Government of India and WHO Central Office. I'm one of the facilitators. We have to train all those people, prepare ourselves in the future epidemics. It's already been done. We have been educating in this context. During that time, what we did was we expected more on that one. Okay. The future expert, you expect the future ways and prepare yourself. We also planned disposal of the dead bodies with respect. We planned all those things and imposing trade and travel restriction whenever it is needed. Next slide, please. And the virus, its job is to propagate itself and also survive against the enemies. That's a different system. This is what it named. During this process, serious death would occur. This is if you look at the spike of the COVID protein, this is the COVID spike. You look at that, the green and yellow solid particles, that is the protein content. It has got a hip, it has got a knee, and it has got the ankle also. I think this has got the greatest mobility, attacks all the cell receptors to enter the cell, propagate rapidly. In addition to that, it has got beautiful flowers around that. That is the carbohydrate molecules. It protects the protein against all the enemies. That is the human defense system. This is ingenuity of the new virus shifted, causing all this problem. And during that time, respiratory etiquette for any respiratory virus is a must. We have to learn that one. By talking, we spread about 100 droplets. By coughing, about 1,000 droplets. By sneezing, about over 1 lakh droplets to do that. Smaller particle, within 10 seconds, it will drop to the ground. A bigger particle, smaller particle, it takes about 10 minutes to stay in the air. So we have to keep it in mind, safeguard ourselves because the airborne infection is the dominant way of spread of this virus. Next slide, please. Now, I think what we did, first phase, we worked very well. Second phase become more and more, more mortality. That's mainly from the change in the behavior of the virus. As I said, it's a smarter virus with the genetic drifting had happened in that one, making it spreading faster. Now we got another spread, it's becoming more and more. Change in the behavior pattern of the people, that's called Peltzman syndrome, forgetting the preventive measures with false perception. First phase, nothing happened to us. Second phase may not happen to. This is what we felt. In addition, we have more festivals, elections came there, that spread. Third is some administrative laxity, we accept it. Next slide, please. Now, the IAP, we felt that people who are not been vaccinated, the children, they are going to suffer more. We have to prepare ourselves. We prepared in IAP and also in our state. I was one of the members involved. There are 10 commandments of IAP recommended important them are update yourself with the reliable, let me understand, reliable website, WHO, CDC, ICMR, Ministry of Health, Family Welfare, Government of India, and avoid unnecessary spreading of the myths and allay the panic, fear, and anxiety in the public mind and encourage the vaccination. Next slide, please. Come to the allergic diseases overview. Allergic diseases are the earliest onset non-communicable environmental chronic respiratory diseases. 70% of the non-communicable diseases are due to environmental pollution. I think 2015, Margaret Chan, then the director of WHO, mentioned at that time there was 1 billion population in the world are suffering in 2015. Anticipated is going to be 4 billion by the end of 2050. And airway allergies are the major psycho-socio-economic healthcare burden. Next slide, please. Now, if you look at our data shows allergic and upper airway allergy in 1994 is 22.5%, is gone up to 40% in 2004 in common general pediatric population. But in asthmatic population, the allergic rhinitis prevalence was 1999, 75%. Now in 2011 is 99.6%. Now you can say 100% asthmatic and allergic rhinitis, you have to look for it. The asthma, lower air allergy, if you look at the 1979 for 2 decades, steadily increased from 9% to 29.5%, just all over the world. Later on, is stabilized. Now we got to 2016, almost 28% of them. When it is stabilized, it is mainly from the change in the, I think, saturation of the genetically saturated population. So the persistent asthma, where they need controller medication, gone from 20% to 72.5%. Persistent severe asthma from 1995 was 4%, now it has gone to 11%, where the hospitalization mortality is high in them. Next slide, please. I think the most of the chronic cough, coughing more than 2 weeks, majority of the 90% is from the allergic airway diseases. Earlier it's the lower airway, now it's the upper airway problem. But the comorbidity contributes significantly. The snoring is only general pediatric population 8%. But on the contrary, children who are having a chronic cough more than 2 weeks, that comes to the sleep disorder breathing about 27%. In them, 42% are the snorers and 43% are the mouth breathers. Conjunctivitis is a major important component. We have to keep it in allergic rhinocyno, conjunctivitis, we call nearly 28% of them. And bruxism, we have to ask, then only pay mothers will tell that 17%, laryngeal dyskinesia is almost 3.2%. Next slide. Having learned at the magnitude why this allergic disease is increasing all over, the non-communicable increase all over. That's mainly from we are losing the threshold of protection by way of depriving the protective germs in our environment, changing our traditional food habits, adopting to the Western lifestyle of living with poor cross ventilation. And at the same time, we got higher pressure exposure to the triggers, such as air pollution, the predominant one, and increase in the viral respiratory infection is another one in children, especially less than 5 years. Less access to the healthcare facility. These are all the imbalance what is causing the allergic disease going up and up. Next slide, please. Now, if you look at the aerobiological triggering factors in asthmatics, our study shows dust mite 50% of the time, cockroaches 25% of the time, fungi and pollen 7.5% each, pets is 5% only, viruses in children, nearly 40% of them are triggered by the virus infection. I don't know, I think the next slide, please. I think the most common trigger for asthma exacerbation, especially in young children, is viral infection. These are all the 2 slides I borrowed my friend Papadopoulos, who is the past president of the EAC, European Academy of Allergy and Immunology. The viral infection damages the epithelial cell, initiate immune response. Next slide, please. I think when the virus infection attacks the cells, the cell get damaged and the cement, each cell, you get a trillions of cells what we have, the cement will be broken. There it make room, early phase reaction with the chemical mediators will be produced. Then the cellular mediators will be coming there. Early phase, late phase, the problem start like that. Because of this cement is broken, bigger molecules are entered the allergens, various chemicals, and nervous exposure will be there. The C level will be the C fibers. They are exposed to that. You have a sensitivity it takes about 21 days the healing process. This is how allergic problem starts there. Next slide, please. Now, what did this, with this virus infection with experience, what did all the CDC prediction, Center for Disease Control, they predicted children with allergy and with moderate to severe asthma may have higher risk of developing severe COVID-19 infection and severe allergic diseases. Take care of them. Don't use early steroids. When a flare-up comes up, we use the 3 to 5 day steroid. Never use that. It may accentuate the viral application and disease will be more in them. That was the prediction of our epidemiologist Jyotishis. What happened in that one? Pediatric cases, the consultation is only 1% of entire COVID-19 population. In them, only 1% have pneumonia. Mortality is less than 9 years. Even in China study shows zero mortality. The hypothesis why it happened? We predicted that it didn't go up. What had happened? That's mainly from the corona receptor ACE2 nematocytes is less expressive in children. More protective immune response is there with the T and B regulated lymphocytes in children. The higher eosinophilia count in allergic disease is a protective aspect because children who died from pneumonia with COVID-19, they had the eosinopenia, nearly 81.2% of them. Steroids usage is beneficial to control the viral replication as suspected. That's what mentioned about. Next slide, please. And do we have any proof? This is Papadopoulos study again. He mentioned about 1,054 patients, 66% improved in the asthma, 33% improved more than expected. The normal lung capacity, they had it. Next slide, please. And what happened to our Indian study? I think 314 pulmonologists interviewed. The study has been published. We found that reduced asthma in OPD visits, reduced hospitalization for asthma, reduce your exacerbation. You have noticed them. Next slide, please. And we found out about previous slide. We found out about nearly no nebulization used in 85.3%. And so definitely it has beneficial effect. We had it. Next slide, please. Then the question comes, when a child with upper airway allergy comes with nasal blockage, rhinorrhea, and sneezing, how do you diagnose is a COVID infection? How do you diagnose is an allergen? The common symptoms, these three are there, but COVID-19 have a constitutional symptoms. On the contrary, seasonal allergic rhinitis have got itching and conjunctivitis the most. Itching is a must as a matter of fact. Next slide. Having learned that, then, what are the inflammatory markers? We identify the mortality. Among various things are exhibited. Next slide, please. We found out about D-dimer and the interleukin-6. If 3 times higher, usually 75 to 80% mortality is there in them. Next slide, please. Now, suggestion from asthma management during this COVID, what we learned, asthmatic are not as increases of COVID-19 related mortality as suspected earlier. Even the hospitalized patient more than 50 years who have been COVID-19 patient using inhaled corticosteroid without any other respiratory content had a lower mortality. Asthmatic should continue inhaled corticosteroid and also oral corticosteroid if prescribed during the flare-up. There is no way anyone in the world distinguish between the worsening to asthma from one virus to other virus, like rhinovirus, the most common virus. Next comes the influenza and COVID-19. So suggestions have been done from this, avoiding spirometry and all this thing in children in Zena guideline. Try to avoid nebulizers, sir. Follow the infection control recommendation. Recommend vaccine COVID-19 children for all asthmatics. Next slide. The long COVID term effect, what is the long-term effect? 10% of the COVID-19 remain sick after 3 weeks. 5% COVID-19 remain sick for many months. Next slide, please. And what is the most common ongoing symptom regardless of hospitalization? Nearly 80 to 95% of them, their fatigue, muscle ache, shortness of breath, and headache. These are the most common things. Next slide, please. So what did my friend in Michigan State University, these are all the usual guidelines we follow in them. These are 2 important things we have to follow it up. He recommended avoiding the vigorous physical exercise 3 to 4 months, avoiding competitive sports activity for 6 months. Next slide, please.
Sorry to interrupt, sir. 3 minutes remaining.
Oh, fine. Thank you very much, sir. I think all the mortality, where it come from? It came from where the pollution is very high. We have to look for the air pollution and all those things. And in future, if you think back, if the air pollution increases, mortality, new viruses going to come there. It's going to have more pandemics in future. Next slide, please. I think this is one thing you should know about it. We have to various marker. Nature, we have to grow a tree for good air and all this thing. Lichen is the one, it is a fungus and algae, a symbiotic growth. It indicates less polluted environment. To grow this kind of this size, it takes about 10 years. So I think a good atmospheric marker will be there in the nature has provided many markers to us. Next slide, please. And take home message, asthmatic don't have any higher risk for increased COVID-19 infection and mortality. There is no way one can distinguish between the worsening of asthma from different viral infection like rhino, influenza, COVID-19. Add oral corticosteroid during acute flare-up in 5 days. Be bold, happy, sleep well, eat well, be positive while awaiting for the vaccination. Encourage the children vaccination. Next slide. Thank you very much for your time.
Parmesh sir.
Yeah.
Dr. Sangvi here.
Yes, sir.
Indeed, it was an excellent presentation and a real eye-opener. But I would like to know one thing.
Yes, sir.
In the first wave and the second wave both, what we have observed is much more significant mortality in US and UK, where the health facilities are at top level, and comparatively very insignificant mortality in India. That too also children. That is one. And second aspect, we didn't have many children with the corona suspicious or corona positive infection struggling or getting severe disease, but PIMS patients we have seen significantly. These two things that I need, you can better explain to all of us.
Well, US management and all these things, their vaccination, they are recognizing now. Initially, a lot of problem happened. They cared for dollar versus the livelihood. We cared for the life against the livelihood, and also care for the birds and animals at that time. The values were different at that time. And also there are a lot of each company promoting their own vaccine. There are a lot of businessmen there. They didn't care for that much, as a matter of fact. That has caused a hell of a problem. Mortality much higher, as a matter of fact, there. That's one of the reasons. We is much less first. Second stage, children is coming there, but mortality is way less. So our own study also shows here. Yes. And also the mask is only what you say. All the 314 pulmonologists in the country, it's only help for only 10%.
Yes.
If you have arm distance, anything like that, you safeguard yourself. So this is what it is, sir.
More than COVID-19 patients, children suffering, many of them we have seen with PIMS, post-infectious multi-system involvement, post-inflammatory.
Yeah, and also if they're coming from the high polluted area, that produces a hell of a problem, sir. In future, pollution going to be more and more because the frosting going to happen, air pollution will become more and more, global warming become more and more, 2.5 million can create hell of a problem for us. And almost 33 variety of viruses are identified in 25,000 feet above sea level. And among them, 28 are new one. If the defrosting happens, and all the snow is melts, they are going to come there, affect us. I think we can expect the future pandemic. We should prepare ourselves. This is an emergency. We just concluded the 26th in Glasgow.
Sorry to interrupt, sir. Time is up.
Okay, thank you.
Thank you, Parmesh. It was really excellent presentation.
Thank you so much, Professor Parmesh. I think it was a fantastic and comprehensive talk. If there is a time, I just wanted to ask you one thing from your wisdom. Do you think, or is there any earlier predictions that, children who have suffered with COVID-19, they are at risk of developing asthma if they do not have asthma or hyperactive airway disease?
Well, that study has not been done. Nothing has been accepted, sir. Still, we have to wait and watch to find out about that. But any virus infection, nearly our own study shows any previous viral infection, 28.5% of them develop asthma later on.
Yeah, okay, yeah.
Later on. In that context, whether it is there or not, we have to wait and watch. The only study I can quote is the Melbourne study where they followed about 45 years. Children who had a wheezing, not wheezing from the viral infection, not wheezing, only 15% developed in 45 years. Children who had wheeze, they had not 50% developed wheezing by age of 42 years. This is life causes, sir.
Yeah, I think it's time will tell.
Yes.
But thank you so much, Professor Pamesh. It was lovely to hear you. Thank you so much.
Thank you, sir.
I will hand over to the next chairperson, please.
Thank you, Dr. Vinny. May I request that the questions be reserved for the end of the presentation so that the speakers complete their talk, please. It's my pleasure to introduce Dr. Jyoti Srinivas, consultant pediatrician, Milton Keynes University Hospital, Associate Director of Clinical Studies, University of Buckingham Medical School, UK. The COVID-19 pandemic, as we have all heard, known and experienced, has thrown unprecedented challenges for healthcare workers world over. They have continued to care for patients despite exhaustion, personal risk of infection, fear of transmission to family members, illness or death of dear ones, friends and colleagues. Isolated from families for months together, they've been affected with anxiety, depression, insomnia, and so forth. Passionate about clinicians, healthcare personnel, and caregivers, Dr. Jyoti Srinivas will be talking to us on the impact on healthcare workers caring for COVID-affected children. Over to you, Dr. Jyoti.
Thank you. Thank you. That was a very good introduction. Thank you, Dr. Elizabeth. Now, as mentioned, I looked at the program and I see we have a lot of talks on how to care for patients, for children or adults with many other issues, medical issues, and COVID. But I think generally we are not so good looking after ourselves first. And that's what we say, you know, there's a saying, you can't pour from an empty teapot. So unless you look after yourself, you cannot look after your family or the rest of the patients. So this is my talk on what's happened to us healthcare workers, which includes doctors, nurses, and pharmacists and everybody else during COVID. So this, when I was looking at what's happened in the last 2 years, I remembered something my history teacher used to tell me when I studied in Bangalore. And she was a history teacher, so obviously she used to say, those who don't know history are destined to repeat it. And I thought that's a good one for us to remember to see how have we got to this stage. So if we remember 2019, December, this seems ages ago that we heard of this Wuhan virus and the whole world was watching. There were people in all these suits walking around, pulling people out of their houses. And we had not heard of such a thing for a long time. So everything was new. And we were wondering, will it spread? Will it not spread? What virus is this? A lot of questions. But we saw within a couple of months, it slowly spread. And we remember this beginning of last year, all of us glued to social media, to newspapers, to WhatsApp groups, seeing the number slowly increase every day, number of deaths slowly travel, other countries reporting COVID as such. And all these graphs going up and down, some countries going way high, others slowly catching up. In the end, we realized no country was going to be spared, but it took us a little time. And we were all waiting. If you remember, January, February, we were just waiting. We had never endured a pandemic, our generation, so this was new. No country, no health resource was prepared for a pandemic at this stage. And then in March, we saw WHO finally declare this as a pandemic. And Dr. Tedros, we heard so much about WHO in the next few months. And it came to UK, it came to India as well. And it came, first one was in Karnataka. And that was a new thing that made the first death, made big headlines. And then the panic started for us. And it's good to remember for a minute or two more all the things we've been through. Some countries like India went through very strict lockdown. Others, not so much. Some others said, we will not do any lockdown, we'll just work through it. And then we saw healthcare workers, learn about lockdown, about public health, giving announcements. PPE, how many of them knew what PPE meant? Now every layman knows what PPE means. About the importance of masks, how some countries like US were so slow to take that up to say masks actually prevent this. And hand washing and not going in crowded places, people taking so long to understand this. And when these came initially at the first wave, how did they look at healthcare workers, whether it was India or somewhere else? They said, we are the heroes. We were superheroes and we were going to save the world. And everybody was grateful for us. But slowly we started seeing the effect on healthcare workers. We saw how wearing PPE for hours affects our skin. We saw how badly it affects the sweating and how you can't change your clothes, how you can't eat or drink for so many hours if you're in that PPE. Now, these are the physical effects, but we also saw, bodies being burnt. Who can remember this? Of going all over the world, these images, not enough people to burn the bodies. About the oxygen tanks, when India ran out of oxygen, when there were no beds around. And we have to remember that as a healthcare workers, whether doctors, nurses, whatever profession you were, we went through all this. And it was so hard for us to see this. The one on the right, the square page, is the UK doctors who died due to COVID. And in that, 2 of them I know very well that I trained with, and they died. One is a neonatologist, the other one is a ED consultant. And the right one, if you go closer, you will see it's the pictures of all healthcare workers in another country who have died of this. So healthcare workers have paid a big price in this pandemic. And India wasn't exempt too. Many, many doctors died in India too. Going to the next slide, please. And WHO has been trying to keeping track of this. And they think between January last year to summer this year, anywhere between 80,000 to 180,000 healthcare workers have died because of COVID. Now, no other occupation has such a high mortality rate as healthcare workers in the last 2 years. Now, death is just one worry for healthcare workers in COVID. There were many other worries if you look. Our shift patterns changed. We were working long shifts on COVID wards. Sometimes we had PPE, sometimes we had no PPE or inadequate PPE. We were worried about infection, getting ourselves infected, about going home and passing the infection on to our family members. We were worried about isolation, about ourselves. How will it work? We worried that we did not have enough support. And many of us who couldn't see our friends and family, we could not travel. There were quite a few healthcare workers, doctors and nurses in UK who couldn't see their families in India for at least 2 years. And in all this, the guidance kept changing, new evidence kept coming, and every day we had new evidence and new guidance. We had to keep on top of it, but also let everybody else know this has changed now. Can we adapt to this? And of course, there were changes, shortages in medicine. There were some colleagues who couldn't come to work. How do we cover them? Now, in all of this, we learned that public health and government policies are so important. If the government is not up to date, will not listen to scientists, it affects how we work. There are some good points of the pandemic. We have so many WhatsApp groups now. We can do virtual ward rounds. I did some in South India from here, helping them do ward rounds. We can do virtual conferences like we're doing now. Sharing information is much easier. We've also learned it's important to have family time among ourselves, not just all the time going around in big groups. And if you look at studies in the last 2 years, there are more than 2,000 publications on the impact of COVID-19 on healthcare workers. These are some of them that I've shown. Next slide, please. And looking at these, the first study started coming out of China and then Italy in last year. But the main thing it came out was the support for healthcare workers, and quite a few institutions started putting up some support groups for them. But the one thing, this is a Scottish doctors project, which said, look at this, we are here, come, we'll help you, see what you can do to help yourself. Next one. So the main things that came out, if you didn't die of COVID, you had a lot of other effects: depression, anxiety, stress, and not being able to sleep. And what they showed was female health workers had higher rates of this compared to male health workers. There are some studies. There are two good ones. This is the first one, which says those that are in dark black are good predictors of mental health issues, and those are on the light gray are lower risk factors. So if you're on media all the time, depending on your profession, where you are, and your hospital policies, they have a very big impact on your mental health. This was from the States. And the next one, which was from the World Psychiatric Association, they looked at a lot of qualitative exploration on Indian frontline physicians. And what they said was, if you have a good social network, if your colleagues support you, if you work together on problems, if you can look after yourself and your mental health, those are the best coping strategies for healthcare workers. And this is their flow chart, which shows challenges, a lot of challenges that we face in UK and India, what we need, including flexible work policies and sensitivity of media. I think that's very important in India and UK, and how we can work through it. And this is two physicians in UK have come up with this to say at the bottom, it says everybody needs self-help and self-care. But if you are going to work, these are the things to look out for, how you can help each other. And as you go up the level, you probably need more support or more official support from mental health personnel. And this is one of the blogs from one of my colleagues in British Medical Journal just from last week, where he talks about, you know, are we in the third wave? Are we in the fourth wave? We don't know, but we are almost coming to the end of our tether. And we think of so many death certificates, that names we can't remember, phone calls we make, and where it changes the lives of the people on the other side. We still carry those burdens, and with every wave, we add to it. So the things we have learned from the pandemic as healthcare workers is that masks, social distancing, hand washing, they're all very useful. Telehealth is the new normal. We have to get used to this. And vaccines are so useful, but many people still refuse in the world to take this COVID vaccine. And this is my passion, which is there are some countries who have money, who have hoarded the vaccines, and we cannot treat everybody equally in a pandemic unless we are willing to share. And we need to take mental health seriously. As clinicians, we are always used to saying, I'm very strong. I will not say I need help. I will not accept I have depression. So we need to be brave enough to say mental health is important. And look how well we did with all these problems. So we can be resilient. We can adapt new ways of working. And our family, our friends, our community is very essential. Yes, technology is there, but our close group are the most helpful group. And sometimes we do need a dose of humility. You know, many scientists have been wrong. Many governments have been wrong. We should be able to say, you know what, we didn't know much about this virus. We were wrong what we said before. The new evidence shows we have to change it. And we have to be upfront about this. And this is one of our favorite authors called Charlie Maxey from UK. And he says, you know, what's the bravest thing you ever said? And it says help. So we should be brave enough to say, we can't fight this on our own. We need help. We need help from the public, from our family, from our colleagues, and from the government. So I think that's the end of my presentation. I'm not sure if we have time for questions or I can wait to the end.
Thank you, Dr. Jyoti. Thank you very much for that passionate concern for healthcare workers, reflected so well in your presentation. The past is where we learned the lesson. The future is where we will apply the lessons. Let us hope we apply the learned lessons in future. Questions, if any, we can reserve to the end of the presentation. Over to you, Dr. Prakash Sanghvi.
Thank you, ma'am. Thank you, Elizabeth, ma'am. And it was really excellent presentation. I really appreciate it. And concern about not only healthcare, but it is a total humanity concern, including a mental health checkup for everybody, or mental health care for everybody. So I really appreciate what concern you have shown for all of us, including all healthcare work. Thank you very much. Now, our next speaker will be Dr. Manjit Raina. She is consultant pediatrician, neurodisability, designated medical officer for ACND. Dr. Manjit sir, welcome. Child Development Center, Birmingham Heartlands Hospital. And he is going to speak to enlighten us about the management of children with spasticity in cerebral palsy. That is one of the topic to my heart. So he will be definitely adding much more knowledge to our present status. Please, Dr. Manjit.
Thank you. Thank you very much, Dr. Sanghvi. And thank you to you and all your team to give me this opportunity to speak on this wonderful conference. I'll start with sharing my slides. Okay, can you see the slides or not?
Not yet.
Yes, it is visible now.
It's come up now? Okay, thank you very much. Thank you. So I'll just start to move. Are these moving?
Yeah, it is moving.
Okay, thank you. So I'll just start briefly with a brief definition of the cerebral palsy. I mean, cerebral palsy was described more than 160-70 years ago by English orthopedic surgeon Christopher Little, but that definition has changed, has been modified over this century and a half. But by no means it is the perfect definition to describe the condition. There's still a debate. What is cerebral palsy? But the current one, which is generally considered the most recent one, was in 2007. So it's basically a group of permanent disorders of development of movement and posture, causing activity limitation that are attributed to non-progressive disturbance that occur in the developing fetal or infant brain. And we all know this is simply not a disorder of motor function. It affects all other modalities of child's human function, as it says in my slide. The main topic is management of spasticity. But before I elaborate on that, I think it's very important we understand the whole context of upper motor neuron syndrome. And it is this context within which one element is spasticity. So how we manage spasticity and what outcomes we would achieve. And what outcomes we would achieve are not only limited to spasticity, but other factors. I think if there is one slide to take home and keep in mind is, I think this one. I'll elaborate on these factors. So children have spasticity, they also have weakness, paroxysmal abnormal movements, they have impaired selective motor control, co-contraction of muscle contraction, then muscular viscoelastic changes happen over time, and then they develop joint and bone deformities. So I'll elaborate on these issues one by one. So first, the weakness or impaired selective motor control. So the muscles, they generate the force and we do the movement, but the origin of this force, we all know, is in the brain. So in our upper motor neuron system. So and that is the, if you like, the battery or the power generator of this system. So if they have a muscle, or if they have a nerve loss there, the battery is not as powerful. So the children will not be able to produce as much force as they should be able to do otherwise. So this just shows a EMG on children with one child with hemiplegia. If you see the side, this child is standing on a swaying platform. So their TA is tendoachilles, so basically gastrocnemius muscles. So the healthy side produces quite a good amount of activity, but the unhealthy side, very low activity. So that shows us they are not able to generate good amount of force. Impaired selective motor control is when we do our movement, we don't movement, we have to do our movement in a controlled fashion to achieve the desired result. So further away the movement is from our trunk, the more tricky it is to do the movement. It's easier to move my shoulder than it is to move my palsy or any other upper motor neuron condition. They have impaired selective motor control. So they are not able to do in a very controlled fashion. Then third is abnormal sequence of muscle activation or sometimes co-contraction. So for example, if somebody pushes me and if I'm standing, to balance myself, I need to balance my base first, which is initially I should contract my distal muscles closer to my ankles to stabilize myself before I do my hamstring and quadriceps muscles of my pelvic girdle. So children with cerebral palsy, they can have this abnormal sequencing of muscle activation. So their base may not be stable enough, so they will fall. So co-contraction. So co-contraction is common in early infancy. It's normal. So to do a movement, I need to contract my agonists. For example, if I want to flex my wrist, I need to contract my wrist flexors, but at the same time, inhibit my antagonist. Only then I can flex my wrist. But if there is co-contraction going on of muscles on this side and this side, I won't be able to produce a smooth movement. So many children with cerebral palsy, there is a co-contraction of muscles going on, which also contributes to their impairment. So all these factors are at play. So if we think of the outcomes we want to achieve, just by managing spasticity, we may not be able to achieve the outcomes which we promise to families. So we need to talk about all those factors before we embark on any treatment for spasticity, so that we can discuss and agree with the family reasonable, achievable outcomes. So what is spasticity? It's nothing but the exaggerated stretch reflex. So basically what we do is how you measure it. So you stretch a muscle slowly. So for example, if I'm bending my wrist this way, I'm stretching muscles on this side slowly and then do fast. So when I do fast, I'm stimulating spasticity. So I should not be able to move my wrist to the same degree as I did with slow. So I should stop here. So that is spasticity. So that's what we call dynamic element. So one can measure this scale called modified Ashford score. So 0 is normal muscle tone. Second is you get a bit of a catch, but then there's a release. 1+ is catch, but you can still move, but there is some resistance you feel. Then 2 is you feel quite a bit of resistance throughout. And then as you go on to stage 4, so level 4 is when the limb is in a rigid posture, either in flexed or extended fashion. So that's one of the scale we can use. So before we think of treating or managing spasticity, we should keep in mind that first job of a doctor is that we don't do any harm before we by our interventions. So we should have some outcome goals that we want to achieve. So because spasticity itself can have some positive aspects, so it can help with maintain muscle mass, it can help with bone density and aid sitting posture. So somebody who's quite weak, but they're just about managing to sit up using spasticity in their truncal muscles, and we take away the spasticity with our drugs or other interventions, they can't even sit up. So we actually have harmed them. And also it can help with the muscle circulation in the periphery. So you would all have experience of children who have got very weak muscles. Distally, their limbs, particularly feet, can be swollen because of poor circulation. So when to intervene? So as I mentioned earlier, we should have some outcome goals we want to achieve. So if spasticity is interfering with their voluntary movement, then to intervene. To maintain the joint range of movement, otherwise the children will develop permanent contractures. And only way you can then fix that problem is by surgical treatments. And we want to avoid that. To make cares easier, handling clothing. So for example, just to give you an example, if a child has got very high spasticity in their pectoralis muscles, they'll be like this. And imagine a family, a parent trying to put them a sweater or shirt. They can't move their arm to the side, so they can't really change their clothing. So that is just one example that spasticity is causing problem. Muscle spasm giving them pain, also interfering with sleep. So when these difficulties arise as a result of spasticity, that's the time to intervene, not just by having some degree of spasticity on its own when it's not causing any problems. So broadly speaking, there are treatments which are generalized to affect the whole body, and some are focal treatments. I'll elaborate on these in my next subsequent slides. So vitally important are therapy interventions. So our physiotherapy colleagues, they will advise on postural care, muscle strengthening exercises, active stretching exercise of muscles, functional electrical stimulation. And sometimes when the muscles are contracted, at times they could lengthen them by doing casting, so they can stretch the muscle out. So you don't need to go for any other invasive interventions. And then maintain the muscle length and joint range by using the splints, like these ankle foot orthoses, knee gaiters, which go across your knee and maintain your hamstring length, or sometimes contracture correction devices we have to use. In terms of medications, diazepam, which is quite a good drug as far as its effect on spasticity is concerned. It does help with spasticity, but the issue is long-term use can be problematic. They develop tolerance, or it can be quite sedative, affect their swallow, affect their drooling, which many of the children already suffer from. So most common drug, I think, used is baclofen in the long term. It has got a reasonably good effectiveness, but there is a therapeutic window is quite narrow. There's a very poor blood-brain barrier penetration. So you have to put in bucket load into the child to get few drops into the CSF where it needs to go. So that's the downside of baclofen. Again, it can cause truncal hypotonia, sedation, as well as can make drooling worse. So more and more people are now using gabapentin, which is works better if children have spasticity with dystonia, but at times we will have to use very high dosages for it. But again, potential side effects of gastritis, fatigue, sedation. Then last to tizanidine, which is an alpha-2 noradrenergic agent. This can also be used, but it's got potential side effects of hypotension and sedation. And the most worrying one is severe hepatic failure. And similar to that, dantrolene, which is the one which acts directly at the sarcoplasmic reticulum level by inhibiting the calcium release. Again, it's not one of my favorites because of severe liver failure risk. So in my practice, I generally, if diazepam, baclofen, gabapentin don't work, I seriously start to have discussion with families about other modality of treatment, which I'll talk about in a short while. So for focal treatment, botulinum toxin injections, so which is Botox, Dysport, Zomin. So these are the formulations available. So it is probably the potent neurotoxin known to mankind. It's produced by Clostridium botulinum bacterium. Which has 7 subtypes. It acts by blocking the acetylcholine release at the neuromuscular junction, and it permanently binds with the junction and then damages the junction forever. But neuronal resprouting occurs, and then the muscle spasticity comes back. But there are risks. Repeated use, very frequent use can cause muscle atrophy. There are a number of papers published which support that. So we have to be very judicious with its use too. Suppose licensing is probably different. I suspect in different countries. In the UK, it's licensed for focal spasticity in children with cerebral palsy, in ambulant children who are over 2 years of age. Dysport has also recently got a license for upper limb spasticity. So we have to have a discussion and get informed consent from parents when we go for this intervention. Adverse effect. It's generally very well tolerated. In my own practice, I probably done over 700-800 children, maybe close to 1,000 children. I've never come across any major problem. We run a service with the ultrasound guided we do, so it's a very, done in a safe manner. Sometimes I see anatomically people do the injections, it could go into the bloodstream, and if that happens, then it's you're asking for trouble. It can paralyze your diaphragm and you end up on respiratory arrest. So it has to be very, very service setup, which is people who are experiencing using it, and strongly recommend using under ultrasound guidance. So as I mentioned, oral baclofen has got very poor blood-brain penetration. So then if that is not working, botulinum toxin is not an option, or oral drugs are causing significant side effects, then other option is intrathecal baclofen pump. So as you see, a very small amount of what one would use orally is needed. So it's a surgical procedure. I look after many children who have had this, and generally it's very well tolerated. So it's a device which sits under your skin or muscle in your abdomen, and a catheter goes into the spine, and it's a continuous infusion of small dose of baclofen, which is happening and helps with the spasticity. You can adjust the dose. Sometimes you can increase the dose in the daytime, reduce in the evening or night, depending upon the difficulties the child is experiencing.
Sorry to interrupt, doctor. 3 minutes remaining.
Okay, thank you. So other option is selective dorsal rhizotomy. So this is the permanent, so there is no going back once that's done. So we have to be really, really selective who we do this on. Is where the sensory nerves are cut in the dorsal region, and you take away the sensory feedback pathway of the stretch reflex. So this is the criteria used in the UK. So generally is used for children who are mobile, the ambulant children, and who have cerebral palsy with the typical MRI changes of periventricular leukomalacia. As I mentioned, if you overdo it or do in the wrong child, the risk of going backwards, so you can lose ambulation. Then our orthopedic procedures, which my surgical colleagues at time will end up doing. So this was one of the systemic reviews published in 2013. So they defined green, amber, and red. So the intervention which we should do or shouldn't do in children with spasticity. So in the green category are CIMT, which is constraint induced movement therapy. I can let you read. So diazepam, toxin, SDR. These are the yellow ones we should do: baclofen, tizanidine, dantrolene, ITB. And these are the ones which we shouldn't do. So we should have some, whenever we do an intervention, we should have some measurable outcomes that what we want to achieve. And these are the patient-reported outcomes. What patients come back and tell us whether interventions helped them with any of these areas. And these are our clinical reported outcomes that we measure their joint ranges, the level of spasticity left in them, and how it helped objectively. So ultimate goals of spasticity management are maximizing child's developmental potential, promote their independence, relief of pain and improve sleep, prevention or delaying of secondary musculoskeletal complications, and improving the quality of life. So thank you very much for listening. And if any questions, please fire away.
Thank you, Dr. Manjit. It's a really excellent presentation. Since I know what are the problems, 2 small questions I will ask you. We have got more cath labs and transplant centers in India than cerebral palsy centers. And the babies you are seeing in every small village, there are few babies you see. Overall, the India's population, if you consider, millions of babies are there with the cerebral palsy. It is not a one-day problem like interventions of transplant or something like that. It's a continued problem, requires continued treatment, multidimensional, multi-therapy centers, occupational therapists, neurologists, neurosurgeons, orthopedic surgeons, and whatnot, and parents' affordability also. So how to bring some combined factor wherein we are now health due to COVID pandemic, our health systems are improving, but we need to do something for that. Even at district levels, government hospitals, though they mention that these are the CDC centers or the centers for the child development, but it doesn't work to that effect, and we are most unfortunate. One more thing I wanted to ask you, I am also invited for seeing a young adult, 24 years, with multiple contractures. He cannot feed himself, no bowel motions, and they continuously crying. Child is from Coimbatore. Now he is brought to Kolhapur and asked me to come home and see. What should be done to such a child when he is 24 years with multiple contractures, cannot sit, cannot go to bowel or anything? How should we, what shall we do?
Yeah, I mean, I think these are very good questions, to be honest, but I don't have any easy answers to. I mean, first question, I mean, I think resource. I mean, that is, it's a multi-million-dollar question, really. So resource, even in the UK, we struggle. We feel that, we need more resources, and I can understand the, context you're talking about. I think earlier we intervene, the better the outcomes and more cost effective. And I think, to me, if we are thinking about in a relatively resource poor environment, I think earlier education of the families, perhaps, YouTube sessions, YouTube videos or something at a very village level, so which are accessible to at mass level. So I think education probably is one of the cheapest way, I suspect, to prevent many of the complications from happening. And then education of the staff, the health staff at large. So we can't, a handful or a small number of experts can deal with the size of the problem, the population in India is. So I think it's the upskilling of the health profession at mass level, I think is probably one way of going about to mitigating the problems, but by no means that's the complete solution. And second question about this young man who's, you mentioned 24, I mean, I suspect he's now gone to that stage where he's now fully contracted. So a lot of contractures have set in. And his muscles will be atrophied. So I doubt botulinum toxin, selective dorsal trisotomy, or medications will be of much help. I think he could be helped to some extent by surgical lengthening. So I suppose orthopedic colleagues or maybe spinal surgical colleagues coming out with the muscle lengthening procedures. But it's a very tricky situation, this young man you have found him in. I hope that answers your question.
Okay, then we move on to the next speaker, Dr. Chaya Prasad, a developmental pediatrician, director of ASHA, the Center for Autism and Intellectual Development, Chandigarh. The ASHA Childcare and Development Center is a one-stop solution for children and adolescents with developmental and behavioral concerns like autism, learning development disabilities, and other concerns. She has also been the past National Secretary of the IAP chapter of Neurodevelopmental Pediatrics at the Indian Academy of Pediatrics. Today's two headlines in the newspapers will be of interest to you, Dr. Chaya. One said 70% of kids are addicted to mobiles for gaming, films, and chatting, thanks to the unintended consequences of the use of gadgets for online classes. Another said that India's goal of universal school enrollment may have hit a stumbling block with a steady decline in enrollment, resulting in 3.3 million fewer children in school than a decade before that. In view of these statistics, the topic that Dr. Chaya Prasad will be talking to us today is on school readiness and enriching learning environment. And I think it's very pertinent and apt. Over to you, Dr. Chaya.
Thank you. Thank you, ma'am, for the kind introduction. And very honored to be here today. Bodhankar sir, Yashwant Patil sir, Rawat sir, Dr. Prajakta, thank you very much. Paramesh sir, thank you very much for inviting me. And I had COVID in May and I was in the hospital in ICU. After a long gap of 8 months, this is the first time that, I'm speaking. So please excuse me because, I still have a lot of anxiety issues and a lot of health issues, and I am undergoing pulmonary rehab at present. So
we are honored, Chaya, that you are here. Really, God bless you.
Thank you so much, sir, with your blessings. So I hope I'll be able to do justice today to what I'm talking. And with the introduction of today's headlines in the newspaper, Dr. Elizabeth. So can I share the screen? I'll share
you
my
are going to be last and best batsman of the inning.
I don't know best. I'm honored to listen to all the talks. It's been so wonderful to listen to everybody. So thank you very much, sir. And I'll just adjust this here. Okay, so because the topic today is about school readiness and how to partner with various stakeholders so that children who are not getting exposed to appropriate environments, how they can get better education. So as we know that health and education system have the most direct link to early child development. And we know that billions of children are at risk of falling behind due to the school closures. And, the countries have tried a lot to connect with children via internets and radios and televisions. But many of the countries have not been able to do, and especially in India, we had many students reporting through the news reporters on television that they were not able to have access to studies. We've heard of cases where children committed suicide because parents were not able to afford mobile phones for them, and children running away from school, and many such cases. So today, through this talk, we have a look at children who have not yet been exposed to the environment of school, and how do we ensure that when they enter school, they have their appropriate things in place. So we know that more than 90% of the countries have adopted these policies, but only 60% have been able to do so far for the pre-primary educations. And considering all the data that is available on the internet, so it's very important that we do not rely only on single remote channels of learning through TV and through the internet, but our main aim should be that how do we prepare parents and how do we train parents so that because we know that they are the first teachers of the child, and how they can prepare these children before the children even enter school. This is some data given by UNICEF on the global education across the globe, and we know that it's not a very happy data. And we have been seeing increasing incidences of school-going children with anger episodes and aggressions, and all these kind of behavior problems and impulsive behaviors. And we know that this all not only because of the anxiety that is created because of the discussions on COVID that is going on at all times, and unpredictable environments, unpredictable things, but also because of excessive use of the digital devices that is causing all these to the children, and parents are not able to understand this and not able to handle this. Now, what about the lockdown babies, the babies who were born during the lockdown? They have no interaction with the outer world, with the strangers, and they are mostly seeing their parents interacting more with the screen. So I used to tell my parents when the parents would say that we are not able to work from home because the babies are crying all the time. I said, why don't you see it like that? That the baby is thinking that the laptop is a sibling and you're spending more time with the sibling and you're not spending time with the baby. And that's why the baby is getting emotionally baffled. So why don't you go to another room and sit in front of the laptop? Don't do that in front of the child. So otherwise they're emotionally broken down. So the environment is mainly consisting of digital devices and, their discussions on COVID in the friends and families. And, it's no more a cordial, stable, happy environment until and unless some families and many families have actually taken a decision on not to watch the news and not to discuss too much of COVID in the house. So let's come to school readiness. Now, when we talk of school readiness, we know that children are born ready to learn. And this learning actually is prior to entering school. And one of the best strategies to ensure development of all individuals, society, countries is through the school readiness programs. And many countries are adopting these school readiness programs very nicely. And many children are benefiting from them. So what is school readiness? So it is basically defined by two features. One is transition and one is gaining of the competencies. So basically, readiness for school is different from readiness to learn. Readiness to school implies being prepared to succeed where the school is in a four-walled area in a structured learning environment. But readiness to learn, this is present since birth. So we can use this readiness to learn to prepare our children to go to school and learn in a better way. And transition, basically, the environments are changing and the baby, the toddler being shifted from the home environment to the school environment. For that, many prerequisites are there. So I'm going to talk about those prerequisites. What are those prerequisites? So once those prerequisites are very well developed in a child, we know that we can send this child to school and he is ready to learn in that second environment. And then he will also be able to build well on his education. So children start learning from the home environment, learn to understand the basic concepts of communication, social behavior, speech, language, cognition at home. Many of our speakers earlier have spoken about these things also. And UNICEF has also given the dimensions of early development and learning, which includes health, physical development, emotional well-being. I'm going to talk a little in detail about these approaches to learning language and cognition things. And the three main dimensions, including the stakeholders. So we need the ready children who can focus on learning. We need the ready schools who can focus on school environment. And now in the COVID pandemic time, about the safety issues, and the ready families. And their attitudes have to change. It cannot be, I've heard many parents, saying that once the vaccine comes, we don't want to give the vaccines to our children. There are other set of parents who are saying that even if the government has not got the vaccines for the children, can you please, arrange vaccines for our children? And there's so many talks of such kind going on, that how do we send our children to school? So they must believe in what the pediatricians are saying, and pediatricians should be able to give the right information. Pediatricians are talking a lot on media, on news channels. So, health authorities and the media concerned with health should give the right type of information, because it's not only the parents who are listening to it, but it's also the children who's listening to all these kind of information. So it's very important that children, families, school education system, the health authorities and the society come together, not only for COVID protection, but also for the mental and physical well-being and for better development of the preschool programs. So just going ahead, pandemic has impacted nearly all skills that are required for a young child to develop during the early developmental years. We've had children at our clinic because I'm a developmental pediatrician and we run clinic for children and adolescents for various behavior problems. We've had children from any age group, especially in the age group between 8 to 12 years with a lot of panic attacks, anxiety attacks, having a lot of sleep problems because they are not able to sleep well, because either they have lost a loved one at home or they are listening too much about the COVID things. So let's come to the main domains. What are the main domains that even small children below the age of 5 years that will help enable them to engage in meaningful social interactions? So there has to be good adult interaction at home, development of self-concept, peer interaction, coping abilities within the home environment. I'm going to talk about in detail. And of course, we all know that, children should learn about self-help skills and task-related skills at home. What has happened that since COVID has come and everything is online, children are so hooked onto the screen that they are not bothered about eating. They have lost their appetite. They've lost their sleep because, probably the ones, the non-health professionals who are involved in making these policies for education, and they do not understand the side effects and the adverse health impact on small children, that how it is impacting their development and growth, especially their mental development. And all of these issues is causing a very different scenario in children. They are growing in a different way. They're thinking in a different way. And they are not able to develop the skills that are actually required for reading and writing, which they are going to require later on, because by the time they reach their first grade, second grade, they will have to write exams. So if they do not, fulfill their prerequisite skills for school readiness now, they are definitely going to have a lot of problem. And we pediatricians are going to face a larger chunk of children with learning difficulties. And our pediatric clinics are going to be full of children who are having learning difficulties and behavior problems. Parents should also look at, the motor domains, developing the fine motor skills, the visual abilities and the visual perceptual skills and visual motor skills at home. And there are such simple exercises and such simple activities that can be done at home along with the children. And these activities help in reading and writing skills later on in school. Communication is most important. What has happened is that we have seen, in fact, it's not only during COVID, but even in the last 5 to 6 years, we have seen many children who are coming with speech and language delays and disorders. And we are not able to fit these children exactly into the criteria of autism or exactly into the criteria of communication disorders. But one main history that we get from parents is that, yes, the child has been hooked to the screen for more than 8 to 9 hours per day. And we know that because the child is hooked on to the screen, their speech and language is, getting impacted and not developing well. We also know from research, when a 1-year-old, 2-year-old child is listening to songs and to words from the screen, whether it is ABCD or 1, 2, 3 or rhymes, the rate and rhythm of that accent is totally different from the rate and rhythm of the accent that the mother and father are talking at home. And the brain, as we talk of the neuronal plasticity, the brain's capacity to learn a language is very active in the first 18 months. So if we introduce a digital device with all of these things before the age of 18 months, the brain gets confused and is not able to develop a fluency of the language. And there is a speech and language disturbance. And these are the children who land up with the developmental problems in developmental clinics. So it's very important to pay attention to the communication domains and social skills and social behaviors. Cognitive domain, I always tell parents that when they come and ask me, ma'am, do you think our child is intelligent? I ask the parents, and they are asking about a 2-year-old, a 3-year-old child about the intelligence. I ask them, how do you measure intelligence in your child? The mother says, ma'am, I showed the child 1 to 10 on the screen, and I said it only once, and my child was able to say 1 to 10 properly, and there was no issue at all. When I asked the mother, is your child able to come to you and ask, Mama, give me water? Mama, can I go to the washroom? She says no. There is no social interaction. How is this kind of a cognition going to help? This is only rote learning from the screen. So this kind of rote learning is going to hamper the social development of the child, the social behavior of the child. So, and this is not the way of understanding the cognition of the child. So there are many other skills like problem solving skills and logic, and how the child, the coping abilities of the child, and many other aspects that makes us understand, even as pediatricians, that whether this child is doing well. So what are the prerequisites for school readiness? So as we already said, physical well-being and motor development, which includes gross motor, fine motor, social and emotional well-being, good approaches to learning, including enthusiasm and curiosity for learning, because children between 2 to 3 years of age are very, very curious to learn, and they point out things and they start pointing out and wanting to know what are things around them. Language development, listening as well as speaking and vocabulary, and of course the general knowledge and the cognition. So what has changed for children during lockdown? Peer interaction has come down. There is restricted environment, restricted interaction. The play is restricted. There is disruption in the routines. Children are not having good sleeping hygiene, and the social behaviors are not developing well because of this. There is excessive use of digital screen. Learning from screen for language, plays, and games, it is also impacting the fine motor skills. And again, social behavior is getting disrupted because of that. And then again, the physical environment, social environment, cognitive environment, all of these three environments are getting impacted. There are poor support structures. Families are facing financial losses. Families are facing loss of loved ones, so creating a lot of anxieties for these children within the home environments. So
sorry to interrupt, Doctor. 3 minutes remaining.
Yes, thank you, sir.
Thank you.
So moving ahead, these environments are changing the neural network of these children, and their thought process is very different from what other children were able to do when they were able to go out and work in the school. Also, there's been a lot of research. Sorry, I was not able to bring the reference over here. It is difficult for children below 3 years of age to bring the information from screen to real life. They get confused. So it's important not to let them do this. Kindergarten to preschool up to 1st and 2nd grade, children are learning to read. They're just understanding what the alphabets are and how to pronounce them. It's only after the 3rd grade that children are able to read fluently, and then they are able to utilize this for learning, whatever learning, question answers and all. These are some pictures of how children hooked onto the screen, and they're missing out on their fine motor skill development, and later on reading and writing skills will be hampered. There may be many comorbidities like anxiety, depression, and developmental coordination disorders involved. So what are the building blocks which are necessary to develop these readiness? Self-regulation, teaching children how to maintain and change emotions and behaviors. So self-regulation is not something that we can teach. Self-regulation is something that a child learns from his or her environment, on how parents are able to manage their emotions. So emotional regulation, the executive functioning, day-to-day activities, planning, self-control, organization, the sensory processing, not only from the environment as well as within one's body, which influences attention and learning. Preschool children, they need to have good attention for learning. Then about language, social skills, planning, sequencing is very important for learning. Reading aloud, most important. Reading aloud to young babies is an enjoyable activity and very important. And it not only helps to build mental vocabulary, it also helps in creation of security and fluency of language. So reading from an early age is very important. There should be positive interaction between family members in the house. Parents working from home on laptop, computer must ensure digital devices are kept away from children. Even the background sounds from digital devices should be less, and they should be monitored. American Association of Pediatrics has given very good screen time guidelines. Then talking about the social and emotional aspects, and also activating the learning process. So grouping the children activity as and when one can during the COVID times, one-on-one learning as well as group learning experiences, this help children to learn better and also to develop confidence. So work on the academic and non-academic skills, simultaneously. One last thing, and this is my very favorite, that mothers are getting time to spend at home a lot. And especially the lockdown babies, mothers must sing very gentle, in Hindi we say loris, the lullabies to their little ones. And there's been a lot of research on this. And they say that the music of singing lullabies by the mother, it strengthens the neural connections in the brain and helps, good emotional connect with the mothers. And there should be good approach learning new skills at home. I'm not going to go through these in detail. Roles of school, of course, appropriate COVID behaviors, hygiene, and well-trained, competent teachers, high-quality school environment, and school that also pays attention to health is very important. Role of health professionals, guiding the parents for COVID appropriate information, vaccinations, sharing health related information for prevention, especially when they are talking on media, and talking to parents and schools about how to prevent mental health issues in children and teaching them about the coping strategies. So parent training programs is important. Nutritional, good lifestyle, good sleep hygiene, positive parenting, good playtime, planning organizational skills, creating an emotionally healthy environment in school, and emphasizing the role of family, parents, school authorities as well. So let's work towards building children who can be psychologically sharp, emotionally rational, and behaviorally mature. Now, just a few pictures that I'm showing, let children spend quality time with family. Once they learn some skills, avoid doing those, supporting them for those tasks, let them do it on their own. Fine motor skills can develop from learning small grooming skills at home, and they will later on help in good reading, writing skills, reading aloud from an early age, hearing skills and exercising together, avoiding digital devices around children, outdoor plays as and when possible during the COVID times. Try to make outdoor visits so that children get exposure to little things as they are not getting good exposure. So thank you very much. I am not sure if I've done enough justice to the school readiness program, but thank you for giving me this opportunity to talk.
Thank you, Dr. Chaya, for detailing that readiness to learn and the school experiences for children, and of course, the role of parents, family, and caregivers. You did a fantastic job with the presentation. We wish you a fast return to normalcy and all the very best to you.
Thank you.
Over to you, Dr. Vijay.
Vijay here.
Yeah. Thank you very much. If there are some questions, we can take some question and answers, and we are in some 10 to 15 minutes again.
Yeah, well done.
Because we are well within time.
Sir, I was listening to the previous talk, and there was a question that children with COVID, have they developed respiratory allergic asthmas later on? So, so you can hear me, sir?
Yeah, we can.
Yeah. So I wanted to share my experience. I have never had asthma, or I've never had respiratory allergies. But after I got completely cured from COVID, I realized that I've become very sensitive. I had a sudden bronchospasm one day when there was a wall paint going on. Then because of any perfumes or because of anything, it's become very, very sensitive. So I'm sure that children, going through these problems will definitely be facing these kind of increased incidence of these kind of problems.
I think, Dr. Sir, can I say something?
Hello.
Yeah.
What happened?
Yeah.
Yes, sir, please.
What happened?
Good evening to all of you. I agree with what Dr. Chayapasad said, because I was having 2 vaccines, Covishield, and then I was down with Delta, 10 days in Morgan, and it was a mild thing. But after that, over 6 months, I found that there is some compromise with my breathing. Whenever I sit in a car, I find that there is I get breathlessness. I done my HRCT, everything, even I done CT angio, normal, fortunately. But as she said, the lung compliance may be less. I think here Dr. Parmeshwar, he is an expert, world-renowned, WHO. Do you agree with me, sir? I don't know. I get
I think this is because the chronic inflammation is there, and all the vital organs, heart and lungs and brain, everything is involved. That takes many months as a matter of fact. This is hyperreactivity reaction.
Okay.
We would call it as asthma, hyperinflammatory phenomena.
Okay.
It takes a longer time. Whether going to develop asthma, atopic variety, this time would tell us. Time would tell us.
Okay. Thank you. Thank you, sir. Because this replies to Dr. Rajiv Gupta's question which you are having. Yeah. Another thing, Dr. Patil, sir, we want to thank each and every speaker, even at the end of the session, all chairperson over here. Definitely, even it is more than 12 hours. Dr. Rajiv, Dr. Manjit,
Yes.
you must appreciate the patience of Indians. 12 hours we are sitting here.
I cannot believe it.
Of screen. And Shaya will not pardon us for spending screen timing more than 8 to 12 hours a day. Please in the 3 days. So thank you very much. All faculty. One thing I would like to say, Dr. Patil sir, we must recognize the presence of people who are there for since 3 days. Rajivji, Dr. Pagdala, who is 90 years young, I will say. Dr. Rawat, 83 years young. We must. I will request Dr. If the chairperson allows me, Dr. Badote, Dr. Cherian, if you allow me, Rajiv, then I will request Dr. Pagdala sir to say a few words and Dr. Rawat. And we must recognize two people here. I was seeing continuously, Dr. Andhare Sangeeta and Dr. Priyanka Bhagat, continuously since like 3 days, 2 to 3 days on this without we break. So definitely we must recognize those who are since morning till end, 12 hours they are there. So over to Dr. Pagdala sir, if you are here, God of blessing.
Sir,
yeah.
Are you there, Pagdala sir?
Yes, he is there. Just asking. And Rawat sir is already there. So before we end, I think, and we must recognize the philanthropic donation given by Serum Institute of India. Yeah.
Short vote of thanks I will give.
Yeah, give it.
Uday, it was a great conference, and I really pray to the God that He continue to give you such a energy throughout the career for the benefit of the COMHAD. Such a wonderful, you see, everybody will believe. What a great, and continuously you are there with this smile. I understand for last 3 days. This is an excellent opportunity for everybody to interact. Lot of knowledge sharing has occurred from the US, UK. So many faculties have come, and we could interact with them. It was a very great opportunity. I really appreciate your efforts and Yashwant's efforts for making this conference a grand success.
Thank you. Behind success, there are two ladies. One is Prayata Kaduskar here, and another is Sohini lady.
Yes, Dr. Rajaram sir.
Yeah. Yashwant sir, Dr. Amir Sheikh, also the three people, Amir Sheikh, Sangeeta Andhare, and Priyanka Bhagat.
But are they online? If they are...
No, they need to be recognized. They need not speak. If they want, they can. They are there continuously since 2 days. I am saying continuously without break.
Yes, sir. We are online.
Yeah, Sangeeta Andhare, please. Can you speak? Yeah, Bhagat, please. Before we end.
Wonderful, wonderful.
Sir?
Yeah.
Sir?
Yes, please.
Yes, sir.
Good evening, everybody.
Sir, namaskar.
I'm so much excited by the 3 days activities that we have carried on. COMHAD must be blessed, should continue, should enlarge, prosper, gain height, and everything that an association in life desires. I'm grateful for everybody, but two people are most important. One of them is Dr. Bodhankar, the other is Dr. Patil. I do not know how to call somebody before of them and the other after. Whatsoever you have seen is because of their efforts and the efforts by Prajakta Karuskar, Shivalkar, and then Madam Dahake, and I'm forgetting some other lady.
Yeah,
anyway, this work has been done wonderfully well all these days and for a few weeks before. So also I should thank all the people who have donated for the that Divyang Jan Fund. And I also announce a small token from my side of 5,000 rupees to that fund.
So, sir, that makes your 85. So we are to only 15,000.
Yeah. No, I'll score a century. Don't worry.
Thank you, sir. Thank you for blessing, sir. Now Rajaram Pagda, sir, if he's there, Sangeet Andar.
Please let me continue. Let me continue.
Yes, sir, please.
I would not leave the mic till I finish.
Don't leave, sir. We are your student.
See, the activities before the valedictory were much inferior to after the valedictory function. Only unfortunate point to my mind was the subjects were too large to be covered within that short span of a time. 10 minutes is short time. So when we have some other conference or any other meeting, we should see that the enough time is given so that the things are put across. And I'm really thankful to you, Dr. Bodhankar and Patil, that at every from A to Z activities, you have called Rawat, Rawat, Rawat. I do not know how to pay my gratitude to you, but God bless you. And it was a wonderful conference, which we'll remember for our lives. And I'm grateful to all speakers, the participants, chairpersons, organizers, and everybody from all corners of the world. Thank you very much. Good night.
Thank you very much again. I would like to say that I have my two friends. I have been part of my India, like Indian Academy of Pediatrics, which was around 35 years ago for 10 years, organized the National IAP Conference, has been part of the multiple vaccine trials and all that. So I have my Janam Bhumi as India and my Karam Bhumi as UK, being here for 25 years. This is one of the best conference which I've seen as united front between two of the participants together and then uniting with the UNICEF. So I think it's given a very good package, and I agree with Rawat that there was a little bit more time. We had a lot more discussion and interpersonal action. So that is good, but we all learn with time. And I would again congratulate once again. It has been done many times with both Uday Badankar as well as Yashwant Patil. I think it was a fantastic thing. On behalf of Bapio, again, once again, thank you for giving us to be a partner in such a wonderful conference. All the speakers, they have been great. And I think it was given a platform to talk. And I think overall these recordings will be, I hope, published so that people can go back into it, learn from it, and do more things, particularly like recent advances. All these things, these ideas generated here need to be taken to the next level in order to bring the action which will affect the future generations. And that is a legacy which both Uday and Yashwant Patil laid. And I know Ramesh Mehta has been instrumental, and all of us just joined it together. So thank you once again, and to all other chairs, speakers, moderators, and the background staff who has worked tirelessly in order to bring it action. Managing this platform of Zoom is not easy with people from different parts of the country and different countries. So I think we all appreciate that, and I think a great appreciation to that. No medal will be equal to the amount of the appreciation you are getting. So,
Thank you, sir. Thank you. We also recognize the presence of Praveen Dubli, Dr. Thomre from OT department. Can I, before handing over to Dr. Yashwant Patil, sir, can I request Bapio UK to say a few words? How do you find what we've taken a lot of effort with only your Dr. Ramesh Mehta sir is there, then Dr. Biju Simon, Dr. Sanjay Gupta, any of these, all of them can speak. And then over to Patil sir.
Ramesh ji is not around here. Yeah, so I am so I am representing Bapio officers actually. And thank you very much. This is a great opportunity, and this is a great privilege and honor to be associated with you. And we enjoyed it. and we learned a lot. And good thing is that I'm always thinking about the timing, and we are 2 minutes to finish, so we are on time too. So that is brilliant. So I'm paranoid about the timing because easily we can lose our focus. So thank you once again for everything and everyone. We need to continue to cooperate, collaborate, and develop from here.
Thank you, Simon, sir.
Bye.
Biju Ramesh has already told us that you are very time punctual for everything. Be very careful.
You and Dr. Patil sir also. So I was in tension. If you
Nice. It's nice that Vijay is in time.
Yeah, time.
We should learn from them about maintaining the time and the punctuality.
Yes, sir. Yes, sir. I think.
Yes.
Yeah.
I think Dr. Sam Lingan is there.
Yeah, Sam. Ajay, is he in? Ask him to speak.
Dr. Sam, are you there? I saw your face.
It is here. Raise your hand, Sam, from UK. Yeah, raise.
Oh, yeah.
Yeah. Say some word.
Say some word.
Sam, don't shy. Come on. You never shy. You speak.
Marvelous team, actually, I must say. Marvelous team. An excellent conference and great. Good to see all of you in face. And I'll be coming to see you all in India when the door is open again.
Yeah.
Very much.
Thank you, Sam. Yashwan, you pointed out, I could not see him. Anybody else? Or over to Patil, please.
Yeah.
8 o'clock now. BU Simon.
Just 2 minutes. I'm not going to mention too much names in that. So friends, with deep sense of satisfaction on behalf of the organizing committee team, I would like to extend my sincere thanks to all those who have contributed this conference for the success, mostly the team BAPIO. I am really grateful and admire their cooperation, support, and what is the guidance they have given for this conference. Especially Dr. Ramesh Mehta sir, Biju Simon, for his excellent execution of the program, time to time, and finishing within time. Hats off to you, sir. Dr. Renu Jainar and Dr. Sanjay Gupta sir for their scientific assistance. Then none other than our team COMHAD. We have already felicitated them in the afternoon, so I should not repeat the names, but to mention our chief patron, vice presidents, respected vice presidents, respected advisors, our executives, and esteemed members of the COMHAD, those who have helped me to sail the boat of this conference, doing the work efficiently, and giving me the moral support. I should not forget the sponsors, because money matters everywhere. Whether it's a virtual or whether it's a in-person conference, and when it's an organization and where there are social activities, money matters everywhere. So hats up to our sponsors like Serum Institute of India and UNICEF and DNR. And it's all because the extreme efforts of our respected Madam Phadke Madam. Because of her contact, we can get the financial support to run this show. Hats up to Cyrus Poonawalla and Adar Poonawalla from Serum Institute of India. The letter was directly written to them, and they, without any hesitance, with the word of Phadke Madam, they sponsored. So thanks to them. Then I should not forget our co-workers from a host of therapies, from occupational therapy, physiotherapy, IIP, especially Dr. Pankaj Agrawal, who has looked after our all in-person conference arrangements, food arrangements, and everything. So I have to that. Then NNM Foundation, who supported our workshop for the surgical aspects of cerebral palsy, which was done today. Then media. In that, my friend Dr. Avinash Gawande, he helped me to have a media support, and he has involved about 30 to 40 reporters for the press conference and the advertisement or the news, press news, all these things. And his some senior members, those who are sitting since morning to evening, I surprised. Even I could not sit since morning to evening. But this more than 80 years old. Hats up to them. Yes, God has given that much of energy to them because of their old age. I think their age factor is there and our age factor, the time difference is there. But they have more energy than us, I will say. Hats up to Dr. Pagdala sir, Dr. Rawat sir. Salute you, sir. Salute you. I am seeing you since morning to evening. Yes, all the days. Then our esteemed faculties, chairpersons, session in charge, master of ceremonies, and none other than the facilitators, those who have executed the program time to time, team from United Kingdom. I will mention one name, that is Jitin, I know, and the other members, those who work under the able guidance of Biju Simon sir. And one more addition, I should extend my sincere thanks to Anandwan Varora.
Yes.
Those who have given us a melodious, unique musical program as a cultural program of our conference just for 1 hour, where it was so engrossing, heart-touching songs they sung. Salute to them, how they could become able, specially challenged. Yes, really, it's a God gift to them. So I thank the Honorable Dr. Vikas Amte and their family members, their associate Dr. Poor and Mr. Tajne, Junior Tajne. All they supported me, guided me, and video recording, Vishal Domle, along with Dr. Shubda Khirwadkar and Dr. Prajakta Kaduskar. Selection was done by them and me. So those who have missed this program, they missed, I think, everything. I think so.
Yes, right.
It was, yeah, it was melodious and it was performed by specially challenged. So we should say it's a God gift to them. And the idea was of Vikas Amte only. He brought up all these kids and shown their mettle. Then what is remaining? Our volunteer team. They are the backbones for us, because unless we have working hand with us as a volunteer, like Shubham and their members, Shubham team and their members, event team, their workers, especially Rahul, Veena, Gokul, and all other members, they supported me like anything. At any time, call them, they were attentive, they were listening to my suggestions. Whatever the changes they want to make, we want to make, they used to do. But it was 11th hour, it was very difficult for them, that we could understand their difficulties also, because it's a virtual. So they have to do many changes at many places. But still, they could manage to some extent to our satisfaction. Thank you very much for the event management and volunteer team. And these people, that is Dr. Bodhankar has mentioned, that is Sangeeta Andare, Dr. Bhagat, and Dr. Sheikh. They were listening to the program since morning to evening. Hats up to them. Yeah. I think I must have covered each and everybody. Yeah. If I forget someone else, please excuse me. Yeah. After all, I am a human being. Mistakes can be there. So please excuse me.
Yeah.
Jai Hind, Jai Kumar, and Jai Bapio. Thank you very much.
Yeah, thank you, Patil sir. Sorry, Dr. Pagdal sir, can you say a few words? He's here. Just sir, listen to. We have been waiting for you since 3 days, and you're not speaking. Not fair. 2 words. Your mic is. Say your mic. Unmute your mic.
Ajay, please unmute, sir.
Yeah. Namaskar to everyone. I think my words are not necessary because I've been watching. It's been a wonderful 3 days for me. And early morning, I was getting up very early morning and watching all the episodes. And really, as Uday said, as Ashwant said, the program that was given as entertainment was wonderful. But the COMHAD, the persons are like spikes of the COVID virus. They're spreading like anything. And Yashwant, Uday, Prakash, Vasant, Parmesh, all these pillars are like spokes. So this spokes has pierced into the community, and the COMHAD is growing like a virus, and it should grow. And I want the COMHAD should consider having future plans. My future plan, which I submitted to Yashwant and Uday, which will be discussed by us at length, and probably if they agree, we'll get it back to the next executive body meeting, is to create coordinators at the state levels, to create coordinators at the country levels, to create young COMHAD members for the future. I have already identified a couple of them in Caribbean island, and probably if the permission is given, we will go ahead. So with these words, with these words, I bless all the youngsters who helped you to organize this function so successfully. I have never imagined that this would be so successful as it was for last 3 days. Thank you very much.
Thank you.
Thank you, sir. Thank you, sir.
Thank you for a word of blessing. Yeah. Over to
It was a nice combination. Paramesh, Prakash, Uday, Yashwant.
Only he has to add Prarat and other young people.
Yeah.
Yeah. Thank you, sir. Over to Patil sir. Now it is 10 minutes past 8. So Biju Simon sir, sir, we have seen your noting. Biju Simon sir has given names of all facilitator. I don't want to name them, and event manager, Rahul team. All of them deserve special comment with so many issues were there. So over to Patil sir, please, to close.
Prajakta, I request Prajakta to close.
Oh my God.
Stop now.
More difficult job.
She should have the last word.
Yes.
Thank you so much. And I'm really thankful to Dr. Podhankar sir and Patil sir for putting their faith in me. And I think I have done my best, and I don't know how it appeared here. But thank you so much again to all of you, and would like to meet all of you in person whenever there will be like next COMHAD conference. So thank you very much, and I don't know what words I should use. every word of gratitude has already been used by a number of people over here expressing their gratitude. So thank you very much, all of you, all seniors, all dignitaries and everybody, all facilitators and helpers. Thank you so much.
Congratulations. Congratulations.
Thank you, Deep.
IT persons. Wonderful. IT, past presidents, present presidents, secretaries, vice presidents, those who have been invited at the 11th hour, they attended without it. Thank you very much.
Yeah, namaskar. Thank you. Thank you. Thank you, everybody.
Credit goes to
for
them.
blessing getting.
You see, credit goes to those people who were informed at the 11th hour.
Yes.
Yeah. It was me and Yashwant. We used to rope in chief guest. Here, there, here.
One thing I need to mention that the collaboration with facilitator Dr. Biju and event, it was wonderful. We were just talking so much for 3 days that now we will miss each other.
Now you sleep today. Every day 2 a.m. was too much for you. और also यशवंत आज मैं तो सोऊंगा नहीं 12 बजे तक, वो बात अलग है। That is
आपको भगवान ने उतनी नींद दी नहीं है कभी।
तो 12 के पहले सो नहीं सकता। Whether I get up at 4 a.m. or 5.
440 का वोल्ट का झटका बैठा है तो नींद।
Thank you.
यशवंत, इसका नाम ही उदय है, वो जब जागता है तो सूरज जागता है।
प्रकाश जी, धन्यवाद। Thank you, Cha.
Thank you.
Thank
you very much, sir.
Take care of your health.
Yes, sir. Thank you. Thank you so much. Thank you for your blessing.
Thank you, sir.
Thank you.
Take care of yourself.
Thank you so much, sir.
Thank you, everybody. Thank you.
Very nice to see you all. Thank you.
Thank you so much.
Bye.
Good night. Take care.
Have a great night, India. Bye.
We'll soon meet.
Take care.
Thank you.
Bye.
Bye.
Thanks,
Good
Uday,
night.
Yashwant,
Thank you, Raj
Krishna,
sir. Kal parso
Sangeeta, Jyoti. Fantastic. Have a
Thank
great
you.
time. Bye.
Thank you.
Thanks, everybody.
Thank you. Bye.
Bye.
Bye. Bye. Bye. Bye.
We have to stay till the end, till
Bye,
everybody
Gupta
goes.
sir.
There will more than 35 then.
You have to stay till end.
Patil, till end, 35 people at 8 p.m. Wonderful.
Yeah.
And physical. I don't know virtual day, how many were there.
विनीत सर छोड़ना ही नहीं चाहते अपने को.
कौन?
वो इतने दिन 3 दिन तक रुके हैं तो अभी 5 मिनट में
छोड़ना ही नहीं
पड़ेगा.
चाहते राजीव सर.
अपन अभी कोल्हापुर में जाएंगे. बिजू सर अपने हैं. बिजू सर, this is off the record. This is not being recorded.
Kolhapur party for you, Uday. Uday, Yashwant and whole team. I will give you party in Kolhapur.
Yes. Okay. Thank you. I
So,
will.
we need to meet up.
Biju sir, you can come to Nagpur. Ramesh Mehta, I think did you come to Nagpur?
Not yet, but I decided I will be coming.
Yeah, because
now you have to come. You have to come.
Welcome.
Because all RCBC team, Dr. Mehta, Dr. Shah, Dr. all of them had visited Nagpur because we had DCH London program in Nagpur for 2 years. Only courtesy of Ramesh Mehta, and I had almost faculty, Arvind Shah, everybody. Even Professor Venugopal, he was also here 2-3 times.
Yeah.